Hello, my dear friend. A very warm welcome to all of you in this FMGE marathon series of PW Meded. And by scanning this scanner, you can join our Telegram group and you can clear your doubts before exam in that Telegram group. And then you can have this rapid revision if you scan here. So come, let's start with discussion of some questions which are expected to come in 2025 FMG exams. Plus, we will discuss the whole topic through which I am expecting the questions. So this first question is saying that we have to understand relationship between weight and height. Whenever they will use the word relationship, the question will change. So if you want to know the association between weight and height, out of these four, which diagram will you use? Will you use bar diagram, histogram, pictogram, or scatter diagram? So out of these four, histogram is for quantitative data which we can measure, and rest three are for qualitative categorical data like data of any disease, and scatter diagram is used for correlation. And what is correlation? Correlation simply means direction of association between two variable. दो वेरिएबल आपस में किस डायरेक्शन में एसोसिएटेड है वो बताता है. फॉर एग्जाम्पल, when we were talking about height and weight, so we can write height here, weight here, or as the height will increase, weight will also increase. So this type of diagram is scatter diagram, छितराया हुआ diagram, and scatter diagram will tell about correlation, which we are writing here. Pictogram can tell us, simplest method is pictogram. Like suppose you want to know that how many population is covered by one doctor. Like WHO say that we need one doctor per 1,000, but India has one doctor for 3,700 population when we include all kind of doctors in that doctors, not just MBBS doctor. And then you already, I hope you know the bar diagram part. If you want to revise the data representation topic, I can revise it. Do let me know in the chat box. Otherwise, I hope you will able to answer such question. Whenever they want to know the relationship, relationship is explained by correlation, and correlation is represented by scatter plot, which I have drawn here. This is showing positive correlation because it is going in the forward direction. Next question is, if we are talking about very low dose OCP, what is the dose of ethinyl estradiol there? So ethinyl estradiol and levonorgestrel, when we talk about normal OCP include Mala N and Mala D, which is free of cost. Mala N is free, D is for Dukan. So ye soaps, Dukan means soap, so it will be sold on soap at 3 to 5 rupees per strip. But both of them have the same composition. Ethinyl estradiol in both of them is 30 microgram and levonorgestrel is 0.15 milligram. But when we talk about low dose OCP, this is normal dose OCP. When we talk about low dose OCP have ethinyl estradiol 20 microgram. But levonorgestrel is same. Levonorgestrel is same 0.15 milligram. So the dose vary only in case of ethinyl estradiol, and it is going to be 20 microgram in low dose OCP. Okay. But I hope you all know, when we try to talk about I-pill or unwanted 72, then the dose of levonorgestrel become 10 times more, 1.5 milligram levonorgestrel. But there are two tablets of I-pill. One tablet comes 0.75 milligram, which you have to take one tablet within 72 hours, next in the next 12 hours. So these are the some of the doses that they ask. Plus, I have seen in one exam they ask that what is the composition of today, which chemical. So today is the other name of vaginal sponge, and vaginal sponge or vaginal diaphragm contain the spermicidal cream name of that cream is nunnu jaan lele nono xylenol. Okay, nono jaan lele 9. So do remember it. Then next question they are asking is that mid-year population is not a denominator in which of the following? Is it not a denominator in crude death rate, age specific death rate, weekly death rate, or proportional mortality rate? So they have already asked the definition of crude death rate in MCI exam. Crude death rate simply means denominator is mid-year population. We multiply it with 1000 and numerator is the total life birth in a year. Sorry. This is talking about death rate, not birth rate. So because it is death rate, so we will write total death in a year by mid-year population into 1000. If you have to make it crude birth rate, तो birth rate में simply death की जगह birth लिख देना है. Just replace death with birth, it will become birth rate. When do we measure mid-year population? We measured it on 1st of July. Okay, so it has mid-year population. Age specific death rate also have mid-year population as denominator. Weekly death rate also have mid-year population as denominator. But what is proportional mortality rate? Proportional mortality rate simply means numerator is same. What is the death due to specific disease? Death due to specific disease. Like let's say suppose we are talking about rabies, or suppose we are talking about cardiovascular disease, BP, sugar. So death due to specific disease by total death, not mid-year population. Multiply by 100. This is proportional mortality rate. For example, all this cardiovascular death, BP, sugar problem, they cause 58% of death out of total death. Let's say 100 Indian are dying, then according to the fake data by Government of India, 58 Indian out of 100 die due to cardiovascular disease. So this is proportional mortality rate, and what it is telling us, ये बता रहा है कि सारी मौतों में कार्डियोवैस्कुलर डिजीज के चलते कितनी मौत हुई. यानी ये बता रहा है कि कार्डियोवैस्कुलर डिजीज का बर्डन कितना है, बोझ कितना है. प्रोपोर्शनल मोर्टालिटी रेट टेल्स अस बर्डन ऑफ डिजीज आउट ऑफ टोटल डेथ. एंड हियर इट इज क्लियर कि if total death is 100, out of them 58 is due to cardiovascular disease. One more definition which you must have to remember is about crude case fatality rate. But case fatality rate numerical has already been asked in MCI exam once. This time I am expecting they will ask proportional mortality rate. They can give a numerical also in this topic. Please do remember this formula, very simple, death due to specific disease by total death into 100. And in case fatality rate, again the numerator is same, death due to specific disease, same numerator, divided by total case and multiplied by 100. Like case fatality rate of rabies is 100%. So if there is 100 case of rabies, out of 100 will die. So case fatality rate is telling us killing power, virulence is told by case fatality rate, and burden is told by proportional mortality rate. I hope this two thing is separately clear to all of you. Okay, total case and death due to specific disease is the numerator. Do remember these two, case and proportional mortality rate. So mid-year population was not a denominator of proportional mortality rate because it has denominator of total death. Okay. Next question is, what is the most important test to assess the prevalence of tuberculosis infection? Infection in a community. कैसे पता लगाओगे कि आपके गांव में कितने लोगों को टीबी का इन्फेक्शन है? How will you detect how many people in your village have TB infection? Is it CBNAT, tuberculin, sputum examination, or clinical examination? What do you think? So in TB, do remember, infection and disease is different thing. 40% of Indian are having infection of TB. Like all of us, doctors are definitely infected with TB. But disease is only in 210 per lakh Indian. So disease is very less, infection is very high. And infection can be measured by only two tests, either tuberculin test or interferon gamma release assay. Of course, which one is better? IGRA is better. because it has very less false positive, false negative. And they have asked this question that in which test of TB we take whole blood sample of patient. Answer is IGRA, interferon gamma release assay, where we take whole blood sample. So tuberculin can only detect infection out of the 4. Remaining this test, they are there to detect the disease. वो बीमारी पता लगाएंगे. And first is of course Jaden smear, which is the best screening test if they ask. Not for infection, best screening test for cases or for TB patient or disease they ask. If they ask best screening test to know the prevalence of TB disease, TB cases, then answer is Jaden smear. But here in this question, they are not asking best screening test for disease. They are asking best screening test for infection. And for infection, best screening test will be tuberculin test. Because IGRA is very costly, we cannot apply it in the whole village. Infection best is detected by tuberculin. Disease best in a village is detected by Jaden smear. Screening is best by Jaden smear. Of course, I know and I hope you also know that TB NAT is better than Jaden smear. And if they ask that patient have 2 Jaden smear negative, this is 2 time PYQ. 2 Jaden smear is negative, but X-ray show TB. Then which test you will do? If this is the condition, we will go for CB NAT. One more test for the disease is fluorescent microscopy. And in micro, you must have read what is the dye which we use in fluorescent microscopy. That is auramine O or rhodamine O. But fluorescent microscopy is again very costly and it needs that dye also, so we rarely use it. Final thing for the disease is of course the culture. आज मत चढ़ कल चढ़, है ना, culture. So in the culture, solid medium, LJ medium you can use, or liquid medium is known as Mycobacterium growth inducer tube, MGIT liquid medium. Okay. So if they ask what is the gold standard for TB diagnosis, then your answer should not be CB NAT. Culture in liquid medium, this is the bestest gold standard. Why? Because sometimes CB NAT overdiagnose. Atypical mycobacteria also come as TB bacteria. So to prevent overdiagnosis, culture is best, because in this you can see the growth of the colony. So there is no chance of overdiagnosis in culture. Culture is gold standard. Jaden is best for case detection in village, and tuberculin is best for infection detection in village. Okay. So I hope this 3-4 point you will separately remember. Chalo. Next question is, good morning, my dear friend. I am present, dear. It's not recorded version. Yes, very good, Ranjan Sahni, for replying. Yes, so we are discussing some of the important topics and their questions, because revision of theory all of us have done many times. What we don't do is practice of objectives. So we are practicing objectives, and if you have any topic which you think is tough, not clear to you, you can tell me. I will summarize that topic also, and we will go through questions also. Okay, so do let me know if you have anything you want to ask or say. Okay, the next question is, School Health Program of India comes under which of the following? So school health program, oh, some students are writing RBSK also. Dr. Harry is saying, sir, is it mixed bag? Yes, it is mixed bag. I will discuss the question and then I will go to the topic and discuss the topic also. So here, like school health program, I hope you should know it comes under Ayushman Bharat, not under RBSK. RBSK, Ayush doctor does screening, and along with Ayush doctor, there is Anganwadi worker and ASA worker. All three do screening of children for 4 disease, 4D, screening for 4D. What are the 4D? First D is बचपन की कमियां, deficiency disease. सेकेंड डी इज बचपन की गलतियां नहीं, बचपन की बीमारियां, डिजीजेस ऑफ चाइल्डहुड। थर्ड डी इज डिफेक्ट सिंस बर्थ, है ना, माई केस डिफेक्ट सिंस बर्थ। एंड लास्ट डी इज डेवलपमेंटल एनॉमली or disability. So they can create three type of question from RBSK. First question is that a child is suffering from some illness and no one know the illness. Which program will do the screening? So screening will be done by RBSK in children. Second question they create from here is that RBSK does not include which of the following disease, and there is a big list of 30 disease which are included in RBSK. तो कौन सी बीमारी नहीं आएगी RBSK में, आपको दिमाग लगा के ऐसे सोचना है कि आयुष डॉक्टर वहां पे सिर्फ एक स्टेथोस्कोप लेके जा रहा है, तो जिस बीमारी के डिटेक्शन के लिए हमें कोई इंस्ट्रूमेंट की जरूरत पड़ेगी वो RBSK में नहीं आएगी. Ayush doctor is going there only with an stethoscope. So if the disease need any instrument for diagnosis, it will not come under RBSK. And what are the disease for which we need instrument? Like in the past, they have created two questions from here. One question was regarding congenital glaucoma. Only in 10% case of congenital glaucoma, there is ophthalmos and you can detect it from outside. Other than that, in 90% cases, you need to measure the eye pressure, or you need to see the optic nerve thickness, so it cannot be screened under RBSK. Second question they have created was zinc deficiency. Zinc deficiency also do not come under RBSK because it's very difficult to screen for it. What are the symptoms of zinc deficiency? One is chote tatte, hypogonadism. This was recent INICT, not recent, one exam back INICT question. एंड आई एम श्योर कि आपने अपने टट्टे कभी नापे नहीं होंगे दूसरे दोस्तों से कि किसके बड़े हैं किसके छोटे हैं, क्योंकि नो वन मेजर्स टेस्टिकुलर साइज. वी नीड एन ऑर्किडोमीटर टू मेजर इट, which is not being carried by us doctor. So zinc deficiency do not come under it. Second thing is dryness around nose and mouth. This is also zinc deficiency sign, asked in NEET 2023 question. And third for zinc deficiency is delayed wound healing. So these are the three things with zinc deficiency. Delayed wound healing. I hope you will be able to answer this thing, that these two diseases, congenital glaucoma and RBSK, not coming under RBSK, not in RBSK, because for them we need instrument for diagnosis. Okay. Now, Ayushman Bharat look over three programs. One is PMJ, प्रधानमंत्री जन आरोग्य योजना, पीपल हेल्दी स्कीम, जन आरोग्य योजना, under which we give 5 lakh rupees insurance after admitting in hospital, and this 5 lakh is for whole family, not for one person. And which family is covered in Ayushman Bharat? Is it BPL or economically weaker section? Economically weaker section family. And it is for private government hospital, both secondary and tertiary level hospital. It, of course, sub-center PHC are primary level, so it's not for them. It is for secondary level like CHC district hospital and tertiary level like medical college. So this is PMJ. Okay. Next is midday meal program, which is no more. Now we have PM Poshan. They have changed the name, and after changing name, they added one more thing कि प्री स्कूल चिल्ड्रन, जो बच्चे स्कूल नहीं जा रहे हैं, उनको भी सरकार स्कूल में खाना देगी, है ना. तो जब जा ही नहीं रहे हैं तो खाना किसको देगी? प्री स्कूल चिल्ड्रन आर दोज हु आर लेस देन 6 years, and less than 6 year children go to Anganwadi. Remember, in Anganwadi age is up to 6 year, not 5 year, है ना. Children go from 6 months to 6 year age. So preschool children will also get food, plus school children will get food, and in the food, which one will be more? Protein is more or calorie is more? Which one is half? Which one is 1/3? So do remember always, half is protein, 1/3 is calorie. देखो, कैलोरी को तो बच्चा घर में चावल खा के भी ले लेगा, प्रोटीन उसको नहीं मिल रहा है, इसलिए प्रोटीन हम ज्यादा देते हैं, कैलोरी कम. कैलोरी द चाइल्ड कैन गेट इवन एट होम बाय ईटिंग राइस, but protein they are not getting at home. So we give more protein, half protein, 1/3 calorie. This is midday meal PM portion. And then ICDS, Integrated Child Development Scheme. This include Anganwadi. Integrated Child Development Scheme means हम स्कूल में खाना और पढ़ाई दोनों दे रहे हैं साथ में मिला के, इसलिए इंटीग्रेटेड कहला रहे हैं. वी आर मिक्सिंग फूड विथ एजुकेशन, सो इट्स इंटीग्रेटेड. आंगनवाड़ी come under it. And there is an international organization, care foundation fund for ICDS Anganwadi program, because who need care the most? Small children. So they are funded by care program. Okay, chal. Next question. Ki yes, very good, Harsh Rawat. Protein is more. Bajigar is also correct. Half protein. Orchidometer is there. Sir, there is one student, Mr. 𝐌𝐞𝐝𝐿, who is asking me to teach vaccination schedule by any trick. And Arjun Raju is asking me to teach incidence and prevalence topic. Okay, I will teach both of the things. Plus, if you have anything in your mind, you can always ask. So let me go and teach this topic of immunization schedule. Very simple to remember. Actually, it's very simple to remember. In the immunization schedule, first thing is, when a child born, we give vitamin K 0.5 ml to prevent bleeding disorders. And to remember the remaining vaccination schedule, आपको बस 3-5 करना है. You just have to keep doing 3-5 and you can remember. First 3 are the vaccine given at birth. What are the vaccine we give at birth? BCG, Hep B and OPV. 3 vaccine. And for these 3 vaccine, ASA don't get any payment, because these 3 vaccine are given at hospital. So whom the ASA will give injection to? And they are not at the home, they are at the hospital. She cannot give it to Sasurji. She cannot give the injection to father-in-law. So for these 3, no payment to ASA. Do remember, they ask again and again. Then the first visit occur at 6 week. At 6 week, we give OPV second dose, first dose, Rota first dose, and pentavalent first dose. Why first dose? Because this OPV, which is given at birth, is considered as 0 dose. So first dose is at 6 week, OPV, Rota, Penta. And the same 3 vaccine is given at 10 week and also given at 14 week. So 3 here, same. Now, there is 2 more new addition in the group, FIPV and PCV. FIPV is fractioned inactivated polio virus, not fucked IPV, and PCV is pneumococcal conjugate vaccine. So FIPV VCV is given at 6, then it is given at 14 week, and then it is given at 9 month. So the key to remember the vaccination schedule is, remember this half separately, this half separately. Can you remember this much part? Yes, you can, because birth you already know, BCG, Hep B, OPV. After that, you have to say it with me and you will remember. OPV Rota Penta 6, 10, 14. OPV Rota Penta 6, 10, 14. है ना? OPV Rota Penta 6, 10, 14. Okay, this much is clear. OPV Rota Penta. Then fractioned IPV and PCV 6, 14 और फिर आपको पता ही है 9 महीना, है ना? तो FIPV and PCV 6, 14, 9 महीना, 6, 14, 9 month FIPV PCV. And I hope this separately you can remember easily. FIPV PCV 6, 10, 14, 6, 14 and 9 month, and OPV Rota Penta 6, 10, 14. Done till this part? Okay. Now at 9 month, the 3 vaccine which we give, first is vitamin A 1 lakh, then we give MR and JE. Then the same 3 vaccine, vitamin A, MR, JE, is also repeated at 16 to 24 month time. Same 3 vaccine. So not tough to remember. Vitamin A, MR, JE. And these 2 vaccine, FIPV, PCV, of course, you will add this at 9 month. Apart from these 3 vaccine, at 16-24 month, We also give DPT and OPV booster. And the good news is the DPT and OPV booster, they are repeated at 5 years. Okay, last dose of vitamin A is also given at 5 year 2 lakh. So this is the main part. First remember up to 14 week, and just remember FIPV PCV 6, 14 and 9 month. After that, remember this part separately. This part separately. That 9 month same three thing goes to 18 month, vitamin A, MRJE, and then DPT OPV, which is added at 18 month. That is the same thing which goes at 5 year. So it is not so difficult, I hope. But do remember remaining one more point, that at 10 year and 16 year, Government of India gave DT, not TT. DT we give. Plus we also give 2DT any time in pregnancy. Any time means, can you give tetanus in first trimester? Answer is yes. We can give it any time in pregnancy at 4-week gap. But if suppose the last pregnancy has occurred, last 2DT or 2TT taken in 3 years, then only one booster is given. क्या कहना चाह रहा हूं मैं? अगर कोई मां आई मेरे जैसी, तो तुम पूछोगे कि पिछली बार मां कब बने थे और क्या उस समय 2 टेटनस लिए थे. मैंने बोला कि पिछली बार मां तो मैं डॉक्टर साहब पिछले साल ही बनी थी, क्या करूं, मेरा मुंह कसम छोड़ता ही नहीं है, हर महीने साल ही मां बना देता है ना. इफ आई से माई हस्बैंड मेड मी प्रेग्नेंट एवरी ईयर, आई वाज प्रेग्नेंट लास्ट ईयर ओनली and I received 2TT there, then because last pregnancy is within 3 years, this time you will not give 2, you will give only 1. But suppose कि मैंने ऐसे कहा कि मैं 4 साल पहले मां बनी थी, क्या करूं, मेरा मुंह कसम कुछ करता ही नहीं है ना. What to do, my husband not do anything with me, and so I was pregnant 4 years back. Because I was pregnant 4 years back, so this time you will give me 2. Because in last 3 years, if someone has taken 2, then we give only 1 DT booster. So this is the complete immunization schedule. I hope you can remember it, dear. If you have still some doubt here, please feel free to ask it. Chalo, now, John is asking a tough question. Yes, sir. Cohort study you want to do? Okay, we will do that. Chalo, now, see, my dear friend, this was the, it's not that I have not tried, but actually I should have put it on the board and discuss it separately. If you see, this was the PDF of my whole session. Okay, but in this PDF, things are not coming so clear. You know, it should be in black. I should have checked it earlier. So I was planning to revise the PDF, but because it was not coming clear, so I thought let's go with the question and discuss PDF. Okay, and don't be worried, my friend. If you want me to summarize the whole PDF, I will make it clear, and on a separate day, I will discuss my whole PDF also. Okay, because I don't do practice, I have huge amount of time with me. So on any free day which will be there, I will schedule my PDF summary and I will post it on YouTube free for all, of course, for sure. So this is one thing which I can do in the next session. Okay, so this PDF summary I can give you, but it is not having that good printing. That's why I was trying to avoid it. But if you want to discuss, let's discuss at least this point which I am writing here. This point is the mother and child program with logo. And they ask a lot of questions from this mother child logo, but it's very simple to remember. See, the first logo you can see here is having half child, half mother, incomplete child, incomplete mother. This is because this program is also incomplete. This is Pradhan Mantri Matru Vandana Yojana, Mother Worship Program, Matru Vandana, in which previously government was giving 5,000, but now government gives 6,000. They give 2,000 rupees at 12 week when mother come for registration. Then 2,000 rupees at 6 month of pregnancy. And finally 2,000 rupees is given at 6 week after delivery. So total money given is 6,000. Which program is that? This is PM Matru Vandana Yojana. Okay. Matru Vandana means mother worship program. Do remember the money also. Why it is incomplete? Because this program is also mostly not implemented in any state. So program is incomplete. Logo also have mother child both incomplete. Now if you have yellow color mother, yellow color child, yellow color is due to susu, urination, and this is who do susu. The program name is who do susu, sishu, child do susu. So this is Janani Sishu Suraksha Yojana. It has mother and child both. Janani means mother and Sishu means child. So this is, and this question has came in NEET 2024 also. This yellow color logo has already been asked. Janani Shishu Suraksha Yojana. Okay. And why it is yellow? Sisu has done susu, so it is yellow. You can remember it like that. In JSSY, 3 free benefits are given. Free ambulance, free treatment, free food. Okay. Then if you see black color child, black color mother, and with this logo of some target, this is the logo of 𝐒𝐿𝐾𝐝 program. And in the 𝐒𝐿𝐾𝐝 program, what we are doing, they have asked it already. This program, we do improvement of delivery facility in labor room and all. So we, in 𝐒𝐿𝐾𝐝 program, we improve 3 things. We improve labor room, we improve maternity OT, and we also improve maternity ward. Okay. So this is 𝐒𝐿𝐾𝐝 program. Black mother child is 𝐒𝐿𝐾𝐝. White mother child, we will take it as foreigner. So this is WHO program, baby friendly hospital initiative to improve breastfeeding in children and all. And do remember, this question has came in NEET exam 3 years back, that the baby friendly hospital initiative do not include which of the following. So do remember, BFHI, baby friendly hospital initiative, don't include prevention of infection, because in this is WHO guideline, and internationally in children ward, delivery ward in US, UK and other country, infection is very rare. So the BFHI do not focus on, don't include prevention of infection. Okay, so these are the various questions that has come from it, and I hope you will remember this 5 mother child logo program first. Incomplete mother child, PM Matru Vandana, JSSY, 𝐒𝐿𝐾𝐝 and BFHI. Then if it is blue color mother, blue color child, this is UNICEF, whose headquarter is in New York. And they have asked this question in NEET 2021, that who fund seed and manure of applied nutrition program. So seed and manure of applied nutrition program is funded by UNICEF. Okay. Then there is one more program with mother child. This green color mother, green color child, this is Anmol. Anmol include, Anmol means ANM online. So what is Anmol? Anmol is a tablet based software. And what is the use of this software? Tablet based software for ANM data entry. और जब ये सॉफ्टवेयर आया तो सभी ANM का एक ही सवाल था कि हुजूर माई बाप दयालु कृपालु, आपने सॉफ्टवेयर तो दे दिया, लेकिन इसको डाले कहाँ, हार्डवेयर कहाँ है ना, वेयर इज द हार्डवेयर टू पुट दिस सॉफ्टवेयर, दैट इज नॉट बीइंग आंसर्ड. But do remember, the software for the tablet is Anmol, so that ANM can do data entry. Green color is Anmol, blue color is UNICEF. Then if you find red color mother child, है ना, ऐसा नहीं लग रहा है कि होलिका प्रहलाद को गोद में ले जाके जलाने जा रही है ना, It's like there is a fire burning and a mother and child is inside. This is the logo of Anganwadi program. And Anganwadi come under which thing? Anganwadi come under ICDS, Integrated Child Development Scheme. Okay. Then I hope all the mother child is revised. Black color was 𝐿𝐾𝐝, white color BFHI, incomplete was PM Matru Vandana Yojana, yellow was JSSY, blue is UNICEF, green is Anmol, and red is Anganwadi program. Okay. So because all of you have this PDF already with you, or if you are watching it, let's say in a recorded session, then you can get the PDF from that Telegram group which was given in the logo, or you can get it by directly messaging me also. I will provide you the PDF. So if the PDF is with you, then I hope we can go along with the PDF and revise the PDF also. And if that is your wish is my command. So I was just putting the question because I think the letters are not coming clear, but because you have the PDF with you, I think you can read the things. Okay. So okay, yes, Dr. Mandal is saying do the mixed bag question, that was going well. PDF is not clear, take this in another session. Okay. Again, your wish is my command, so I will do that. But I hope mother child program you will not forget and remember it properly. Okay, chalo. So now let's do this questions. The question is, this is an interesting new topic question. The question is based on internal and external validity. I hope very few of you might be knowing about it. What is internal validity and what is external validity? See, some people, they have very less followers on Instagram, very less followers on Facebook and all. That means they are not known externally. So their external validity is low, but they may be happy from inside. So their internal validity is high. And then there are some people who have lakhs of followers, but who are not happy from inside. So their external validity, people know about them, but internally they are not happy. And then there are people who have thousands of followers also, and they are happy from inside also. So their internal, external validity both are high. Maybe they are also high. So the same concept we apply on study. Internal validity means study correct from inside. Study correct from inside. How it is correct from inside? A study is correct from inside if two groups are comparable. If you are taking one group of people as young people, suppose you want to know what is the reason of anxiety among exam going student, and one group, in the anxiety group you took exam going student, but in the control group, other group, you took first year MBBS. So is it comparable? No, one is exam going student, one is first year, so you cannot compare them. So this study is not correct from inside. The internal validity is low because they are not comparable. But if one group, if you want to know the reason of anxiety in exam going student and you ask them to choose chit and go by chit method in two group, randomly in two group. So if they are going randomly in the two group by chit method, then they both are from the same exam going batch and they are comparable. So this will make internal validity high because they are comparable. So do remember, how can you increase internal validity? To make the study good from inside, we can do randomization and matching. What is matching? Matching means if in one group you took exam going student of FMGE exam, in other group also you have to took exam going student of FMGE exam. That is matching. Same exam, same year, similar type of people in two group, matching. And if you have similar type of people in two group, internally that study is good because these two group are comparable. Okay. Now, what is external validity? External validity means applying the result on general population. Okay, external validity simply you can say generalization of result. Can we apply it on general population? Okay, so suppose you are doing a study in which you are including students from first year of MBBS till their whole medical life, and you are trying to know how many of them develop anxiety and all. So you are including age group 17 year till 80 year. This big age group you have included. Now you can apply this study on the whole medical fraternity. So your external validity is high because you can apply it everywhere. Okay, generalize it to normal people. So this is external validity, this is internal validity. I hope it is clear. Now the question they are asking was, they did a study in Delhi on hypertension, and they found out that in this study there was the lisinopril drug they were studying, and the patient who were taken in the study, they have not discussed that which group of patient I have taken. The question that they are asking, that which would indicate poor internal validity, है ना? What will be the reason of poor internal validity out of these four? Okay, out of these four reasons, which reason will cause poor internal validity? So look at the option number 1. If they exclude men from the study, if men are not there, you cannot generalize it to men. So if you remove men, external validity become less. Second option, average age of study population 80 year. If you take only 80-year people, no young age people, you cannot apply it on young age. Again, generalization will be low. So removing young people will also decrease external validity. Third group, if you are taking only those patients who have kidney disease, so then you cannot apply it on every diabetic patient or hypertensive patient. You can only apply it on kidney disease hypertensive patient. So again, this will also decrease external validity. But if you don't have a control group, you just give your lisinopril tablet to one group of patient and you did not compare it with other group, then how can you say that my lisinopril is better? And you can say that you are better when you compare your score with other student score. Na? If there is no control group, no one to compare, how can you say that I am better? So this means if there is only one group, no two group, study is not correct from inside. And study not correct from inside means internal validity is low. So which one out of the four is making internal validity low? Lack of control group. This is making internal validity low. Okay. So this, I hope, is a new question, new concept, but I hope you have understood it. If not clear, feel free, I can give you another example to make it clear. Don't worry. Okay. चलो, हेमंत कुमार कह रहा है कि सर थोड़ा हिंदी में समझा दीजिए. क्यों नहीं मेरे भाई? इट्स वेरी सिंपल टू अंडरस्टैंड. अगर हमने एक ही ग्रुप रखा, दो ग्रुप नहीं रखा, तो स्टडी अंदर से बकवास हो गई. अंदर से बकवास यानी इंटरनल वैलिडिटी कम हो गई. तो यहां पर वही हो रहा है, एक ही ग्रुप है, अगला नहीं है, इसलिए इंटरनल वैलिडिटी कम है. लेकिन अगर हम लोगों को एक जैसा चुनेंगे दोनों ग्रुप में रैंडमली या मैचिंग करके, तो दोनों ग्रुप अंदर से एक जैसे कंपेरेबल होंगे और वो स्टडी अंदर से अच्छी होगी. अंदर से अच्छी मतलब इंटरनल वैलिडिटी हाई. एंड एक्सटर्नल वैलिडिटी का मतलब कि हम आम जनता पे अप्लाई कर सकते हैं कि नहीं. तो अगर हमने सिर्फ आदमी चुना या सिर्फ 80 साल के बुढ़े चुने या सिर्फ किडनी बीमारी वाले को लिया, तो हम आम जनता पे अप्लाई नहीं कर सकते हैं. तो ABC के चलते एक्सटर्नल वैलिडिटी कम हो रही है और कंट्रोल ग्रुप नहीं होने के चलते इंटरनल वैलिडिटी कम हो रही है. अगर नहीं क्लियर हो तो फिर से पूछना, डोंट वरी, कीप आस्किंग व्हेनेवर यू थिंक इट इज नॉट क्लियर. ओके, चलो. देन नेक्स्ट क्वेश्चन वाज कि देयर इज अ स्टडी ऑन ए न्यू टाइप ऑफ वायरल इन्फेक्शन and you took one group of passenger who were traveling in a cruise ship in Caribbean Sea area, and there is another group of people who were traveling in Pacific coast area. Okay, so there is two group of people. who were traveling, and they both developed new corona type of infection. Now, they took both this group of patient to hospital. They took the history, timing of onset, how the disease occur. They give the treatment. They compare the possible causal organism, and they find it out that both of them have same organism. So which study is done here? Which study design is this? हो क्या रहा है, दो अलग अलग जगह के लोग पकड़े गए, उन दोनों ग्रुप के पेशेंट्स को हॉस्पिटल लाया गया, हॉस्पिटल ला करके पूरी हॉस्पिटल स्टोरी लिखी गई कि हॉस्पिटल में हिस्ट्री क्या थी, हॉस्पिटल में इन्वेस्टिगेशन क्या हुए, ट्रीटमेंट क्या हुआ, सर्जरी क्या हुई, ये सब आपने कहानी की तरह लिख दिया. You write this, all the things which happened with this two group of patient in the hospital. Like a story, you write everything. So if you are writing the story of two group of patient, but both this two group of patient is having common illness, their infection is by the same organism, and you are writing their hospital story, not just hospital data, complete hospital story of two or more than two group of patient having common illness. What do you call it? Will you call it case control study, case series, crossover RCT और क्रॉस सेक्शनल स्टडी? क्या कहोगे आप इसको? तो देखो, in case control, one group is having disease, one group is without disease. Case means disease, control means no disease. And in our story, both group have disease. हमारी कहानी में तो दोनों ग्रुप को बीमारी थी. So it cannot be case control because there is both group have the disease. There is no one without disease. So it cannot be case control. Now, what is cross-sectional study? Cross-sectional study को कहते हैं prevalence study. In cross-sectional study, we ask question from everyone कि do you have infection or नहीं or not, है ना? How many of the student in the class have cough and cold? This can be prevalence study, and we call prevalence study as snapshot study. क्योंकि देखो, जैसे पिक्चर को पास्ट या फ्यूचर में नहीं ले सकते हैं, इसलिए कितने लोगों को क्लास में इंफेक्शन है, प्रिवलेंस पता लगाना है, तो ये अभी पता लगेगा प्रेजेंट मोमेंट में. तो क्योंकि क्रॉस सेक्शनल स्टडी प्रेजेंट मोमेंट में होता है, जैसे पिक्चर हम सिर्फ प्रेजेंट मोमेंट में लेते हैं, इसलिए क्रॉस सेक्शनल को स्नैपशॉट प्रिवलेंस स्टडी कहते हैं. बिकॉज वी कैन नॉट टेक पिक्चर इन पास्ट और फ्यूचर, वी कैन टेक इट ओनली इन द प्रेजेंट मोमेंट. एंड इफ आई वांट टू नो हाउ मेनी ऑफ यू हैव इन्फेक्शन, दैट इज प्रिवलेंस स्टडी, क्रॉस सेक्शनल स्टडी, व्हिच इज डन. Crossover RCT is an RCT where we do give medicine for some time, then we wait for some time, wash out time, and after this wash out time, suppose I am giving modafinil to some student and placebo to some other student to know modafinil can improve your study performance or not. So if I give modafinil to one group, placebo to other group for let's say 3 months, I gave them, and after 3 months I let them modafinil placebo to go out from their urinary system. Then I will give placebo here in group A and modafinil here in group B. So, and then again I will do follow up for 3 months. This is crossover RCT. I am changing. Why it is crossover? Because I am crossing over the treatment. मोडाफिनिल जो ए में दी जा रही थी अब बी में देंगे, प्लेसिबो जो बी में दिया जा रहा था अब ए में देंगे, है ना. द मोडाफिनिल विच वाज गिवन इन ए, नाउ वी गिव इट बी. Placebo which was given in B, now we give in A. So this is crossover which I did, and there is two parallel RCT. First parallel RCT, then wash out time, then next parallel RCT. This is crossover RCT, and crossover RCT is not the answer, because in this study we are not giving one treatment to another group and another treatment to another group. We are just writing down whatever treatment we are giving to them. हम लोग अलग अलग ट्रीटमेंट एक्सपेरिमेंट नहीं कर रहे हैं, हम बस लिख रहे हैं कि हमने इलाज क्या किया. तो ये एक्सपेरिमेंटल स्टडी है ही नहीं, आरसीटी है ही नहीं, बिकॉज देयर इज नो रैंडमाइजेशन एंड वी आर नॉट गिविंग ट्रीटमेंट एंड प्लेसिबो, सो इट्स कैन नॉट बी आरसीटी ऑफ एनी टाइप. तो आरसीटी इज गॉन, क्रॉस सेक्शनल इज गॉन, केस कंट्रोल इज गॉन. आंसर इज केस सीरीज. केस सीरीज क्या होता है? अगर हम 2 या 2 से ज्यादा ग्रुप ऑफ पेशेंट की हॉस्पिटल स्टोरी लिखते हैं तो उसको केस सीरीज कहते हैं. ओके, if 2 or more than 2 group of patients story, hospital story is written, that is case series. Okay, yes, multiple reports can become case series also. Correct, very good. Chalo, so I hope it is clear, understood. Now okay, स्टडी डिजाइन नहीं समझ में आता है, बादशाह का भी कहना है और भी लोगों का कहना है काइंडली एक्सप्लेन स्टडी डिजाइन, एंड सावित्री इज आस्किंग लेप्रेसी का ट्रीटमेंट विथ डोज इफ पॉसिबल इन दिस लेक्चर. एनीथिंग इज पॉसिबल डियर सावित्री, व्हाई नॉट? वी विल गो विथ दैट definitely. Let me give you the first. Savitri have asked the leprosy treatment and dose, and then some students have asked the design of study. So let's finish the design, then we will go to the treatment. Design, let's start with the first thing. One thing is case study. Case study is known as case report. केस रिपोर्ट को लिखते हैं केयर स्टडी, CARE भी लिखते हैं, केयर. केस स्टडी और केस रिपोर्ट मीन्स वन पेशेंट हॉस्पिटल स्टोरी. ओके, suppose you found a case patient of lymphoangiosarcoma of intestine, special case, you write about it, case study, case report. What is case series? We just studied one example. Case series means multiple report of many patient having same disease, so it is also hospital story but two or more than two group of patient. Then we have cross sectional. In cross sectional, what I do, I ask question from everyone about present moment. So cross sectional study is known as prevalence study or snapshot study. Very simple thing, I hope you understood it. If I want to know how many of you have infection, that is cross sectional, by which I know the prevalence. Then we have ecological study. In ecological study, we simply correlate. That's why we know it as correlational study. ये दूसरा नाम भी पूछ सकते हैं. What do we correlate in ecological study? In ecological study, we correlate hospital data with patient data. Population data, not patient data. With population data. So the first confusion is when in the exam they gave only one group of patient. How to prevent, how to decide whether it's case control, cohort, cross sectional, ecological. I am telling you the hint for that, secret for that. पहला चीज जो आपको ध्यान देना है कि क्वेश्चन में एक ग्रुप है या कई सारे ग्रुप हैं. If there is one group, answer can be 1 out of 4. And of course, केस स्टडी को तो आप तुरंत पहचान जाएंगे, एक पेशेंट होगा. केस सीरीज को पहचान जाएंगे कि एक ही बीमारी के 2-3 ग्रुप ऑफ पेशेंट हो सकते हैं, है ना. आई होप केस स्टडी, केस सीरीज सिंपल, वन स्टोरी, वन पेशेंट स्टोरी, केस स्टडी, वन और मोर देन वन ग्रुप, केस सीरीज. बट क्रॉस सेक्शनल इकोलॉजिकल, हाउ विल यू आइडेंटिफाई? In cross section, question will be from every participant. In ecological, question will be from no participant. अगर सबसे सवाल है तो है क्रॉस सेक्शनल, और अगर किसी से सवाल नहीं है तो है इकोलॉजिकल. Every participant asked. Cross sectional, no question asked, no question from participant. किसी से सवाल नहीं पूछोगे, सीधे पॉपुलेशन का डेटा लोगे और हॉस्पिटल के डेटा से जोड़ दोगे. तो if no question asked from participant, then we call it ecological. If every participant asks, cross section. So this part is clear, cross sectional, ecological. Now the actual confusion come in cohort and case control, which is also very simple. देखो, as I said, case control, what is the starting two group? कहते भी हैं हम अपने दोस्त को कि अबे ये तो केस है. केस है मतलब बीमार है, कुछ अलग है. सो केस मीन्स बीमार होना चाहिए, डिजीज, या परिणाम पहले आ चुका हो. डिजीज और आउटकम प्रेजेंट शुड बी द केस. एंड कंट्रोल मीन्स नॉन डिजीज, जो बीमार नहीं है, नॉन डिजीज या आउटकम एब्सेंट. परिणाम है तो केस है, और परिणाम नहीं है तो कंट्रोल है. बीमार है तो केस है, बीमार नहीं है तो कंट्रोल है. तो In a case control study, always remember, we start with case, that means we start with effect, and then we go to the cause or the reason. We start with disease, and then we go to the risk factor why this disease started. So case control, always remember, starting two group will be disease non disease. अगर दो ग्रुप दे दिया, मोटे नॉन मोटे, ओबीज नॉन ओबीज, इट इज केस कंट्रोल. One group is diabetic, other is non-diabetic, and then we are asking the past history, it is case control. But how will have the two group in cohort? In cohort, one group is which are exposed. Exposed का मतलब होता है कारण present, risk factor is there, risk factor present. And other group in cohort is non-exposed. Non-exposed means risk factor absent. Okay, risk factor present is case, risk factor absent is risk factor present is exposed, risk factor absent is non exposed. जिसमें कारण है वो है exposed, जिसमें कारण नहीं है वो non exposed. तो अंतर करने का बड़ा सिंपल तरीका है, शुरुआत कहानी की कहां से हो रही है. अगर शुरुआत कारण से हो रही है और फिर हम परिणाम की ओर जा रहे हैं तो केस कंट्रोल है, तो कोहॉर्ट है, क्योंकि कारण से परिणाम की ओर कोहॉर्ट जाता है. लेकिन अगर शुरू में ही दे दिया है कि एक ग्रुप में बीमारी है एक ग्रुप में नहीं है, और फिर हम पीछे जाके बीमारी के कारण देख रहे हैं, तो केस कंट्रोल है. द मेथड टू आइडेंटिफाई केस कंट्रोल कोहॉर्ट इज सिंपल. इफ द टू ग्रुप इज डिजीज नॉन डिजीज, इट इज केस कंट्रोल. If the two group is risk factor present, not present, it is cohort. Okay, and rest is RCT. RCT will have randomization, or drug will be given to one group, not to other group. So RCT is easy to identify. And cross-sectional ecological will have one group. Cohort and case control will have two group. So if they have not given two group, answer cannot be case control cohort. If they have given two group, only then it is case control cohort. And in the two group, if they talk disease non-disease, case control. If they talk risk factor present absent, it is cohort. And now you need to practice some question on this topic. Only by practice you can be sure that you know this topic or not. So in my next session, which I will take summary of the whole syllabus in 4 hours, I will start with 7-8 example of studies, and I will create some 8-10 examples. I will write it down already before starting session, and then we will practice those example in one go, and it will get clear. Within this week probably I will have that session. Okay, I will try to have this within before finishing your or at the last day when the session will end. On the last day I will have separate session summary. Okay, chalo. Now the next question being asked to me was what is the treatment and dose of leprosy drugs, leprosy treatment was being asked by Dr. Savitri. It's something which is a bit confusing, but it's not so confusing actually. See, in leprosy we say pauci and multibacillary. Paucibacillary is when it is less than or equal to 5 skin patch, and multibacillary we say when it is 6 or more than 6 patch. So first is in the multibacillary part we give dapsone. Then we give rifampicin, and third thing we give is clofazimine. So how we give them? The dose part you have asked. It's a pharma topic. I have left teaching this topic, but I will definitely be able to teach it here. Yes, I remember the key. Dapsone we give, first we give 100 mg per day. Okay, And with this 100 mg per day, we add clofazimine 50 mg per day. Oh, sorry, I have forgotten the dose, and being a teacher, I cannot do the guesswork. I have a bit of confusion myself, so I am not being able to write the dose. In the summary session, I will take the dose also. This is in derma and pharma. I don't teach the dose, so I have forgotten it. Earlier, I used to teach it. But do remember, these three drugs are here. And there are three questions which they have asked from this part already. First question is, ki if a patient have darkening of skin, which drug is causing this problem of darkening of skin? So darkening of skin and opacification of lens, like cataract like changes in lens. These two problems, opacification of lens and darkening of skin, they both occur due to clofazimine. Okay. Second thing they have asked is that if a patient have lepra reaction, in case of lepra reaction, what is the treatment of choice, drug of choice? Will you give dapsone, rifampicin, clofazimine, or prednisolone, methylprednisolone? So the drug of choice for lepra reaction is methylprednisolone steroid. The second question which they ask is, when you give methylprednisolone, will you continue the treatment or will you stop the treatment? If you stop the treatment and give steroid, leprosy bacilli will multiply very high number. So we will give methylprednisolone plus we will continue the treatment. We will not stop it. Continue the treatment. Okay. So do remember these two questions being asked. Plus you should also know that in the paucibacillary, the treatment is given for 6 months only and the follow up is for 2 years. But when it is multibacillary, the treatment is given for 1 year and follow up is for 5 years. So multibacillary have double the treatment and follow up is 2 years in pauci, 5 years in multi. Plus do remember these other question. Sorry, I was unable to tell you the dose because I have forgotten it myself. I will read it and will discuss it in our next session. Okay. I hope your two doubts of different type of case, different deciding the study and the leprosy is clear. Yes, very good. Some of you have written the treatment. I remember it, but I was doubting it, so I left it. Chalo, come here. One more question is regarding the biostat part. They are saying that and as soon as we see biostat, we think it is very hard, we leave it. But no, many biostat questions are very simple, like this. Focus here. First question you have to focus is what they are asking. They are asking about variance. So now focus on the formula of variance. Do you know any formula of variance? There are two formula of variance. One is variance is equal to standard deviation square, or we can say standard deviation is under root of variance. Okay, this is one formula. Second formula is coefficient of variance. This coefficient of variance is standard deviation by mean, and we can multiply it with 100 if we want answer in percentage. So are they asking coefficient of variance or only variance? They are asking only variance, so we just have to focus on this formula, standard deviation square. Now there is two things they are measuring. One is diastolic BP, which is 110, and standard deviation is 11. So what is the standard deviation of diastolic BP? Standard deviation of diastolic BP is 11. And then they are talking about vitamin D, who have a standard deviation of 3. So standard deviation of vitamin D is 3. The question that they are asking is, who will have bigger variance? Vitamin D variance will be more than diastolic BP, or diastolic BP variance is greater than vitamin D. who will have greater variance? तो वेरिएंस उसी का बड़ा होगा जिसका स्टैंडर्ड डिविएशन बड़ा होगा, क्योंकि वेरिएंस इज स्टैंडर्ड डिविएशन स्क्वायर. If you have bigger standard deviation, your variance will be bigger. And here, standard deviation किसका बड़ा है? Diastolic BP have standard deviation of 11. So, if you look at the variance of diastolic BP, variance is standard deviation square. 11 square is 121. But what will be the variance of vitamin D? Variance of vitamin D is again standard deviation square. Standard deviation is 3, so 3 square is 9. So it was a very lollipop question. If you see, if you know the formula, it's very simple. If you don't know, it's very tough. And the formula is clear, that variance is standard deviation square. So who will have bigger variance? Of course, diastolic BP have bigger variance than vitamin D. Now, there are two things which you should know from this topic. First is why we use coefficient of variance. This question has been asked 2 times in NEET exam in last 6 years. The purpose of measuring coefficient of variance is that coefficient of variance do 2 things. It compare quality of data and it also compare dispersion of data. डेटा कितना फैला हुआ है ये कंपेयर करता है, और क्वालिटी. और आप ही सोचो ना, कैसा डेटा आपको पसंद आएगा, फैला हुआ या टू द पॉइंट? कैसा रायता पसंद करते हो, फैला हुआ या कटोरी वाला? ऑफ कोर्स कटोरी वाला. फैला होगा तो कैसे खाओगे, बहुत दिक्कत होगी ना. सो बेसिकली कोएफिशिएंट ऑफ वेरिएंस टेल अस हाउ मच द डेटा इज स्प्रेड and which type of data we like, which is to the point. And if it is spread data, it's difficult to manage. So if the coefficient of variance is less coefficient of variance means better quality data. Smaller coefficient of variance, better quality data. Similarly, do remember, in case of confidence interval also, if there is less range of confidence interval, or small range of confidence interval. A small range of confidence interval also means better quality data. So we want big things in life, but 2 things which start with C should be smaller. Smaller the better. हमें जिंदगी में बड़ी चीज पसंद है, लेकिन 2 चीज जो C से शुरू होती है वो छोटी होनी चाहिए. कौन सी 2 चीज जो C से है? Coefficient of variance or confidence interval. These 2 things with starting with C should be smaller, more significant. Now, how does coefficient of variance compare the quality of data? We can understand by a very simple example. Suppose you are sitting in my OPD and 2 patients came to you and you ask from both the patient कि when does it wake up? कब खड़ा हो जाता है, कब उठ जाता है? Which OPD you are sitting? You are sitting in my OPD, means sex and marriage counseling OPD. I am a trained sexologist from AIMS New Delhi actually. So in MD PSM they used to send us there. And out of these 2 patients, first patient said, sir, sometime 4 a.m., sometime 5, sometime 6 a.m. When the neighbor cock make the sound, my cock wake up also, 4, 5, 6. And second patient said, sir, sometime 2 a.m., sometime 6 a.m., sometime 10 a.m. 2, 6, 10. So in these 2 patients, if you have to find coefficient of variance, what is the formula? Standard deviation by mean. Now, in 4, 5, 6, what is the mean? Mean is 5. How can I tell without calculation? क्योंकि इस डेटा में हर एक नंबर बराबर दूरी पर है, और जब हर एक नंबर बराबर दूरी पर होता है तो बीच का नंबर ही मीन होता है. Because this data is symmetrical data, every number is equally away. And if every number is equally away, middle number is the mean. So mean is 5. What is standard deviation? Standard deviation का सीधा मतलब होता है कि हर एक नंबर मीन से कितना दूर है, इसी को कहते हैं स्टैंडर्ड डिविएशन. और आप ही सोचो, 6, 5 से कितना दूर है? 1. 4, 5 से कितना दूर है? 1. तो स्टैंडर्ड डिविएशन कितना हो गया? 1. So standard deviation is not a big thing. It simply means how far is each number from the middle number. And because here each number is 1 away from 5, standard deviation is 1. So 1 by 5 is 0.2. Now in the second case, you find coefficient of variance yourself. Pause the video and find it yourself. What is the mean here? Mean is 6. What is the standard deviation? How far is each number from 6? 4. So standard deviation is 4, mean is 6, 4 by 6 is 2 by 3, 2 by 3 is 0.66. So which is smaller coefficient of variance? Patient 1 has a small coefficient of variance, and that is why you can say patient 1 is having better quality data because it has less coefficient of variance. Actually, in this story, patient 2 is telling a lie. And penile erection cannot be at 2, 6, 10. It's not about mood. And so this happen. Sometimes patient don't agree their complaint and they say, my friend have this problem. So it's the same thing here. Do remember, if the data has less coefficient of variance, less standard deviation, less confidence interval, it is a better data because it is to the point, precise. Okay. So this is one part you have to remember. Second part you should know is, they ask the question from the formula of standard deviation. They just ask you to identify the formula. One is standard deviation is under root of variance. और इस एग्जाम में आपको आएगा, ये पूछेंगे कि स्टैंडर्ड डिविएशन का करेक्ट फॉर्मूला क्या है, बस पहचानो. 2 बार INICT में आ चुका है. तो क्या करेक्ट फॉर्मूला है मैं आपको बता दूं. लिखते हैं हम लोग मीन को लिखते हैं x के ऊपर बार लिख करके, और मीन से माइनस करते हैं नंबर को. मीन माइनस नंबर. नंबर को किससे लिखते हैं? नंबर को लिखते हैं म्यू से. तो x माइनस म्यू हो गया, और इन दोनों का करोगे स्क्वायर, और यहां पे एक ऐसी साइन देते हैं, इसको कहते हैं साइन ऑफ समेशन. दिस इज साइन ऑफ समेशन. वी आर एडिंग ऑल द नंबर. मीन माइनस नंबर. मीन इज x बार, नंबर इज म्यू, होल स्क्वायर डिवाइडेड बाई सैंपल साइज माइनस 1. सैंपल साइज को n कहते हैं, n माइनस 1 is in the denominator. So can you remember this formula of standard deviation? X bar minus mu whole square by n minus 1 under root of whole of it. This definition is a PYQ. Do remember this definition. They never give numerical on it. Numerical is on this. Standard deviation is under root of variance. Okay, so do remember this. Now let's go to the next question. The next question is that there is a chest physician who had measured the force effective volume in 200 smokers, and they found the median value is 2.5 liter. First quartile is 1.5 liter. Third quartile is 4.5 liter. So based on this data, how many person in the sample are expected to have force effective value between 1.5 and 4.5? 1.5 लीटर और 4.5 लीटर के बीच में कितने लोग आएंगे? अब ये देखो, देखने में टफ लग रहा है, क्वेश्चन है सिंपल. सपोज ऑप्शंस गिवन आर 50, 100, 150, 75. Okay, what is your answer out of this question? If you know the answer, please do answer it. तो देखो, in all this question, first thing you have to do is write the sample size. Sample size is 0 to 200. There are total 200 people. And then divide this sample size into 4 halves. First half is known as first quartile. Quartile means 25%. So where is first quartile? 1.5 liter. Then the third quartile they have given as 4.5 liter. 4.5 and 1.5 is first and third quartile. Third quartile is at 75%. First quartile is at 25%. तो यहां पर 25% लोग बाहर हो गए. फिर बीच में 1.5 to 4.5, this is total 50% in between, and 25% are more than 4.5. यही तो होगा. And they are asking how many are between 1.5 to 4.5. So 1.5, 4.5 will have 50% of people. And what is 50% of 200? 200 का 50% कितना होगा? 100. So answer become 100 because they are asking how many people are between 1.5 and 4.5, and 1.5 is 25%, 4.5 is 75%. So between 25 and 75% there are 50% people, and 50% of 200 is 100. So answer is 100. So क्या steps है in question के? First step is write the sample size, divide it into 4, and then see what they are asking. If they are asking how many people are less than 1.5, answer will be 25% of 200, that is 50. If they ask how many people are more than 4.5, more than 4.5 is 2.5% of 200, 25% of 200, that is again 50. But they are not asking how many are less than 1.5 or more than 4.5, otherwise the answer will be 50. They're asking how many are between 1.5 4.5, that is 50%, and therefore answer is 100. Okay, do you need one more question on this topic? Do let me know in the chat box. Okay, chalo, theek hai, very good. 25 50 is the answer coming. Only Dr. DRX gave 100, है ना, but very good that you replied it. Chalo, yes, chalo, let's move ahead. If you need more question on this, once more, Dr. Dibay wants one more question or one more explanation. One more question will be better. Question is, in your class, who are attending my class, out of 300 student, okay, first quartile of weight, 25% of you weight 50 kg, and third quartile means 75% of student weight 90 kg. So 50 kg is first quartile, third quartile is 90 kg. My question is, how many student of course weight less than 50? Less than 50 कितने बच्चों का weight होगा? This is my next question. कि 50 से कम कितने बच्चे होंगे? ऑप्शन इज, ऑप्शन ए 50 से कम होंगे 25 बच्चे, बी 50 से कम होंगे 50 बच्चे, सी 50 से कम होंगे 150 बच्चे, या डी 50 से कम होंगे 75 बच्चे. सेम 4 ऑप्शन. नो, 25 50 150 75. सोच के बताइए क्या आंसर होगा. इन योर क्लास 25% स्टूडेंट वेट 50, 75% weight 90. How many are weighting less than 50 kg? Dr. Dibay, DRX, Nisa Panda all have given the answer already. Dr. Toluddin Blue also have given answer, and all of you are correct. Let me give you the explanation. क्या करना है आपको? First focus on the sample size. What is the sample size? 300. So divide 300 into 4 parts. Each part is 75. So then between 0 and 50 there is 75 people. Between 50 and 90, 50 is 25%, 90 is 75%. So between 50 and 90 there are 50% people. What are 50% people of 300? 150. And how many are more than 90? More than 90 is also 75. But here they are not asking more than 90. They are asking how many are less than 50. So less than 50 is just 25%. And what is 25% of 300? 25% of 300 is 75. So answer is 75. Very good. 75 is the answer. Okay. So very good. I hope you understand. अगर इसी क्वेश्चन में मैंने पूछता कि 50 से 90 के बीच में कितने लोग हैं, तो आंसर होता 150, क्योंकि 50 से 90 के बीच में 50% है. बट कभी कभी वो पूछेंगे कि फर्स्ट थर्ड क्वार्टाइल के बीच में कितना है, कभी वो ये पूछ देंगे कि फर्स्ट क्वार्टाइल से कम कितना है, कभी वो ये पूछ देंगे कि थर्ड क्वार्टाइल से ज्यादा कितना है. तो आपको सैंपल साइज को 4 में डिवाइड करने के बाद देखना है कि वो पूछ क्या रहे हैं और उसके बेसिस पे आंसर करना है. ओके, व्हाट आई वाज सेइंग इन हिंदी वाज, here if they ask how many are between 50 to 90, then answer will be 150 because that will be 50%. but they are not asking how many are between 50 to 90. They are asking how many are less than 50. So less than 50 means they are only asking about how many are in the first quartile, and first quartile is 25%, and 25% of 300 is 75. So the answer is 75. Okay. Yes, very good. So I hope it is clear to all of you. Chalo. Now, the question in recent ionicity from this topic was, when we talk about quartile, quartile means 4 equal part. When we talk about percentile, percentile means 100 equal part. Or when we talk about outliers, outliers means very big value, extreme value, बड़ी बेकार बाहर की value को outlier कहते हैं. So question was quartile, percentile, outliers, what do they tell about data? ये बताते क्या हैं डेटा के बारे में? What do they tell about data? Question option A. Do they tell about position or location of value? क्या ये बताते हैं कि हमारा डेटा कहां पर है? Do they tell about position or location of value? Do they tell about central tendency? कि डेटा के बीच में क्या है? Do they, what is in the middle of the data? That is central tendency. Do they tell about dispersion of data? डेटा फैला कितना है इसके बारे में बताते हैं. और do they tell about quality of data? कि डेटा की क्वालिटी कैसी है ये बताते हैं. चलो, do give me the answer of this new question came in recent INICT, which can be repeated again also. Okay. So अभी हमने पढ़ा कि क्वालिटी ऑफ डेटा कौन बताता है? Who tell about quality of data? That is coefficient of variance. So quality is by coefficient of variance. This cannot be correct answer. Then who tell about central tendency? Central tendency बताते हैं 3 चीज, mean, median, mode. These 3 things tell about central tendency. Then dispersion of data कौन बताते हैं? Most of you student are answering that quartile, percentile are answering dispersion, है ना? Dr. Parul, Dr. Musaddiq, Dr. Dibake, Toluddin Blue, you all are replying. Thank you for being active in this group and replying. And most of the students are answering dispersion. But dispersion का मतलब होता है कि डेटा फैला कितना. Dispersion tell how much spread is the data. And the spread of data is detected by 5 things. One is range, upper limit to lower limit. Second is mean deviation. Mean deviation is almost same thing as standard deviation. Third is variance. Variance is standard deviation square. Remember, we just read. Then fourth is standard deviation, and 5 is standard error. 5 things tell about dispersion. Remember them separately. Mean, median, mode tell about central tendency. And quartile, percentile, outlier, they tell about position of data, location of the value. अभी तो हमने बात करी कि first quartile means the value is at 25%. Third quartile means the value is at 75%. So it is telling us position of that value, कि where the value lie. Okay. And how do we identify outlier? Outlier is something which is identified by box and whisker plot. Box and whisker plot help us to identify outlier. This is the box and this is the tail of the box. Tail of the box is whisker. Box is between 25% to 75%, and any data which is very far away outside the whisker, we call this data which are outside the whisker, this data is outlier. For example, in every 2-3 years they do a survey in UK that how many sexual partner you have lifelong. So answer usually came 2 to 7 sexual partner lifelong. But in the same UK population, some hunter have this data that we have 699 sexual partner, 598 partners. So क्या उन शिकारियों का डेटा आम जनता के डेटा में इंक्लूड करना चाहिए? Should we include those hunters data of 596 and all in the normal population data? Of course not. Because if you include their data in normal population will think everyone is doing, I am not doing, and they will feel depressed. And also this type of extreme value are outlier. Who identify outlier? Box and whisker plot. And what does outlier is telling us again? Outlier means it is telling the position of the value is far away. So outlier, percentile, quartile, they all tell about position or location of value. Okay, I hope you will remember it. Chalo, now let's come to the question which we were discussing here. The question which was covered was Quintanilhac fever is transmitted by which of the following? Do remember, my friend, there is a very common fever, Q fever, which is transmitted by air. Q fever is caused by कॉक्सीलिया बर्नीटी. कॉक्सीलिया बर्नीटी. तो मैं अपने एमबीबीएस में इसको ऐसे याद करता था, नेटी का मतलब भोजपुरी में होता है गला. क्यों पकड़ा गला? और ऐसे याद करता था, हवा चली, मूड बदला, पकड़ लिया. तो एयर इज ट्रांसमिटिंग कॉक्सीलिया बर्नीटी क्यू फीवर. QY, you hold neck. So just air blow and I hold neck like that. I used to remember it. Okay. So air transmit Q fever, but not Quintanilhac. Quintanilhac fever is the other name of trench fever. Why? Because trench fever is caused by Bartonella quintana. And this trench fever is transmitted by, who transmit trench fever? Louse. Remember the mnemonic PUT. P for pediculosis, E for epidemic typhus, big one, epidemic typhus. Relapsing fever, trench fever. So these four disease is transmitted by louse. And if you remember, in our childhood day, when you used to take out the juu ya dheel nikalte the, when you used to take out the lice and used to kill it, it produces a sound of pat. So the mnemonic is also pat. Pediculosis, epidemic typhus by Prowazaki. Relapsing fever and trench fever. Trench fever is known as Quintanilhac fever. So here, who transmit Quintanilhac fever? It is louse. Okay. Now, the next question was on which type of test we apply. So, option is something which I hope you already know. Is it pair t-test, unpaired t-test, chi-square or ANOVA? The question is, a study was done to assess the malnutrition among young children. 100 children were selected, each from rural area and urban area. Out of these, 30 among rural and 20 among urban were found to be malnourished. So which test you will apply here? Will you apply pair t-test? This is a question which I am expecting in your recent MCI exam, upcoming exam, because 2 questions has came from this topic in NEET 2024 already. So will you apply pair t-test? Will you apply unpaired t-test? Will you apply ANOVA? Or will you apply chi-square? Which you will apply and why? What is the logic? So I have discussed this topic many times in most of my session, but I think we should keep revising this topic because it's an expected topic. So to decide the test, पहला पॉइंट क्या है, आपको बहुत आसानी से पता चल जाएगा. आपको बस ये देखना है कि क्या किसी बीमारी की बात हो रही है क्वेश्चन में, या क्या क्वेश्चन में कहीं पर उन्होंने मीडियन या मोड लिख दिया है, या क्वेश्चन में उन्होंने कहीं पे परसेंटेज या प्रोपोर्शन लिख दिया है, या क्वेश्चन में वो किसी भी ऐसी चीज की बात कर रहे हैं जो कैटेगरी में बांटी जा सकती है. जैसे मोटापा, मोटापा बीमारी भी है और कैटेगरी में बांट सकते हो, कम मोटा, छोटा मोटा, फटने वाला है. तो अगर इसमें से कोई भी एक चीज आपको मिल गई क्वेश्चन में, बीमारी कैटेगरी, परसेंटेज, प्रोपोर्शन, मीडियन मोड, सीधे सीधे आप आंसर दे दोगे chi-square टेस्ट. You will answer such question as chi-square test if there is two or more group of data. Which type of data? Data of any disease. Let's say they are talking about hypertension. You cannot measure hypertension. You can measure BP. So BP is quantitative, measurable. Weight and BMI is measurable, but you cannot measure my obesity and say, sir, you are 2.9 obese. So obesity is category, it's not measurable. Similarly, hypertension is category, not measurable. So whenever they talk about disease like hypertension, obesity and all, answer will be chi-square. But if they talk about quantitative data which you can measure, we call quantitative as continuous, and we call categorical as qualitative. They ask many times, this data is quantitative or qualitative. Okay, so you have to understand this. Like, tell me one thing, cholesterol, is it quantitative or is it qualitative? Cholesterol, do answer it in the chat box. Cholesterol is which category? So if they talk about BP, height, HB, anemia, anemia is the disease. Anemia will be categorical, answer will be chi-square. But if they talk about hemoglobin, blood sugar, these are measurable, quantitative. And in the quantitative or continuous, if in the question they have used the word pre-post, before giving drug, after giving drug, or match data, if any of these three words is there, answer will become paired t-test. Simple. Paired t-test. Now, second point is, if they are talking about quantitative and there is two group of data, then we will apply unpaired t-test. And unpaired is also known as student t-test. Okay. If they apply three or more group, then we will apply ANOVA, analysis of variance. Simple. So in case of quantitative, there can be pre-post paired, two or more unpaired, three or more ANOVA. But if it is categorical, answer is mostly chi-square only. Now you have to decide in this question which type of variable they are using. Is it quantitative or qualitative? So see, first thing they are saying rural, urban are two groups. So there is two group, rural and urban. Now they are saying in the rural group, 20 are malnourished, and in the urban group, 30 are malnourished, like that, something. So malnourished, can you measure malnourished? Can you say that this child is 1.8 malnourished? No. You can say severe malnourished, moderate malnourished, no malnourished. So it's just category. Malnourished is a disease. It's a category. Bimari ki baat aayi, disease category. What is the answer? Chi-square. So answer will be chi-square based on this logic. I hope the logic is clear to you. And if you need more question on this topic, or if you still not clear with this topic, feel free and ask it, my dear friend. Don't hesitate. Because some of you were answering ANOVA. Ubaid Khan is saying, sir, your way of teaching is good. Thank you, Ubaid Khan. Shukriya. But my dear friend, if you have any doubt, feel free to write. Nisa Panda, Dr. Mistro, Parul Patel, all of them have answered it correct, that it is chi-square because malnourished is a quantitative data. But let me make you practice this question. Two question I will like to give you. The question is ki, okay, suppose I am asking BP of, I'm just searching for some, yeah. I am asking, let's say, BP of two group of patient compared before and after giving drug. After giving, let's say, le beta lol, mere beta le lol, le beta lol. Which test which test will compare it? Is it paired, unpaired, chi-square or ANOVA? Answer it. Two group of patient compared before after giving labetalol. Very good. All of you correctly and fastly answered. It's paired. But you can see it is two group also written. Two group goes in unpaired also. And two group can also go in chi-square. So first thing you have found is they are measuring BP. BP is which type of data? Quantitative measurable. Second thing you are sure is they have used the word before after. And whenever they use before after pre post or match word, answer become pair t test. Very good. If I ask the question just like this, BP of two group compared only after giving drug, not before after, only after giving drug, if I say. So if it is only after giving drug, not before after, then answer will become unpaired t test. Okay. And if they say BP of three group is compared only after, three group or four group is compared after giving drug only, then it will become ANOVA. Now, in the same question, if I say कि percentage of hypertension people, percentage of hypertensive people in two group compared after giving drug, hypertensive people in two group. So this time one hint is percentage word, second hint is hypertensive people. Hypertension is a disease, percentage they have written. So this time you will apply chi-square test. So the same question of BP, all four can become the answer. And I am sure you must be clear with this example that in which condition which test is applied. Okay, very good. Chalo, now let's move to do some more new questions. One new question which has came in previous year that we are discussing. One question is, what is lead time definition? What is lead time? So lead time is the diagnose point where between diagnostic test and screening test. This is lead time. Time between diagnostic test and screening test is lead time. For example, they have given this good question in one of the MCI exam already, that if this is the point of entry of pathogen, okay, and suppose this is point A, this point B is the point when you can do early screening test or early detection. You can do earliest detection is possible only here. Earliest, you cannot detect before it. Then C is the point when cancer start spreading. This is critical point of spread of cancer. Okay. And D is the point where you can do confirmatory test. For example, if it is colon cancer, you can do colonoscopy with biopsy. And E is the point when the patient death. So in this story, which time is lead time? This is my question. What is lead time in this story? Is the lead time is option A, between A to B is lead time, or is it B, between B to C is lead time, or is it C, between B to D is it lead time, or is it E, between C to D it is lead time? So what is the lead time here? What is the lead time? Very good. Nisha Panda, Jay Saxena, Tollywood Blue, all are saying B to D because this is the definition of lead time. Lead time is the gap between early detection to usual diagnostic test. Early detection to usual diagnostic test is lead time B to D. Now, when this question came in MCI exam August 2020, the question was, what is B to C? What can you tell about B to C? What is this time B to C? B to C is the, can you tell me the answer? What is B to C? It is the screening test time. Because we cannot do a screening test before early detection, and there is no point of doing a screening test after the cancer has spread. After C, there is no point of doing a screening test, and before B, we cannot do a screening test, because between A to B, the pathogen is hidden. So A to B is the latent period. When it is hidden is A to B. B to C is the screening test time. And C to D is nothing. C to D is just part of lead time. Okay. And in this story, you can see, before the cancer is spreading, we can do a screening test and we can save the patient, because our screening test is done before spread. So in this story, lead time is useful. We can use the lead time to prolong life of the patient. Lead time is useful. And because lead time is useful, so lead time is not a mistake. Lead time bias is absent. क्योंकि इस कहानी में हम लीड टाइम है हमारा बी टू डी, और उसमें बी टू सी के बीच में हम कुछ सर्जरी वगैरह करके कैंसर फैलने से पहले बचा सकते हैं जान. तो ये जो लीड टाइम है वो पूरा का पूरा बेकार नहीं है, बी टू सी काम का है. और अगर लीड टाइम काम का होता है तो लीड टाइम बायस नहीं कहलाता है, लीड टाइम बायस एब्सेंट होता है, क्योंकि वो लीड टाइम काम का है. तो आई होप यू अंडरस्टैंड दिस लीड टाइम बायस कंसेप्ट एंड लीड टाइम कंसेप्ट, स्क्रीनिंग टेस्ट टाइम कंसेप्ट ऑल्सो. इफ इट इज नॉट क्लियर, फील फ्री एंड आस्क इट. चलो, वेरी गुड. नाउ let me give you one more question on this topic. The question was something like this, ki they put point A as entry, B as A to B they have written pre-pathogenesis. Okay, and then B is there yes, antibody detected at B. Pre-pathogenesis there, antibody. They are just asking A is pre-pathogenesis, B to C is pathogenesis, and C to D is post-pathogenesis. Okay. The question is, when do clinical symptom appear? When do clinical symptom appear? Option A, before B, after B, between A to B, or after C. When do clinical symptom appear, like that they ask. And this B to C whole part is pathogenesis, and A to B whole part is pre-pathogenesis, and C to D, this whole C to D is post-pathogenesis. So when do clinical symptom appear? After C or after B or after A, like that they will ask. Of course, clinical symptom will appear when the pathogenesis period is there. So clinical symptom will appear after B. After B, because now the symptom is there. So after B, clinical symptom will appear. I hope it is clear. And in the pathogenesis phase, we do secondary level of prevention, and secondary level means early diagnosis and treatment. Early diagnosis and treatment. And that is why if you are doing any screening test, all screening test is something which come under secondary level of prevention. All screening tests are secondary. They ask this question again and again. A son took his hemiparesis father for physiotherapy. So because the father is going for physiotherapy, physiotherapy is post pathogenesis, physiotherapy is tertiary. So answer will become tertiary level or rehabilitation. But if the same son took the father for checkup after hemiparesis, checkup means screening test, it will be secondary. If I took BP of you people, tell me, BP of healthy medical student, which level of prevention will be this? Healthy medical student, BP. Is it primordial, primary, secondary, tertiary? BP of a healthy medical student who comes to me without any diagnosis. Is it primordial, primary, secondary, tertiary? BP of a healthy medical student. Very good. Very good. Some of you are confusing also. Keep confusing. That confusion in the class is a good thing. It helps you in building good concept. When we talk about pre-pathogenesis, in the pre-pathogenesis, there can be primordial or primary. What is the difference between primordial and primary? I hope you all know. Primordial we do before risk. जैसे देखो, अगर कोई क्लास में कॉन्डम पहन के बैठा है अभी, सेक्स करेगा वो डेफिनेटली पीएसएम क्लास के बाद ही करेगा. कोई पीएसएम क्लास सुनते सुनते तो मूड बना के सेक्स करेगा नहीं. तो सेक्स से पहले ही कॉन्डम पहन के बैठ गया, वो प्राइमोडियल है. And if someone is wearing condom in the class, that is primordial, because no one is going to do sex in the class, so it is primordial. If someone is preparing for MCI exam from first year, that is primordial, because the risk is not yet present. But if someone is preparing for MCI exam after clearing 5 years of MBBS, that is primary, because now the exam is there, now the risk is there. And if someone is wearing condom before sex, that is primary, because in primary risk is present. In both primordial, primary, of course, disease is absent. Primordial, risk is also absent. Risk is in future, not in present. Okay. So now this is the point, man. Of course, this example should be such weird example that it is stuck in your mind. Condom in the class is primordial. Condom after the class, before sex, is primary. And then putting condom on a ultrasound probe and detecting early pregnancy, because till 12 week it has not gone before pubic bone. So if you are putting the condom over ultrasound and doing the ultrasound of a newly pregnant mother, that is secondary, because it's screening test. Okay. I hope you will answer it correctly in the exam also. So what is BP of healthy medical student? Some of you are giving answer as BP of healthy medical student. Some of you are answering as primordial, primary. Some of you are answering secondary. No matter whose BP I will take, BP is always secondary, because BP is under a screening test. Even if I am taking healthy adult BP, why I am taking your BP? For early diagnosis of hidden hypertension. आपका BP भी ले रहा हूं जो हेल्दी हैं, तो छुपे हुए बीमारी का पता लगाने का, जल्दी पता लगाने का, और जल्दी पता लगाना, इलाज करना को सेकेंडरी कहते हैं. तो जितना भी स्क्रीनिंग टेस्ट होगा, किसी का भी बीपी लूंगा मैं, सब सेकेंडरी होगा. 5 साल के बच्चे का, पैदा होते हुए बच्चे का बीपी लूंगा तो भी सेकेंडरी होगा. Even if I am taking BP of a newly born child, it will be secondary, because all BP screening test is for early diagnosis, and early diagnosis come under secondary. Okay. So I hope you will not be confused here and you will remember it. Yes, very good. Chalo. No, class, why the class need headphone? Some person are saying you condom. If I was taking one session with one of my friend, and in a live session he took out condom from the pocket, and his father was there in the chat box. Guess what his father written in the chat box? I am proud on you, my son. Yeah, because if you are using condom, you're talking about it, it means you are a scientific person. You are applying the knowledge which you learned in the class in your life. So it's a good thing, it's a scientific thing. And I personally think PSM department name should be changed to condom department. It's such an important part. Prevention is better than cure. Who said it? Charak. It's the main thing we have to know. Okay, chalo. Now let's come to discuss this one question which was not discussed here. Yes, lead time is discussed. This question. More false positive cases in screening test. Make the test more specific, more sensitive, less sensitive, more specific, and more sensitive. Which is correct answer? More false positive. What? How does it will make the answer? So let me give you a very simple example to answer this question. In NEET exam for last 2 years, what is the cutoff in NEET PG? NEET PG cutoff is reduced to 0%. Do you know it? 0 percentile is NEET PG cutoff. NEET PG, which is the diagnostic confirmatory test, has 0 cutoff, and MCI exam has 50% cutoff, which is a screening test. Ideally, it should be the opposite way, but anyway. So when the cutoff becomes 0 percentile, what happened was a student got minus 12 marks and he got radiology branch. Okay. Even his guess did not work. तुक्का भी नहीं लगा था भाई का और रेडियो मिल गया. So this type of student who got minus 12 and radiology, he got a positive result for sure. He must have given party after getting that branch, positive result. But is he a true positive student or is it a false positive student? क्या वो पढ़ के पास हुआ या बिना पढ़े पास हुआ? Of course, he is a false positive student. False positive. He passed without studying. So, I hope you will understand this topic from the simple example. When I lower cutoff to 0 percentile, lowering cutoff means more student will pass, and the more you include, more sensitive the test become. So when cutoff is reduced, test become more sensitive. Remember, test become more sensitive. जैसे समझो ना, अगर शुगर का कट ऑफ, फास्टिंग शुगर का कट ऑफ 126 की जगह हम 90 कर दें, तो आप लोग भी आ जाएंगे पॉजिटिव. ज्यादा लोग इंक्लूड हो जाएंगे. ज्यादा लोग इंक्लूड हो गए तो सेंसिटिव हो गया, और आप लोग भी पॉजिटिव आ गए. आप लोग किस टाइप के पॉजिटिव हो? क्या आपको शुगर है? नहीं. फिर भी आप पॉजिटिव आ गए, तो कैसे पॉजिटिव हो? फॉल्स पॉजिटिव हो. क्यों आए फॉल्स पॉजिटिव ज्यादा? क्योंकि हमने कट ऑफ को कम कर दिया, ज्यादा लोग इंक्लूड हो गए, सेंसिटिविटी बढ़ गई, और जो लोग इंक्लूड हुए उसमें से वो लोग इंक्लूड हो गए जो जिनको शुगर था ही नहीं, या वो लोग पास हो गए जिन्होंने कुछ पढ़ा ही नहीं था. तो डू रिमेंबर, व्हेन यू रिड्यूस कट ऑफ रिड्यूस, टेस्ट विल इंक्लूड मोर पीपल, सेंसिटिविटी विल इंक्रीज. सेंसिटिविटी बढ़ेगी when cutoff is reduced, and if cutoff is reduced, बिना पढ़े लोग ज्यादा पास हो जाएंगे. If cutoff will be reduced, false positive increase, sensitivity also increase. That means sensitivity is directly proportional to false positive because they both are increasing. I hope it is clear. जब भी हम कट ऑफ कम करते हैं, ज्यादा लोग इंक्लूड होते हैं, सेंसिटिविटी बढ़ती है, उसमें से वो लोग इंक्लूड हो जाते हैं जो एक्चुअल में बीमार नहीं है या एक्चुअल में पढ़ लिख के नहीं पास हुए हैं. फॉल्स पॉजिटिव बढ़ जाता है, क्योंकि दोनों बढ़ता है, इसलिए दोनों डायरेक्टली प्रोपोर्शनल है. What I was saying in Hindi was, when you reduce cutoff, more people included, sensitivity increases, and many of them are false positive. So that also increases because both are increasing, sensitivity and false positivity. So we can say that more false positive means more sensitive. Okay, I hope you will remember. Second question they can ask is, what do you mean by more prevalence? अगर ज्यादा लोग बीमार हुए तो क्या हुआ? More prevalence means more positive predictive value, more PPV. Because PPV and prevalence are directly proportional, false positive and sensitivity are directly proportional. Of course, sensitivity is also directly proportional to true positive. but it is also directly proportional to false positive. Okay, proportional to both. Achha, sometimes they ask you to remember the formula of sensitivity specificity and do some numerical on it. And under exam pressure, we get confused, but there is no point of confusion. I hope you all know sensitivity formula have true positive in the numerator. You just remember true positive. In the denominator, you will write true positive and just opposite of that. What is opposite of true? False. What is opposite of positive? Negative. So you will write true positive by true positive and just opposite of true positive, false negative. Like that, you can always remember it. And you can multiply it with 100 if you want answer in percentage, but it's not compulsory to multiply. Similarly, many a time in 2 NEET exam, they ask you just to know the formula of specificity. But we get confused, but it's no confusion, same logic. Just remember true negative. And in the denominator, there will be again true negative and just opposite of that. What is opposite of true? False. What is opposite of negative? Positive. So true negative and true negative plus false positive is specificity. True positive and just opposite of true positive, false negative will be sensitivity. PPV, I hope you all know, PPV has everything positive. True positive by true positive plus false positive. And NPV has everything negative. True negative by true negative plus false negative is negative predictive value, NPV. So do remember these 4 formula. Yes, many of you already remembered it and answer such question very well. Chalo. Next question is, this plot which you are seeing here, this is which plot? Can you see a funnel like a structure here? If I draw this thing like this, it's a reverse funnel. So this plot is known as funnel plot. And there are 2 plot, funnel plot and forest plot. Both of them are drawn in meta-analysis. If they ask which study have strongest evidence, कौन सी स्टडी का एविडेंस सबसे स्ट्रांग होता है, आंसर होगा मेटा एनालिसिस. इट हैज स्ट्रॉन्गेस्ट एविडेंस, बेस्ट स्टडी. व्हाई इट इज बेस्ट स्टडी? बिकॉज मेटा एनालिसिस के अंदर हम एक टॉपिक पे जितनी भी स्टडी हुई हैं सबके डेटा को कंबाइन करते हैं, तब कहते हैं मेटा एनालिसिस, नॉट मोटा, मेटा एनालिसिस. When we combine all study done on one topic, then we get meta analysis. So because it is by combining many studies, so it is the best study. Okay, and when you combine various study, the combined result is represented by funnel plot, forest plot. This is funnel plot. Forest plot will look something like this. There will be central line with odds ratio equal to 1. And I hope you know odds ratio या relative risk equal to 1 means no association. So there will be one line in the center with no association. Then they will draw some other lines, like first line here, second line here, third line here, fourth line here, fifth line here, sixth line is not given. And after giving this image, they will ask the question कि how many study so negative association. How many studies show negative association? Negative कितनी स्टडी बता रही है? How many show negative association? or protective association? Or they can ask how many show positive association or causative association? So देखो, it's very simple. I hope you can answer it. How many are showing negative association out of the 5 study? 1, 2, 3, 4, 5. How many are showing negative association? Very good. See, any study which is less than 1 is negative association. Like here it can be 0.5 to 0.8, 0.5 to 0.8. If odds ratio is less than 1 or relative risk is less than 1 means protective association or negative association. So very good, my dear friend. DRX, who first replied it, that odds ratio, if it is less than 1, then it is showing negative association, and there are 2 studies which show negative association. There is one study from 1.1 to 1.5 here. This is more than odds ratio 1. So this is showing positive, and positive is also known as causative. So this is showing causative association. Okay. So causative or positive is only one study. Negative association or protective association is two study. Very good. You were correct in answering. Two studies show negative association. And if you look at study number 2 and 4, these two study, one here and one here, they are crossing this odds ratio of 1. If you cross it, it means these two studies show no association. So this is an image based question which has already been asked in NEET and INICT, and I am expecting it in your next MCI, this upcoming MCI exam. They will give an image based question. How many say negative association they will ask, or how many show positive association they will ask. Positive are not crossing this line 1, and in this direction more than 1. Negative are less than 1 and not touching line 1. If they touch this central line, these studies are useless because they have odds ratio of 1. Okay, is this topic clear to you or not? Let me reply. Okay, some person is saying ki go with the workbook, you have joined the session late. Workbook I will revise separately because the printing part is not good and I should have checked it. It's my problem, it's my fault here. I should have checked it early before the class by putting it here, but I didn't did it. So I will take a separate session of the workbook. On the last day when the session of FMG marathon will end, I will take on the last day separate FMG session of 4 hours when I will revise the workbook. Don't worry, follow this type of question because in workbook, mostly we already know the things, we just revise it and we think we know it all. It gives us happy feeling. But when you do questions like this, then you realize that, oh, we have to know so many new things also. So doing question is something which is, I think, more beneficial in this last time rather than reading the same theory again and again. Because in exam, they are asking theory or question. In exam, they ask questions, objective question. So that's my two request. Every time I take any session, I make two requests. First request, I know this is a FMG exam, but please do 5-year NEET PG and do their 2-3 revision with topic. If you do this, your marks will increase by 30 to 40 just by doing this 5-year of NEET PG, minimum 5 year. And I say 5 year, but again and again a student do 2-3 year. And they said कि सर किया था हमने NEET PG, कितना साल? 2 साल. 2 साल को नहीं कहते हैं किया था मतलब 5 साल. 5 year has only 1000 question. If you are practicing 200 per day only, in 5 days you can do it. Please do it because the language, real language come only in NEET recall, not in FMG recall. Second request I do is in last 20 to 30 day which you have, 20 or 25 day which you have, at least in this 20 to 25 day, at least 20 day practice 300 question at home. And this 300 question which you practice, if it is previous year question, it's better. Because if an examiner has to create question, I am already overburdened with my children, with my wife, and I don't have time to create new question. So what I will do as an examiner, I will not buy some app and take the subscription. Na? I will take some previous year, change their language and put it. So if you do 5 to 7 year of NEET, minimum 5 year, 5 to 7 year is what I request. And in that, when will you practice it? In this 300 question, practice this NEET question. And in the last 20 day, practice 300 question at your home at same time when exam occur. Because I have heard this complaint with many students that, sir, till 50-100 question my mind was working well, then it all become foggy, cloudy, nothing was clear. Because at your room you have not done 300 in one go. You have given GT from 9 AM to 10 PM. It's not the correct way actually. Na? You have to give it, and giving 1 GT per week will not make that practice good. And do not give too many GT, because in GT I have seen that if one time marks become low, you become depressed. And GT papers are usually prepared by students, not by teacher. Teacher don't have time to prepare GT papers. So GT paper do not come in exam. PYQ come in exam. That's why do 5 year of NEET PYQ, and in remaining 20 day, please practice 300 question at your home at the same time as exam, and you will definitely clear with more than 160-70 marks if you do this two thing only. Please do this two thing, okay? Now, come, let's discuss this one more question here. Incorrectly rejecting null hypothesis. What is when it is true? Incorrectly rejecting null hypothesis when it is true is known as confounding bias, type 1 or type 2 error. Type 1 error is alpha error. Type 2 error is beta error. And one thing you always have to remember is alpha error and p value, they have almost the same meaning. अल्फा एरर और पी वैल्यू दोनों का मतलब होता है फॉल्स पॉजिटिव. बोथ मीन्स when you try to act over smart, say a useless thing as useful, that is alpha error. When you give a false positive result, that is alpha error. So let me give a very good example why this question, incorrectly rejecting null hypothesis, what does this mean? If you know the answer to this question, please do reply, my friend. Yeah, YY has replied also. Let's say Dr. YY came to me with his stethoscope in his hand, and he put his stethoscope on my stomach and said, "Congratulations, you are pregnant." Actually, at the same time when he put his stethoscope, my intestine had this gurgling sound, and he thought I am pregnant. So what is happening here? Which type of report Dr. YY is giving me? False positive. So which error he is doing? Alpha error, type 1 error. Now what is happening here is, in my case, my stomach is just a normal stomach. माँ कसम मैं pregnant नहीं हूँ. I'm not actually pregnant. It's just a normal stomach. So actually my stomach is null. Actually null hypothesis is true. I am not pregnant. Null hypothesis is true. But what Dr. YY did? He came to me, and this null hypothesis which is true, he rejected it. So null hypothesis is true, but Dr. YY rejected him, this null hypothesis, and forcefully make me pregnant. Forcefully gave me a positive pregnancy test. So he gave a false positive report by rejecting null hypothesis. So what is happening here? Dr. YY is incorrectly rejecting null hypothesis. Actually my stomach was null. He should not have rejected it. He should have said that it is null. But he wrongly rejected null hypothesis. When actually null hypothesis is true, he still rejected it and gave a false positive report. So which type of error is happening? Type 1 error or alpha error. Do remember this line. Incorrectly rejecting null hypothesis is alpha error, type 1 error. Okay? Chalo, Dr. DRX also gave the correct answer. Type 1 error. Chalo, next question. If you want to represent secular trend, for secular trend, which diagram you will use? Line diagram, bar graph, box and whisker, stem and leaf plot. Which plot we will use for secular trend? Can you reply? Secular trend. Which diagram for secular trend? What is secular trend? And this is the same thing which we use for sometime in politics also. This is a secular leader. This is a communal leader. What do you mean by that? Secular trend. See, a leader is secular when he is equal to all religion, and not just before election but also after election. For a long time someone is equal, that is secular. So similarly, secular trend means all those diseases which are constantly increasing or constantly decreasing in the world. For example, this cardiovascular disease, hypertension, diabetes, these all are constantly increasing from 1950 till 2025. This is constantly increasing in the world. So all this cardiovascular disease, hypertension, diabetes, these are example of which trend? Secular trend. And do remember this one line, that whenever you want to represent trend of event, trend of any event is represented by line diagram. So who represents secular trend also? Line diagram. So that's simple answer. And do remember, again and again they ask the example of secular trend. It's cardiovascular disease, which is example of secular trend. This is line diagram. So next question is, okay, they have given the image here and they ask, what is this statistical diagram shown here? Is it a multiple bar chart or is it a histogram? Only two options I am giving you. Is it multiple bar chart or histogram? So do reply, A or B. What is the answer? Okay, Dr. Ayushi and Bajigar has answered it's histogram. Why not multiple bar? Because if it is multiple bar, first of all, it will start with a gap. Then after fixed number of bar, let's say 3 bars, there is again gap. Then there is again 3 bar. Then again gap. Then there is again 3 bar. So this is multiple bar. Multiple bar will have gap again and again, and it will always start with a break also, start with a gap also. And for example, if I am talking about road accident cases, percentage road accident cases in different month in 3 states. And it is in Delhi, let's say we are talking about Delhi, UP and Tamil Nadu, and we are talking about corona cases percentage in these 3 years, or we are talking about, let's say, road accident cases here. So if road accident cases January, February, March is like that, January, February, March, this saying that the trend of diseases they are telling. January, February, March, or this month and all those things they are using for Delhi, UP, Tamil Nadu. Delhi, UP, Tamil Nadu are just name, just category, and percentage is also. So this is categorical data, qualitative data for which we use bar chart. So this is bar chart. And this is very good. You all were correct. It's histogram. Why? Because in histogram, gap can come anywhere. It's not after fixed number of bar that gap can come. Plus they are talking about age and frequency. Both are measurable, quantitative. And for quantitative data, we use histogram. So here it is histogram. They are just saying that between 80 to 90, no case was reported. But it's not representing a true gap. Okay, so it's a histogram. Multiple bar will be different. And I hope you all know what is component bar. In component bar, one above another, there will be different color like this. One yellow, then white. This is component bar. Okay, component bar. Chalo. Next question is, a researcher undertake follow-up study for a certain time period duration and tell that people increasingly develop the disease with time. With time, more people are becoming patient. This is known as incidence rate. With time, more people develop it. That is incidence rate. What is incidence rate? It's simply new cases divided by how many people develop it for how many person multiplied by how many time. So if you have any question with time written, new cases and time, this is incidence rate. New cases with person time is incidence rate. What is cumulative incidence? Cumulative incidence is same as incidence. And cumulative incidence or incidence means total new case divided by total population at risk, total susceptible population. How many people can develop the infection? That is the population at risk. And how do you find total population at risk? Total population at risk means you will write the population. From that, you will subtract those who are already suffering, already disease. You will subtract. Because जिसको पहले से ही बीमारी है, क्या वो दोबारा से बीमार होगा? नहीं ना. तो वो रिस्क में नहीं है. क्योंकि वो रिस्क में नहीं है, इसलिए हम उसको माइनस कर रहे हैं. या फिर जिसको जो इम्यूनाइज्ड है, जिसको वैक्सीन या कुछ और तरीके से इम्यूनिटी आ चुकी है, तो क्योंकि इम्यूनिटी आ चुकी है, इम्यूनाइज्ड है, वो भी रिस्क में नहीं है, तो उसको भी हम माइनस करते हैं, है ना। इस ग्रुप में किसी ने बोला था कि इंसिडेंस प्रिविलेंस डिस्कस करिएगा, तो मैं इसको डिस्कस कर ले रहा हूं आपसे एक साथ, बिकॉज समवन हैज ऑलरेडी आस्क्ड, सो आई एम डिस्कसिंग इट इन मोर डिटेल. When we talk in, and new question has came on this topic in INICET also, when we talk about new cases, incidence is measured new cases by population at risk. Population at risk means population minus infected minus immunized, then it is population at risk. So how they ask new question in INICET from this topic? The new question was that out of 100 student, suppose 10 have HIV, okay, or some infection. If uh, if 20 new cases occurred this year, and I do not remember the exact data, but the concept, if you remember, you can easily answer. If 20 new cases occurred this year, incidence of HIV will be, what will be the incidence of HIV? Option A, will it be 20 by 100? Option B, will it be 10 by 100? Option C, will it be 10 by 90? Or option D, will it be 20 by 90? So what is the answer to this question? Do reply. And in the group, Kishore Hegde has a question. Sir, can we use multiple bar chart for quantitative comparisons? Usually we don't use it, but sometime we can convert the value. Like for example, if the value is age is measurable, you can measure age of anyone, and age become quantitative data. Age is quantitative, simple, because we can measure it. But suppose I do not write age in any study, rather than age, I put three category: 15 to 20 year, 20 to 25 year, 25 to 30 year. So now the same age which was a quantity now become qualitative data, because now it is categorical, it is into category. And when I converted age into category, now I can use multiple bar chart for this categorical data. Okay, so yes, you are right, sometime we can use multiple bar chart for qualitative also, but how we can use sometime we can use bar chart for age like quantitative data also. But when do we use it? When we first divide age into category. Like suppose I am talking about weight, so weight is quantitative, but if I write weight as less than 80, 80 to 100, 100 to 20, then it become categorical, and then we can use multiple bar chart there. Okay, so that's, I hope is clear. Dr. Kishore Hegde, good question. Now here answer is 20 by 90. Very good. My dear friend Bajigar and DRX has replied it very quickly. Why 20 by 90? Because new cases which occurred was 20. So new cases is 20. But in the total population of 100, 10 were already having the hepatitis HIV. So we will subtract 10 from 100. Only then we will get how many are at risk. क्योंकि 10 लोगों को तो पहले ही HIV हो चुकी थी, तो अब उनको क्या दोबारा थोड़ी होगा HIV? अब खोल के बिना कॉन्डम जितना मर्जी जो करो, है ना? So now because they are not at risk, we subtract those 10 people from 100. So denominator become 90, numerator is 20. It is 20 by 90, option D. Okay, chalo. Now next question. I hope it is clear. Plus, if you want to know about prevalence, do remember they have asked this question in MCI also, NEET also. Prevalence is incidence means new case into duration of disease. Sometimes they just ask the formula also. Okay. So in this formula, they ask two questions, conceptual question. First is, do remember, if they talk about any drug, with drug, incidence do not get affected. Incidence is always same. Now, the two type of question which I have also discussed in many session is, the first question they ask is that if a new drug does not cure patient but prevent death from it. Okay, but prevent death from it. For example, suppose our doctor friend Musaddiq Siddiqui bro find out a treatment for HIV. Just one drug you take and lifelong you will not die. And of course, HIV once happened, it will not cure HIV also. So it is not curing HIV, not letting them die. As a result, HIV patient will suffer for longer time. And if they will suffer for longer time, prevalence will increase. So what this drug will do? This drug will increase prevalence. Okay. Let me explain the same thing in Hindi. अगर मुसद्दिक भाई ने ऐसी दवा बनाई जिससे HIV के मरीज ना तो ठीक हो रहे हैं, ना तो क्योर हो रहे हैं और ना तो मर रहे हैं, तो जब ठीक भी नहीं होंगे, मरेंगे भी नहीं, तो लंबा सफर करेंगे, और लंबा सफर करेंगे तो फॉर्मूले के हिसाब से प्रिवलेंस बढ़ जाएगा. ठीक है. अब आप मान लो मुसद्दिक भाई ने ऐसी HIV की दवा निकाली जिसको खाते ही HIV क्योर हो गया, 1 हफ्ते में HIV ठीक कर दे रहा है ना. अब लोग डर ही नहीं रहे हैं, कॉन्डम कोई पहन ही नहीं रहा है, सब सेक्स कर रहे हैं, बोल रहे हैं मुसद्दिक भाई जिंदाबाद, है ना, कि कोई जरूरत ही नहीं है अब कॉन्डम की, है ना, कोई मतलब नहीं है, अब कोई डरना नहीं है ना. तो ऐसी दवा अगर खोज दी मुसद्दिक भाई ने जिससे HIV तुरंत ठीक हो जाएगा, तो ड्यूरेशन कम हो गया. ड्यूरेशन कम हो गया तो प्रिवलेंस कम हो गया, है ना. तो यहां पर प्रिवलेंस घटेगा. लेकिन एक ही बात सोच के बताओ, क्या दवाई बनने से नए केस कम होंगे? नए केस कम होंगे जब लोग कॉन्डम यूज करेंगे ज्यादा या मोनोगैमस रिलेशनशिप में रहेंगे, तब न्यू केस कम होंगे ना. तो न्यू केस का दवाई से फर्क नहीं है, सिर्फ प्रिवलेंस का दवाई पे फर्क पड़ता है. और अगर ऐसी दवाई है जिससे लोग ना मर रहे हैं ना ठीक हो रहे हैं, तो प्रिवलेंस बढ़ेगा. और अगर ऐसी दवाई है जिससे या तो तुरंत ठीक हो जा रहे हैं या तो मर जा रहे हैं, तो प्रिवलेंस घट जाएगा, क्योंकि ड्यूरेशन घटने से प्रिवलेंस घटता है. क्या ये कंसेप्ट सबको क्लियर है? इफ द ड्रग डू नॉट क्योर डिजीज and let them suffer longer, like this story, then prevalence will increase. But if it cure quickly, prevalence will decrease. Okay, chalo, I hope it is clear. Now next, if you have any doubt in any topic, feel free, you can ask it again and again. The next question is very good question, I have discussed it. Which of the following out of 1 2 3 4 which are measure of dispersion? So measure of dispersion, which are measure of dispersion? Standard deviation, range. Only two things are measure of dispersion: mode, median and mean. These three things, what do these three things tell? It's just a revision of the thing which we already discussed. Mean, median, mode, they talk about central tendency. They never talk about dispersion. Dispersion, first thing range, after range mean deviation, then after mean deviation there is variance, then standard deviation, standard error. 5 things tell about dispersion, not mode and median. Only 1 and 2 will tell. So correct answer is 1 and 2, they tell about dispersion. Okay, next question is based on Horrocks apparatus. What is the use of Horrocks apparatus? So in the chlorination, first step is we take some water from the well and we put it in 6 white tubes with a blue color indicator liquid in it. that liquid indicator is starch iodine. And if fourth tube change color, based on that we calculate how much bleaching powder we need to put, which will kill all the bacteria. So that means this much bleaching powder water is demanding, asking, give this much bleaching powder so that I can kill all bacteria. So this is the bleaching powder demand by water. Or bleaching powder releases which thing? Chlorine. So which thing is detected by Horrocks apparatus? Chlorine demand. What is chlorine demand? This was the question in actual MCI exam, that what does Horrocks apparatus detect? And one of the option was bleaching powder amount is detected by Horrocks apparatus needed to kill all bacteria. This is detected by Horrocks apparatus, that how much bleaching powder we will put which will kill all the bacteria. And which indicator is there in the Horrocks apparatus? The indicator is starch iodine. This is a blue color liquid. So this is the first step, that you put you put bleaching powder after detecting it with Horrocks apparatus. Image based question can also come. 6 white tubes and blue liquid, if you found, that is Horrocks apparatus. It detects how much bleaching powder we put, that will kill all the bacteria. So first step is done. After this first step, in the second step, we leave that bleaching powder for 1 hour. So this was the question in MCI, that what was the contact period? The contact period is 1 hour. In that 1 hour, bleaching powder will release different ion which will kill the bacteria. But the question they asked in NEET 2018 from this part was, which ion kill maximum bacteria? HOCl1 minus ion kill 85% bacteria. We call it hypochlorous ion. तो कैसे याद रखोगे? जिसमें रस है, juice है. Because the second ion is hypochlorite. And examiner think you will be confused in chlorus, chlorite. So best way to prevent confusion is don't read about chlorite. Just read chlorus. Chlorus, HOCl minus. That has maximum killing property. It will kill 85% of bacteria. Hypochlorous ion, HOCl minus. And after this 1 hour contact period, in the last step, we detect how much chlorine is left in the water. We detect residual chlorine. Residual chlorine should always be more than 0.5 or equal to it. And how we detect residual chlorine? To detect residual chlorine, we use the instrument chloroscope. Chloroscope we use. So this is the 3 step of chlorination. And this was the question in just 1 year back MCI exam, that what is the contact period duration? 1 hour. What is the residual chlorine concentration? 0.5. Okay. कम से कम 0.5 क्लोरीन पानी में हमेशा रहना चाहिए, वरना कोई भी अपना नया लोटा डेक्ची डालेगा और उससे इन्फेक्शन आ जाएगा. So minimum 0.5 should always be there, otherwise anyone will put their utensil and again infect the water. And this minimum chlorine, residual chlorine by chloroscope. First step was chlorine demand detection by which apparatus? Horrocks apparatus. And middle step, second step is contact period of 1 hour, in which hypochlorous ion will kill most of the bacteria. Okay. And do remember, in this chloroscope, there is 2 type of test. This has came in MCI exam 3 years back, and it one of the toughest question it was. That chloroscope can do orthotoluidine test or orthotoluidine arsenite test. And the question was that orthotoluidine detect free chlorine or combined chlorine. So remember, whether it's orthotoluidine or orthotoluidine arsenite, both detect both free and combined chlorine. Both detect free chlorine and combined chlorine both. फ्री कंबाइंड दोनों से डिटेक्ट होता है. तो अंतर क्या है? अंतर यह है कि ऑर्थोटोलिडीन उसको एक साथ पता लगा पाता है, अलग अलग नहीं. और ऑर्थोटोलिडीन उनको अलग अलग पता लगा के बता देता है कि कितना कंबाइंड क्लोरीन यानी हाइपोक्लोरस बाकी है, कितना बैक्टीरिया अभी भी पानी मार सकता है. अभी भी पानी में जो ब्लीचिंग पाउडर है वो कितना बैक्टीरिया मार सकता है. So orthotoluidine arsenite, remember they both detect both free and combined. Difference is orthotoluidine detected together, orthotoluidine arsenite detected separately. And if you detect it separately, you know how much is combined chlorine. Combined chlorine means hypochlorous ion. If you know how much is hypochlorous ion, you know how much killing action is left in the water. So that's why orthotoluidine arsenite is better, because it can detect them separately. Orthotoluidine detect it together. So these are the 3 steps of chlorination. I hope you will not forget it. Yes, FMG is asking again, सर आप कब लेने हो वाले हो क्लास नोट्स के साथ? तो I will tell you the date of the class with class note. I hope till what time is your FMG marathon session? Till what day? Last day. After the last day of FMG marathon session, I will take it. I think the last day is by 10th or by 20 or something. So on 21, I will take it. Okay. So after last day of FMG marathon session on YouTube. Okay. Because you have the marathon session going on. So I cannot disturb that session, of course. After last day of FMG marathon session, just after last day, whatever day it will be, I will take the session. Okay. So just after the last day, I don't know the last day, otherwise I would have, oh, last day is 13. So just after last day is 14th. So I will take it on 14th. On 14th, I will take it. Okay. It's not too far away. It's just 1 week away. Okay. So now let's come to the next question. What is the method of choice for purification of highly polluted water on large scale? Big pond is there with highly polluted water. Which step you will use? Answer is, we will do super chlorination and then we will do dechlorination. गंदा तालाब है तो एक ही बार बहुत ज्यादा ब्लीचिंग पाउडर डाल दो और उसके बाद क्लोरीन को धीरे धीरे कम होने दो, या तो इवोपरेट होकर के या कुछ केमिकल डाल के भी कम कर सकते हो. तो इसको कहते हैं सुपर क्लोरिनेशन, जो बहुत गंदे तालाब में किया जाता है. ओके, सुपर क्लोरिनेशन मींस पुटिंग टू मच क्लोरीन इन वेरी पॉल्यूटेड वाटर and then let it decrease by itself. So this is the method of purifying highly polluted water. Super chlorination followed by dechlorination. Okay. Next question. Which of the following is not a characteristic of causal association under Hill criteria of association? This is again in July session. They give a part clinical or tough question paper. So if they created it like that, then this question can be really useful. And this Hill criteria, they have already asked in NEET and NICT. If you know the answer, feel free to write the answer. What is Hill criteria of association? Hill said that correlation does not imply causation. अगर दो चीज साथ में हो रही है तो इसका मतलब ये नहीं है कि एक की वजह से दूसरा हो रहा है. If two things are happening together, it doesn't mean one is causing the other. For example, if let's say there is hot weather and your friend mood is off, you will think his mood is off due to hot weather, because these two things are happening together. These are correlated, but it doesn't really mean the same thing. Maybe he just had a breakup, or he just planned to have sex but was not able to do it. So he can have off mood due to many reasons. Two things which are together doesn't mean one is causing other. Like for example, Government of India say more vaccination decrease the cases of corona. But there were 5 countries in the world where 95% vaccination was there, still second wave came. China, America, UK, Seychelles, Israel. So that means vaccination did not lower the case. Two things happened together, but it doesn't mean one is causing other. So how will you know that one is causing the other? For that, Hill gave 9 factors as association. And you can remember all the 9 factors, but the question they ask from this part is, what is the most important criteria in Hill criteria of association? What is the most important criteria? So most important criteria is temporal association. What is temporal association means? Temporal association means natural history of disease. And whenever they ask this question, which study tell about temporal association the best? And because sometimes they ask which study tell natural history of disease best. So as soon as students see history word, they take case control tell about temporal association best. But no, here that is case control is not the answer. Temporal association means cause precede effect. परिणाम से पहले कारण, cause precede effect. And which study is known as cause precede effect, cause to effect? That is cohort study. So which study tell temporal association best? Temporal association is best told by or best detected by cohort study. Okay, are you understanding it? You have to remember it for sure. Best association is this temporal association. For example, let's say I am drinking this water. Why I am drinking water? Because you will say ki you are thirsty, so you drink water. You are taking the session and you are thirsty, drink water. This is cross-sectional observation. Present moment you thought it. But this is not the correct answer. If you have seen me taking classes in previous batches, whenever I teach this topic, I take water. So I am taking water. The real reason is to teach you this topic. And how can you know the real reason? If you have done follow-up. If you have attended my past class and this class, so you have done follow-up, then you know the real reason. And in which study we do follow-up? Cohort study. So only by cohort study, only by follow-up, you can know the real reason. Like, you understand the point. If a student or a batchmate is doing accident again and again, and you want to know the real reason, what is the reason which occurred before accident? What you have to do? Follow the person. Only then you can know the reality why the person is doing accident. So this is cohort study which tell it best, and it is most important. Hill most important criteria is temporal association. After this, the second criteria is strength of association. How strongly two things are associated. And this question they ask separately. They have already asked in PYQ separately. That which factor tell about strength of association best. तो दो चीजें आपस में जुड़ी हैं कि नहीं, इसको सबसे अच्छा बताता है रिलेटिव रिस्क. Relative risk tell best about strength of association. Why? Because relative risk talk directly. If you will smoke, chance of cancer is 9 times more. So it is telling strength directly, relative risk. And that's why relative risk is used by clinician, because clinician who are sitting in clinic, they like to talk directly. So second is strength. Third is specificity. Specificity, let me give you an example. They found that only in the coal tar chimney viper testicular cancers are occurring. टट्टों का कैंसर सिर्फ उनमें हो रहा है जो कोल टार चिमनी में झाड़ू लगा रहे हैं. So because testicular cancer is only in coal tar chimney viper, it is specific. Because it is specific, you can say that it is correlated. Coal tar chimney viper and testicular cancer is associated. For example, bladder cancer occur only in aniline dye industry factory worker. So that means aniline dye working and bladder cancer are associated. So specificity is the third criteria. Then other criteria are also there, like coherence is a criteria, biological plausibility is a criteria, but do remember sensitivity is not a criteria. Okay. So if you want to know all the criteria, I can summarize it with a very simple mnemonic. The mnemonic can help you in remembering all these criteria together. It is like STSC is a great political controversy for India. So if you want to remove this, you need to do some experiment and analogy. So these are the various things. Experiment study means RCT. Analogy means same result when done in different area. It is analogy. S stand for strength of association. T stand for temporal association. Two things we already discussed. Then this S is specificity. C is consistent or coherence. Coherence means pathology, pedia, PSM, all telling the same thing, that increased pollution in Delhi is causing asthma and all. So 2-3 things saying the same thing, that is coherence. Then we can say that okay, asthma and pollution is associated. And what is GPC? It is not GPL, है ना? GPC. GPC, first G is biological gradient. Like for example, when air pollution increases in Delhi, cases of asthma also increases. So there is a gradient. More cigarette lead to more chance of cancer. So gradient is there. Then there is biological plausibility. There is a biological explanation also now, that asthma can occur with infection, with air pollution. Cancer can occur with smoking. So there is biological explanation. Then we can say it is associated. And last C is consistency. If every year in winter cases of asthma is increasing after air pollution increases, then we can say air pollution and asthma is consistent. So these are the 9 criteria for Hill criteria of association. Remember again and again, most important is temporal association, and they do not have sensitivity as a criteria. Specificity is a criteria, but not sensitivity. So this is all about Hill criteria, which we just discussed. Okay, I hope it is clear. Now, next is, after Hill criteria, the question is about Factory Act. In the Factory Act, which one is correct? Of course, in the Factory Act, child less than 16 years cannot be employed. Is it correct or false? Option A, correct or false? Child less than 19 years cannot be employed. Maximum working hours should be 48 hours per week for adult. Working hours are 8 hours per day for children. So out of the 4, which one is correct? I hope you all can easily do this question. Minimum working age is not 16, it's 14 years. So both these are wrong. Maximum working hours should be 48 hours per week. This is correct, or should it be 60 hours? 60 hours per week is 60 hours per week. This is maximum working hour, including overtime. If you include 2 hours overtime, then it is 48 hours of normal work plus 2 hours into 6 days, 12 hours. So 48 plus 12, it will become 60 hours. When it is overtime word is given, then only overtime word is given, only then you will answer 60. If overtime word is not given in the question, then maximum hour is 48. So this is a controversial area. Do focus. Maximum is 48 per week. Maximum including overtime is 60. Similarly, if they ask maximum hour per day, Park has written maximum hour per day as 9 hours, not 8 hours, and it has used the word including 1 hour of break. So actually it's 8, but if asked in exam, better answer is 9. Then working hour are for children. Children below 14 years cannot work, but adolescent can work. And what is the working hour for adolescent? Adolescent age group is 10 to 19, but till 14 they cannot work. So adolescent is 15 to 19 years. They can work between 6 a.m. to 7 p.m. only, and they can only work in non-dangerous condition. Maximum 5 hours per day work they can do, and they can work only after surgical. Surgeon will give fitness, physical fitness, only then they will work. And surgeon physical fitness is needed. So my question is ki why we need physical fitness from surgeon? What I will do with my stamp of community medicine? Put it on my bum or what? They will ask it for surgeon because this adolescent might be engaged in lifting heavy weight. So surgeon will first check for hernia, then will allow them to work. Okay, so these are the three things about adolescent, do remember. Then in the Factory Act, this was the recent question, how much space for each worker? The space for each worker is 500 cubic feet. But they made it tough. They ask, okay, it's 500 cubic feet. And cubic feet means all around. So all the factory owner, they started making rooftop very high. And they say, see, there is 500 cubic feet space. So then government said, no, 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 no. 500 cubic feet, but only 14 feet above head counted. You cannot count all the space. You can only count 14 feet above head. And when we talk about space, let's also revise the space for students in a school health program. What is the space for a student? That is 10 square meter. Okay, meter or centimeter? 10 square centimeter. Cubic feet. 10 square feet. Sorry, 10 square feet. So 10 square feet is for student, 500 cubic feet is for worker. But do remember 14 feet above head. Then there is one more thing, safety welfare canteen. In the Factory Act, they have said that for every 1,000 worker, there will be a safety officer. Safety is the first thing because savdhani hati, durghatna ghati. Then W is for welfare. And one welfare officer is for 500 people. And then C is for canteen, most important. So canteen is for least people, 250. Mnemonic is southwest corner, SWC. Safety welfare canteen. Safety 1,000, welfare 500. Canteen is 250 only. Then one more thing in Factory Act is how much money is given by which people. So the money given by employer, manager is 3.75% of total. The workers will give 0.75 and they will give it 0.75 only if their salary is more than 15,000 per month. Because if it is less than 15,000, तो नंगा नहाएगा क्या, निचोड़ेगा क्या, how they will contribute in ESI. So only after more than 15,000 salary. Plus, who give more contribution, state government or central government? State government give 1/8. Central government gives 7/8. And similarly, they have asked the question about other program also, like Ayushman Bharat. Is it a program by central government or state government or both? Tell me. Do reply it in the chat box. Ayushman Bharat is funded by central government and state government both, or is it funded only by central government, or is it funded only by state government? Who give the fund for Ayushman Bharat? What is your answer? Who give the fund? Who give the fund? Who give the fund? Yes, 10 square feet. Very good, Parul and Harsita, for writing it. Oh, Cool Medico and Muhammad Saif Ali, they both replied central government. Ajad Ahmad also replied central government. And the correct answer is both central and state. That is why all the state government, without having BJP government like West Bengal and other Kerala and all, they say we will not implement Ayushman Bharat because people think it is only by center government, and actually we are also giving money. So we will give money and credit will go to BJP. That's why they deny it. It is not only by central government. 60-70% is by central government. Remaining is by state government, Ayushman Bharat. Okay. Plus, similarly, I just discussed ESI. ESI is also funded by both central and state government. Similarly, there is FSSAI, Food Safety Standard Authority of India. Food safety come under state list or center list. It come under both state and center list. So these three mainly, remember, is both by state and center. Okay. And this all money which I was discussing, this money is of ESI scheme. In ESI, main funder is central government 7/8, state government give 1/8 money. Okay, sure. Now let's come to the next question. This is the next question, which they are saying कि Modi and Mamta are together contributing in Ayushman Bharat, and I am telling you there is an affair going between them. You will find their picture one day somewhere. Anyway, come focus here. So, which of the following regime you advise for mass prophylaxis of anemia? If you are the MOIC or Health Minister of India, will you distribute ferrous sulfate tablet in your area? Ferrous sulfate plus vitamin C plus folate plus vitamin B12, or ferrous fumarate, or injection iron sucrose? What will you give in your area? So if you are the administrator, give everything. Why? Because vitamin C, I hope you know, help in absorption of iron better. That is why we give it with lemon thing. And remember, this question has also come, we never give iron tablet with tea or milk because it will decrease the absorption of iron, but vitamin C will increase the absorption. Folic acid is needed for proper maturation of RBC, and vitamin B12 is also needed for proper maturation. Otherwise, in vitamin B12 deficiency, you all know megaloblastic anemia can occur. So these are the things which you already know. Let's move ahead. Next question is, someone is giving FeSO4. If you give only FeSO4, then who will give the folic acid? So you have to add the folic acid thing for sure. Okay. Best method for routine monitoring of air pollution. First tell me which is the best chemical indicator of, if you know the answer, do give it. Which is the best chemical indicator of air pollution? That is sulfur dioxide gas, which is the best chemical indicator. So best chemical indicator must be included if you want to know routine monitoring. So sulfur dioxide, you have to focus. Sulfur dioxide is only in option B or D. So answer can be B or D. Only two option can be correct. Now, other than sulfur dioxide, what we use? What else we use? We use other thing to measure as particulate matter. ये matter को MU लिख दिया है. Sorry for the printing mistake. Particulate matter, because all the air quality index which we listen, this air quality index is particulate matter of size 10 micrometer or particulate matter of size 2.5 micrometer. So sulfur dioxide and particulate matter we use, plus we can use lead also. Lead, if in air, lead can cause of course plumbism, and the most common route of plumbism is inhalation. I asked it in one of the class, students say by ingestion. I said why? He said, sir, lipstick is there, so I think ingestion. I said, bro, you are eating too much of lipstick, but it doesn't mean that it is most common route. Most common is inhalation, because lead is in paint also, in gasoline also. So lead is most common route of poisoning is inhalation. So we can use lead, sulfur dioxide and particulate matter. But the best answer will be sulfur dioxide, particulate matter and smoke. How do we measure smoke? We measure smoke and dust by swirling index. So this question also come. Swirling index measure air pollution or soil pollution or both? Tell me. Swirling index, does it measure air pollution, soil pollution or both? What does swirling index measure? Plumbism, inhalation is most common route by smelling. And someone is asking what about in children? I don't know. I just read most common route of lead poisoning is inhalation. That's all I know. And they have asked in NEET 2024 only that if you found in urine two things, alpha aminolevulinic acid or coproporphyrin. If you found these two things, coproporphyrin, if you found any of these two things in urine, the diagnosis is plumbism, lead poisoning. And in lead poisoning, the drug of choice is ethylene diamine tetraacetate. And I hope you all know they can give an image based question of blue line on upper gum, Burtonian line. That is lead poisoning. Okay. So here best answer is D. My question was swelling index only air or air sound soil both? Very good. Swelling index do not measure soil pollution. Swelling index only measure air pollution. Swelling word का मतलब होता है गंदा. तो हम एक स्पेशल टाइप का कपड़ा बांध देते हैं एक कुछ कुछ जगहों पर और सामने उतार के देखते हैं कि वो कितना गंदा हुआ इंफ्रारेड लाइट के अंदर. तो स्वेलिंग इंडेक्स सिर्फ ये बताया कि डस्ट कितना आया, ऊपर ऊपर स्मोक कितना आया. तो सॉइल पोल्यूशन से कोई लेना देना नहीं है, वो एयर पोल्यूशन बताता है. बिकॉज इन स्वेलिंग इंडेक्स वी आर जस्ट मेजरिंग हाउ मच डर्टी द क्लॉथ बिकेम by putting that one piece of cloth in separate areas and then taking it out in the evening and putting it under infrared light and measuring the dust particle on the cloth. So it is not telling anything about soil pollution, it only tell about air pollution. Okay. One more thing which you must know in air pollution part is that the classification of air pollution you must know. The question which came, let me ask you this question, that if air quality index is, let's say, 372, it belong to which category? Okay. Option A, is it moderate? Is it poor? Is it very poor? Or is it severe? Similar question has already been asked in NEET exam, but the data was a bit different there. Let me see whether you can answer it or not. Where does the air quality belong? Moderate, poor, very poor, severe. Resma is asking how to avoid silly mistakes, sir. Very good question, dear Resma. To avoid silly mistake, you have to do two things. First thing, 5 to 7 year of NEET PYQ with topic 2-3 revision. How it will prevent silly mistake? Because if you will practice NEET PYQ or any PYQ again and again, then you will not do silly mistake. We are doing silly mistake because we are doing PYQ from module. We are not doing it year wise. We do it module, and in module the problem is you only revise the wrong answer. You don't see the correct answer and you don't revise those things. So when you don't revise correct one, you can do mistake the next time. So my advice is, do in this last 20 days, do this PYQ year wise. Now how to do it year wise? Suppose you have any app, type 2020 NEET exam anatomy, then come out and type 2020 NEET biochem, then come out after solving 5 questions of biochem and type 2020 NEET physio, do 4 questions there and come out and type 2020 NEET patho. Like that, do all 19 subjects together. Don't do it subject wise, because if you do subject wise, pharma you did now, next turn will come after 15 days. So that will be a big gap for pharma, and in exam the question is not subject wise, year wise. So do it year wise. This is will, and revise it. This will prevent mistake. First thing. Second thing, to prevent silly mistake, do PYQ more. Do 300 PYQ for 20 out of 25 days. You will say, ki, sir, if I will do so many PYQ, when will I revise the theory? So my question is, why are you revising theory 4 times, 5 times? Why this theory is so important for you? Because in theory there is no mistake, so you feel happy. In objective, when you do mistake and you feel sad. So you want to do theory again and again because theory make you feel good. But the problem is, in exam they are not asking theory, they are asking PYQ. And you are doing silly mistake because of reading theory. If you will not practice PYQ, you will not become smart, and silly mistake will keep on happening. So if you do 300 PYQ, 20 out of 25 days with explanation, first thing is, in the explanation, you will revise theory only, na? Like all the short subject. One thing is you can read their theory 6 times, 7 times. Second thing is, just do 7 year of NEET, 5 year of FMG, and see all the topic from which it came. And in the explanation, you will get that topic. How many topics are there in all those subjects? 20, 30 topic. In the PYQ explanation, you can get all the topic. So when you read explanation, it is theory only. Do not underestimate the value of doing objective question. Don't read theory. And many students in the group also, they are saying, sir, when will you revise theory? When you, last time is not for theory. last time is for solving PYQs and practicing objective question. Okay, because knowledge is not what they are testing in exam. They are testing your recalling ability, that under exam pressure, can you recall from memory or not? And if you are not recalling at your home, how can you recall in exam? Okay, so do this two thing. I said it earlier also, and I'm sure your silly mistake will be less. Chalo, come. Next question is, sir, are PYQ repeated in NEET PG also? Yes, in NEET PG also PYQ repeated. Let me give you a very simple example. 2023 NEET, I personally observed very closely. And in NEET 2023, they asked 6 questions from nutrition topic. In MCI December exam 2023, there were 4 questions from nutrition. And in July the 2024 MCI exam, there were 7 questions from nutrition. So the same nutrition topic which came in NEET, then keep on repeating in FMGE and again exam. And they repeat, NEET and FMGE are made by same board, same NMC board, MCI board make it. So the question are more repeated there. Always do that, please. Sorry for distracting the class, but I think this is more important for your result. If you don't read PSM from me or any teacher, it's okay. But if you don't do PYQ, don't revise 200-300 question per day, then your exam result will get affected seriously. But if you will do it, I am sure you will get very good marks. But still, if you have question, feel free ask it. Now, the question here was, what has happened to this patient? But before coming to this, let's answer this question which I asked. What is the quality? You got confused. Some are writing poor, some are writing very poor. Okay, let me tell you. If it is the mnemonic here, which you can use is MPVS, moderate, poor, very poor, severe. Less than 50 is good quality air. If someone fart and it does not smell, it means it is less than 50. Achhi hawa chodi, good quality air. If it is 51 to 100, we call it Satiswa ka factory, Satish factory quality air. That is 51 to 100, satisfactory. Then story start with 100, and everyone is 100, 100, 100, 100. MPVS is the mnemonic. So if you remember the mnemonic and after 100 they start, you can answer it. Like moderate is 101 to 200, poor is 201 to 300, very poor is 301 to 400, and more than 400 is severe. So here it is 372. Because it is 372, so it is very poor. But in your exam, if they ask question from this topic, probably they will give option as 473. And if it is 473, it is severe. Why they will give 473? Because it has asked in NEET exam, and NEET question they copy exactly. Like, let me tell you, NEET 2023, one question was that EAR. What is EAR? Estimated average requirement. Estimated average requirement, is it for fulfillment of 50% population need or 97.5% population need? Actually, this question first came in MCI, and then NEET exam was going to happen. So I posted it on my introduction slide that this question is going to be repeated, and actually it was in NEET 2023 got repeated. So they exchanged the question a lot. Do NEET question for sure. Please, NEET question, please do it before FMG exam. And you will not stuck in 140-50. You will definitely clear it. So EAR fulfill need of 50% population. 50% population need EAR. Recommended dietary allowance, RDA, fulfill 97.5% population need. Okay, do remember it. Chalo. Now let's come to this question. What has happened to this patient? There are many rough things coming out from the skin. Rough, dark, blackish skin. This is known as phrynoderma. And this phrynoderma, which you will read in derma, is due to deficiency of essential fatty acids ADEK. So that is phrynoderma, essential fatty acid and vitamin ADEK deficiency. Okay. Toad skin they call. Toad, brother of frog with rough skin. So that is toad skin. Chalo. Then this question was one FMG question that Village Health Nutrition Day is observed once every year, every month, every week. What is the answer? Village Nutrition Day is observed every month. Okay. Now, there were two questions from this topic which was really tough. The question was, one question was regarding this similar topic was, which is not a work of JSY, which is not done under JSY. JSY, you know, Janani Suraksha Yojana, Mother Safety Program. It's not JSSY, not double S. It's single S. Option A, JSY not done is Safe Abortion Services. Not done is Village Nutrition Day once a month. Okay. Not done is free checkups in pregnancy. Free ANC checkup, of course, in pregnancy. Then not done is Village Nutrition Day once a month, early ANC checkup, maternal death review. Which is not done under JSY. Chalo, try to answer it. Maternal death review or which is not done under JSY. Do reply. I'm waiting for your reply. In JSY, first work is, of course, money after delivery. And I hope you all know. Money after institutional delivery to mother and ASA USA. This is the first work. Okay, ASA or USA. This is definitely the first work. But other than this money given, what is not done under GSY? If you know, please do reply. Very good. You all are replying D, and Abhishek tried to guess it earlier saying ambulance, but ambulance was not in the option. Okay, institutional delivery money is given. Yes, you know that. So, my dear friends, correct answer is free ANC checkup do not come under GSY, man. Free ANC checkup or free investigation come under two programs. One is JSSY, which give free food, free investigations, free treatment, and free ambulance. So these things, free things was under JSSY. And then we have this Pradhan Mantri Surakshit Matritva Abhiyan, under which you can give all the same free things, but on 9th of every month. Okay, 9th of every month, if you give free things, that is PM SMA. तो भाइयों और बहनों, किस दिन ले जाओगे माओ को अस्पताल? 9 तारीख को. और अगर मिस कर गए, 9 को नहीं ले गए, तो क्या होगा? तो घंटा कोई फर्क नहीं पड़ता है, क्योंकि ये चीज महीने भर फ्री मिलती है. सरकार ने 9 तारीख को वही फ्री दिया है जो ऑलरेडी महीने भर फ्री था कई सालों से, है ना? स्मार्टनेस. ओके, सो डू रिमेंबर PMSMA and JSSY do this free thing, and JSY have 6 work under it. First work is money. Second work is Vande Mataram program. What is Vande Mataram program? Private ops gynae doctor will keep a logo of Vande Mataram program on their hospital, and all the things which ASA was distributing like condom, OCP, iron calcium tablet, malaria treatment kit, they can also distribute if they put this logo of Vande Mataram on their OPD, private ops gynae doctor. This is second work. Third work is, of course, safe abortion services. Fourth work is the follow-up of pregnancy, है ना? Especially high-risk pregnancy follow-up. Follow-up of high risk pregnancy, high risk or normal pregnancy also you can do follow up. And which software help us to do follow up? Anmol software help us to do follow up. Okay, so this is follow up. Fifth work is village nutrition day. This do come under JSY, village nutrition day once a month. This is known as Mamata Divas. Okay, and last 6 work is maternal death review. So these are the 6 work. You can remember it with a story also. Na? Let's say suppose Abhishek came to me in one cloudy dark night and it was very dark and we did something, I became pregnant, okay, as you can see. So after pregnancy, first thing I need is to go for ANC checkup registration, which is done under JSY Anmol. Then after registration, I need good nutrition at my home. So village nutrition day will help me in doing that. Then I need iron calcium tablet and I have a nearby private or scanny doctor. So Vande Mataram can help us in getting all those free things. So what are the things here? First is ANC checkup, then is follow up pregnancy, means an ANC mother review, maternal follow up. Then we did Vande Mataram and village nutrition, 3 things. Then suppose after that 6-7 months I came to know that Abhishek is not loyal to me, he's doing the same thing with other also. So I went for abortion services, that is also under it. During abortion, if I died, people will come to my home and will ask why the death occur. So sometimes this is known as verbal autopsy. By asking question, we are coming to the reason why death occur. We are cutting the body with our question, verbal autopsy, maternal death review. So this is also done. And last thing is, if I would have delivered, money will have been given to it. So all the 6 work come under JSY. Do remember, test is done under JSSY and PMSMA. Okay, sure. Next question is, next is in disaster management, following are practiced except what we don't do in disaster: triage, rehabilitation, mass vaccination, disaster response. What we don't do during disaster? Can you answer it? Very good. CCC, mass vaccination we don't do during disaster. We can give only, do remember this thing, tetanus, typhoid, TTP, tetanus, TTC, tetanus, typhoid, cholera, only to health worker. To health worker we can give tetanus, typhoid, cholera. But remember, mass vaccination or no vaccination is given to general public. No vaccination to general population. Why we don't give vaccination to general population? Because immunity comes after 3-4 months. So what is the point of giving vaccination to general public? And for health worker, TTC 3 vaccines are given. Now there is a controversy on this because measles is a disease. If you give vaccine for measles vaccine induce, this question has come separately, that for which disease, which vaccine, immunity come before symptom. Measles vaccine induce immunity before symptom appear. लक्षण आने से पहले ही रोग प्रतिरोधक क्षमता पैदा हो जाती है, यानी मीजल्स में सर्दी खांसी होने से पहले ही एंटीबॉडी बन जाते हैं अगर हमने वैक्सीन ले लिया है तो। सिम्टम आने में लगता है 10 से 14 दिन, याद रखना 14 दिन क्वारंटीन पीरियड है, 14 दिन है मैक्सिमम इंक्यूबेशन पीरियड, और मैक्सिमम इंक्यूबेशन पीरियड ही क्वारंटीन का पीरियड होता है. सो 14 day is the maximum incubation period, is the quarantine duration of measles, and in maximum 14 day symptom will definitely come, but immunity comes in 7 to 8 day. So at least we can give measles vaccine, if not other. Why are we not giving measles also? Because measles is not a common disease which occur during disaster. What is the most common disease during disaster? Gastroenteritis. Second problem is, during disaster always nurses and doctors are in shortage, so we cannot engage them in vaccination. Third problem is, if you give vaccine during disaster, the sterile condition is difficult to maintain, so it can lead to infections also. So do not give any vaccine during disaster, written clearly in PARC, CDC and WHO guideline. Measles also we don't give to general public. We can give tetanus, typhoid, cholera only for doctors and health worker who go there. So this mass vaccination question come again and again. And second question which come is from the disaster cycle. So of course, in the disaster cycle, we all know impact is first. Main confusion occur in 3R. What is the first R? Is it reconstruction? Is it rescue, rehabilitation? What is the first R? So first R, if you apply logic, you will never forget. First, we will try to save them. Rescue relief will be first R. After rescue relief, we try to give them some job. Giving them job is known as rehabilitation. Making person self-dependent, आत्मनिर्भर बनाना, है ना, making them. So which job you can give them? You can give them the job of construction of houses which are broken. So after giving job, then they will construct the house. So after rehabilitation, there is reconstruction, not before that. Reconstruction is after that. And then there is mitigation. Mitigation means trying to decrease effect of future disaster. Like a very good example that has been asked is, if you are trying to make earthquake proof houses, it is preventing future earthquake effect. So it is mitigation. And then there is preparedness. Preparedness means you are preparing warning signal, team of doctors and all those things. That is preparedness. And whether you are prepared or not, there will be next impact. So this is the disaster cycle. 2 questions came in NEET 2024 from this cycle. To remember it, main confusion is in triple R. So do remember triple R separately. And if you add all this triple R, 3R, adding together become recovery. Okay. So to remember it, you can think it like this, that triple R, after their movie success, they went to MP Ujjain, mitigation and preparedness. And in Ujjain, they give a lot of thandai, bhang with milk. So they had it, and after having bhang, of course, there will be impact. So triple R, MP, impact is the way to remember the cycle. R is rescue relief. Then we will give them job. After job, their house will be ready. So job, then reconstruction. And mitigation, then preparedness. Of course, then impact. So triple R, MP, impact. Do remember the cycle. Do remember this answer. And during vaccine, during the earthquake, suppose they have asked this question in NEET. Yes. Wah wah. Dr. Mysterio has a mysterious question. That, sir, marking of building after disaster, will it come in mitigation? Yes. What do you mean by marking of building? Marking of building means you are putting red notice on those buildings which can fall under earthquake or which can fall by itself. So if you are identifying it, you are preventing effect of earthquake. That is mitigation. So definitely it will come under mitigation. Very good question, Mysterio. You have given correct answer. Correct question was correct and answer was also correct. Okay. And one more question is, who is the in charge of disaster program at district level? District collector. Similarly, they will ask, who is the in charge of I program at district level? District collector. Okay. I program, disaster program, both are managed by district collector. Let's do the question now. Can you do it? In disaster management, all are true except which is not correct. Do try to find the answer and give the answer. I am waiting for your reply. Read it and answer. Which one are true except? Which one is false? They are asking in a way. Tell me. Okay. Mahesh, son of Krishna. Oh wow. Has written B. Tolodine B. Mysterio, Parol, Abhishek Jadhav all have written B, 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 B. Yes, very good. Response is not before disaster. Before disaster, we do preparedness. Response is post disaster. So this line is not correct. Mitigation before disaster strike, yes, it can be partially correct. Yellow color, this is one question. Do reply. Who is relatively stable? Relatively stable, is it yellow or is it green? Who is relatively stable? Yellow or green? Who is relatively stable? So yellow color is medium priority, we can say. Gastroenteritis is commonest infection, we just discussed. So wrong option is B and you all are correct. But relatively stable, who is relatively stable? Green or yellow? 3 people replied green. Toledin blue is replying yellow only. Savitri also said green. Musaddiq also said green. So this was a confusing question. My dear friend, always remember, red is of course unstable, who need life-saving surgery quickly. As compared to red, yellow is relatively stable and green is completely stable. Green are those patients who are ambulatory. Ambulatory means they can move from one place to another on wheelchair or stretcher. So green is not relatively stable, green is stable. Relatively stable is always yellow. Okay, so do remember, yellow is relatively stable, green is stable, and of course black is moribund or dead. So this is a common mistake, that's why I put it here. One more question I have is, suppose you are a MOIC in Sikkim or Arunachal Pradesh or Nagaland, and green is good to go, very good way. Dr. MD, Mr. D has given good option. Green is good to go. And good to go. Green is stable, ambulatory. Okay. Chalo. Now, during earthquake, will you listen to the orders or the request coming from senior or community or not? During earthquake, this was one of the neat question which came. Will you follow command from seniors and community or not? Yes or no? Answer is yes. What do you think? Will you follow command? Yes or no? Answer is, what is the answer? Answer is no. Don't listen to senior or community, because senior or community can say any bullshit thing. Community will say कि मौत करीब है, भागना छोड़ो, ऊपर वाले को याद करो. तो तुम भागोगे कि याद करोगे? भागते भागते याद कर सकते हो, जब फटती है तो एक साथ कर सकते हो. So they can misguide us, community or senior. You are there, and in medical profession we teach to take independent decision. We are not in army to follow command. So you will not listen to them, you will take your own decision. Okay. Sure. Now let's come to this next question. The question is, broken, very controversial question, broken vaccine ampule, where it will go? Yellow, red, blue, black. I will ask 2-3 more questions, just do the matching after this. First answer this broken ampule. Empty wrapper of syringe, where it will go? Throw it, say it. Culture plate, where it will go? Throw it. Then cotton, where it will go? Then PPE kit, where it will go? Chalo, tell me. All these 4 things, where it will go? Start with first answer my question. Broken vaccine ampule, where? Okay, acha, chalo, theek hai. Some student has answered it another way. Let's say it's broken vaccine ampule, and suppose it is again another one is vaccine ampule. Just vaccine ampule is next one and broken is this one. Where it will go? Without broken, someone has written yellow. Some written yellow. Then you move to other question without answering the first one. Blue. Oh, no. You have replied. Very good. Azad Ahmad, Musaddiq, Mahesh, son of Krishna, Toledin blue. All of you are right. When they talk about vaccine ampule, whether it's broken or unbroken, vaccine ampule will always go in blue because it is glasses and metallic implant, and glasses and metallic implant goes in blue. Why not yellow? Some people, they write yellow, but they have not seen the classification given in Park textbook. In Park, they have written it that if the vial is with cytotoxic drug, only then it goes in yellow. Cytotoxic drug goes in yellow. But is vaccine cytotoxic? No. Vaccine cannot be cytotoxic. Cytotoxic are anti-cancer medicines or some medicine which kill other cells and all, but it cannot be. Vaccine purpose is not to kill other cell. Vaccine purpose is to induce immunity. It's never cytotoxic. So cytotoxic vial goes in yellow. And how cytotoxic waste is disposed? Best method of disposal is collect in yellow wooden box and send back to manufacturer who have created it. But if you cannot send it back to manufacturer and you want to dispose cytotoxic waste, this is the best option. Second option is inertization, a very unique area of question being asked in MCI also, but 4 years back. What is inertization? Inertization means to all the mercury and cytotoxic waste, you mix 15% cement and 15% lime. If you mix cement and lime in this, it will not contaminate the surrounding. ये सुसुप्त अवस्था में चले जाएंगे और पानी और नेचर को contaminate नहीं करेंगे. It will become inert and not affect surrounding. So inertization, 15% cement, 15% lime. It is second method. First method, collect and send it back. Cytotoxic will go in yellow. All kind of vaccine vial will go in blue only because they are glasses. And now you will say, sir, it has liquid inside it. Always you can open the ampule and throw the liquid other way and then put the ampule without broken also in blue. Why? Because in blue category, if it is not broken ampule, we will put it under autoclave, and after putting it autoclave, we can reuse it. And if it is broken, we can still sterilize it if you wish, and then we can directly recycle it after sterilization. So broken or not broken, both will go in blue only. There is no doubt. Park has written it in a table. If you wish, I can share the table. Now, empty wrapper of syringe, very good. This is not contaminated with patient blood, so it will go in black category. Black is for garbage. Empty wrapper, black. Culture plate. Yes, this is a controversial one. Where will you throw culture plate? Park has written all culture medium and culture plate, all microbiological waste goes into yellow. So culture plate look like glass but goes in yellow. Cotton, of course, goes in yellow. PPE kit, real PPE kit made up of plastic. So PPE kit goes in red. And there is mask-like material, it will go in yellow. But the real PPE kit is made up of plastic, and plastic thing always goes in red. So plastic rubber goes in red, that's why it is red. Very good. I hope you are all correct. Empty wrapper black, culture plate yellow, PPE kit yellow, cotton yellow. Okay. Culture plate yellow. Yes, you are right. Very good. Correct. Chalo. Now, next question. Woman traveling from Bihar to Delhi suspected to have Kala Azar. Which investigation she will do? P24, RK39, combo RDT, HRP2 antigen. HRP2 is what? Histidine rich protein 2 antigen. Histidine rich protein 2. So what she will go through? This question has came in NEET exam. Histidine rich protein kit. Will it detect falciparum or vivax both, or only falciparum? So histidine rich protein kit detect only falciparum. Do remember. How? Dekho, falciparum cause serious malaria like cerebral malaria, renal malaria, and with that patient can die, become history. So history only with falciparum. Histidine only with falciparum. Very good. Pooja is correct. RK39 test. RK39 is for Kala Azar. P24 is of course for HIV. P24 antigen give result give positive result earlier than ELISA. ELISA will be development of antibody. सिपाही बनेंगे तब ELISA आएगा, और चोर को पकड़ ले रहा है P24, तो चोर तो पहले घुसेगा, बाद में सिपाही बनेंगे ना. First thief or antigen will enter, so P24 will be detected first. Then we have antibody or police active against it. So ELISA will come later on, P24 will come first. This question has also came one time. Combo RDT. RDT is here for falciparum, vivax both. Combo RDT is known as optimal kit. And this optimal kit have which enzyme? It has lactate dehydrogenase enzyme. So if you have lactate dehydrogenase enzyme, it can detect both. But histidine only detect falciparum. And whenever we talk about Kala Azar, of course, the drug of choice for Kala Azar is same which we use for black fungus, liposomal amphotericin B. And Kala Azar, first, of course, Bihar has maximum case. And then which state is not endemic for Kala Azar, they ask. So there are 4 states which has endemicity of Kala Azar: Bihar, then neighbor of Bihar, UP and West Bengal, and then the brother of Bihar, Jharkhand. So 4 states are endemic. Assam and other states are not endemic for Kala Azar. Okay, so do remember it like this also. Miltefosine is an oral drug which we can give for Kala Azar, very good. But drug of choice is always liposomal amphotericin B. Okay, chalo. Next question. Your reply is coming really good. I am very happy with the way you are replying. Next question here is, which rashes is shown here? You can see some dots, dot rashes. Is it due to vitamin K deficiency? Is it due to taking NSAID when you have chikungunya? Is it due to dengue? Or is it due to measles? Which rashes is here? So these are pink dot like rashes, petechial rashes, and petechial rashes always occur with dengue. Petechial rashes with dengue. But do remember one more thing. In dengue, during recovery phase, a special type of rash occur. During recovery, the rash is known as island of white in sea of red. लाल सागर में सफेद टापू, है ना, यानी पूरी और लाल लाल होगा, बीच में सफेद सफेद दाने होंगे. There will be red all around and there will be some white dots. That will be during recovery from dengue. And do remember, dengue show antibody dependent enhancement. एंटीबॉडी डिपेंडेंट एनहांसमेंट का मतलब यह है कि जब पहली बार होता है डेंगू तो उतना सीरियस नहीं होता है, दूसरी बार जब होता है तो वही सिपाही पहचान नहीं पाते हैं अच्छे से डेंगू को और उसको दोस्त समझ के अंदर ले जाके मल्टीप्लाई करने में हेल्प ले लेते हैं, इसलिए दूसरे टाइम का डेंगू जानलेवा हो सकता है. एंटीबॉडी डिपेंडेंट एनहांसमेंट में फर्स्ट टाइम डेंगू एंटीबॉडी फाइट एंड ट्राई टू रिमूव इट. सेकेंड टाइम व्हेन अदर वेरिएंट ऑफ डेंगू इंटर, antibody assume them as friend and take them inside and help in their multiplication. So antibody help in multiplication of dengue. That's why it's more lethal in second time. And the vaccine for dengue is 𝐷𝐴. But a more twisted question which is coming from this part again and again from dengue part is that in dengue there is 2 tests which we do. But suppose a patient come at 5 days of fever, है ना, dengue fever. Of course, dengue fever you will identify by retroorbital pain and frontal headache. अगर किसी को भी आंख के पीछे दर्द हो रहा है और सर में यहां दर्द हो रहा है, आंख के पीछे और सर में यहां, तो ये पक्का डेंगू है, खासकर इस मौसम में, बरसात में. So retroorbital pain, frontal headache is definitely dengue. You will do which test? NS1 antigen or IgM antibody? So this NS1 antigen test, which one is correct? IgM antibody. Which test you will do? Which test you will do? A or B? And then one more question regarding it was, patient have fever with calf muscle pain and कंजंक्टाइवल सफ्यूजन, आंखें लाल हो गई, बिल्कुल वैसे जैसे गांजा फूक के हो जाता है तुरंत तुरंत, या गांजा चरस जो भी कह लो. Conjunctival suffusion, calf muscle pain, fever. What has happened to this patient? This is one question. And what will you do on 5th day of fever? This is another question. Do answer me both of it. So very good. Many of you are answering NS1, but in exam if they ask it, correct answer will be B, IgM antibody test. NS1 is up to 4 day or up to 5 day also they say. And 5 day onward you do IgM. So this was a question which was very controversial because they have asked 5th day, and on 5th day we can go do both the thing, but the point is usually fever patient notice from 2nd day and report it from 2nd day. So 1 day is usually lost, and therefore if the patient is saying 4 day, you can take it 4 day as 5. If the patient is saying 5, you can take it 5 as 6. This is a bit controversial, I know, but based on all the microbiologists which teach this topic and some standard book, it is better to do IgM antibody test here. Up to 4 day NS1 is better, 5 day better answer is IgM antibody. It's controversial, but this is what all the microbiologists who teach you also agree, plus books also agree. And if it is fever with calf muscle pain with conjunctival suffusion, it is leptospirosis. Leptospirosis, for the prevention of leptospirosis in Kerala after flood, government distributed doxycycline. But along with doxycycline, they need to spread mosquito killer or rat killer. What is the life cycle of leptospirosis? I hope you know. In the life cycle of leptospirosis, they talk about rat urine. So if rat urine, चूहे का मूत है उसके अंदर, so हमें चूहा मारने की जरूरत है या मच्छर? We need to kill rat or mosquito? We need to kill rat. So we will use rodenticide. Which rodenticide? Zinc phosphide we can use. So that's why the correct answer is zinc phosphide, but some good places they have written malathion, which is wrong answer. Rat killer we have to give, so we'll give zinc phosphide with doxycycline here. Doxycycline to prevent from leptospirosis and rat killer to kill it. Okay, chalo, very good. So this was the races of dengue. Now, question is, which of the following site is not used for measurement of skin fold thickness? अच्छा, tell me, किसकी चमड़ी मोटी है? Skin fold thickness किसमें बड़ा होता है? Greater in male or female? किसकी चमड़ी मोटी है ना? Similarly, they ask about waist and waist to hip ratio. So whenever we are discussing one question, we try to discuss the whole topic. It's very easy. 10288. Do answer this question first. More than 1, more than 0.85. Okay. So, okay, we do not measure mid-arm circumference in gluteal region. We don't measure it there. So what are the 4 places where we measured? Mid triceps area is the best place where we measure it. Very good. It's the best place, mid triceps. Second is suprailiac region, which is known as anterior superior iliac spine, where our belt gets stuck. So if anterior superior iliac spine is not there, where our belt will go stuck, where our pant will stuck? Tell me. And if it is not there, so it is second area, ASIS. Third is biceps. And fourth area, which you should know, is subscapular, below scapula. In older day, when stethoscope was not there, doctor used to put his ear on this subscapular area on the backside to hear Vijay's and Ronchi. Okay, so that is the 4 area: mid triceps, suprailiac, biceps, suprascapular. And after measuring it in 4 area, not on gluteal area, then they take the average. So if average of 4 area more than 40 mm in male or more than 50 mm in female, then we call it obesity. So kitna bada hai female ka? 10 बड़ा है, फीमेल हैव 10 बिगर स्किन फोल्ड थिकनेस। तो चमड़ी किसकी मोटी है? फीमेल हैव बिगर स्किन फोल्ड थिकनेस। Why? Because they have subcutaneous layer of fat below their skin. That is why female skin is so soft to touch. Is it soft or not? It is soft. In one of the class, I asked it, and the student start touching the skin of the girl sitting next to her and said, yes, sir, it is soft. I said, no, don't do it. You have to pinch it to know it. Because we pinch it with which instrument? We pinch and find the skin fold thickness. The instrument is pendant caliper. So see, caliper also have her written on it. And as soon as I said it to the boy that you have to pinch it, he pinched also. Very naughty boy. So do remember, it is bigger in female, measured by her pendant. And what is the difference? 40 mm, 50 mm. Now, if they talk about waist, who have bigger waist circumference? कमर किसकी मोटी होनी चाहिए? मेल, है ना? क्योंकि कहीं किसी पिक्चर में नहीं सुना होगा कि वाह क्या जवां मर्द है, क्या पतली कमर है ना? मेल is bigger in, male has bigger waist circumference. So if it is more than 102 centimeter in male or more than 88 centimeter in female, then we call it obesity. है ना? We call it obesity. Obesity definition 102, 88. 14 का difference है between male and female. Okay, 14 difference. Do remember. Now, question they ask is from waist to hip ratio of female. Tell me, waist to hip is bigger in male or female? If male has bigger waist, waist to hip is also bigger in male, na? So if it is more than 1 in male or more than 0.8 in female, we call it obesity. Do remember this part for sure. Waist to hip ratio in female for obesity is more than 0.85. So whenever they talk about waist, remember me, male with bigger waist circumference. But in skin, remember female, okay? Chalo. Now, Dr. Sarath is saying randomly found this class and now enjoying your class. Shukriya. Focus here. Question is, which is not a pillar of primary health care? What is not pillar or principle? Tell me. Which is not pillar? Community participation, appropriate facility, intersectoral coordination, equitable distribution. Which is not a pillar? So, in this question, they play with spelling also. Sometimes they write equitable as equal. Equitable means giving more importance to needy people. So this is a pillar. Intersectoral coordination is pillar. We coordinate with transport ministry and all other ministry. Appropriate technology is a pillar, not appropriate facility. An example of appropriate technology can be Sakir tape. Remember in Sakir tape, if it is red color indicate less than 10.5, 11.5, 12.5, it is less than 11.5 centimeter, and it means severe acute malnutrition, 1 criteria. So even an illiterate or less educated female can see the red color and can tell that the child is malnourished. That's why it is appropriate technology, because even less educated people or rural people can have this technology. Other example of appropriate technology which they ask in exam also is WHOORS. Okay, and then pulse oximeter can also be there. Do also revise the definition of SAM. When they say SAM, the criteria for severe acute malnutrition is weight for age nahi, weight for height. Weight for height less than -3 standard deviation. Okay. Weight for height is the criteria. And of course, third is visible wasting or edema. So if you fulfill all the 3 criteria, then you are SAM, severe acute malnutrition. Okay. So which is not a pillar? Appropriate facility is not a pillar. Now the question which INICT has asked from it, very interesting question, was कि in community participation, who give idea and who implement it or who monitor idea implementation? Tell me. मान लो आपको मन किया कि गांव की सड़क को बेहतर कर दें, क्योंकि पीएचसी से आने वाली सड़क पे जो माएँ आती हैं नॉर्मल भी, उनको भी इतने झटके लगते हैं कि लेबर पेन आ जाता है, कई बार तो डिलीवरी हो जाती है। तो आपने सोचा सड़क होनी चाहिए एकदम हेमा मालिनी के गाल जैसी स्मूथ। कैसे बनाओगे? ट्रांसपोर्ट मिनिस्ट्री को कॉल करके बना सकते हो, इसको इंटरसेक्टोरल कोऑर्डिनेशन कहेंगे। दूसरा तरीका क्या है? गांव वालों को बुलाओ और पूछो कि क्या क्या गांव का विकास के लिए करना चाहिए, तो आइडिया कौन देगा सड़क बनाने का? विल द आइडिया ऑफ मेकिंग द रोड कैन कम फ्रॉम डॉक्टर और शुड इट कम फ्रॉम कम्युनिटी? Idea always comes from community. They will tell that, sir, we have this problem. When they will come to road, they will say, yeah, this is main problem. But it should come from them, not from your side. Second point is, who will monitoring the implementation of idea? This was INICT, good question. Will it be doctor who will implement, monitor whether the people are making roads or not? Or will it be the community? ASA has no role here. She is just a part of community here. Again, the answer is community. Idea will also be from community and monitoring and implementation will also be from community. Now you will say कि तो sir doctor हम लोग क्या करेंगे? क्या हम लोग नाचे वहां पर करें क्या? So your role is just to bring the community together, because you know, in rural area, even in urban area, but mainly in rural area, people are too much divided into various caste and subcaste and undercaste also. So your work is to bring them together and make them do the work which is needed for the growth of the village. So idea and implementation both are from community, not from you. Okay. Chalo, next question is this question. ये मेरा लौंडा है मान लेते हैं. This is suppose my child, है ना? There are some rashes which you can see here. The question is, he came to PHC with runny nose and fever since last 3 days. Rash started on face, then covered the trunk and part of the body. What is the most likely diagnosis here? Is it measles? Is it rubella? Is it chickenpox? Or is it Epstein-Barr virus? What is the answer? Tell me. Tell me. This is definitely measles because of 3 reasons. First reason, this typical characteristic they have given, rash start from face, then go to trunk and other part. So do remember, measles start from कान के पीछे से शुरू होगा. किसके पीछे से? कान के पीछे से. Back of hairline or back of ear, then go to face and then it go to body. Second point is, chickenpox is known as chickenpox because just like beak of chicken come out, chickenpox rash come out from skin. Chickenpox, dew drop on rose petal, है ना? It's like गुलाब की पंखुड़ियों पर ओस की बूंदों की तरह बाहर आ जाते हैं. So it will come out then only chickenpox. Here it is within the skin surface, not coming out. So because it is within the skin surface, it is measles. That's why measles rashes are known as sand particle rashes, because they are like sand particle merged with each other and within the skin surface. Okay. Second point is, only measles is having cough, cold, coryza, conjunctivitis. So if you found an image with face of the child and cough, cold, coryza, पानी निकल रहा है कहीं से भी, measles है. But do remember, if they give chickenpox or rubella both have dry fever with rash. There is no cough, cold, coryza. So in the image, if you found secretion, cough, cold, etc., it is definitely measles, because chickenpox, rubella are dry fever. And chickenpox is centripetal or centrifugal? So it is centripetal, more on trunk, less on palm and sole. No rashes of chickenpox will occur on palm and sole. So easy to remember. CP for chickenpox, CP for centripetal. Okay. Now, the main area from which NEET is asking the controversial part is diphtheria. They are asking the diphtheria treatment for contact, diphtheria treatment for cases, diphtheria drug of choice. Diphtheria is a controversial area. And before going to other question, I want to discuss diphtheria first, because I am expecting diphtheria question again in NEET 2024 was there. So it will come in MCI also as per my speculation. First thing is diphtheria. Let's talk about cases. Case, how to manage. So when we talk about case of diphtheria, the drug of choice is diphtheria antitoxin. Okay. Not any antibiotic. But along with antitoxin, we always add in a case some antibiotic. Now, which antibiotic is the antibiotic of choice? If we are talking about children, azithromycin is drug of choice. And if we are talking about adult, then we can give erythromycin. The good news is, this is the same drug of choice for pertussis also. For whooping cough also, in children, the drug of choice is azithromycin. In adult, erythromycin, same thing. But here, drug of choice is diphtheria antitoxin, but antibiotic of choice can be azithro in children. Now, this antitoxin, this will be the question. This is given in different amount. If it is mild diphtheria, in case of mild diphtheria, we give antibiotic 20 to 40,000 international unit. Now the question they ask is, which diphtheria is more dangerous? Nasal, nasopharyngeal or oropharyngeal? नाक का इन्फेक्शन ज्यादा दिक्कत है या मुंह का? बताओ, नाक का कि मुंह का? Which one is more infectious? Nasal or oral? More infectious. Chalo, tell me. Very good. Nach. It's nasal, because in nasal, if you sneeze, you can infect a lot of people. So moderate, they can use, or they can use the word nasopharyngeal. Nasopharyngeal is never mild, moderate. So in moderate or nasopharyngeal, we have 40,000 to 60,000 international unit which we have to use. But if it is a serious case, severe case, in case of severe case, the unit which we use is 80,000 to 1 lakh. Now you will ask, sir, where is 60 to 80? There is no 60 to 80. 20, 40, 40, 60, and then 80, 1 lakh. And always remember, in case we give antitoxin plus antibiotic, both the things. Now let's talk about contact. I hope you know what is contact. Contact means the one who live in close facility with diphtheria person, contact of diphtheria. So in case of contact of diphtheria, first thing is, if last DT or any vaccine with diphtheria like DPT or Penta in 5 years. So now you will say, nothing you will give. No, nothing need to be done. And that was the question which came in NEET exam 2024, and unfortunately, 2 of the teacher gave wrong answer to it because they gave answer without looking at PARC. The question was, there is a 5-year-old elder brother Ram. He had a younger sibling, 2-year-old. That 2-year-old is fully vaccinated till his age. What will you do to this 2-year-old kid when he will brought to you in your OPD? So 2-year kid is a contact and he is fully vaccinated. That means he had taken vaccine in last 5 years. So we don't have to do anything. Nothing was the answer. Okay. Then second case is, if last DT more than 5 years back, then you will give 1 diphtheria toxin, DT or DPT you can give. Okay. But DPT you can give only up to 7 years. Not after 7 years we give DPT. So if it is more than 5 years, DT or DPT. And third thing is, agar koi aa jaye bhoola, forgotten history. I don't remember when did I took diphtheria. So if it is bhoola, forgotten, in that case, you will give him toxoid plus antibiotic both. DT plus antibiotic. And you know what is antibiotic? Erythro for adult, azithro for children. So it is not at all difficult to remember. एकदम आसानी से याद हो जाएगा. क्यों? क्योंकि टेटनस में भी यही काम करते हैं. 5 साल के अंदर अगर टेटनस का कोई भी मरीज आए, चाहे वो गंदा घाव लेकर आए, धूली धूसरित होकर के आए, कटा छटा कैसा भी लेकर आए, no matter which kind of wound is brought, if last tetanus is taken in 5 years, nothing is done except for washing. If it is 5 to 10 years, no matter which kind of wound, dirty or clean, 1 DT or 1 TT we can give. 5 to 10 years, same management, 1 DT, 1 TT. Same thing here. More than 5 years, 1 DT. And if it is forgotten in tetanus, then we give F for forgotten, F for full course. And in case of dirty, only we add tetanus immunoglobulin. So it's almost the same thing, we can easily remember. Okay, don't forget diphtheria. Don't underestimate it. Now, very good. Next question is this one, I think. This one is the next question. Yeah. The next question is, in a 16-month-old child weighing 7 kg, bite spot is there in both the eye. Which of the following is most appropriate schedule to give vitamin A to this child? Will you give 2 lakh international unit IM on day 014, 1 lakh on day 014, 2 lakh on day 0114, 1 lakh on day 0114? So first thing is, this child because you can see the bite spot, this child is suffering from xerophthalmia. Zero means dry, सूख गया. पैथेल्मिया मतलब आंख, आंख की मां की आंख हो गई है, सूख गया है. Eye is dry. Dry means there is less secretion of tear. So when there is less secretion of tear, vitamin A is wholly responsible for it, and the treatment we need to give is not on 2 day, is on 3 day, 0, 1, 14. But which dose will you follow? Will you follow 2 lakh or 1 lakh? क्या डोज दोगे? 3 तो देंगे, कौन सा डोज? Yes, very good. Dr. Saif Ali is saying D and Toluidine Blue is explaining it. All of you are saying D. Very good. If the weight is less than 8, so we give 1 lakh. If the weight is more than 8, then we will give 2 lakh. So 7 kg, definitely 1 lakh. 8.5 or more than 8, then 2 lakh. Second point is, with vitamin A, they ask it again and again, what is the first sign of vitamin A deficiency? First sign of xerophthalmia. Can you tell me the first sign of vitamin A deficiency? Is it bite spot? Is it night blindness? Or is it conjunctival xerosis? What is the answer? Night blindness is something. Yeah, do answer. Do answer. Then nothing like corneal here. Corneal is not an option. Conjunctival xerosis, bite spot, night blindness. Yes, very good. Night blindness is something which only patient can come and tell. You cannot see night blindness. आप देख के नहीं बोलोगे अबे ये रात में अंधा हो जाता है, नहीं. He will come and tell कि सर रात में नहीं दिखता. So night blindness is first symptom, because what patient come and tell is symptom, not sign. And first sign is definitely conjunctival xerosis. Very good, correct answer. कंजंक्टाइवल जीरोसिस को एक डॉक्टर था जिसके अंदर एक कवि की आत्मा थी, उसने ऐसे बोला कि ऐसा लगता है मानो सागर की लहरों पर रेत की एक परत हो. आहा, क्या कहना चाहता है कवि. देखो आंख तो गई है सूख, तो जो भी धूल आएगा जमा हो जाएगा, थोड़े आंसू थोड़े धूल, थोड़े आंसू थोड़े धूल, तो ऐसा लगेगा कि सागर की लहरों पर रेत की परत है. Sand on tide, because the eye is dry, so all the dust particle will deposit on the eye, and then there will be some tear, some dust, some tear, some dust, so it will look like sand on tide appearance. This is the first sign, conjunctival xerosis. Now the question is, if an ASA or a health worker has to find it in the village, can they go deep into the eye and look conjunctival xerosis? No. So what we use for screening? For screening, we use bite spot. First sign is conjunctival xerosis, and first symptom is bite spot. First symptom is night blindness, sign is xerosis, and what we do for screening is bite spot. Now, very good that you answered this question correctly. There is a very good question which comes from this part. The question is that if you want to know vitamin A is a public health problem or not, to know this vitamin A is public health problem or not, what should be the prevalence of night blindness and what should be prevalence of bite spot? So vitamin A is a public health problem if vitamin A is a public health problem if bite spot is in more than 0.5% people, and night blindness is in more than 1% people. So this is 0.5 and 1. कैसे याद रखोगे? देखो, नाइट ब्लाइंडनेस मरीज आके बता देगा तो ज्यादा मिलेगा 1%. बाइट आउट स्पॉट तो आपको स्क्रीनिंग के लिए खोजने जाना पड़ेगा, तो कम होगा 0.5. नाइट ब्लाइंडनेस पीपल कम एंड टेल, सो इट इज मोर 1%. बाइट आउट स्पॉट you have to go and search, so it is less 0.5. Second way to remember, B is second alphabet, 1/2 is 0.5 anyway, like that also you can remember. So bite out 0.5, night blindness 1. Tricky one, but I hope you will remember. Chalo, now let's come to our next question. The next question is, in a hospital you want to, 3:20 is the time, so now we will have to stop it, the session, hai na? It was still 3 only. I missed, I was in the flow, I missed. So the question is, you want to know whether doctor is spending more time on patient management or without patient management. So if you want to know how much time is given for patient management, how much for other work, which sampling will you do? Answer is work sampling. Work sampling. if you compare people based on time taken to do work, this is work sampling. Okay, so suppose you have to choose two surgeon, out of two surgeon, one surgeon you have to choose. One method to choose is you can take feedback from group of people where they work. Okay, so if you take feedback from group of people, this is known as Delphi method. And because let's say if you choose only one feedback, they can be biased, they can give you wrong. So group method is Delphi method, one method to choose out of two surgeon. Second is you will ask both of them that, okay, I will give 3.5 lakh salary to both of you. Then who will be more effective to our hospital? Who will be more useful? So if you are comparing cost effectiveness, salary is same. You want to know who will do the extracurricular work, effectiveness, है ना? Like what extracurricular work will doctor do? He will not dance or something. Na? He can do campaigning, he can do publicity and other thing. So if you are comparing cost effectiveness based on extracurricular work, this is known as system analysis. System analysis means system फाड़ देंगे नहीं. Comparing cost effectiveness is system analysis. And last thing is work sampling, कि आप दोनों डॉक्टर को बुला के सर्जरी कराओ. मान लो एक डॉक्टर ने सर्जरी किया 1 घंटे में, दूसरे ने किया 10 मिनट में, तो वर्क सैंपलिंग कहता है कि 10 मिनट वाले को चूज कर लो, है ना. इफ वन डॉक्टर इज डूइंग हर्निया रिपेयर इन 1 hour, अदर इज डूइंग इन 10 minutes, वर्क सैंपलिंग से that based on time taken to do less work, choose the one in 10 minutes. But maybe it's not always correct to choose the 10-minute person, because suppose the one who is connecting, doing hernia repair in 10 minutes, maybe he is connecting the wrong wire together, and now whenever patient cough, he had an erection, है ना. जब भी patient खांस रहा है उसका खड़ा हो जा रहा है. तो 10 minutes is not always a good strategy to choose. That's why we can use all the three methods to select out of two doctor. Remember, group method is Delphi, cost effectiveness comparison based on extracurricular work is system analysis, and work taken to do work, time taken to do work is compared by work sampling. Okay, so I will end my session here. On 14th, I will again come with my revision of FMGE notes, and there I will cover every theory thing. Plus, if you have any doubt, anything, any question you want to ask, feel free. I have given you my number. You know this PW Telegram group. You can join. The logo is there in this thing, which we will forward it to you. Let me know if I can be of any help to you. Okay, and don't forget to do 5-7 year of NEET with 2-3 revision and 200-300 question practice each day till your exam day, on the same time when the exam is there. Okay, love you all. Thank you so much. Update latest information. Okay, in the next visit when I will come with some latest information also, which they will not ask in exam, but if you ask, I will still give it to you. Okay, thank you so much. Bye bye. Bye bye. Good night. Good evening.
Yes. Good evening, everyone. It has been a long day for you. So let us start with our pediatric revision for your FMGE workbook. Previously, you were finding it difficult to understand my handwriting, so I made it clear that it was in a PowerPoint mode. So it will not be tough for you at present to understand the concepts and the answers. Predominantly, it is meant as a one-liner, so that just revise, go and uh, instead of memorizing, you can understand the fact and remember, and you can opt the answers in a very easy manner. So let me start my session without wasting much of your time. Right. So you have your workbook with you now. Right. So let me go to the first topic. What are all the important things that can be asked in neonatal resuscitation? So first point, as far as neonatal resuscitation is concerned, the questions mainly will be focused on what is called delayed cord clamping. What do you mean by delayed cord clamping? Anyone? So what do you mean by delayed cord clamping? So delayed cord clamping is nothing but you are clamping the cord 30 seconds to 1 minute after birth. 30 seconds to 60 seconds after birth is called delayed cord clamping, so that it will avoid the evolution of anemia in a term baby. So it is 30 seconds to 60 seconds after birth. Second point. Then there was a question regarding what is called sniffing position. What do you mean by sniffing position? Sniffing position is nothing but you are keeping the roll of towel under the shoulder blade, so that your nasopharynx, your oropharynx, and your trachea will be in a straight line, as a result of which there will not be any delay in the passage of air into the lung during resuscitation. So flexion of the neck and slightly extended the head is called as a sniffing position. Right? You need to keep the baby in sniffing position during resuscitation. And then you will be asking suctioning of which one should be done, whether suctioning of mouth or suctioning of nose. Whenever you do suctioning of nose, first what will happen? The secretions that are present in the mouth can go inside the trachea, as a result of which there are very high chances for the child to develop meconium aspiration. So as a result of which you need to do suction of the mouth followed by suction of nose. What we call it as M followed by N. And finally, what is this single most effective steps in neonates with apnea? So what is the answer? Single most effective steps in neonates with apnea. You all know that whenever you do resuscitation, in the first 30 seconds is meant for initial steps of resuscitation. What are all the initial steps of resuscitation? What are all the initial steps of resuscitation? Initial steps of resuscitation is getting the baby in a pre-warmed towel, keeping the baby under a radiant warmer, keeping the baby in sniffing position, suctioning of mouth followed by suctioning of nose. These things will take a minimum of 30 seconds after birth. The next 30 seconds will be meant for tactile stimulation, gentle tickling of palms and soles and spine. When the baby doesn't cry after 30 seconds of birth, instead of going for any other things, you need to directly go for answer. You need to directly go for answer. What is the answer? You need to directly go for positive pressure ventilation, otherwise known as bag and mask ventilation. So what are all the indications for positive pressure ventilation or bag and mask ventilation? When the baby is not showing, when the heart rate is less than 100 per minute. I repeat, when the heart rate is less than 100 per minute after 1 minute of birth, you need to do a positive pressure ventilation, right? So this is very, very important. Positive pressure ventilation is nothing but bag and mask ventilation, right? So whenever you do a positive pressure ventilation, invariably, that is bag and mask ventilation, people will be asking you what is the contraindication for positive pressure ventilation. So what is the answer? Yes, what is the answer? What is the contraindication for positive pressure ventilation? Anyone? So it is not meconium aspiration syndrome. Very good, Mahesh. Very good, Anushka. So it is not meconium aspiration syndrome. Previously, it was thought that meconium aspiration is a contraindication for positive pressure ventilation, but it has disproved now. Right now, the contraindication for positive pressure ventilation is, what is it? Positive pressure ventilation is congenital diaphragmatic hernia, and meconium aspiration syndrome is not a contraindication. So it is congenital diaphragmatic hernia is not a contraindication. Congenital diaphragmatic hernia is a contraindication, and not a contraindication is meconium aspiration syndrome, right? So what is the indication for chest compression? What is the indication for chest compression? Anyone? So what is the Ayushi, Mahesh, Anusha? What is the indication for chest compression? What is the indication? When the heart rate is less than 60 per minute. Very good. When the heart rate is less than 60 per minute, despite 30 seconds of bag and mask ventilation, you need to go for chest compression. And chest compression, previously it was either two thumb technique or two finger technique. But later they found that two finger technique will not produce adequate pressure over the xiphisternum, as a result of which it is universally two thumb technique right now. Right. So now the question is, only medication used for resuscitation. What are all the medicines that are used for resuscitation? What are all the medicines that are used for resuscitation? Apart from bag and mask ventilation or positive pressure ventilation and chest compression, what are all the medications that are used? The medications, anyone answer? Ayushi, Anusha, Mahesh. Indications for, what are the medications that they use in resuscitation? So usual available things are many. Previously it was methadone and so many things, but we are not using right now. Previously it was mentioned as oral. We are not using oral right now. Right now only three drugs are used. One is adrenaline, second one is normal saline, third one is O negative blood. I repeat, adrenaline, normal saline and O negative blood. Adrenaline available strength is 1 in 1000. I repeat, adrenaline available strength is 1 in 1000. That 1 ml of adrenaline is mixed with the 9 ml of normal saline to make it 1 in 10,000 adrenaline. That 1 in 10,000 adrenaline we give, okay, 0.3 ml. I repeat, that 1 in 10,000 adrenaline we give 0.3 ml. Either it can be given through intravenous route or umbilical vein or endotracheal route. If nothing is possible, it can be given through intraosseous route. So any route can be preferred for adrenaline, but the dose of adrenaline is thrice the dose of IV adrenaline when it is used over endotracheal tube. Remember, previously we were using oral, but we are not using oral. In fact, oral has become a contraindication during resuscitation. The reason is, any child who has undergone birth asphyxia will be having some kind of acidosis. So when you use oral, it will lead to again increasing the lactic acid content in the blood and leading to deterioration of the baby during resuscitation. So oral is not used at present. Methadone is not used in Indian standards. What we use is 1 in 10,000 adrenaline, O negative blood as well as normal saline. 10 ml per kg of normal saline if the child is in profound shock, or 10 ml of O negative blood if the child is not responding to normal saline. Right. Then comes 1 in 10,000 dilution. Very good, Ash. Very good. Right. Now I will ask you one more question that was not asked in the workbook. So the question is, you are starting positive pressure ventilation. I repeat, you are starting positive pressure ventilation. That means bag and mask ventilation. After 15 seconds of positive pressure ventilation, heart rate is not rising. What will you do? Heart rate is not rising. What will you do? Yes. Anushka, Vai, Ashwi, Harsh. Heart rate is not increasing after 15 seconds of positive pressure ventilation. What will you do? I am waiting for your answers. Heart rate less than 100 per minute, you start chest compression, adrenaline. What happened to you, my dear boys and girls? The question is, heart rate is more than 100 per minute, you don't do anything. Heart rate is between 60 to 100 per minute, you do positive pressure ventilation. heart rate is less than 60 per minute, apart from positive pressure ventilation or endotracheal tube, endotracheal intubation, you start chest compression. The question is, you do positive pressure ventilation, 15 seconds after that the heart rate is not increasing. What will you do? What will you do? No, it is not the answer. It is not the answer. So what is the answer? Let me tell you right now. So it was told that heart rate less than 100 per minute, you start bag and mask. You start bag and mask ventilation. One. The second question is, heart rate 60 to 100 per minute, you continue bag and mask ventilation. Yes, you are correct. Heart rate less than 60 per minute, my kids know that they are going to start chest compression along with the bag and mask ventilation. By this time you should have intubated the child, but the question is, heart rate less than 600 per minute but more than 60 per minute, but heart rate not rising with PPV. That is the question. So what is the answer? Let me see whether any answer is there or not. Continue chest compression? No. Wrong. Anushka is saying chest compression? No. Mahesh? No. Harsh? No. Siddiq, adrenaline. Again, Harsh is trying to answer something. Anushka trying positive ventilation. Mahesh is saying invasive ventilation. Somehow or other, Mahesh is little bit correct. But what you need to do is Mr. Sopa. I repeat, what is called as Mr. Sopa? What do you mean by Mr. Sopa? M starts for what? So M means what? R means what? S means what? O means what? A means what? So Mr. Sopa. What do you mean by Mr. Sopa? M stands for mask. You need to snugly fit the mask, covering the nose as well as the mouth. So first M stands for mask. R stands for reposition of neck. The neck should be in extended posture. The neck should be in sniffing position so that your nasopharynx, oropharynx and trachea should be in the straight line. Very good. And the S stands for what? Suction. Suctioning of mouth followed by suctioning of nose. You need to know whether you have done adequate suctioning or not. That is suctioning. Then O stands for what? Mr. Sopa. O stands for what? Adequate opening of mouth. Adequate opening of mouth. So without opening the mouth, if you do bag and mask, how the air will go inside the trachea? Unlikely, na? So opening of mouth. And then P for adequate pressure. P for adequate pressure. You need to put adequate pressure. And finally, as Mahesh son of Krishna told, invasive ventilation. Yes, invasive ventilation means it is of two things. One, if you are able to put endotracheal tube, you can put endotracheal tube. But you are a new intern and you cannot put endotracheal intubation, then you need to go for laryngeal mask airway. You need to go for what? Laryngeal mask airway. So that's it. So the question right now is, if the heart rate is more than 60, less than 100, it should increase with positive pressure ventilation. If it doesn't increase with the positive pressure ventilation, always remember you need to do Mr. Sopa, right? Reposition of mask, reposition of neck, suctioning of mouth, open the mouth, adequate pressure, and then if nothing is possible, either you need to intubate the child or you need to use laryngeal mask airway before starting chest compression. Okay? Right. So this is over. Right. So you need to know what is called Mr. Sopa when it should be done. Right. And what other things? One more question they can ask you. Let me say the child is having labored breathing. The child is having labored breathing. Okay. The child is having cyanosis. The child is having labored breathing. The child is having cyanosis, but the heart rate is more than 100 per minute. What will you do at present? Yes, waiting for your answer. Anushka, Mahesh, Arsh. Yes. What is your answer? Labored breathing, cyanosis, but the heart rate is more than 100. Less than 100, invariably you will start your wagon mass, but the heart rate is more than 100, but child is having labored breathing and cyanosis. Answers. Waiting for your answer. Yes, what will you do? Waiting for your answers, my dear boys and girls. Say something. The child is having labored breathing, the child is having cyanosis, and the heart rate is more than 100 per minute. One labored breathing. Labored breathing means there is no adequate chest rise. This is good chest ride, but if the child is not having good chest rise and the child is having cyanosis, but the heart rate is more than 100 per minute, so what will you do? It is there in the neonatal resuscitation chart. So what is it? Anyone? I am waiting for your answers. So this is where you will do CPAP, continuous positive airway pressure. Please write. So this is where you need to start CPAP. Continuous positive airway. Very good, Dr. Mysterio. Very good. CPAP. CPAP is continuous positive airway pressure. So remember, as far as neonatal, as far as newborn is concerned, two places where you need to consider CPAP. One, heart rate is during neonatal resuscitation. Heart rate is more than 100 per minute, but labored breathing and cyanosis. One indication. Another indication is, so this is one indication. Okay. Another indication is, one more indication is hyaline membrane disease. Another indication is hyaline membrane disease. So what is that, a hyaline membrane disease? Hyaline membrane disease is whenever you see a preterm, the child can develop respiratory distress syndrome because of poor surfactant. So invariably, when any child with the preterm under respiratory distress, you will start surfactant administration. It is not so. For all cases of preterm with the mild respiratory distress with a Downey score of mild respiratory distress with a Downey score of Downey score between less than 4. Downey score mild, moderate, severe. Severe is more than 7. Moderate is 4 to 6, where up to 4 it is mild respiratory distress. In mild respiratory distress, there is no need for any surfactant. You can just start CPAP. So there are two indications for CPAP as far as neonatology is concerned. One is, as I told you already, labored breathing, cyanosis, and heart rate more than 100. Whereas in preterm with the mild respiratory distress, you can start CPAP instead of surfactant. Now another question is if the Downey score. So let me finish it right now. Downey score, very very important. So Downey score or respiratory distress syndrome. So if the Downey score is less than 4, 4 to 6, whereas 7 to 10. Downey score less than 4, start CPAP alone, continuous positive airway pressure. 4 to 6 means you start CPAP, it is not working, then the Downey score is increased to 4 to 6. Then what will you do? Ensure. What is called ensure, my dear boys and girls? Ensure is you are intubating the child, you are giving surfactant, and then you are extubating, so intubate, surfactant administration, and extubate, ensure. And still if ensure fails, it means your Downey score will increase to 7 to 10. Then you will do mechanical ventilation, and then you give surfactant administration. So what are all the points in Downey score? The points in Downey score are respiratory rate. Second one is retractions. Third one is cyanosis. Fourth one is air entry. Fifth one is grunting, audible sound. These are all the 5 parameters in Downey's score, right? So we have learned some new things today with respect to neonatal resuscitation. Please do not forget about that indication for CPAP, and please do not forget about the indication of Mr. SOPA, right? Right. So again, let me come again with some more points on neonatology. Now, some important aspects. You will not escape any question without reading vitamin deficiencies, in particularly in FMGE. This must be very, very easy for you. Start. So which micronutrient deficiency that can occur with microcytic hypochromic anemia not responding to iron, and it is associated with neutropenia and hair depigmentation? Answer. So answer: Mysterio, Harsh, Anusha, Harsh, Mahesh. Wait. So tell me, what is the answer for? So what are all the causes for? What are all the causes for microcytic hypochromic anemia? You all know microcytic hypochromic anemia means what are all the causes? Tell me. It is not that tough. Mahesh, fantastic. Mahesh, fantastic. So it is copper deficiency. That's it. Fantastic, Mahesh. Copper deficiency. So it is copper deficiency. Apart from that, what are all the causes for Minky? No, it is copper deficiency. Okay. So what are all the causes for microcytic hypochromic anemia? One is CETA. People used to say CETA. Sideroblastic anemia. I stands for iron deficiency anemia. T stands for thalassemia intermedia. A stands for anemia of chronic disease. Sita everyone knows, but many forgets the point copper deficiency. Many forget the point about copper deficiency. Very good. So the answer is copper deficiency. Remember IRIDA. What is called IRIDA? Iron resistant iron deficiency anemia. Okay. So remember, when it is associated with neutropenia and hair depigmentation, you need to consider an underlying copper deficiency. Right. So one, correct, copper. Second, hypocalcemia, tetany, not responding to calcium infusion. Many of you know about that Trosius sign, etc. Swastak sign, etc. My question is, the child is having a serum calcium of, the child is having serum calcium of less than 8 milligram per deciliter, and you are giving IV calcium gluconate, but still the child is not responding to calcium. What is the answer? What is the answer? Peaceful world, you don't worry, just listen to this. I will change the pattern of the background and I will post a separate PDF for you. Don't worry, my dear. Okay, vitamin D deficiency, absolutely not. Hypocalcemia cause, one of the cause is vitamin D deficiency. You are correcting calcium with tetany. You are correcting tetany with calcium, but the child is not responding. What is it then? So it is hypomagnesemia. It is no. Everyone knows. Everyone knows that calcium deficiency leads to tetany. Whenever you get tetany, you need to give 10 ml per kg of calcium gluconate IV infusion over 2 hours. But even after giving IV calcium gluconate, if the child is not responding, you need to think in terms of underlying hypomagnesemia. Very, very important. Right. So then, what are all the things associated with the cardiomyopathy? This was asked twice. Cardiomyopathy, dilated cardiomyopathy. Vitamins that are associated with the cardiomyopathy. Vitamins and micronutrients that are associated with cardiomyopathy. Anyone? Harsh Rawat, very good dear. It is magnesium deficiency. Cardiomyopathy associated micronutrient. Waiting for your answer. Anushka, Harsh, Mysterio. Cardiomyopathy. Which produces cardiomyopathy? Very, very easy. It starts with B. It can be either dry or wet. What is dry? What is wet? Harshravat, no, my dear. Cardiomyopathy is not produced by vitamin K. No, hypokalemia will produce cardiac arrest. That is different. Which produces dilated cardiomyopathy. Very good, Mahesh. It is apart from thiamine. Apart from thiamine, the correctable causes for dilated cardiomyopathy are, remember, calcium deficiency. It is not potassium. It is thiamine, calcium, carnitine, magnesium. Look at this. Selenium. What happened? None of you had opted for thiamine. Okay, Divya, yes, very is correct. Very is correct. Peaceful world, okay. Sarath thiamine, Arshravat thiamine. But remember, my dear kids, apart from thiamine, you all know that selenium deficiency can produce Keshan's cardiomyopathy. Hypocalcemia can be a subtle, your dilated cardiomyopathy can be a subtle manifestation of dilated cardiomyopathy, hypophosphatemia, and remember carnitine. So please do not forget the micronutrients and vitamins and minerals that are associated with the dilated cardiomyopathy are thiamine deficiency, carnitine deficiency, calcium deficiency, phosphorus and selenium. Very good. Now let me go to the next question. Glucose intolerance. You all know it is not that much tough. Which micronutrient deficiency is associated with the glucose intolerance? So that it can be used at times with the diabetes mellitus. But it is a drug under research purpose only, not in routine practice. What is it? Harsh, Sarath, Peaceful World, Divya, Mahesh. No, Chirag. Chirag must be slow right now. It is not Chirag. What is it? The question is which micronutrient deficiency is associated with the glucose intolerance. I can't give you so much of time because we need to go for the next questions to finish it within 2 hours. Tell me, dear. It is chromium. Very important. Please do not forget. Glucose intolerance is associated with chromium deficiency. It was asked twice in INICET also. Chromium deficiency is associated with glucose intolerance. Right. Let me go to the next common vitamin deficiencies. Now tell me which micronutrient deficiency is associated with hypogonadism, reduced cell-mediated immunity, periorifacial and perianal erythematous rash. It is not that tough, I think. To Mahesh, Harsh, Divya, Sharad, Peaceful World, Chirag. Which micronutrient deficiency is associated with? Yeah, it's very easy. It is zinc. Okay, very easy. It is zinc. Okay, so which one is associated? Which micronutrient deficiency? Yes, I agree. Acrodermatitis enteropathica. Which micronutrient deficiency is associated with the neonatal goiter? Second, let's go for the second question of this slide. Which micronutrient deficiency is associated with the neonatal goiter? Waiting for your answer. Not that tough. Because the most common cause for hypothyroidism in newborn is thyroid dysgenesis. I repeat, my dear boys and girls, the most common, what are all the causes for chromium? I think Chirag has here. I think the coverage for Chirag is low. Okay, no problem. But I appreciate your answer and attempt. Iodine deficiency. Okay, right, as many told, neonatal goiter is associated with the 3 conditions. One is endemic iodine deficiency. The second one is maternal antithyroid antibodies. The third one is dysharmonogenesis. Dysharmonogenesis is nothing but you all know that The rate limiting step is thyroid peroxidase, and many other enzymes are involved in the production of T3 and T4. So whenever there is a problem in any of these enzymes concerned with the production of T3 and T4, that is otherwise called dysharmonogenesis. So three conditions that can produce neonatal goiter are: one is endemic iodine deficiency, the second one is maternal antithyroid antibodies, the third one is dysharmonogenesis. But the most common cause for neonatal hypothyroidism is thyroid dysgenesis, in which thyroid will be visibly absent on palpation as well as absent on ultrasound also. I repeat, the most common cause for congenital hypothyroidism is thyroid dysgenesis, right? Very good, Peace World. It is iodine deficiency, right? Now tell me, what is the one that is associated with the hemopericardium? What vitamin deficiency is associated with hemopericardium? Hemopericardium means you have accumulation of blood in the pericardial area. Which vitamin deficiency is associated with this? Ashravat says vitamin C. Apart from that, why is it so, my dear boy? Okay, yes, very good. Hemopericardium is associated with two vitamins are associated with bleeding. What are all they? Two vitamins. So whenever someone is bleeding, two vitamins are involved. Two vitamins. So what are all the vitamins? Very good. So one is vitamin K deficiency. Another is vitamin C deficiency. So, but in vitamin K deficiency, what will happen? Your prothrombin time will increase and your partial thromboplastin time will increase. Then you can consider vitamin K deficiency. In vitamin deficiency, your prothrombin time will be normal and the partial thromboplastin time will be normal. So, when a child is bleeding, look for prothrombin time and partial thromboplastin time. When both are normal, look in terms of vitamin C deficiency, because step 1, what is step 1? Vasoconstriction. Step 1 is vasoconstriction. So for vasoconstriction, you need to have a good collagen. Collagen should contain a good cross link. So that cross link is produced by hydroxylation of vitamin C. So when there is no cross linking, you will have bleeding manifesting as, apart from hemopericardium, what else can occur? It can occur with what? It can occur with bleeding into the joint, hemoarthrosis. It can present with gingival bleed. It can present with gingival bleed. It can present with poor wound healing. Which one? Vitamin C deficiency. So vitamin K deficiency and vitamin C deficiency are associated with bleeding. Can anyone tell me which vitamin excess can lead to bleeding in? So this is deficiency. Which vitamin excess can lead to bleeding in newborn period? Waiting for your answer. Which vitamin excess can lead to bleeding in newborn period? I will give you a gift through PW if you answer this. Which excess of which vitamin? That's it, Mahesh, you are correct, my dear boy. A gift will be parceled to your home. Okay, message your address, please. It will be sent from my side. So vitamin E excess, the excess can lead to bleeding because it antagonizes vitamin K. Which one? Your vitamin E excess vitamin E antagonizes vitamin K. So this is very, very important. You can take a screenshot if you want. Okay, again, since you mentioned hemorrhagic disease of newborn, so three things are very important with respect to hemorrhagic disease of newborn, which are mainly due to vitamin K deficiency. One is early hemorrhagic disease of newborn. which is due to it is mother taking some drugs, mother on anti-vitamin K drugs. Either it can cause, either it can be ATT, anti-tuberculous drug, or anti-convulsion therapy, phenytoin 1. Second one is classic HTN. This early onset HTN occurs within day 1 after birth, whereas classic hemorrhagic disease of newborn usually occurs from 1 to 6 days. 1 to 6 days. Yes, mother on warfarin. Okay. 1 to 6 days. Which one? Classic HTN. This is due to not giving vitamin K at birth. This is due to not giving vitamin K at birth. This is classic HTN. But what is called late onset HTN? Late onset HTN. What is called late onset HTN? Late onset HTN, anything that occurs after 7 days of life is called late onset HTN, and this late onset HTN is mainly due to malabsorption or neonatal cholestasis. Neonatal cholestasis. Malabsorption or neonatal cholestasis. One such cause is cystic fibrosis. Okay, one causes cystic fibrosis. Okay, take a screenshot if you want, because hemorrhagic, and remember this late onset HTN is prone to present with intracerebral hemorrhage. Very, very dangerous. The child may die. Intracerebral hemorrhage is the manifestation of late onset HTN, whereas classic HTN and early onset HTN usually presents with gingival bleed. They can present with umbilical bleed, or they can present with hematemesis. But the dangerous intracerebral hemorrhage is the manifestation of late onset HTN. Late onset HTN means hemorrhage that occurs after 7 days of life due to vitamin K malabsorption. The most common at present is, one is prolonged antibiotic use. Second one is cystic fibrosis. Okay, I'll wait 6 seconds. Take a screenshot of this slide. 1, 2, 3, 4, 5, 6. That's it. Let me go to the next question. Right. So, hemopericardium, as my children had already mentioned, vitamin C, hemolysis in preterm. Hemolysis in preterm. So, for term we saw hemolysis in preterm is what? Can anyone answer? Hemolysis in preterm. Harsh, Mahesh, Sarath, peaceful world. Hemolysis in preterm is due to what? Hemolysis in preterm means it usually occurs less than 32 weeks, because the RBCs are fragile. RBCs are fragile. So very good, peaceful world. RBCs are fragile. So vitamin E is an antioxidant. Hemolysis in preterm is mainly due to vitamin E deficiency. Very good. Right. Now the next question is, what is the dosage of vitamin A in a 8-month-old child? What is the dosage of vitamin A in 8-month-old child? Waiting for your answer. Dosage of vitamin A in a 8-month-old child. 1 lakh. 1 lakh. Okay. So less than 6 months it is 50,000. 6 months to 1 year 1 lakh, and more than 1 year it is 2 lakh. Very good. Not such a tough question. Leave it. 1 ml of vitamin A solution contains how many units of 1 ml of vitamin A solution contains how many units of vitamin A? 50,000, 1 lakh, 2 lakh. 1 ml of vitamin A solution. Yes, Srini, it is not that tough. It is 1 lakh. 1 ml contains 1 lakh. So not a tough slide for you. Okay, right. Going for the next one. So bleeding in newborn we have already discussed. Hemorrhagic disease of newborn we have already discussed in detail. So leave it then. Leave it then. No, 1 ml contains 1 lakh international units. Harsh and the peaceful world. Okay, ataxia associated with which vitamin deficiency? Ataxia is associated with which vitamin deficiency? Ataxia is associated, DRX correct. Harshravat said B12. I mean, we are not speaking, yes, Harshravat, one way or other, you are correct. I will ask you, I will put forth two questions. One is, no. I will put forth two questions. One is, what are all the water soluble vitamins and what are all the fat soluble vitamins? Many says ataxia in pediatrics. I am not asking. Peripheral neuritis is a common manifestation, dry beriberi, but ataxia is more commonly due to, in our pediatrics book, 𝐒𝐿, what happened to, okay, Korsakov? No. See, remember, this is not adult. In adults, you can think in terms of one is B12, subacute combined degeneration of spinal cord. Second one, you can think in terms of dry beriberi, peripheral neuritis. It produces vitamin B1 thiamine deficiency. I agree. But in pediatrics, whenever you say an unexplained ataxia, apart from vitamin B deficiency, thiamine, apart from your what is that B12, you have answer. I will give you an answer. No, all of you are wrong. B1 can be answer, dry beriberi, peripheral neuritis. I agree. B12 subacute degeneration of spinal cord. Yes, I agree. But in pediatrics, your RB, your myelin is made up of, your nerve tract is made up of myelin. Myelin requires an antioxidant. So if antioxidant is not there, myelin will be degenerated, leading to ataxia. So what is the answer? Yes, the highest in the world. You are correct, my dear boy. It is vitamin E deficiency. So as far as pediatrics questions are concerned, it is very little bit tricky when compared to an adult question. So ataxia associated with vitamin deficiency is vitamin E, and it is not thiamine or not B12 as far as pediatrics is concerned, right? But you can have in your mind when other symptoms and signs are present. So what is called burosumab? What is called burosumab? What is called burosumab? Answer. No problem. See, isolated ataxia is the manifestation of vitamin E deficiencies. Whereas other manifestations like hyperpigmentation in case of B12 deficiency, megaloblastic anemia, or in case of thiamine also you can get the megaloblastic anemia. Those picture, apart from ataxia, other manifestations will be given. Pure ataxia is a manifestation of vitamin E deficiency. Harshravat, you are correct, my dear boy. Burosumab is monoclonal antibody used against fibroblast growth factor with is a potent phosphotonin and causing X-linked hypophosphatemic rickets. Correct. Remember, X-linked hypophosphatemic, remember you use Joule solution which contains phosphorus. Second, but the drug of choice has now become burosumab. And here, remember here it is dominant. It is X-linked dominant. They can ask you this question. It predominantly involves lower limb rather than upper limb. This question can also be asked. It predominantly involves lower limb rather than upper limb. Next, other question that they can ask you is, it is associated with the dental abscess. It is associated with dental abscess. Whereas your BDDR type 2 rickets is associated with alopecia. Right? And the most often famous question, which the next one, the most often famous question is, vitamin deficiency is associated with alopecia along with the neuroregression. The child is having neuroregression by about 6 months, lost all the milestones, and you are using multiple anticonvulsant to control the seizure, but it is not controlling, and the clue was alopecia. So alopecia and neuroregression is associated with which vitamin deficiency? This question was asked plenty of times in your institutional questions. What is that? Tell me. Which vitamin deficiency is associated with alopecia and neuroregression? No, it is not so, my dear peaceful world. It is not so. That is associated something related to egg. Something associated to egg. Avidin. So what is the answer? B6 is pyridoxine. No, it is not vitamin E. When you boil that vitamin, that avidin will be gone, so that vitamin will be biotin. The answer is biotin. Remember, my dear boys and girls, there are only few correctable causes for inborn errors of metabolism with the help of cofactors or vitamins. One such deficiency is biotin deficiency. An important clue is any child with developmental delay and neuroregression, you need to look for presence or absence of hair. Absence of hair invariably in terms of biotin deficiency, otherwise known as multiple carboxylase deficiency. Very, 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 very important. Any child with developmental delay, neuroregression, look for alopecia. It is biotin or multiple carboxylase deficiency unless otherwise proved. Right. Now another question. In which anemia you will have hyperpigmented knuckles? In which anemia you will get hyperpigmented knuckles? Answer. Okay, you are absolutely correct. It is B12 deficiency. Hyperpigmented knuckle is a manifestation of B12 deficiency. You are correct. Right. Then Srini, in which case you will get macrocytic megaloblastic anemia? Macrocytic megaloblastic anemia. Is it only B12 or something else? DRX. Is it only B12 or something else? Macrocytic megaloblastic anemia. Folic acid. So remember, my dear boys and girls, whenever you have an MCV of more than 100 femtoliter, MCV of more than 100 femtoliter, you need to look for hypersegmented neutrophils. You need to look for hypersegmented neutrophils. Okay, so more than 6 lobes. When hypersegmented neutrophils are present, it means it is megaloblastic. It means it is megaloblastic. Then you have 3 deficiency: B12 deficiency, folic acid deficiency, and then you have hereditary orotic aciduria. I don't think you will be asked that question. Hereditary orotic aciduria. These 3 things are associated with macrocytic megaloblastic anemia. Whereas when you don't have this hypersegmented neutrophils but the cells are large, means it can occur in liver disease. It can occur in hypothyroidism. It can occur in hypothyroidism. So, 2 conditions are associated with the macrocytic anemia. Okay, can you make background white? Okay, I'll change it. Don't worry. So, I'll change with this. So, right, liver disease, hypoproteinemia, and the last one more question. Okay, so one more question is, so macrocytic megaloblastic anemia is B12 and folate. Now tell me how to differentiate between B12 and folate. How to differentiate between B12 and folate? Tell me. How to differentiate between B12 and folate? I'll give you a treat if you tell the answer. Already one parcel is waiting. How to differentiate B12 and folate? So remember methyl malonic acid. Methyl malonic acid is increased in case of B12 deficiency. I repeat, methyl malonic acid is increased in case of B12 deficiency, whereas in folate it is not, because methyl malonyl CoA is converted to succinyl CoA with the help of B12. So when B12 is absent, methyl malonic acid is increased in B12 deficiency. Very, very important. Remember, it is not the Schilling's test. It is the investigation of choice. The investigation or the screening test of choice for B12 deficiency is methylmalonic acid levels in the urine or blood. I repeat, it is not Schilling test. The screening test of choice for B12 deficiency is methylmalonic acid in urine. Right? Okay. Now, very, very important, often asked questions. What is this? So let us go fatafat. Noisy breathing. One question you will be asked on noisy breathing. Let me make clear. What is called stutter, snoring, stridor, rattle, grunting, wheeze? Very, very important. So remember stutter. What do you mean by stutter? Stutter is this sound. This sound is called stutter. So stutter is predominantly an inspiratory sound. Where is the site? Presence of, you have running nose. Now whenever you have a running nose, you will have this kind of sound. This is called stutter. So the site is nose. Etiology is acute viral coryza. That is viral coryza. Acute viral coryza. This is called stutter. So it is not an expiratory sound. So what is called snoring? This is called snoring. Again, snoring is an inspiratory sound. It is not an expiratory sound. Where is the site of pathology? The site of pathology is nasopharynx. The site of pathology is in nasopharynx. Nasopharynx. Okay, what is the commonest cause in pediatric age group? The commonest cause in pediatric age group is adenoid. Commonest cause in pediatric age group is adenoid. What is called stridor? This is called stridor. Again, stridor is inspiratory. It is not expiratory. Stridor is inspiratory. The site of pathology is in larynx. For your level, it is larynx. Larynx, and the most common cause is laryngomalacia. Most common cause is laryngomalacia. Common is laryngomalacia. Very good. And it also can be congenital or acquired. Congenital is laryngomalacia. Acquired is croup or ALTB. Rattles. Rattles is again inspiratory. And the site of pathology is in large airways. Large airways. That is trachea. Mainly due to presence of secretions in trachea. Secretions in trachea. And finally grunting. So grunting and wheeze are both expiratory. Grunting and wheeze are both expiratory. So this question can be asked for you with respect to all the following are except. So grunting is expiratory, both grunting and wheeze. Grunting usually occurs, so expiratory, they are not inspiratory. Grunting means it is due to alveoli issue or parenchyma, that is lung parenchyma. Etiology for grunting is usually pneumonia, or it can be due to hyaline membrane disease in newborn. Whereas wheeze, it is again an expiratory sound, it is not an inspiratory sound. Remember, my dear boys and girls, wheeze means two things. One is monophonic wheeze, another is polyphonic wheeze. Wheeze, the site of obstruction is bronchus. Wheeze, the site of obstruction is bronchus. Monophonic means you are hearing the same tone of wheeze in each and every part of the chest. It is suggestive of foreign body. Monophonic wheeze is suggestive of foreign body, whereas polyphonic wheeze heard here with one pitch, here with one pitch, here with one pitch, different pitches in different areas. That is asthma. That is asthma. So stutter, stridor, snoring, rattles, inspiratory, whereas grunting and wheeze are expiratory. In wheeze, monophonic wheeze is mainly due to foreign body, whereas polyphonic wheeze is mainly due to asthma. Okay, don't worry. So you can take a screenshot right now. Okay, right. Then let us go to the next one. What is this? Colostrum milk, transition milk, and mature milk. Answer. Colostrum is, what is the first vaccine that we are giving to the baby? What is the first vaccine that we are giving to the baby? The first vaccine that we are giving to the baby is not your BCG, not your OPV, not your, what is that? Hepatitis B. The first vaccine that we give to our newborn is colostrum. Okay, colostrum is very thick. First 4 days, very thick. It is rich in immunoglobulins and vitamins. So the answer is it is rich in immunoglobulin. That's why it is called as first vaccine. Transitional milk, it is rich in sugar and fat. Rich in sugar and fat. Sugar rich, fat rich. Whereas mature milks usually from 2 weeks. Colostrum in the first 4 days. Transitional milk in the second half of the first week to second week. And after second week, you will get mature milk. Mature milk is relatively thin and watery. Mature milk is relatively thin and watery. Is relatively thin and watery. Right, very good. Next comes, what is that? Fore milk. Fore milk. What is the difference between fore milk and hind milk? What is the difference between fore milk and hind milk? Waiting for your answer. What is the difference between fore milk and hind milk? Fore milk is meant for what? Hind milk is meant for what? Waiting for your answers. Fore milk is meant for what and hind milk is meant for what? Fore milk is the milk that is produced in the initial part of the suction from the breast. Fore milk is predominantly meant for thirst. Very good. Water, water, water. It quenches thirst. Whereas hind milk is the one which comes in the later part of the secretion, and it is predominantly what? Rich in fat. So it is energy rich, so that the appetite will be reduced. So one which quenches thirst is fore milk. One which quenches appetite is your hind milk. Very good. You are all confident. Going to the next. Compared to cow milk, breast milk has. So you have two things. One is lactone, one is protein, one is fat, and one is vitamin deficiency. My question is, compared to cow milk, breast milk has more lactose, more protein, more fat, or vitamin deficiency. Which one? So the lactose is more in breast milk or cow milk? The lactose is more in breast milk or cow milk? Very good, Srini. The lactose is 7/5. So 7 grams in case of breast milk and 5 grams in case of cow milk. So 7 grams in case of breast milk and 5 grams in case of cow milk. Cow milk. Protein. Protein is more in case of cow milk, less in case of breast milk. So 1 gram in case of breast milk, whereas 3 gram in case of protein. But whey protein is more in whey protein, which is easily digestible. Whey protein is more in breast milk, whereas the much allergic casein protein is in cow milk, which is very much allergic. Which one? Casein. Right, fat. With respect to fat, both the human and cow milk contain one and the same, 4 gram each. Vitamins deficiency associated with the breast milk are, one is vitamin D. One is vitamin D. Vitamin D usual requirement is 400 international units in the first first year, and after first year it is 600 international units. Okay, vitamin deficient in breast milk is vitamin D, that's why it has to be given up to 2 years. Vitamin K is present in breast milk, but it takes some time for the intestinal flora of the child to produce vitamin K. Till then, there are chances for the child to die because of bleeding. So invariably, all term babies are given 0.1 milligram of vitamin K intramuscular thigh immediately after birth. In case of preterm, we are giving 0.05 milligram of vitamin K intramuscularly in thigh. 1 milligram, 0.5 milligram, 0.05, 1 milligram and 0.5 milligram. So this is not that easy. And no question in a newborn will be completed without any surgical condition, associated conditions. So what are all they? So fatafat, start answering. This is not that tough for you. You can start answering one by one. Okay, I'm waiting for the slide to open. Shall I? Okay, newborn with the cough while feeding and frothing. That is not a tough answer. Fatafat. Tracheoesophageal fistula. Very easy. Newborn with bilious vomiting. Only 6 seconds will be given. 1, 2, 3, 4, 5, 6. No answers. Newborn with bilious vomiting is no. Pyloric stenosis is non-bilious vomiting. Esophageal atresia, non-bilious vomiting. Duodenal atresia is non-bilious vomiting. Newborn with bilious vomiting is malrotation with volvulus. The answer is malrotation with alveolus. Twisting of the stomach. Okay, it is not pulmonary, it is not pyloric stenosis, it's not esophageal atresia, not duodenal, all of them are non-bilious. So what is this? Newborn with respiratory distress and reduced air entry on one side. What is that? Mahesh, you tell me. Newborn with respiratory valve. Very good, Arjun. Very good, very good. Newborn with respiratory distress and reduced air entry on left infrascapular area. Congenital diaphragmatic hernia. Okay, very good. If it is congenital, so what are all the things that you need to know, my dear? Let me see. So reduced air entry. The question is reduced air entry. Reduced air entry means the possibilities are, I repeat, my dear boy, there are 3 possibilities. One is congenital lobar emphysema, another is congenital diaphragmatic hernia. Very good. Another is pneumothorax. There are 3 possibilities you can think of under pneumothorax. So 3 possibilities or you can answer with respect to a newborn with respiratory distress and reduced air entry, particularly left infrascapular area, because congenital lobar emphysema is often asked question in FMGE and NEET. It usually presents with a newborn with minimal respiratory distress, and when you auscultate, air entry will be reduced. Air entry will be reduced in all these conditions. But in case of congenital diaphragmatic hernia, you won't see any diaphragm line and you will see the intestinal gurgling sounds in your chest when it is placed over the chest. Whereas in pneumothorax, you will not see pulmonary vasculature. Whereas in congenital lobar emphysema, you can see white pulmonary vasculature. Right. Newborn not passing stools within 24 hours. What should be ruled out? Newborn not passing stools within 24 hours. What should be ruled out? It's not that tough. Normal. So in term baby it is 24 hours. In preterm baby it is 48 hours. I repeat. In term it is 24 hours and preterm it is 48 hours. Hypo. What is that hypo? What do you mean by hypo? Hypothyroidism. Jejunal atresia, but the common things are, okay, Hirschsprung's disease you need to rule out. I won't say you are wrong. Jejunal atresia is not that common. Hypothyroidism is very good point, but here we are speaking in terms of a surgical newborn. So invariably you need to think in terms of an Hirschsprung's disease. Invariably you need to think in terms of an Hirschsprung's disease, right? Again other condition, newborn with meconium ileus. Newborn with meconium ileus. That is, meconium is obstructing the ileum. Which newborn condition is presenting with meconium ileus? That is associated with the CFTR. What, Arjun? Silly mistakes. Don't worry, you won't do mistakes. Okay. Newborn with the meconium ileus, waiting for your answer. That means the meconium is getting obstructed in the intestine. Very good, Srini. Love you, dear. Love you, love you. Newborn with the meconium ileus is cystic fibrosis unless otherwise proved. Can anyone tell me, Maya, Srini, Arjun, what is the newborn invest screening test of choice for cystic fibrosis? Very good, Ash. What is the newborn cystic fibrosis screening test? Ajo? No. Yes, peaceful wall. Yes, I agree. Tell me, Ajju, Srini, Mahesh, Arsh. Screening test for cystic fibrosis in newborn period. It is IRT means immunoreactive trypsinogen. Gene, no, not gene, you are correct, but it is immunoreactive trypsinogen. It costs around 500, but gene testing will cost around 17,000 rupees. Immunoreactive trypsinogen. Okay, right. So newborn with meconium ileus is immunoreactive trypsinogen. IRT, please. Yes, I agree. Gene test is okay, but immunoreactive trypsinogen is 500 rupees, whereas your gene test is somewhere around 7,000 to 17,000. A screening test should be of low, it is relatively, it should be economical. Okay, so immunoreactive trypsinogen, because of obstruction, damage to the pancreatic duct, your what is that, your immunotrypsinogen will be released into the blood, that is immunoreactive trypsinogen. So please don't do mistakes, my dear boys and girls. Krickenberg classification is meant for, Krickenberg classification is meant for, it is not it is, I don't know, it is anorectal malformation. Okay, herniation through umbilicus in a newborn and herniation lateral to umbilicus, you all know. What is this? I don't think it is a tough one. Arjun, ARMS, really anorectal malformation. Classification, very good, very good, very good. I'm literally very, very happy. I was thinking that you will not answer anorectal malformation. Very good. Herniation through umbilicus is amphiloceal. In newborn, I am speaking. Okay, with intestinal contents in amphiloceal, whereas herniation lateral to umbilicus is usually gastroschisis. One is herniation through umbilicus is amphiloceal, and herniation lateral to umbilicus is gastroschisis. Tell me, with respect to amphiloceal and gastroschisis, which one is more causing, which one is more associated with the congenital malformations? Is it amphiloceal or gastroschisis? Which one is associated with intestinal atresia? Amphiloceal is more to produce, more associated with other malformations. More associated with other malformations. Which one? Amphiloceal, whereas gastroschisis is associated with intestinal atresia. Associated with intestinal atresia. Which one? Gastroschisis. Yes. With this slide, all my kids are doing superbly. Very good. Keep it up. Now you all know that thermoregulation is conduction, convection, radiation, evaporation. But what is this question? So, fatafat, what is the normal newborn temperature? What is the normal newborn temperature? Tell me. Harsh, OP, Srini, Arjo, Purush. What is the normal newborn temperature? Normal newborn temperature is 36.5 to 37.5 degrees Celsius. Not, no. 36.5 to 37.5 Celsius. Now tell me, the most important question among all these in this slide is two. What is called mild hypothermia or cold stress? You need to mention the range of temperature. What is called mild hypothermia or cold stress? What is that? Waiting for your answer. OP, Arjun, Srini, it's a wide range, my dear boy. You said OP little bit closer but wrong. Harsh closer but wrong. Mahesh wrong. Waiting for 6 seconds. If I get a correct answer, a gift parcel to you. 1. What is mild hypothermia? It is ready. 1, 2, 3. It is 36 to 36.5. None of you had answered. Very, very important. No. No Vaibhav. No. No Vaibhav. Arju. Wrong. Mild hypothermia or cold stress is 36 to 36.5 Srini. Okay. Moderate is 32 to 36. Severe is less than 32 degrees Celsius. So among all this, cold stress, cold injury or hypothermia is 36 to 36.5 degrees Celsius, Very, very important. It's a very narrow range, so you will tend to do mistakes in this. I repeat, cold stress or cold injury or mild hypothermia is just 0.5 degrees Celsius between 36 to 36.5 degree Celsius, right? So to TK, don't forget, my dear boys and girls, please do not forget this, right? Then okay, let me fill here. Now next question, is it okay? Arshu, Srini, OP, will you do mistake right now? Will you make mistake in mild hypothermia or cold stress? Those whoever posted wrong answer, kindly put correct answer, then only I will proceed. Okay then, right. At least one more good answer. No show, right. But I want the answer again, at least from one of you to say, I am confident with you. Mild hypothermia means it is, that's it, OP 36 to 36.5. Okay, Srinima, okay. Right, done dear, done. So, abdomen warm, feet cold to touch. So, among this one, you need to choose. Abdomen warm, feet cold to touch. This is called mild hypothermia. This is called mild hypo. What happened to you, my dear boy? So again, abdomen is warm, pit is cold to touch, means this is called cold stress or cold injury, and the temperature is 36 to 36.5. Again, don't do mistake. 36 degree Celsius to 36.5 degrees Celsius is cold stress, in which abdomen is warm, feet is cold to touch. What is non-shivering? Again missed, my dear fellow. Again missed. Okay, no issues. Non-shivering thermogenesis. What is called non-shivering thermogenesis? It is mediated by what? It is mediated by what? Non-shivering thermogenesis. Waiting for your answer. Brown fat. Love you, dear. Love you, Srini. It is brown fat, brown fat, brown fat. What is happening in brown fat? What is happening in brown fat? What is happening in brown fat, Ashik? Arjo, I agree. What is happening? What is the mechanism? What is that called as? What is it is called as? It is called non-shivering thermogenesis. What is happening? Uncoupling of oxidative phosphorylation. Mahesh, you need to use that word, my dear boy. Instead of saying heat production, you need to say uncoupling of oxidative phosphorylation. That means in electron transport chain, in inner mitochondria, ATP is produced. If ATP production is converted to heat, if ATP instead of ATP production, if hydrogen transport is utilized for heat production, that is called uncoupling of oxidative phosphorylation. Arju, biochemistry topic na in electron microscopic. Yesterday I was watching for sir's teaching. Okay, so what happens when your NADH, your FADH, your coenzyme Q, everything is getting transferred. Your hydrogen gradient will be formed. That hydrogen gradient finally will be converted to water, and under this effect, you will get ATP synthesis. This hydrogen gradient, instead of going in the left direction, if they are used to produce heat, that is called non-shivering thermogenesis. Yes, exactly, Ashik. Yes, exactly. Okay, can you tell me what is the neurotransmitter involved in this new shivering thermogenesis? What is that? What is that? What is that, Ashik? Adrenaline? Is it adrenaline? Mahesh, is it adrenaline or noradrenaline, my dear? It is noradrenaline. Again, a very, very important MCQ. Noradrenaline is responsible for non-shivering thermogenesis or uncoupling of oxidative phosphorylation, in which heat is produced instead of ATP. Heat is produced instead of ATP. Okay? Right. Noradrenaline. Right. Okay, then don't say adrenaline, my dear boys and girls. It is noradrenaline. Can anyone tell me which drug produces uncoupling of oxidative phosphorylation? Which drug? Noradrenaline by physiological. By pathological. If you had completed pharmacology, tell me which drug is associated with the non-shivering, is associated with heat production. So when you take the drug, more fever will come. What is that? Because of this uncoupling of oxidative phosphorylation. The answer is aspirin. The answer is aspirin, but not related to pediatrics. No, very good, Mahesh, very good. Atropine is something different. It produces because by inhibiting the sweat, but aspirin is the correct answer. Aspirin is the correct answer. Now let us go and find some of the gimmicks in torch infection, toxoplasmosis, rubella, cytomegalovirus, herpes, syphilis, varicella zoster, and Zika. So let's go. Torch infection. Which one causes fatafat? It is not that difficult. Okay. Periventricular calcification with torch infection. We don't have time. Make it faster. Periventricular calcification is associated with what? Torch infection. Periventricular what? Diffuse calcification is what? No, you are wrong. OP Luffy, you are wrong, my dear. Mahesh, is it CMB, my dear boy? Yes. Mahesh, you are correct. Mahesh, you are correct. It is periventricular calcification is cytomegalovirus, whereas diffuse cerebral calcification is toxoplasmosis. Please don't do mistake. Periventricular calcification is cytomegalovirus. Diffuse calcification is toxoplasmosis. And you all know cataract, sensory neural deafness, and PDA is a manifestation of congenital rubella syndrome, and this triple C syndrome. Chorioretinitis, calcification, and hydrocephalus again is a manifestation of, waiting for you, 1, 2, 3, 4, 5, 6. Chorioretinitis, calcification, and hydrocephalus is a feature of toxoplasmosis. Okay, it's a feature of toxoplasmosis. Very good, very good, very good. Okay, now what is this? Persistent rhinorrhea, pseudo-paralysis, and notched central incisor. Not a tough one to answer. What is this? Not a tough one. What is it? What is that? Persistent rhinorrhea, pseudo-paralysis, notched central incisor. Very good, Luffy. Very good, my dear. Very good, my dear. Very good. It is congenital syphilis. Very good. Congenital Purushot. Very good. Congenital syphilis. Normally, sepsis is associated with hypothermia. I repeat, sepsis in newborn is associated with hypothermia. Infection, bacterial infection usually do not cause fever in newborn. But two infections can produce fever in newborn. What are all they? Waiting for your answer. Two infections that can cause fever in newborn. What are all they? Because bacterial infections are unlikely to produce hyperthermia. In fact, it produces hypothermia. What is the answer? It is, waiting for your answer. Guru, Luffy, Mahesh, Srini. Only infection that can cause fever in newborn. One is herpes simplex, another is malaria. So herpes simplex is notorious. Yes, Luffy, you need to mention it as viral, not viral, but as herpes simplex. Only torch infection that can cause a recurrent abortion. Only torch infection that can cause recurrent abortion. Rest of them will not cause recurrent abortion. It is syphilis. What is the investigation of choice for CMB? Remember, sensory neural deafness is the delayed manifestation of cytomegalovirus. Chorioretinitis can come. Microcephaly will come. Periventricular calcification will come. Hepatosplenomegaly along with petechiae are manifestations of CMB. Repeat. What is the investigation of choice for CMB? Waiting for your answer. 6 seconds. Investigation of choice for CMB. Answer. Urine PCR. You need to mention as urine PCR, my dear boys and girls. You need to mention as urine CMV PCR. Okay? Urine. No serology should be mentioned, Purush. No serology should be mentioned. It is urine CMV PCR. Please, please, please. So, Luffy, you are correct, my dear girl. Okay. Right. Most dangerous torch infection is congenital rubella syndrome. Less than 12 weeks, there is no cure. You need to go for an abortion. Toxoplasmosis, you can treat with the pyridoxine sulfamethamine. Sulfadoxine pyrimethamine for toxoplasmosis. CMV to a certain extent, ganciclovir. Okay, herpes simplex, acyclovir. Syphilis, penicillin. But congenital rubella syndrome, there is no treatment. Abortion is the rule. So the most very good Sidhu. Rubella, correct. Malnutrition, fatafat, go for it. Okay, baggy pant appearance and monkey faces are features of not that tough. One, baggy pant appearance and monkey faces. Baggy pant appearance. So look at this. So baggy pant appearance and monkey faces are features of marasmus due to what? Loss of subcutaneous fat. Whereas skin and then hair changes like flaky paint dermatosis and flaxane are features of kwashiorkor. What are all the lethal triad of severe acute malnutrition? Lethal triad of severe acute malnutrition is what? Lethal triad of severe acute malnutrition is 3 T's. One is hypoglycemia, second is hypothermia, third one is infection. So when one is present, you need to presume that the other two are present. The lethal triad of severe acute malnutrition is hypoglycemia, hypothermia, and infection. And remember one more point. Whenever you consider severe acute malnutrition criteria, apart from a mid upper arm circumference of less than 11.5 centimeter, bipedal edema, loss of subcutaneous fat, is it weight for height or weight for tell me, is it weight for height or weight for age? Tell me, is it weight for height or weight for age? I am waiting for your answer. Is it weight for age or weight for height? Weight for height. Very good, Maggie. Weight for height. Right. Next, going for that, which micronutrient should not be started during stabilization phase? Which? Very good, very good, very good, very good. Srini, Arju, Sidhu. Never ever mention weight for age. Very, very important. Micronutrient that should not be started during stabilization phase. Yes, Mahi, it is iron. It is iron. How to prepare Risomol from standard ORS? How to prepare Risomol from standard ORS? Standard ORS is 245 millimole per liter. Risomol is 300 milliosmol per liter. Risomol is meant for rehydration solution for malnourished children. More dilution, more potassium. Simple. Very good, very good, very good. Very good. Luffy, more dilution. Beautiful point, my dear one. More dilution, more sugar, more potassium. Say, very good, Luffy. It is more dilution, more sugar, more potassium. So add more ORS. So instead of 1 liter, you add 2 liter. Second, add more sugar, add additional 50 gram of glucose. And third one is add 40 ml of potassium chloride solution. 50 grams of glucose, ORS plus 2 liter oxygen plus 50 gram of glucose plus 40 kilocalories. Okay. See, don't get confused, my dear boy. Sidhu, weight for height is wasting. Weight for height is wasting. Okay. Height for age is stunting. Weight for age is, Sidhu got confused. Sidhu, weight for age, if reduced, it is wasting. That means you are dealing with something acute. Weight for and then height for, I am sorry, weight for height. And let me rub. Okay. So weight for height, height for age, height for age. If weight for height is low, that is called wasting. If height for age is low, that is called stunting. Okay, SAM means it is weight for height less than 70%. Less than 70%. Okay, right. F75 and F100 formula that is used in F75 and F100 formula is used in, okay Sidhu, F75 and F100 formula is used in, F75 formula is used in stabilization phase, whereas F100 formula is used in okay, continuation phase. F75 formula F75 formula 100 ml contains 75 kilocalories and 1 gram of protein, whereas F100 contain 100 kilocalorie from bar 3 grams of protein. So you have been answering. Okay, done. Very good. Fever with the rash. The next concept is fever with the rash. So fever with the maculopapular rash. So what are the things that can present with fever with the maculopapular rash? They are measles, infectious mononucleosis, chikungunya, enteroviruses, and what is this MIS-C? Can anyone tell me what is this MIS-C? MIS-C is multisystem inflammatory disease associated with COVID-19. For undergraduates, measles, chikungunya is more than enough. MIS-C you need to know. MIS-C means a multisystem inflammatory disease associated with COVID. Very good, Srini. Fever with peeling and desquamation. You need to answer. I am not going to answer. OP Luffy, you are not supposed to say chicken pox, my dear girl. You are not supposed to say. Vesicular rash is chicken pox. What, Mahi? Tell me, fever with the peeling. Fever with the peeling. What you need to say? Fever with the peeling. What you need to say? Fever with the peeling. Staphylococcal scalded skin syndrome. Okay. But more you need to think in terms of Kawasaki disease. I agree. Staphylococcal syndrome, Kawasaki disease, as well as SJS syndrome. So SJS, Kawasaki, MISC, scarlet, all the things are associated with the peeling and desquamation. Fever with the vesicular rashes, chicken pox, herpes, enterovirus, and hand foot mouth disease. Right. Okay, remember, two things are many common. Fever with the vesicular rash can never be Kawasaki. This question was often asked. Fever with the vesicular rash can never be Kawasaki. That will be asked. Okay, Kawasaki, two things can be asked. One is, it is not purulent conjunctivitis. Second one is, it is never ever a vesicle. Fever with petechiae. Very easy. Fever, petechiae, shock. Only one answer for an undergraduate. Fever, petechiae, rash. Fever, petechiae, shock. Only one answer. Meningococcal meningitis. Apart from that, scrub typhus. Very good. Dengue, meningococcus. Three things they will ask in exam. Fever with urticaria. Cabis, cutaneous larva migrans. Very good, Arjun. Fever with the nodular rashes, molluscum and erythema nodosum. Fever with the nodular rashes, molluscum and erythema nodosum. Right? Okay. Congenital heart disease. Right? Congenital heart disease. Make it clear. Cyanotic congenital heart disease associates Kawasaki disease is the most common vasculitis in children. Siddharth Gomes is asking. The most common childhood vasculitis is Sidhu. The most common childhood vasculitis is Inox-Schonlen purpura. I repeat, Inox-Schonlen purpura is the most common childhood vasculitis, followed by Kawasaki disease. Is it okay? Very good. Okay, don't worry, video will be saved as well as video. Let me get at the end of this session. Let me give you the PDF of this one. Don't worry, right? So 𝐒𝐿 purpura and IgA mediated vasculitis is the most common cause for childhood vasculitis, followed by Kawasaki. And remember one more point: the most common cause for acquired heart disease in children is Kawasaki disease, and it is replacing acute rheumatic fever. Okay, I repeat, my dear boy, the second most common vasculitis is Kawasaki, but the most common vasculitis replacing acute rheumatic fever as the most common cause for acquired heart disease is Kawasaki disease, right? Okay, then congenital cyanotic congenital heart disease with the left axis deviation. Answer. Waiting for your answer. Cyanotic congenital heart disease with the left axis deviation. Cyanotic congenital heart disease with the left axis deviation is what? Tricuspid atresia 1. Cyanotic congenital disease with the largest heart is Epstein's anomaly. When you have a S2, it can have fixed split, variable split, or reversible split. When you have a fixed split, it is AST. When you have a variable split, it is VST. When you have a reversible split, it is PDA. When you have a very good, tricuspid atresia, Luffy, correct. Okay, Epstein's very good. So fixed split, variable split, and reversible split is PDA. Very good. Acyanotic congenital heart disease with absent both femoral. You all know it is coarctation of aorta. Acyanotic congenital heart disease with both femoral and brachial absent. It can be either critical aortic stenosis or more in favor of a hypoplastic left heart syndrome. Both critical aortic stenosis and hypoplastic left heart syndrome are presenting with absent femoral and absent brachial. What is the clue? Carotid bruit. Presence of carotid bruit is indicative of critical aortic stenosis, whereas absent of carotid bruit is more in favor of hypoplastic left heart syndrome. Right. Then, what is this? Duct independent lesion. Your tricuspid atresia, pulmonary atresia, tetralogy of Fallot. These are all duct dependent pulmonary circulation. Whereas your coarctation of aorta and critical aortic stenosis are duct dependent systemic circulation. Your TGA will depend for mixing duct independent lesion. That means you need not give prostaglandin E1 analog alprostadil to save the baby. What are all the two duct independent lesions in cyanotic congenital heart disease? What are all the two duct independent lesions? One is total anomalous pulmonary venous connection. The second one is truncus arteriosus. So many times this question was asked. Duct no, my dear, no, TGA you require. What happened, Nazar? TGA you require a PDA immediately. There are only two conditions which doesn't require. Okay, which doesn't require ducts are. One is truncus arteriosus, no use of giving prostaglandin analog. Total anomalous pulmonary venous connection, no use of giving prostaglandin E1 analog. Okay, so then Patafat. Drug that opens PDA is alprostadil, prostaglandin E1 analog. What is the drug that we use right now to close PDA? Waiting for your answer. What is the drug that we use to close the PDA? Indomethacin. Then, Nazar, I'll be waiting for two more answers. We don't have any time. Brufen. No, I am sorry, Mahesh. Yes, my dear. Luffy, you are correct. The drug that we use. Yes, Srini, you are correct, my dear boy. Paracetamol is the drug of choice to close your patent ductus arteriosus. It is neither indomethacin nor brufen. We have moved so away from all those drugs. Right. Okay, then Rastelli procedure, I don't think you will be asked. It is usually used in TGA with the VST, but I don't think you will be asked. But the rash kind you will be asked. Crash kind is balloon atrial septostomy used in transposition of great arteries to produce a hole so that blood will be mixed at the level of the atrium. Cathenis is arterial switch surgery, a definitive procedure used in TGA. Definitive procedure used in TGA, arterial switch surgery. Norwood procedure is used in hypoplastic left heart syndrome. Norwood is hypoplastic left heart syndrome. Okay, then inborn errors of metabolism, very often asked question only I have included here. Very important, often asked question. Start. IEM urine odor. Can anyone mention IEM urine odor? Thyroxinemia is associated with what kind of odor? Thyroxinemia is boiled cabbage odor. Okay. Very good, Sidhu. Hypoplastic left heart syndrome, you are correct. Thyroxinemia is associated with boiled cabbage odor, whereas homocystinuria is associated with fishy odor. Maple syrup urine disease is associated with the burnt sugar odor, whereas isovaleric acidemia is associated with sweaty fit odor. Is associated with sweaty fit odor, right? Okay, this is not that tough. Isovaleric acidemia is associated with sweaty fit odor, not that tough. Then multiple carboxylase deficiency is associated with what kind of odor? It is tomcat's urine, phenylketonuria, musty odor or mousy odor. Musty odor or mousy odor, phenylketonuria. Majority of inborn errors of metabolism are autosomal recessive. Autosomal, all enzyme disorders are usually autosomal recessive, so consanguineous marriage is the rule. But some inborn errors of metabolism are X-linked recessive and they present only in boys. What are all they? They are Fabry's disease, X-linked adrenoleukodystrophy, ornithine transcarbamylase deficiency, as well as Hunter's disease. Hunter ornithine transcarbamylase, Leishman syndrome, and Fabry's disease. Autosomal dominant IEM are porphyrias, familial hypercholesterolemia. Porphyria and familial hypercholesterolemia, but most often you will be cornered here, X-linked recessive. Cornered X-linked recessive disorder. Okay, then. So what is the answer? Match the following. What is the answer? Fabry's disease. What is the answer? Tell me. Fabry's disease, Farber's disease. What is Farber's disease? Farber's disease is associated with the deficiency of what? Ceramidase. Is ceramidase. 1. You can answer. Okay, ceramidase. Krebs disease is associated with aryl sulfatase. Associated with aryl sulfatase. What? Krebs disease or metachromatic leukodystrophy? Which one is associated with aryl sulfatase? Not all, but majority of them are autosomal dominant. So one by one, Krebs disease is galactocerebrosidase. Krebs disease is galactocerebrosidase. Metachromatic leukodystrophy is aryl sulfatase H. Aryl sulfatase. Niemann-Pick's disease, you all know. Niemann-Pick's disease, G is associated with sphingomyelinase. Sandoff and Tay-Sachs. Tay-Sachs is associated with 𝐒𝐿-saminidase A, and Sandoff disease is also associated with 𝐒𝐿-saminidase A and B. Okay. Gaucher's disease. Gaucher's disease is associated with glucocerebrosidase. Glucocerebrosidase, whereas Gaucher GM1 gangliosidosis is associated with what? GM1 gangliosidosis is associated with what? Beta galactosidase, and then Fabry's disease is associated with alpha galactosidase. Okay, remember Fabry's disease is associated with normal intelligence. Associated with normal intelligence. Farber disease is associated with rheumatoid-like nodule. Is associated with rheumatoid-like nodule. nodule. Tay-Sachs disease, MCQ, no hepatosplenomegaly in Tay-Sachs disease. No hepatosplenomegaly in Tay-Sachs disease, you remember. Okay, right. So definitely this is most often a biochemistry kind of question rather than a pediatrics, but the pediatric question arises right now. And remember one more point, there is no optic, there is no cherry red spot. There is no cherry red spot. In what? There is no cherry red spot where? No cherry red spot in crepes and gotchers. No cherry red spot in crepes and gotcher. Cherry red spot in crepes and gotcher. Right? Then biotin is used in very compared to the previous slide. This slide has got more marks. More marks. Biotin is used in multiple carboxylase deficiency. Wherever you find alopecia with neuroregression, you need to give. Niacin, you lose tryptophan in urine. So, Hartnupp's disease. B12, methylmalonyl-CoA is converted into succinyl-CoA. Methylmalonic acidemia. B6, pyridoxine. Pyridoxine is used to wear homocystinuria because it is a cofactor for cystathionin beta synthase. Cystathionin beta synthase. Which one? Homocystinuria B6, pyridoxine. Where will you use nitisinone? Nitisinone is a substrate reduction therapy used in two conditions. One is tyrosinemia, another is alkaptonuria. One is tyrosinemia, another in alkaptonuria. Nitisinone. Lorenzo oil. Lorenzo oil is used in X-linked adrenoleukodystrophy, whereas riboflavin is used in mitochondrial disorders. Thiamine is used in maple syrup urine disease because thiamine is the cofactor for alpha keto acid dehydrogenase that is mainly essential for the oxidation or dehydrogenation of branched chain amino acids such as leucine, isoleucine, and valine. Thiamine is also very important. Okay, right. So nitisinone, one is alkaptonuria, next one is tyrosinemia. So this is cofactors used in substrate reduction therapy in IEM. Okay, right. So milestones, with respect to milestones, this is not that tough for you. So neck holding usually occurs by about 3 months. Rollover usually by about 5 months. Tripod sitting with their own hand by about 6 months. Sitting with support by about 8 months. Standing with support by about 9 months. Standing without support by about 1 year. Walk alone 13 months. Runs alone 15 months. 2 feet per step is 2 years. Alternative step up 3 years. Alternative down 4 years. Alternative down 4 years. Okay, right. Down 4 years. So among this tripod will be asked. Now language. Alerts to sound by about 2 months. Cooing by about 3 months. Laugh loudly by about 4 months. Okay, laugh loudly. Okay, again monosyllable 4 months. Bisyllable 6 months. Okay, right. 1 to 2 words with the meaning is by about 1 year. 8 to 10 words by about 15 months. Pronoun he, she, everything occurs by about 2 years. Full name and gender by about 3 years. Tell stories by about 4 years. Ask meaning by about 5 years. Okay, ask meaning by about 5 years. This is with respect to language milestones. Okay, language milestones. Okay, bidextrous grasp 4 months. Unidextrous grasp by about 6 months. Immature pincer grasp starts by 9 months, matures by about 12 months. Scribbling by about 15 to 18 months. Scribbling. 2 blocks, 15 months, 3 blocks, 18 months, 6 blocks, 2 years, 9 block, 3 years. 6 blocks, so into 3 into 3. 6 blocks, 2 years, 9 blocks, 3 years. Bridge with the blocks is 4 years. Bridge with the block is 4 years. When you make a gate with the block is 5 years. When you make a step with the block is 6 years. 6 years. Okay? Right. Then language milestones. Language milestones usually occurs by social smile 2 to 3 mothers. Okay, recognizes mother 2 to 3 months. Changer anxiety 6 months. Bye bye 9 months. Simple ball game 1 year. Domestic mimicry or sweeping by about 18 months. Ask food, go to toilet alone by about 2 years. Full name and gender by about 3 years. Goes to toilet by about 4 years. By about 2 years, toilet training needs to be starts. By about 4 years, the child can go to toilet alone. Dress and undress again by about 3 years. Can anyone tell me when does the child tie shoelaces? When does the child tie shoelaces? Waiting for your answer because it has become monotonous. When does the child tie shoelaces? Waiting for your answer. Siddhu, Arju, Harshrini. When does the child tie shoelaces? Harsh 5 years, Arju 4 years. Tie shoelaces by about Ashrini and Harsh told it is 5 years, my dear boys and girls. It is 5 years. Right? Then let's come to the important X-ray session. Patafat. Okay, I agree. What is the one on the left side? Newborn with respiratory distress. So newborn with respiratory distress, reduced air entry, left infraclavicular area. Answer CDH. This one is the CDH. Diaphragm perfect. Perfect. How can it become CHT, my dear boy? Look at this hyperlucent left lung. What is that I told you? Hyperlucent left lung. What is that I told you, Moy? What happened to you? This is congenital lobar emphysema. This is harsh. This is congenital lobar emphysema. Often asked. This is congenital lobar emphysema. What happened to you? Congenital lobar. Here there are no diaphragm. So this is congenital diaphragmatic hernia. Okay. What is this? The last one. There is coiling of. There is coiling of tube. There is coiling of tube in the neck. What is that? So remember, my dear boys and girls, congenital lobar emphysema is often asked. Second one is congenital diaphragmatic hernia. Third one is esophageal atresia, that is type C. Type C, tracheoesophageal fistula. I agree. Very good. So these are all very fatafat X-rays. Next. What is this? What is this? What are all the other X-rays? What is this? What is this X-ray? The first one. Waiting for your answer. What is the first one? This is figure of 8 or snowman appearance, or what is total anomalous pulmonary venous connection? Again one question. TAPC is a duct dependent or duct independent lesion? TAPC duct dependent or duct independent lesion? Sidhu, Arju, Harsh, Pablo, is it a TAPC is duct dependent or duct independent lesion? Just now we read now. Say yes or no. No, that's it. No. That's it. No. So what is this? What is this? Congenital cyanotic. So this is congenital cyanotic heart disease. No murmur. The child become cyanosis, goes for cyanosis 60%. So what is this? Egg on side appearance. Egg on side. So what is this? This is called transposition of great arteries. The first treatment is prostaglandin E1 analog. The second treatment is, what is this, balloon atrial septostomy. The third one is arterial switch surgery. The third one is arterial switch surgery. Right. What is this? This is very easy. Caron Sabot or food shaped heart. Food shaped heart. So this is tetralogy of Fallot. What is the last one? Yeah, you know. Srini Arju Harsh, you know, I know you will answer. I know you will answer. What is the last one? What is the answer for last one? I know, no need for this one. I am not asking. Magi, are you Mahi, Srini, box shaped heart, largest heart? I don't know whether Mahesh and Srini are correct. Waiting for Siddhu, Arjo, Harsh for your answer. Fifth one is what? Fifth one is what? Is it large box-shaped heart, Epstein's anomaly? The answer is correct, Mahi and Srini. Correct. Largest heart in cyanotic congenital heart disease is Epstein's anomaly. Is Epstein's anomaly. Is Epstein's anomaly. Yes, very good. You are correct. Very good. You are correct. Epstein's anomaly. Next, going to that. What are all the three X-rays? All indicates one disease. What it is? All indicates one disease. What it is? Going for the next one. All indicates one disease. What it is? All indicates one disease. What it is? So the first one is cavity. The second one is miliary pattern. The third one is hilar adenopathy. So the first one is cavity. No, cavity. The second one is dot dot picture miliary TB. The third one, it is not pneumothorax. The third one is hilar adenopathy. Hilar adenopathy. So all indicates TB, my dear boy. All indicates TB. So whenever fever more than 2 weeks, whenever cough more than 2 weeks, along with the contact who took ATT in the past 2 years, the next investigation of choice is not CB naught. The next investigation of choice is look for upfront X-ray. When X-ray shows either cavity, miliary pattern, or hilar adenopathy, then proceed for CB naught. Then proceed for CB naught. Okay, right. Then proceed for CB naught. Okay, CB naught. So this is very important. Cavity, miliary TB, hilar adenopathy. What is this? What happened? One exam. What is this? Upper lobe. So what is this? Going for the next one. Going for the next one. Upper lobe cystic changes. Upper lobe cystic changes. What is the diagnosis? Boy or girl with the bronchiectasis, upper lobe cystic changes. What is the diagnosis? What is the diagnosis? Upper lobe bronchiectasis is cystic fibrosis. What is the answer for this one? What, Mahi, what happened to you, my dear? It is cystic fibrosis. Srini, you are correct. Second one, what is the answer for this one? Harsh, you are correct. Right upper lobe bronchiectasis is cystic fibrosis unless otherwise proved. Yes. Dextrocardia. Very good, Gopi. Very good. Very good. So dextrocardia, what? It's right-sided heart. Dextrocardia, what disease is associated with it? What disease is associated with this? What disease is associated with this? It is primary ciliary dyskinesia, otherwise known as Carter-Jenner syndrome. Otherwise known as Carter-Jenner syndrome. Very good, Gopi. What is the last one? What is the last one? Mahi, what is the last one, Dra? So second one is Carter-Jenner syndrome. Mahi, what is the last one? Sudden onset cough, pediatric age group. What is the last one? Pneumothorax group, sudden onset cough, I told you. Sudden onset sound means group. Sudden onset cough, it is not pneumothorax. There is no underlying collapsed lung. Very good, very good. It is not, my dear. Since I have rounded it, Arju was looking at that picture. No, the problem is, look at this. The right lung is voluminous. No, Gopi ma. No, 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 no. There is no steeple sign. There is no steeple sign at all. Look at this. Look at this. The right lung volume is more than the left lung volume. This is called obstructive emphysema. The right lung volume is more than left lung volume. This is called obstructive emphysema and it is suggestive of foreign body in the right main bronchus. This is not steeple sign. This is where steeple sign. Those they don't look here, ma. Look at the history. When I say sudden onset sound, mean look here. When I say sudden onset cough, mean look for obstructive emphysema. Look for obstructive emphysema. It is foreign body in the right main bronchus. Look here, this is more voluminous and more aerated compared to left lung. So this all you know, already you see. So this is called flaxine. This is called flaxine. So what is this? This is called flaky paint dermatosis. This is monkey faces. And this is baggy pant appearance. This is baggy pant appearance. So flaxine, flaky paint, monkey faces and baggy pant appearance. I don't think my children are finding it difficult to answer this one. So what is this? Hyperpigmentation of knuckles and soles, suggestive of what? B12. B12. The child is not having radius and the child is not having radius. The child is not having thumb and the child is pancytopenic. What is the diagnosis? The diagnosis is any radial anomaly or facial hyperpigmentation along with the absent thumb and pancytopenia is Fanconi. Very good, Gopika. Look at the urine. This is my clinic kid's urine. You wonder whether all these diseases are there in India or not. It is there. We are living in 150 crore population. All diseases, Western diseases are there in India. Alkaptonuria. This is my clinic kid's urine. This is alkaptonuria. Black discoloration on prolonged standing is alkaptonuria. Right now the child is absolutely normal. He is 9 years old. But when he becomes 15 or 16, he develops osteoarthritis like picture, involving large joints along with intervertebral disc calcification. Okay, now pervasive developmental and autistic spectrum disorder. What is this? Atypical social interaction. The child is not interacting with anything. Restricted range of interest. The child is playing with the same toy. Disorder and delayed and disordered communication. The child is not talking with anyone. Onset is before. Very good, my dear boy. This is autism. This is autism. Very good. Next, going back to the next one, is similar to autism, but he could speak. Language is relatively intact. Cognition is not affected. But remember, awkward postures, looking at you like this suddenly, and deficit in non-verbal and pragmatic communication. What do you mean by non-verbal and pragmatic communication? The answer is simple. Whenever you fall in love with a girl or boy, you will look like this. But those children, they cannot have facial expression, and for each and everything they will be looking at you like this. So expressionless face. A little bit higher form of autism is called as A. Another A. What is it? Very good, Arsh. Very good, very good, very good, Arsh. Very good, Gopi, Mahesh. Very good. It is Asperger syndrome. It is Asperger syndrome. What is this third one? Almost affect girls, MECP2, regression of skills 6 to 18 months of age, periodic hand wringing movements, Rett syndrome. My children are very clever right now. It is Rett syndrome. Fourth one, I don't think you need to know. That is Hiller's dementia. I don't think it will be asked to you. Just leave it. 1, 2, 3 is more than enough. My children are very confident on it. Just leave it. So now rickets. Congenital. Okay, rickets. So let me finish rickets first, then go to congenital adrenal hyperplasia. Go to rickets. Go to rickets. What is this? My children are going to fill the answer. First, phosphorus is low, 25-OH-T3 is low, parathyroid hormone is high. What is the answer? Tell me what is the answer. Low phosphorus, high PTH, low 25-OH-T3. What is this? What is this? So whenever you have low 25-OH-T3, no, no, no. 25-OH-T3 less unless otherwise prove it is what happened. Gopika Mahesh. Very good, Ash. Very good. It is nutritional vitamin D deficiency. Nutritional vitamin D deficiency. This is nutritional rickets. The only condition in which by 25 OA Paget disease. I am talking about pediatrics, my dear boy. Okay. Right. No, don't worry. Okay. Arjo. Right. Then. The next question is phosphorus is low, parathyroid is high, 25-OH-T3 is low, 125-OH-T3 is 25-OH-T3 is normal, 125-OH-T3 is low. Now you tell me what is the answer for this one. Second one. 25-O3 is cannot be converted into 125-OH-T3. Now you tell me the answer for this. Go, Harsh. Now you tell me the answer. Renal failure. In renal failure, Srini, in renal failure, phosphorus will be high. Srinima, in renal failure, phosphorus will be high. When 125 is low, what does it indicate? 25 hydroxylase is absent. 125 hydroxylase is absent. So this is vitamin D dependent rickets type 1. 1 alpha hydroxylase is absent. This is vitamin D dependent rickets type 1 in which 1 alpha hydroxylase is low. What is the next one? The same. Phosphorus is low. Parathyroid is high. Your 125 dihydroxy T3 is high. So what does it mean? Despite being high, the child is having rickets. So it is end organ resistance. This is end organ resistance. So this is called vitamin D dependent rickets type 2, end organ dependence. This is vitamin D dependent rickets type 2. And finally, here comes Srini. Srini, here comes. Look at this. Phosphorus is high, parathyroid is high. Phosphorus is high, parathyroid is high. 125 is low because kidney is not working. This is CRF, Srini. This is CRF. And finally, what is this? The only condition which is associated with the normal parathyroid hormone and low phosphorus is X-linked hypophosphatemic rickets. So remember, by knowing only this chart, I bet you will get one correct answer in a ricket scenario. You'll get one correct answer in a ricket scenario. Don't get confused. In vitamin D mediated rickets, all are associated with low phosphorus and high parathyroid. When 25-OH-D3 is low, you are very simple, Srini. Don't get confused. So whenever you get a combination of high PTH and low phosphorus, the answer is very simple. You need to look for two things. One is 25-OH-D3. If it is low, the diagnosis is only one, nutritional rickets. If this is normal, then look for 125-OH-D3. 125-DH3 low means VDDR 1. 125-OH-D3 very high means end organ resistance VDDR type 2. That's it. Very simple. Why confusion, my dear boy? Then if phosphorus is high, parathyroid hormone is high, it is chronic renal failure. Okay. When phosphorus is low, parathyroid hormone normal, the only condition is X-linked hypophosphatemic rickets. That's all. What is the fourth, sir? Fourth. See, Phosphorus high only in CRF, my dear boy. Okay, right, done. Done. So what is this one? 21. This is again very easy one. Very easy one. In 21 alpha hydroxylase and 11 beta hydroxylase, both are associated with precocious puberty in boys. 21 alpha hydroxylase BP will be low, whereas 11 beta hydroxylase BP will be high. Atypical genitalia in girls. Atypical genitalia in girls. Treatment for this one, you need to put hydrocortisone plus fludrocortisone, because both the cortisol and aldosterone will be low, whereas in 11 beta hydroxylase only hydrocortisone is fine. Whereas 17 alpha hydroxylase, boys will have atypical genitalia. Boys will have atypical genitalia because 17 alpha hydroxylase and 1720 layers are associated with the production of testosterone. Blood pressure, all these unused things will be converted to aldosterone. So blood pressure will be very high. So you again give only hydrocortisone, don't give fludrocortisone. And finally, in 3 beta HST deficiency, what will be high? Your dehydroepiandrostenedione will be high. So no one will be getting precocious puberty. Both boys and girls will have atypical genitalia. Boys will have hypospadiasis. Boys will have hypospadiasis, whereas girls will have hirsutism and mild clitoromegaly. Hirsutism and mild clitoromegaly. Hirsutism and mild clitoromegaly. Again, BP will be low. So you will be requiring both hydrocortisone and fludrocortisone. Okay. This one you just try to have in your mind. I can explain in detail, but that alone will take more than an hour. Okay. So this you just complete. Very simple to remember. Precocious puberty with hypertension in boys is 11 beta, with the hypotension is 21 alpha hydroxylase. In both these conditions, girls will have atypical genitalia, whereas 17 alpha hydroxylase and 1720 layers are both associated with atypical genitalia in boys. Diaz is your 3 beta HST is associated with the undervirilization in boys, a little bit of virilization in girls, right? So what is this one? Very easy. What is this X-ray? What is this X-ray? What is this X-ray? So this child is pancytopenic. That is the clue. This child is pancytopenic. What is this is the clue. Pancytopenic. How can the child will be scurvy? Bone within bone. Arshuma, what is the condition? Bone within bone. Bone within bone occurs in which condition, Arsho? Petrosis. Very good, Gopi. My dear students, whenever any child with pancytopenia and the X-ray is given, it is osteopetrosis unless is proved. The treatment of choice is stem cell transplant. Pancytopenia, why? Peaceful world, very simple, my dear boy. Medulla produces bone marrow. When bones are occupying the medulla, how does the medulla will produce bone marrow? Bone marrow, so how the cells will come? Don't come. That's why you'll get pancytopenia. So what is this? What is the one on the left side? What picture it had shown? I could see bilateral kidney, bilateral ureter and urinary bladder extended. So what is this? What is the picture? Very good. It is micturating cystourethrogram vesicoureteric reflex. Tell me what is the most common cause for recurrent UTI? Tell me what is the most common cause for recurrent UTI? Please do not mention vesicoureteric reflex. Even though this picture shows vesicoureteric reflex, the most common cause for recurrent UTI is bladder bowel dysfunction, otherwise known as constipation. Second most common is vesicoureteric reflex. So this is grade 4 VUR. This is grade 4 VUR. E. coli is most common organism. I am asking you most common etiology. So what is this? Boy with poor stream. Boy with poor urinary stream. Boy with poor urinary stream. So what is this condition? Boy with poor urinary stream, and MCU shows what? Dilated posterior urethra. Very good. Posterior urethral wall. Transvulgaration is the treatment of choice. Very good. So you all know about vaccination. Okay, very good. You all know about vaccination, but what about 6 weeks, 10 weeks, everything? But here I am going to talk about vaccination schedule of an unimmunized child. At evaluation after first month, after 2 months, and after 6 months, what we need to go with. So first one, at 6 years, if the child is, you will give DPT. Okay, you will give DPT, you will give hepatitis B. The child is less than 5 years, you can give BCG. Again, you will give DPT. Okay, DPT hepatitis B. Again, DPT hepatitis B. So 016. After 2 months, what you will give? You will give measles, rubella, and typhoid. Whereas if the child is more than 700, you can't give DPT. Instead, you give Tdap, Td, Td. Along with that, you will give hepatitis B, hepatitis B, hepatitis B. So that measles, rubella, and typhoid will come on the second month after the missed out vaccine. So this is very, very important. Missed out vaccination schedule. BCG can be given up to 1 year in an unimmunized children in case of national immunization schedule, up to 1 year. In case of Indian Academy of Pediatrics, it can be given up to 5 years. For you, BCG can be given up to 1 year. That is the thing that you need to know. Right, next one, other fatafat developmental questions. Fatafat developmental questions. Delayed eruption of teeth is said to be what? Delayed eruption of teeth is said to be what? If there is no teeth by dash months. We don't have time. Make it fast. Delayed eruption of teeth. 12 months, 13 months, 14 months, 15 months. Very good, Mahi. 13 months. Poor eye contact, delayed speech is autism. What is this? Bullying, robbing, firing, antisocial activity. Bullying, robbing, firing, antisocial activity. What is that? Not 15 hours, it is 13 months. Bullying, robbing, firing, antisocial activity. What is this? This is called conduct disorder. This is called as what? Conduct disorder. One who often argues with authoritative figure is called oppositional defiant disorder. It is called as what? Oppositional defiant disorder. They will frame a question and you will find these hidden clues in that question, right? It is not ADHD, my dear boy. One who often argues with authoritative figure is oppositional defiant disorder. Very good, Srini. Okay, eating non-edible things of more than dash month is called as pica. Eating non-edible things for more than dash month is called as pica. Answer. Non-edible things of more than dash month is called as pica. What is the answer? For more than, waiting for your answer. Mahiyar, Sharju, Gopes, Blue, Srini. Eating non-edible things of more than dash month is called pica. Waiting for your answer. Arju, you will ask that you will wait till the child is eating for 18 months, my dear boy. 18 months. I am not asking you the definition. For how many months? 1 year you will allow the child to eat. What happened to you? It is 1 month. The answer is 1 month. Eating non-edible things for more than 1 month is said to be pica. Okay, prolonged crying lead to cyanosis is called as breath holding spell. Perinatal period is usually 22 weeks to 7 days after birth. Small for gestational age is less than dash centile. Almost all of you have answered wrongly for pica. Pica means eating non-edible things for more than 1 month only. Small for gestational age is said to be less than 10th centile. Is said to be 10th centile, right? Okay, what are all the other things that you need to know? At birth, 30%. What happened, Arjun? 10th centile. So, 10th less than 10th is SGA. 10 to 90 is appropriate for gestational age. More than 90% is large for gestational age. More than 90 is large for gestational age. Okay, very important. Right. So at 6 weeks you will give. At 6 weeks you will give. At birth you will give OPV, hepatitis B, BCG. What is the vaccine that you will avoid in preterm? Avoid in preterm. Avoid in preterm is hepatitis B. Very good. Avoid in 6 weeks and 14 weeks. OPV, 10 weeks OPV, 14 weeks OPV. So penta, penta, penta. Rota, rota, rota. So what is the thing that is missing in 10th week? Intradermal IPV is missing in 10th week. Whereas PCV1 is given in 6th week, PCV2 is given in 14th week. Okay, 9th month you will give MR1. 9th month MR1, JE1, FIPV, fractionated booster dose IPV, whereas PCV booster is given at 9th month. 15 months MR2, DPT2 and then OPV. Okay, 15 to 18 months. 5 to 6 years capital D, capital P, capital T, DPT. 10 years it is TD, it is not TT, it is TD. 16 years it is TD. In some places 9 to 14 years HPV1, HPV1, 9 HPV2, 2 doses 6 months apart in some states. In some states HPV vaccine has been introduced 2 doses at 6 months apart. 2 doses at 6 months apart HPV vaccine. TD at 10 years and at 16 years TD and between 10 to 16, 14 years HPV vaccine 2 doses. HPV vaccine 2 doses. Route of administration you all know, BCG intradermal left deltoid insertion. OPV cholera oral, not much an issue. Subcutaneous, all live vaccines are subcutaneous. Live attenuated flu virus, sometimes it can be given to live attenuated nasal, it can be given, but subcutaneous, all live vaccine subcutaneous. Killed vaccine intramuscular, live vaccine subcutaneous. Intradermal is BCG plus IPV plus one more vaccine, rabies vaccine, that can be given intradermal. Diluents for vaccine. What is the diluent for vaccine? Remember, normal saline for BCG yellow fever. Normal saline for BCG and yellow fever. Normal saline for BCG and yellow fever. Whereas rest of the things sterile water. Rest of the things are sterile water. BCG and yellow fever normal saline. Rest of the things sterile water. For these vaccines, other vaccines will be used. Remember only 2 things. For BCG and yellow fever, normal saline. For rest of things, sterile water. What is this? Most common cause for obstructive uropathy in children. Most common cause for obstructive uropathy in children is posterior urethral wall. Most common cystic renal malformation in kidney. Waiting for your answer. Most common cystic malformation in kidney. Most common congenital cystic malformation in kidney. Waiting for your answer, Srini, Mahesh, Arjo. PCKD wrong, ARPCKD wrong. Wrong. Most common is multicystic dysplastic kidney. Most common is multicystic dysplastic kidney. Very good, Gopika. Most common cause hereditary nephritis is Alport. Whenever any child is brought with recurrent hematuria along with the anterior lenticonus and hereditary sensory neural deafness, it is Alport syndrome. Most common cause for community acquired renal failure, which is often associated with schistocytes and thrombocytopenia. So, what is the answer? What is the answer? Most common cause for community acquired renal failure. It is hemolytic uremic syndrome. It is hemolytic uremic syndrome. Very good. Most common cause for hypertension in children. Most common cause for hypertension in children is renal parenchymal disease. Chronic renal failure. Most common vasculitis just now asked. What is that? Enoch-Schonlen purpura. Most common cause for recurrent UTI is bladder bowel dysfunction, and it is not vesico-ureteric reflex. So with this, we are completing our topic for today. And if you are next Thursday, we will be teaching on my pediatric clinics on Thursdays. If you have any issues, let me teach on congenital adrenal hyperplasia to discuss in detail on this Thursday. So with this, my revision for pediatrics is over, and this PDF will be shared right now. So thanks for your patient listening. Bye bye. Take rest and go for the next session. Bye bye. All the best for your examination. Bye bye. Okay, shall I stop streaming, my dear boy, with your permission? Okay, I'll be sharing my annotated PDF. Bye da. All the best. All the best for your examination.
So hi students, hello. Just one moment. Hello, hello. Okay, I got this. So hello to all of you. Am I audible? Am I audible to all of you? Okay. We'll start. Just one moment. Okay, let us begin. So, hello students. I'm Dr. Pradeep Pawar, Professor of Anatomy at PW Med Ed. चलो, so let us start with anatomy. हाँ, कुछ doubts है, कुछ anything that you have not able to understand, that also you can ask me. Chalo, we'll start now. Have a look at this. This is the sequence of lectures. Okay, so we'll start with the workbook. Workbook start करते हैं. Muscles and actions. ठीक है, आप आंसर करिए. You be interactive, so it will be easy for you to understand. Fine. So let us start with biceps brachii. Biceps. Nerve supply of biceps बोल सकते हो बच्चों? Nerve supply of biceps. I'm not able to see the comments. Nerve supply of biceps. Can anyone tell me? Nerve supply of biceps. Just one. Just one moment. I'm not able to see the comments. Just one moment. Oh, hi, hi, hi. Now I'm able to see the comments also. Okay, got it. Hi, Subjit. You're also attending. देख रहे हो? चलो बच्चों, let us start. Let us start. So biceps brachii, nerve supply. बोलो बच्चों, nerve supply. Hi Harshal. Hi Harsh. Hi Harsh. Hi Subjit. Hi John. Peaceful mind. Okay, fine. चलो बच्चों, let us be interactive. थोड़ा सा interactive रहिए, so it will be easy for me also, for you also. चलो. So what is the nerve supply of biceps? हाँ हाँ हाँ, काफी है महेश, काफी है. So nerve supply of biceps, musculocutaneous nerve. हाँ, मैं short में लिख रहा हूँ. I'll just write in short. Nerve supply of biceps is musculocutaneous nerve. What is the main action of biceps? बच्चों बोल सकते हो, what is the main action of biceps? That's supination at the radioulnar joint. Second, it's flexion at the elbow joint. Third action, flexion at the shoulder joint. Flexion at the shoulder joint. ठीक है? So the main action of biceps is supination at the radioulnar joint, flexion at the elbow, flexion at the shoulder joint. ये है biceps brachii. कुछ इंपॉर्टेंट मसल्स मैंने लगाए आपके लिए. डेल्टॉइड. बच्चों बोल सकते हो, what is the nerve supply of deltoid? Anyone? चलो बच्चों, this will be a quick revision for you. एक quick revision होगा. What is the nerve supply of deltoid? Anyone? Yes, very good Subjit. It will be a good revision, Subjit. हाँ, चलो बोलो. What is the nerve supply of deltoid? Axillary nerve. Nerve supply of deltoid is axillary nerve. And what is the main action of deltoid? Main action of deltoid is abduction. Abduction from 15 to 90 degrees, है ना बच्चा? 15 to 90 degrees of abduction कौन करता है? Deltoid. 0 to 15 degrees of abduction, anyone? 0 to 15 degrees of abduction is done by supraspinatus. 15 to 90 degrees, it's acromial fibers of deltoid, and 90 and above abduction is done by serratus anterior, trapezius, and the lateral rotation of scapula. ये MCQ ऐसे आता है, initiation of abduction is done by, your answer, supraspinatus. Deltoid का action क्या है? Abduction from 15 to 90 degrees. ठीक है बच्चों? Fine. Who supplies the deltoid? Axillary nerve. वैसे axillary nerve और एक muscle supply करती है. It supplies one more muscle. Anyone? 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 हाँ, axillary nerve supplies one more muscle. चलो बच्चों, guess करिए, be interactive, answer करिए. It will be a very informative session then. Axillary nerve supplies two muscles. Number one is the deltoid. Number two, teres minor, and ये cutaneous branch देता है, that is known as the upper lateral cutaneous nerve of arm. Huh? So axillary nerve supplies deltoid, teres minor, and gives a cutaneous branch जिसका नाम है upper lateral cutaneous nerve of arm. Injury to this nerve leads to रेजिमेंट बैच साइन. रेजिमेंट बैच साइन बच्चों, ये बहुत इंपॉर्टेंट एमसीक्यू है आपके लिए. रेजिमेंट बैच साइन इज सीन इन लीजन्स ऑफ विच नर्व? आंसर, एक्सिलरी नर्व. ठीक है ना बच्चों? फाइन, समझ में आ रही है? हाँ, इट इज अ क्विक गो थ्रू, क्विक रिविजन. ट्राई टू अंडरस्टैंड दिस. फाइन. सो दैट्स अबाउट द एक्सिलरी नर्व एंड द डेल्टॉइड. Brachialis. Who supplies the brachialis? Again, musculocutaneous nerve. Brachialis का nerve supply है musculocutaneous nerve. What is the main action of brachialis? Main action of brachialis is flexion at the elbow joint. और कहीं पे सुना है आपने brachialis? Have you heard this brachialis somewhere else? Yes बच्चों, brachialis कहीं पे सुना है? Answer this. Brachialis. Have you heard this somewhere? In the floor of cubital fossa. So floor of cubital fossa में brachialis है, supinator है. Brachialis and supinator. Oh, comments I'm not able to see. Just one moment. Comments नहीं दिख रहे हैं. Floor of cubital fossa कौन बनाता है? Brachialis and supinator. एक मिनट, just one moment बच्चों. I'm not able to see your comments. कहाँ गया ये? ओके, okay, fine, got it. And I was not able to see the comments. चलो बच्चों, सुभजीत, ये जो भी है ना सब इंपॉर्टेंट ही है. ये बेसिक्स है, ये इंपॉर्टेंट है. दिस विल बी इंपॉर्टेंट फॉर एवरीथिंग. ओके, वेदर इट्स एनी कॉम्पिटिटिव एग्जाम, ये सब इंपॉर्टेंट होगा. सो इट विल बी अ क्विक रिविजन. ओके, सो ब्रेकियालिस का एक्शन, व्हाट इज द एक्शन ऑफ ब्रेकियालिस? फ्लेक्शन एट द एल्बो जॉइंट. ये ब्रेकियालिस आपने कहाँ पे सुना है? इन द फ्लोर ऑफ क्यूबाइटल फोसा. फ्लोर ऑफ क्यूबाइटल फोसा में दो मसल्स थे, एक था ब्रेकियालिस, दूसरा है सुपाइनेटर. ब्रेकियालिस एंड सुपाइनेटर, दे आर प्रेजेंट इन द फ्लोर ऑफ क्यूबाइटल फोसा. ठीक है ना? कमिंग टू सेराटस एंटीरियर. बच्चा आप बोल सकते हो व्हाट इज द नर्व सप्लाई ऑफ सेराटस एंटीरियर? चलो बोलो, नर्व सप्लाई ऑफ सेराटस एंटीरियर बोलो बच्चों. व्हाट इज द नर्व सप्लाई ऑफ सेराटस एंटीरियर? एनीवन? Answer this. Nerve supply of serratus anterior. I'm not able to see the comments. ठीक है, that's okay. Nerve supply of serratus anterior is long thoracic nerve or nerve of Bell. हाँ, okay. Now long thoracic nerve of Bell, इसका root value क्या होता है? C5, C6, C7. C5, C6, C7. ठीक है, it arises from the roots of the brachial plexus. Fine. So that's serratus anterior. The nerve supplies a nerve to serratus anterior, long thoracic nerve or the nerve of Bell. व्हाट इज द एक्शन ऑफ सेराटस एंटीरियर? इसका एक्शन क्या होता है सेराटस एंटीरियर का? एनीवन? बॉक्सिंग करते हो? बॉक्सिंग इट हेल्प्स इन प्रोट्रैक्शन ऑफ स्कैपुला. सो सेराटस एंटीरियर का एक्शन क्या होगा? प्रोट्रैक्शन ऑफ स्कैपुला. याद रखना, दिस कम्स इन एमसीक्यूज. प्रोट्रैक्शन ऑफ स्कैपुला इज डन बाय योर आंसर सेराटस एंटीरियर. फाइन. रोम्बॉइड्स. व्हाट इज द नर्व सप्लाई ऑफ रोम्बॉइड्स? नर्व सप्लाई ऑफ रोम्बॉइड्स मतलब जो लिवेटर स्कैपुले है, रोम्बॉइडस माइनर है, रोम्बॉइडस मेजर है, इनका नर्व सप्लाई क्या होगा? That's a nerve to rhomboids. Nerve to rhomboids or the dorsal scapular nerve. ये कहां से अराइज होता है? C5 root of the brachial plexus. The dorsal scapular nerve arises from C5 root of the brachial plexus. The action of rhomboids, serratus anterior क्या करेगा? Protraction of scapula. It takes the scapula forwards. Rhomboids क्या करेंगे? Retraction of scapula. Fine. So retraction of scapula is done by rhomboids. Fine. Coming to the last muscle, here we go. Climber's muscle. बच्चों बोल सकते हो climber's muscle कौन है? Who's a climber's muscle? ये कौन सा muscle है which helps us to do pull-ups? ये ऐसे जिम में जाते हो, you hold the bar and you pull the body up. Pull-ups कौन करता है ये? Which is this muscle which is pushing the body up? Yes, it is also known as a climber's muscle. Answer this. Latissimus dorsi. Very good. ये है latissimus dorsi. So climber's muscle is latissimus dorsi. Nerve supply होगा nerve to latissimus dorsi or the thoracodorsal nerve. फाइन है बच्चों, क्लियर है? ये सब जो जो इंपॉर्टेंट लगता है फ्रॉम द पॉइंट ऑफ व्यू ऑफ एमसीक्यूज, हाँ, तो ये सब लगा दिया मैंने. आई पुट ऑल दिस फॉर यू. ओके, नाउ कमिंग टू द नेक्स्ट वन, ट्रायंगल ऑफ ऑस्कल्टेशन. बच्चों अगर ये विजुअल स्लाइड आता है आपके लिए, हाँ, दिस कम्स एज अ विजुअल स्लाइड एंड ये पूछा गया व्हाट इज दिस, ये क्या है? दैट्स द ट्रायंगल ऑफ ऑस्कल्टेशन. सो बाउंड्रीज क्या होता है? व्हाट आर द बाउंड्रीज ऑफ ट्रायंगल ऑफ ऑस्कल्टेशन? हु इज दिस नंबर वन? ये नंबर वन कौन है? ट्रेपीजियस. नंबर टू कौन है? हु इज दिस नंबर टू? ये द स्कैपुला. नंबर टू इज द स्कैपुला एंड नंबर थ्री is the latissimus dorsi. So triangle of auscultation तीन चीजों से बनता है, by the trapezius, the medial border of scapula and the latissimus dorsi. Okay, and ये which intercostal space is here? यहाँ पे होता है sixth intercostal space. And there's a muscle rhomboidus major. Rhomboidus major फ्लोर में होता है. That's rhomboidus major. ये फ्लोर में होता है. आप अपने नोट्स बना लीजिए इसके साथ. हाँ, I hope you have made the notes. हाँ, नोट्स बना दिए ना. So triangle of auscultation के बाउंड्रीज क्या होंगे? The trapezius, the scapula and the latissimus dorsi. The floor is formed by the sixth intercostal space and rhomboidus major. Fine, that's triangle of auscultation. यहाँ पे we can hear the sounds very clearly. अगर left side पे आप auscultate करोगे तो left side is the stomach, तो you can feel the liquids going down into the stomach, हाँ, through that this triangle of auscultation. समझ में आ रहा है बच्चों? triangle of auscultation के boundaries याद रखना. ये आया है, पहले भी आया है, so this is important. Okay, look students, look, what is this? ये क्या है? What is this triangle? Look at this triangle. This is the Petit's triangle. Very good, Subjit. Very good. Abhi, if you sit for the exam, you'll crack the exam. Very good. Okay, so ये क्या है? Triangle of Petit's. इसके boundaries देखिए बच्चों. What are the boundaries of this? Number one. Who's this number one? Who's this number two? And who's this number three? बोलो इसका आंसर बोलो. नंबर वन कौन है बच्चा? एक्सटर्नल ऑब्लिक. नंबर वन इज द एक्सटर्नल ऑब्लिक. नंबर दो कौन है? हु इज नंबर टू? चलो बताइए. यस, द रेस्ट ऑफ यू कैन ऑल्सो आंसर ना बच्चा. बाकी के बच्चे भी आंसर करो. हर्ष आंसर करो. हु एल्स इज देयर? यस, द रेस्ट ऑफ यू. पीसफुल, अर्जुन, महेश, श्री, all of you can answer बच्चों. आंसर करिए. you answer. चलो बोलो. what is this muscle? एक तो external oblique हो गया आगे, पीछे होगा latissimus dorsi. तो number 2 is latissimus dorsi and number 3 is the iliac crest. This is the Petit's triangle. याद रखना. external oblique, latissimus dorsi. The floor is formed by iliac crest, the base is formed by iliac crest, that's the Petit's triangle. Fine है बच्चों. रोटेटर कफ मसल बोल सकता है कोई? रोटेटर कफ मसल इज फॉर्म बाय व्हाट? एक मसल आगे होता है शोल्डर जॉइंट के, एक मसल ऊपर होता है, दो मसल्स पीछे होते हैं. हाउ इज द रोटेटर कफ फॉर्म्ड? एनीवन आंसर दिस. रोटेटर कफ मसल इज फॉर्म बाय, आई मीन द रोटेटर कफ इज फॉर्म बाय विच मसल्स? नंबर 1 जो आगे की तरफ है, ये कौन सा मसल है? सबस्कैपुलरिस, जो ऊपर होता है. सुप्रास्पाइनेटस सिट्स, वेरी गुड, सुप्रास्पाइनेटस. पीछे दो मसल्स हैं, इंफ्रास्पाइनेटस एंड टिरिस माइनर. इंफ्रास्पाइनेटस एंड टिरिस माइनर. सो सबस्कैपुलरिस आगे, सुप्रास्पाइनेटस ऊपर, infraspinatus and teres minor पीछे की तरफ. This muscles are known as rotator cuff. Very good, peaceful world. Very good. वेरी गुड बच्चा पारुल, वेरी गुड. चलो बच्चों ऐसे ना बी इंटरैक्टिव, हाँ, तो इट विल बी इजी फॉर यू. रोटेटर कफ वेरी इंपॉर्टेंट, एमसीक्यू आएगा ही आएगा. ठीक है, ओके, क्लियर विद दिस. एबडक्शन एट द शोल्डर जॉइंट, अभी मैंने आपको बोला 0 to 15 डिग्रीज, इससे हम बोलेंगे इनिशिएशन ऑफ एबडक्शन. ये कौन करेगा? सुप्रास्पाइनेटस. 15 to 90 डिग्रीज डेल्टॉइड, एंड 90 एंड अबव दिस इज कॉल्ड ओवरहेड एबडक्शन. ये कौन करेगा? सेराटस एंटीरियर, ट्रेपेजियस. परफेक्ट. क्या बच्चा? हाँ, वेरी गुड. इंफीरियरली नहीं होता, इंफीरियरली देयर इज नथिंग, दैट इज व्हाई द शोल्डर जॉइंट इज डिसलोकेटेड इंफीरियरली. शोल्डर जॉइंट नीचे डिसलोकेट क्यों होता है? बिकॉज नीचे कुछ सपोर्ट नहीं है. फाइन, okay, very good. So we come to the next page. Come on students, if you can answer this. Structures piercing the clavipectoral fascia. बहुत ज़्यादा important MCQ है. Structures piercing the clavipectoral fascia. Anyone? Anyone? Come on, you can answer this. Number 1. Cephalic vein. एक है cephalic vein. Second is thoracoacromial artery. Thoracoacromial artery. Next is the lateral pectoral nerve. Lateral pectoral nerve and lymphatics. Lymphatics. तो चार चीजें होती हैं: cephalic vein, thoracoacromial artery, lateral pectoral nerve and lymphatics from the breast. ये याद रखना, ये बहुत इंपॉर्टेंट है बच्चों. This is very important, right? मतलब सब कुछ इंपॉर्टेंट है जो ये वर्कबुक में है. Which is the nerve? एक ऑप्शन आता है medial pectoral nerve. So medial pectoral nerve does not pierce the clavipectoral fascia. So medial pectoral nerve क्या pierce करता है? Pectoralis minor. It pierces the pectoralis minor. याद रखना. So structures piercing the clavipectoral fascia, एक बार वापस: cephalic vein, thoracoacromial artery, lateral pectoral nerve, lymphatics from the breast. Perfect. Okay, that's good. ब्रांचेस ऑफ लैटरल कॉर्ड ऑफ द ब्रेकियल प्लेक्सस. ब्रांचेस ऑफ लैटरल कॉर्ड, ये ब्रेकियल प्लेक्सस है ना, कंप्लीट आना चाहिए. पूरा ब्रेकियल प्लेक्सस शुड बी परफेक्ट फॉर यू. सो ब्रांचेस फ्रॉम द लैटरल कॉर्ड, यस, वन इज द लैटरल पेक्टोरल नर्व. मैं शॉर्ट में लिख रहा हूं, यहां पे जगह नहीं है. लैटरल पेक्टोरल, लैटरल रूट ऑफ मीडियन नर्व एंड मस्कुलोक्यूटेनियस नर्व. So branches from the lateral cord of the brachial plexus क्या है? Lateral pectoral nerve, the lateral root of median nerve and musculocutaneous nerve. Musculocutaneous, yes, very good, very good. गोपिका, very good बच्चा, very good. सब लोग इंटरैक्टिव रहो, आंसर दिस, अच्छा रिवीजन हो जाएगा. फाइन. ब्रांचेस ऑफ मीडियल कॉर्ड, ब्रांचेस ऑफ पोस्टीरियर कॉर्ड. चलो पूरा ब्रेकियल प्लेक्सस खत्म कर देते हैं ना, पूरा ब्रेकियल प्लेक्सस खत्म कर देते हैं. सो लैटरल कॉर्ड के ब्रांचेस बोलो बच्चों: लैटरल पेक्टोरल, लैटरल रूट ऑफ मीडियन नर्व, मस्कुलोक्यूटेनियस. आपको तो ये पता ही होगा. ब्रांचेस ऑफ मीडियल कॉर्ड: medial pectoral nerve, medial root of median nerve, the medial cutaneous nerve of arm, the medial cutaneous nerve of forearm and ulnar nerve. Ulnar nerve. ठीक है? So what are the branches of medial cord? One is the medial pectoral nerve, the medial root of median nerve, the medial cutaneous nerve of arm, medial cutaneous nerve of forearm and ulnar nerve. Ulnar. ठीक है? एक बार वापस: medial pectoral, medial root of median nerve, medial cutaneous nerve arm, medial cutaneous nerve forearm and the ulnar nerve. ठीक है बच्चा? ओके, पोस्टीरियर कॉर्ड के ब्रांचेस बोल सकता है कोई? अपर सबस्कैपुलर नर्व, लोअर सबस्कैपुलर नर्व, nerve to latissimus dorsi. Yes, that is thoracodorsal. So upper subscapular, lower subscapular, nerve to latissimus dorsi, axillary nerve and radial nerve, axillary nerve and radial nerve. ठीक है ना, क्लियर है ना, ये तो पता होगा ना आपको. ब्रांचेस ऑफ पोस्टीरियर कॉर्ड, चलो बच्चों बोल सकते हैं ब्रांचेस ऑफ पोस्टीरियर कॉर्ड. वन, अपर सबस्कैपुलर, अपर सबस्कैपुलर, lower subscapular, thoracodorsal, axillary and radial. Fine है बच्चों, clear है? So this becomes the branches of the posterior cord. What are the branches from the roots of the brachial plexus? Branches from the roots of the brachial plexus. C5 रूट से कौन आता है? डॉर्सल स्कैपुलर नर्व. C5 रूट से डॉर्सल स्कैपुलर नर्व. C5, C6, C7 से लॉन्ग थोरैसिक नर्व. लॉन्ग थोरैसिक नर्व. ठीक है. C5 से डॉर्सल स्कैपुलर नर्व. हाँ, ओके सुभजीत, वेरी गुड. ठीक है. ब्रांचेस फ्रॉम द रूट्स ऑफ द ब्रेकियल प्लेक्सस. C5 से कौन आता है? C5 से आता है डॉर्सल स्कैपुलर नर्व. एंड C5, C6, C7 से आता है नर्व टू सेराटस एंटीरियर, दैट इज लॉन्ग थोरैसिक नर्व. बच्चों ब्रेकियल प्लेक्सस शुड बी परफेक्ट. हाँ, ब्रेकियल प्लेक्सस बहुत ज्यादा इंपॉर्टेंट है, कहीं से भी एमसीक्यूज आ सकते हैं. फाइन, क्लियर टू ऑल ऑफ यू? कुछ डाउट्स हैं यहां तक? बोलो. यहां तक कुछ डाउट्स है तो बोलो. यस, आई विल प्रोसीड. यस बच्चों, बोलो बच्चों. गोपिका, फाइन. गोपिका, सुभजीत इज आंसरिंग. पारुल क्लियर. पीसफुल वर्ल्ड. हु एल्स इज देयर? हर्ष कहाँ गया? हु एल्स इज देयर? महेश, आंसर सब लोग आंसर करिए. आई शुड नो दैट यू आर एबल टू फॉलो. अर्जुन, श्रीनी, ओके, ऑल ऑफ यू आर देयर, वेरी गुड. ओके पारुल, ठीक है. रिवीजन हो रहा है ना? रिवीजन हो रहा है ना? ओके. Coming to the spaces around the arm. Spaces around the arm, upper triangular space, lower triangular space, quadrangular space. ये तीन spaces है, इसको याद रखिए. अब इसको कैसे याद रखोगे आप? How do you remember this? Look, if I have to draw a slide, अगर मुझे slide draw करना है, this is the scapula. Okay, that's a humerus. ये humerus हो गया. ये कौन सा मसल है? बोलो बच्चों, व्हाट इज दिस मसल? ये क्या मसल है? ये है लॉन्ग हेड ऑफ ट्राइसेप्स. लॉन्ग हेड ऑफ ट्राइसेप्स, ठीक है. व्हाट इज दिस मसल? व्हाट इज दिस मसल विच बिगिंस फ्रॉम द स्कैपुला? व्हाट इज दिस? यह है एक्रोमियन प्रोसेस. यह है टेरिस माइनर. सॉरी, यह है टेरिस माइनर. दैट्स टेरिस माइनर. एंड ये होगा टेरिस मेजर. टेरिस मेजर. ओहो, सॉरी. टेरिस माइनर, टेरिस मेजर. Fine, this is teres. अरे यार, what's happening? Fine. So देखो, अब मैं लेबल करता हूँ इसको. लेबल करता हूँ. What is this? Number 1, this is the long head of triceps. ये number 2 कौन है? Teres minor. Teres minor. And what's this? Teres major. Teres major. Huh? So you get 3 spaces. 3 spaces बनते हैं यहाँ पे. What is this space? This is the upper triangular space. This is the lower triangular space. ये होगा quadrangular space. Upper triangular space, lower triangular space, quadrangular space. इसके boundaries याद रखना बच्चा. This is very very important. Boundaries are always asked. Upper triangular space के boundaries, teres minor, teres major, long head of triceps. Lower triangular space के boundaries, teres major, long head of triceps, shaft of the humerus. And quadrangular space के boundaries, teres minor, teres major, long head of triceps and the neck of the humerus. Neck of the humerus. Contents बोल सकते हो. Contents here. What is this? Artery. This is the circumflex scapular artery. Circumflex scapular artery. What is this? Artery here. And what is this nerve here? एक nerve है, एक artery है. This is the axillary nerve. Axillary nerve. And the posterior circumflex humeral artery. Axillary nerve and the posterior circumflex humeral artery. Okay, Subjit, very good, very good. फाइन. एंड व्हाट इज हियर? यहाँ पे होती है रेडियल नर्व एंड एक आर्टरी होती है प्रोफंडा ब्रेकाई आर्टरी. सो कंटेंट्स ऑफ लोअर ट्रायंगुलर स्पेस, ये है रेडियल नर्व एंड द प्रोफंडा ब्रेकाई आर्टरी. रेडियल नर्व एंड प्रोफंडा ब्रेकाई आर्टरी. Upper triangular space, circumflex scapular artery. Quadrangular space, axillary nerve, the posterior circumflex humeral artery. Axillary nerve and the posterior circumflex humeral artery. Perfect है. याद रखना ये स्लाइड एंड ये स्लाइड याद रखना, ऐसे डायग्राम्स ड्रॉ करना बच्चा, एक फटाफट ऐसे डायग्राम ड्रॉ कर सकते हो ना आप विद द पेंसिल, एंड दैट इज हाउ यू रिमेंबर the spaces around the arm. Very important. I hope this is clear. ठीक है बच्चा, that is okay सुभजीत. हाँ, okay, fine. Anatomical snuff box. अब anatomical snuff box की boundaries क्या है? Okay, can anyone tell me the contents of cubital fossa? Contents of cubital fossa. इससे MCQ आता है. MCQ ऐसे आता है, contents of cubital fossa are all except. एक ऑप्शन होता है अल्नार नर्व. अल्नार नर्व बच्चों रिमेंबर, अल्नार नर्व इज नॉट अ कंटेंट ऑफ क्यूबाइटल फोसा. अल्नार नर्व क्यूबाइटल फोसा में नहीं होता है. सो व्हाट आर द कंटेंट्स ऑफ क्यूबाइटल फोसा बोल सकते हैं बच्चों? व्हाट आर द कंटेंट्स फ्रॉम मीडियल टू लैटरल? द मीडियन नर्व, द ब्रेकियल आर्टरी, मीडियन नर्व, ब्रेकियल आर्टरी, द टेंडन ऑफ बाइसेप्स एंड द रेडियल नर्व. रेडियल नर्व, ठीक है. फ्रॉम मीडियल टू लैटरल, मीडियन नर्व, MBBR. हाँ ये तो आपको पता होगा ना, MBBR, वेरी कॉमन निमोनिक. मीडियन नर्व, brachial artery, yes, the tendon of biceps and the radial nerve. Perfect, very good बच्चों, very good, you are answering very well. हाँ, रिवाइज करो अपने मन में, रिवाइज करो हाँ, and try to answer this. So that's it. एनाटॉमिकल स्नफ बॉक्स एक दूसरा बहुत ज्यादा इंपॉर्टेंट क्वेश्चन है, एनाटॉमिकल स्नफ बॉक्स. अब हाउ डू यू रिमेंबर दिस एनाटॉमिकल स्नफ बॉक्स? कैसे याद रखोगे? आई जस्ट टेल यू वन इजी वे. ये है अपना हेड ऑफ द रेडियस, ये नेक ऑफ द रेडियस, ये रेडियल ट्यूब्रोसिटी, शाफ्ट ऑफ द रेडियस, एंड दैट्स द स्टाइलॉइड प्रोसेस ऑफ रेडियस. ये स्टाइलॉइड प्रोसेस, ठीक है. सो हेड, नेक, रेडियल ट्यूब्रोसिटी, शाफ्ट, स्टाइलॉइड प्रोसेस. ये कौन है बच्चों? दैट्स अ अल्ना, है ना, ये अल्ना है. अब पीछे से देख रहे हो डॉर्सल एस्पेक्ट से. अब बच्चों बोल सकते हो व्हाट इज दिस मसल? व्हाट इज दिस मसल विच बिगिंस फ्रॉम द रेडियस एंड अल्ना? यह है एब्डक्टर पॉलिसिस लॉन्गस. एब्डक्टर पॉलिसिस लॉन्गस गोज लाइक दिस, ऐसे चला जाता है. व्हाट इज दिस मसल विच बिगिंस फ्रॉम द रेडियस? एक्सटेंसर पॉलिसिस ब्रेविस. ये भी इसके साथ गया. So abductor pollicis longus and extensor pollicis brevis जो है, they go together, वो साथ में जाते हैं. So what boundary are they going to form? The lateral boundary of the snuff box. ऐसे याद रखना आपको. So lateral boundary of the snuff box is formed by, yes, very good. So lateral boundary of the snuff box is formed by abductor pollicis longus, extensor pollicis brevis. The medial boundary is formed by a muscle here, extensor pollicis longus. ये बनता है medial boundary. बस इस पे कंफ्यूजन होता है बच्चों का. स्टूडेंट्स बहुत ज्यादा कंफ्यूज होते हैं एनाटॉमिकल स्नफ बॉक्स के बाउंड्रीज पे. सो जस्ट रिमेंबर दिस व्हाट आई हैव टोल्ड यू. द लैटरल बाउंड्री इज फॉर्म बाय एब्डक्टर पॉलिसिस लॉन्गस, एक्सटेंसर पॉलिसिस ब्रेविस. ये स्लाइड याद रखना बच्चा, इट्स वेरी इजी. The medial boundary is formed by extensor pollicis longus. Floor में क्या होगा? Floor में the floor is formed by, yes, very good. The floor is formed by the styloid process of radius, scaphoid and trapezium. Scaphoid and trapezium bone. ये बहुत common MCQ है. Boys मतलब clinical बनाते हैं इसको. 10 years old boy is driving a bicycle and meets with an accident. When he falls down, he puts his hand in between. There's a fracture of the bone in the anatomical snuff box. So which bone is fractured? Which bone is fractured? The scaphoid. Scaphoid fracture होता है anatomical snuff box में, याद रखना. So floor में कौन है बच्चा? Floor में styloid process, scaphoid, trapezium. दो tendons आते हैं यहाँ पे, दो tendons. What are these tendons of? ECRL and ECRB. Who's the content of the snuff box? Content बोलिए बच्चों. Who's the content of the snuff box? हाँ, content of the snuff box is radial artery, and there's the who's in the roof में कौन है? Cephalic vein and the superficial branch of radial nerve. Cephalic vein and superficial branch of radial nerve roof में होता है. कंटेंट कौन है? रेडियल आर्टरी. बी वेरी क्लियर, वेरी क्लियर. इसमें बहुत ज्यादा कंफ्यूजन होता है. स्टूडेंट्स गेट कंफ्यूज्ड अ लॉट. लैटरल बाउंड्री एब्डक्टर पॉलिसिस लॉन्गस, एक्सटेंसर पॉलिसिस ब्रेविस, medial boundary extensor pollicis longus, floor styloid process, scaphoid, trapezium, though tendons, two tendons, ECRL, ECRB, they are in the floor. Content, radial artery, roof, cephalic vein, and the superficial branch of radial nerve. Cephalic vein and the superficial branch of radial nerve. Perfect है? So just remember the slide, हाँ? इतना याद रखना बच्चों. This is very important. Fine. Okay, now coming to the next slide. Tell me बच्चों, what are the branches of axillary artery? This is very important, very important. बोल सकते हो? Axillary artery के 3 parts होते हैं. Pectoralis minor muscle divides the axillary artery into 3 parts. First part 1 branch. First part से एक branch आती है. First part से 1 branch, second part से 2 branches, third part से 3 branches. Answer this. First part. Anyone? हाँ ठीक है बच्चा, ठीक है. रेडियल आर्टरी, रेडियल है वो. पीसफुल वर्ल्ड. So axillary artery is divided into 3 parts by whom? Pectoralis minor. So what are the branches from the first part? Lateral, no, superior thoracic artery. First part की branch है superior thoracic artery. Second part की branch है lateral thoracic and thoracoacromial artery. Lateral thoracic and thoracoacromial. थर्ड पार्ट की ब्रांच है एंटीरियर एंड पोस्टीरियर सर्कमफ्लेक्स ह्यूमरल एंड सबस्कैपुलर. यू गेट एमसीक्यूज ऑन दिस. इस पे एमसीक्यूज आते हैं. सो ब्रांचेस ऑफ एक्सिलरी आर्टरी इज वेरी इंपॉर्टेंट. फर्स्ट पार्ट सुपीरियर थोरासिक, सेकेंड पार्ट के 2 ब्रांचेस है लैटरल थोरासिक एंड थोरैकोएक्रोमियल. थर्ड पार्ट के 3 ब्रांचेस है एंटीरियर सर्कमफ्लेक्स ह्यूमरल, पोस्टीरियर सर्कमफ्लेक्स ह्यूमरल एंड सबस्कैपुलर आर्टरी. Subscapular artery. Okay, clear to all of you? Fine. बाकी मस्कुलोक्यूटेनियस नर्व आपको पता है, एक्सिलरी नर्व आपको पता है. मस्कुलोक्यूटेनियस नर्व 3 मसल सप्लाई करती है. बाइसेप्स ब्रेकाई, कोरैकोब्रेकियालिस एंड ब्रेकियालिस, मीडियल हाफ ऑफ ब्रेकियालिस. मस्कुलोक्यूटेनियस नर्व सप्लाइज, हाँ ओके. मस्कुलोक्यूटेनियस नर्व सप्लाइज बाइसेप्स, ब्रेकियालिस, कोरैकोब्रेकियालिस. Axillary nerve supplies deltoid and teres minor. Deltoid and teres minor. Fine. यहां तक कुछ डाउट्स है तो बोलो. Then we proceed. यहां तक कुछ डाउट्स है बच्चों, एक बार देख लो. यहां तक अगर कुछ डाउट्स हैं तो let me know. Fine. दैट्स ओके बच्चा. अभी जो भी कंफ्यूजन है, जो भी मिसअंडरस्टैंडिंग्स है, ट्राई टू क्लियर योरसेल्फ. ओके, आई एम देयर. इफ यू हैव एनी प्रॉब्लम लेट मी नो. आई एम हियर टू सॉल्व योर डाउट्स, टू मेक योर एनाटॉमी क्लियर. यस सुभजीत. ओके चलो बच्चों, विल स्टार्ट विद दिस. मसल सप्लाइड बाय मीडियन नर्व इन द हैंड. मसल सप्लाइड बाय मीडियन नर्व इन द हैंड. बहुत ज्यादा इंपॉर्टेंट है ये, बहुत ज्यादा इंपॉर्टेंट. बहुत ज्यादा एमसीक्यूज आते हैं. हाँ क्या चाहिए बच्चा, क्या चाहिए? वन मोर टाइम, व्हाट डू यू वांट? हाँ वेरी गुड. पारुल बच्चे क्या चाहिए? व्हाट डू यू वांट? मस्कुलोक्यूटेनियस नर्व. मस्कुलोक्यूटेनियस नर्व सप्लाइज द बाइसेप्स ब्रेकाई, ब्रेकियालिस एंड कोरैकोब्रेकियालिस. 3 मसल सप्लाई करती है. बाइसेप्स ब्रेकाई, ब्रेकियालिस, कोरैकोब्रेकियालिस. बस ये याद रखना. वेरी गुड सुभजीत, वेरी गुड. ऐसे कोरिलेट करोगे ना तो आगे चल के इट विल बी वेरी इजी फॉर यू. ओके ग्रेट. नाउ टेल मी द मसल सप्लाई बाय मीडियन ऑन द हैंड. कितने मसल सप्लाई करती है मीडियन ऑफ हैंड में? 5 मसल्स. 5 मसल्स. दिस यू शुड नो, दिस यू शुड नो. हाँ यू मस्ट नो. मसल सप्लाई बाय द मीडियन ऑन द हैंड. चलो स्टार्ट करते हैं. 1 इज द एब्डक्टर पॉलिसिस ब्रेविस, फ्लेक्सर पॉलिसिस ब्रेविस, ओपनंस pollicis, opponens pollicis, abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, first and second lumbrical. फर्स्ट एंड सेकेंड लम्ब्रिकल्स. फ्लेक्सर पॉलिसिस ब्रेविस का सुपरफिशियल हेड, ये याद रखना बच्चा, फ्लेक्सर पॉलिसिस ब्रेविस के दो हेड्स होते हैं. सो वन हेड इज सप्लाइड बाय मीडियन नर्व, दैट्स अ सुपरफिशियल हेड. सुपरफिशियल हेड, यस, वेरी गुड. हाँ, हैंड डिस्कस करें सुबजीत, हैंड. हाँ, so muscle supplied by median nerve in the hand कौन है? abductor pollicis brevis, flexor pollicis brevis का superficial head, opponens pollicis, first and second lumbricals, first and second lumbricals. Fine. Now muscle supplied by ulnar nerve in the hand. So median nerve is also known as what? median nerve का दूसरा नाम क्या है? laborer's nerve. laborer's nerve. So laborer's nerve कौन है? median nerve. ulnar nerve is what? musician's nerve. ulnar nerve को क्या बोलते हैं अपन? musician's nerve. Why? Because it supplies 15 muscles in the hand, and this 15 muscles are used for very fine movements. musician's nerve. musicians. चलो देखते हैं. which are the muscles supplied by ulnar nerve in the hand? anyone बोल सकते हो? ulnar nerve in the hand. 1 abductor digiti minimi brevis, flexor digiti minimi brevis, opponens digiti minimi, third and fourth lumbricals, intraossei कितने होते हैं? 8. 4 palmar, 4 dorsal intraossei. Then adductor pollicis, and ये जो superficial head है इसका deep head of flexor pollicis brevis. So this becomes 15 muscles. ठीक है. So abductor digiti minimi brevis, flexor digiti minimi brevis, opponens digiti minimi, the third and the fourth lumbricals, intraossei, 4 palmar, 4 dorsal, so total 8, adductor pollicis, and the deep head of flexor pollicis brevis, ये याद रखना बच्चों, ये हमेशा आता है. दिस ऑलवेज कम्स फॉर यू इन योर एग्जाम्स, तो ये याद रखना. मसल सप्लाइड बाय मीडियन नर्व, अल्नार नर्व इन द हैंड. ठीक है पारुल, फाइन, ओके. सुभजीत, क्लियर नो? पीसफुल वर्ल्ड, आपको तो पता ही होगा ये सब. इट्स अ क्विक रिवीजन. हाँ, ये रिवीजन सीरीज है. दिस इज अ एफएमजी रिवीजन सीरीज गोइंग ऑन. फाइन, मिशन एफएमजी. ओके, ठीक है बच्चों, विल प्रोसीड. चलो आगे चलते हैं. विल प्रोसीड देन. ओके, ग्रेट. मसल सप्लाइड बाय रेडियल नर्व, मसल सप्लाइड बाय रेडियल नर्व. कैसे अभी इसको, इट्स अ लॉन्ग लिस्ट, काफी लंबा लिस्ट है. मसल सप्लाइड बाय रेडियल नर्व, चलो फटाफट देख लेते हैं. सो नाउ द फर्स्ट मसल सप्लाइड बाय रेडियल नर्व इन द आर्म इज ट्राइसेप्स. हाँ, मसल सप्लाइड बाय रेडियल नर्व, वन इज ट्राइसेप्स. फिर ब्रेकियालिस का लैटरल हाफ. जो musculocutaneous nerve supplies the brachialis, that's a medial half. So this is lateral half. Then comes brachioradialis, extensor carpi radialis longus. ठीक है. So what are the muscles supplied by radial nerve? Radial nerve क्या मसल सप्लाई करती है? एक तो ट्राइसेप्स को सप्लाई किया, ट्राइसेप्स को. Then it supplies the brachialis. It supplies the anconeus. It supplies the brachialis, that's lateral half. Brachioradialis, extensor carpi radialis longus. Okay, देखो सुभजीत कैसे आंसर कर रहा है. ओके, so triceps, brachialis, lateral half, anconeus, brachioradialis and ECRL, extensor carpi radialis longus. इसके बाद the radial nerve divides into two branches. One is the superficial branch and the other one is the deep branch. Deep branch is known as the posterior interosseous nerve. The deep branch of radial nerve is known as posterior interosseous nerve. अगर MCQ आता है muscles supplied by radial nerve, so these are the muscles supplied by radial nerve. अब radial nerve divides, है ना, अब radial nerve divides into a superficial branch and deep branch. अब इसके बाद जो भी मसल होगा that will be supplied by whom? The deep branch of radial nerve, जिसका नाम है posterior interosseous nerve. Posterior interosseous nerve. So after this it is going to be posterior interosseous nerve. So just remember it like this. बाद में सारे extensors, जितने भी extensors हैं, that is all supplied by posterior interosseous nerve. Fine. Coming to Erb's paralysis. Erb's paralysis. Anyone? Can anyone tell me? Yes, बच्चों बोलो. Peaceful world, Parul. और कोई है? Shrini. Answer. How is the position of the upper limb in Erb's paralysis? तो arm is adducted. Arm is medially rotated. So arm adducted होता है, arm medially rotated होता है, forearm is extended, forearm is pronated. And fingers ऐसे हो जाते हैं, ऐसे. इसको क्या बोलते हैं? Policeman stiff hand. हाँ? So arm is adducted, arm is medially rotated, forearm is extended, forearm is pronated, and the fingers becomes like this. इसको बोलते हैं policeman stiff hand. Policeman stiff hand. So how is the position of upper limb? Arm is adducted, medially rotated. Forearm is extended, pronated, and policeman's stiff hand. Policeman's stiff hand. बस ये याद रखना. Waiter's stiff hand. Very good, peaceful world. Waiter's stiff hand बोलते हैं, policeman's stiff hand बोलते हैं, anything. So Erb's paralysis is injury to the upper trunk of the brachial plexus. Very good, बच्चों, very good. ठीक है, that's the position of the arm, forearm. Excellent. Good. ये बोल सकते हो बच्चों, ये क्या है? What is this? What is this clinical condition? Claw hand. And claw hand कैसे होता है? It is hyper extension at metacarpophalangeal joint and hypoflexion at interphalangeal joints. Extension at metacarpophalangeal joints and flexion at interphalangeal joints. This is due to paralysis of which muscle? ये कौन से muscle के paralysis से होता है? Claw hand. Anyone? Which muscles when paralyzed leads to claw hand? Yes, lumbricals. So paralysis of lumbricals leads to claw hand. ठीक है ना बच्चों? And lumbricals का nerve supply बोल सकते हो? Nerve supply of the lumbricals medial to उसको ऐसे लिखते हैं first and second. हाँ, nerve supply of the lumbricals first and second, third and fourth. First and second is median nerve, third and fourth is ulnar nerve. हाँ, very good बच्चों, very good, है ना? So lumbricals, 4 lumbricals है अपने पास. तो first and second is supplied by median nerve, third and fourth is supplied by ulnar nerve. Paralysis of lumbricals leads to claw hand. ये है ना visual slide है, देख के रखना इसको, आ जाएगा एग्जाम में. Look at this बच्चों, what is this? ये देखो, ये आप देख सकते हो, the flat shoulder. Look at this shoulder. इसका shape देखो कैसे round है. And you can see the shape is gone, the rounded shape is gone. इससे हम बोलते हैं flat shoulder. अब बोलो बच्चों, which is the muscle which gives the shape to the shoulder? ये जो beautiful shape है, contour. इसे हम बोलते हैं contour of the shoulder. Who gives this contour? Deltoid. ये कौन करता है? Deltoid. Who supplies the deltoid? Axillary nerve. Deltoid is supplied by axillary nerve. And अगर deltoid paralysis हो गया, तो we get a flat shoulder. हाँ, flat shoulder. Paralysis of deltoid. Nerve is axillary nerve. Axillary nerve. Very good बच्चा, very good. सुभजीत, best है, very good. चलो बच्चों, समझ में आ रही है? ऐसे आंसर करिए. देखो, गलत भी हुआ ना, that is okay. This is a learning process. तो गलत अगर करोगे तो उसे और अच्छे से याद रखोगे, ठीक है। तो गोइंग टू द नेक्स्ट स्लाइड, आंसर दिस, व्हाट इज दिस? दिस इज द विंगिंग ऑफ स्कैपुला। ये देख सकते हो, दैट्स अ विंगिंग ऑफ स्कैपुला। एंड विंगिंग ऑफ स्कैपुला इज कॉज्ड बाय पैरालिसिस ऑफ ट्रू मसल्स। एक तो सेरेटस एंटीरियर है, दूसरा ट्रेपेजियस भी होता है, trapezius. So winging of scapula is caused due to paralysis of two muscles. Number one is serratus anterior and number two is trapezius. अब बोलो बच्चों कैसे डिस्टिंग्विश करोगे? How are you going to distinguish whether ये serratus anterior paralysis से हुआ है या फिर ये trapezius के paralysis से हुआ है? How do you know this? So winging on attempted movement, that's serratus anterior, and winging at rest is trapezius. मतलब if a person is beginning a movement, अगर person is performing a movement and winging of scapula हुआ तो that is because of serratus anterior. And person is at rest, ऐसे rest है, is not doing anything, and winging of scapula है तो that is due to paralysis of trapezius. Clear है? You'll be able to distinguish. अगर ये visual slide आता है तो आपको लिखना है winging of scapula if the person is shown like pushing a wall, ऐसे वो wall को push कर रहा है, winging दिख रहा है. So winging on attempting movement, that's serratus anterior. And if a person is resting, ऐसे बैठा है and winging है तो that is trapezius. Fine? हाँ, nerve is long thoracic nerve. Trapezius, okay, this is long thoracic nerve and this is spinal accessory nerve. ट्रेपेजियस को कौन सप्लाई करता है? स्पाइनल एक्सेसरी नर्व. सेरेटस एंटीरियर को कौन सप्लाई करता है? लॉन्ग थोरैसिक नर्व. लॉन्ग थोरैसिक नर्व. वेरी गुड. फाइन. wrist drop. Can anyone tell me wrist drop is due to paralysis of extensor carpi radialis longus and the nerve is radial nerve. So who supplies the extensor carpi radialis longus? The radial nerve. Radial nerve supply करती है इसको extensor carpi radialis longus को. Extensor carpi radialis longus का action is extension at the wrist joint. Extension at the wrist joint. And अगर ये radial nerve damage हो गया, the extension is gone, ये बनता है wrist drop. That is wrist drop. Fine. So paralysis of ECRL and that's radial nerve. I hope this is clear to all of you. Chalo. Carpal tunnel syndrome. What is carpal tunnel syndrome? What is carpal tunnel syndrome? It is the compression of the median nerve in the carpal tunnel. Okay, carpal tunnel syndrome is the compression of the median nerve in the carpal tunnel. तो जितने भी muscles होते हैं which are supplied by the median nerve, हाँ, जितने भी muscles हैं supplied by the median nerve in the hand are paralyzed. See, ये है flattening. ये आप देख सकते हो. This is the flattening of thenar eminence. So thenar eminence जो है that becomes flat. That is carpal tunnel syndrome. ठीक है? That is compression of median nerve in the carpal tunnel. Carpal tunnel syndrome. याद रखना. बच्चों इसमें कुछ यहाँ तक कुछ डाउट्स है तो बोलो. So that is about the upper lip. इतना you have to know. Must know है ये, must know. Yes, बोलो बच्चों. Peaceful world, Parul. Subjit, it's a quick revision है ना? Very good. कुछ डाउट्स है तो we'll proceed. There'll be a loss of sensations of this 3.5 fingers. Loss of sensations of 3.5 fingers, but sensations of the thenar eminence would be intact. Sensations on the thenar eminence is intact. चलो प्रोसीड करते हैं. बाउंड्रीज ऑफ फीमोरल रिंग. बच्चों ये बहुत ज्यादा इंपॉर्टेंट एमसीक्यू है. बाउंड्रीज ऑफ फीमोरल रिंग कोई बोल सकता है? बाउंड्रीज ऑफ फीमोरल रिंग देखिए, ये आ गया ऐसे. दैट्स आवर फीमोरल शीथ. ये femoral sheath है, हाँ, ये femoral sheath है, that's the femoral ring, ये femoral ring है, हाँ. तो what are the boundaries of femoral ring बताओ? What are the boundaries of femoral ring? Number 1, number 2, number 3, and this is number 4. Number 4. Boundaries of femoral ring. This is femoral ring. So what are the boundaries of femoral ring? Number 1 कौन है? Number 1 is the inguinal ligament. Number 1 is the inguinal ligament. Number 2, number 1 is inguinal ligament. Number 2 is lacunar ligament. Number 3 is pectinate ligament. And number 4 is the septum. Number 4 is the septum which separates it from the femoral vein. यहाँ पे कौन है? Femoral vein. यहाँ पे क्या होता है? Femoral artery है ना? Femoral artery होती है. So that's the femoral canal. Femoral canal is हाँ बच्चा सुखजीत, that's fine, that's fine. yes, that's fine. Huh? So anterior boundaries formed by what? Inguinal ligament. Anteriorly inguinal ligament. Medially कौन है? Lacunar ligament. पीछे कौन है? Posteriorly is pectinate ligament. And laterally is the septum separating it from the femoral vein. Laterally is the septum separating it from the femoral vein. ठीक है? So these are the boundaries of femoral ring. बस ये याद रखना, this is very important. Sartorius muscle. Sartorius muscle का nerve supply बोल सकते हो. What is the nerve supply of sartorius? That's a femoral nerve. Nerve supply of sartorius is the femoral nerve. Femoral nerve. What is the action of sartorius? Sartorius का दूसरा नाम है honeymoon muscle. Honeymoon muscle. That's sartorius. So what is the action of sartorius on the hip joint? On the hip joint and on the knee joint. Huh? So sartorius on the hip joint and on the knee joint. So hip joint पे action क्या है? Abduction, lateral rotation and flexion. This is very important है बच्चा, ये याद रखना. sartorius बहुत ज़्यादा important है. मैंने खाली important सवाल आपके लिए लगाए हैं. हाँ, so nerve supply of sartorius is femoral nerve. That's fine. Anterior division is fine. अब वो है ना, anterior posterior division is very important for that first year. अभी for this competitive exams, femoral nerve is fine. So hip joint. What is the action of sartorius on the hip joint? Abduction, lateral rotation, flexion at the hip. And knee पे क्या action होगा? Flexion and medial rotation at the knee joint. So इसका nerve supply is femoral nerve. Sartorius का nerve supply is femoral nerve. Action on the hip joint is abduction, lateral rotation, flexion. Knee joint पे action है flexion and medial rotation. Sartorius is also known as a honeymoon muscle. Honeymoon muscle. वैसे who's an anti-rapist muscle? Anti-rapist muscle कौन है? Honeymoon muscle, sartorius. Anti-rapist muscle बोल सकते हो? Which is a muscle which is known as anti-rapist muscle. वो जो muscle है ना, it does adduction at the hip joint and medial rotation at the hip joint. Sartorius क्या करता है? Abduction and lateral rotation at the hip joint. The other muscle does adduction and medial rotation at the hip joint. That muscle is known as the gracialis. Very good. वो है gracialis. So gracialis का action क्या होगा? Adduction and medial rotation. Gracialis is known as हाँ. Very good. Very good. Excellent. Chalo, good. That's fine. Florofemoral triangle is fine. Now you tell me obturator nerve. What is the obturator nerve supply? Obturator nerve के दो divisions होते हैं. Obturator nerve has got two divisions, anterior division and posterior division. बस ये याद रखना, ये table याद रखना. So obturator nerve has anterior posterior division. Anterior division supplies adductor longus, adductor brevis, adductor longus, adductor brevis, gracialis, pectineus, pectineus. So adductor longus, adductor brevis, gracialis and pectineus. Posterior division supplies adductor magnus and obturator externus. Obturator externus. बस ये याद रखना. So ऑब्चुरेटर नर्व के दो डिविजन है, एंटीरियर पोस्टीरियर। जो एंटीरियर डिवीजन है वो क्या सप्लाई करती है, एडक्टर लॉन्गस, एडक्टर ब्रेविस, ग्रीशालिस, पेक्टिनियस। पोस्टीरियर डिवीजन सप्लाइज एडक्टर मैग्नस, ऑब्चुरेटर एक्सटर्नस। इस पे एमसीक्यू आते हैं, यू गेट एमसीक्यूज ऑन दिस। व्हाट इज द एंटीरियर डिवीजन सप्लाई, व्हाट इज द पोस्टीरियर डिवीजन सप्लाई। फाइन है बच्चों, क्लियर, ओके फाइन। ओके, हैमस्ट्रिंग मसल्स। हैमस्ट्रिंग मसल्स के नाम बोल सकते हो, कैन एनीवन टेल मी द हैमस्ट्रिंग मसल्स। हैमस्ट्रिंग मसल्स कहां पे होते हैं, पोस्टीरियर कंपार्टमेंट ऑफ थाई। Posterior compartment of thigh में the muscles are known as hamstring muscles. Which are this? Semitendinosus, semimembranosus, biceps femoris, adductor magnus. Semitendinosus, semimembranosus, biceps femoris, adductor magnus. These are the hamstring muscles. हैमस्ट्रिंग ये पीछे वाले हैं, थाई के 3 कंपार्टमेंट्स हैं, एंटीरियर, मीडियल, पोस्टीरियर। सो पोस्टीरियर कंपार्टमेंट के मसल्स को हम बोलेंगे हैमस्ट्रिंग मसल्स। फाइन, दे आर सप्लाइड बाय द टिबियल पार्ट ऑफ sciatic nerve, टिबियल पार्ट ऑफ sciatic nerve। वेरी गुड। ग्लूटियस मैक्सिमस, बच्चों दिस इज एक्सट्रीमली इंपॉर्टेंट, एक्सट्रीमली इंपॉर्टेंट, वेरी इंपॉर्टेंट। ग्लूटियस मैक्सिमस नर्व सप्लाई बताइए, नर्व सप्लाई। चलो बच्चों, दिस यू शुड नो, नर्व सप्लाई ऑफ ग्लूटियस मैक्सिमस। एनीवन? नर्व सप्लाई ऑफ ग्लूटियस मैक्सिमस। आई एम वेटिंग। चलो पारुल बच्चे बोलो। यस, हु एल्स इज कम? यस प्रवीण, यस प्रवीण, वेरी गुड। आंसर करिए बच्चों, आंसर करिए। ग्लूटियस मैक्सिमस का नर्व सप्लाई, हाँ बताओ। इंफीरियर ग्लूटियल नर्व, वेरी गुड पारुल बच्चे, वेरी गुड। It is the inferior gluteal nerve. Nerve supply of gluteus maximus, inferior gluteal nerve. What is the main action of gluteus maximus? कोई बता सकता है main action of gluteus maximus? Standing up from a sitting position. अभी आप बैठे हो, you're sitting on the chair. When you stand up from a sitting position, this is done by whom? The gluteus maximus. So gluteus maximus का action है extension at the hip joint. Extension at the hip joint. That's gluteus maximus. फाइन है बच्चों। स्टैंडिंग अप फ्रॉम अ सिटिंग पोजीशन, एक्सटेंशन एट द हिप जॉइंट। एक्सटेंशन है, फिर लैटरल रोटेशन है, abduction है, abduction, extension and lateral rotation at the hip joint, standing up from a sitting position. Gluteus medius and minimus. ओहो, दिस इज सो नाइस, बहुत ज्यादा इंपॉर्टेंट है। वैसे ग्लूटियस मिनिमस, मीडियस, एक और मसल है टेंसर फेशिया लैटा। Tensor fascia lata. What is the nerve supply? Superior gluteal nerve. So superior gluteal nerve बच्चे 3 मसल सप्लाई करता है, gluteus medius, minimus and tensor fascia lata. Very good. That is superior gluteal nerve. Gluteus maximus का nerve supply inferior gluteal nerve. No confusion in this. No confusion. Maximus is inferior gluteal nerve. Gluteus medius, minimus and tensor fascia lata का nerve supply है superior gluteal nerve. What is the main action of gluteus maximus? The main action of gluteus medius, abduction. Main action of gluteus medius होता है abduction. Main action of gluteus minimus होता है medial rotation. हाँ, Trendelenburg sign, ठीक है। Gluteus medius, abduction, minimus, medial rotation, and gluteus medius and minimus also support the pelvis when one foot is off the ground. एक फुट जब जमीन पे होता है तो it supports the opposite pelvis. Fine. Okay. Okay, so foot drop. Can anyone tell me foot drop is due to injury to which nerve? Bacho, this is extremely important. Lurching gait. Fine, Subjit. Very good. Foot drop is due to injury to which nerve? Answer this. चलो, the question is open to all of you. Foot drop is due to injury to which nerve? ये बहुत ज़्यादा important MCQ है आपके लिए बच्चों. Foot drop is due to common peroneal nerve. Very good. Common peroneal nerve winds around the neck of the fibula. ये neck of the fibula पे wind करता है. If the common peroneal nerve is injured, दो nerves injury होती है. Superficial peroneal, deep peroneal. So foot drop is due to injury to the common peroneal nerve. Very nice, very nice. बहुत अच्छे, बहुत अच्छे. ठीक है, चलो, we'll proceed. Okay. अब बोलो बच्चों, लेफ्ट सुपीरियर इंटरकॉस्टल वेन ड्रेन्स इनटू व्हाट? हाँ, वेरी गुड. चलो बच्चों ऐसे आंसर करो. यस यस, एम सिद्दीकी, वेरी गुड. हाँ, वेरी गुड, बहुत अच्छा आंसर कर रहे हो आप. चलो, ये बता सकते हो बच्चों लेफ्ट सुपीरियर इंटरकॉस्टल वेन क्या होती है? एक मिनट, आई जस्ट एक स्लाइड बनाता हूँ. दिस इज द इंटरनल जुगुलर, ये है सबक्लेवियन. दिस इज द ब्रेकियोसेफालिक. ये इंटरनल जुगुलर वेन है, ये सबक्लेवियन वेन है, ये ब्रेकियोसेफालिक वेन है राइट साइड पे, ये लेफ्ट साइड पे है. दिस इज द ब्रेकियोसेफालिक. ये कौन है? SVC. एंड व्हाट इज दिस वेन? ये कौन है बच्चों? दिस इज द एजाइगस वेन. ये है एजाइगस वेन. ठीक है बच्चा सुभजीत, वेरी गुड. चलो, सो ये इंटरनल जुगुलर वेन है, ये सबक्लेवियन वेन है, ये राइट ब्रेकियोसेफालिक है. दिस इज द लेफ्ट ब्रेकियोसेफालिक. ये होगा SVC एंड दैट्स द एजाइगस वेन. ये एजाइगस वेन. MCQs बहुत आते हैं इसमें. देयर आर प्लेंटी ऑफ MCQs ऑन दिस. ओके, सो विल स्टार्ट. द फर्स्ट राइट पोस्टीरियर इंटरकॉस्टल वेन, ये है फर्स्ट राइट posterior intercostal vein drains into right brachiocephalic. The first right posterior intercostal vein drains into right brachiocephalic. The first left posterior intercostal vein drains into left brachiocephalic. Second, third and fourth joins to form a vein. यह है right superior intercostal vein. So second, third and fourth on the right side joins to form the right superior intercostal vein. The right superior intercostal vein drains into what? Azygous vein. Azygous vein. ये MCQ है. ये MCQ है. The right superior intercostal vein will drain into. yes बच्चे. स्ट्राइक रेट और भी होगा. देखो कैसे ना, एक सवाल जब डिस्कस करता है ना, when we discuss one question there are 3-4 MCQs we discuss simultaneously. It will give you a good strike rate. Okay, so first posterior intercostal vein drains into what? Right brachiocephalic. Second, third and fourth on the right side joins to form the right superior intercostal vein. That right superior drains into azygous. Second, third and fourth on the left side joins to form a vein. इसका नाम है left superior intercostal vein. अब ये जो left superior intercostal vein है बच्चा, that drains into left brachiocephalic. That drains into left brachiocephalic. ठीक है? So this is the MCQ. अब the rest of the veins on the right side they drain into azygous vein. बाकी सारे veins azygous में drain होते हैं. ये azygous है. 5, 6, 7, 8 joins to form a vein. इसका नाम है accessory hemiazygous. 9, 10, 11, 12 joins to form a vein here. This is known as a hemiazygous vein. So this is 5, 6, 7, 8 joins to form the accessory hemiazygous. On the left side, they joins to form the accessory hemiazygous. This drains into azygous vein. 9, 10, 11, 12 joins to form the hemiazygous vein. That drains into azygous vein. बस इसमें important क्या है ना? This is very important. ये याद रखना. Right superior intercostal vein drains into, answer है azygous. Left superior intercostal vein drains into left brachiocephalic vein. ठीक है? Okay, fine. Have a look at this. The left superior intercostal vein drains into, your answer is the left brachiocephalic vein. The right superior intercostal vein drains into, your answer is azygous vein. Azygous vein. ठीक है? Fine. ठीक है बच्चों? अब बोलो intercostobrachial nerve. ये सुभजीत अभी गया है, अभी the rest of you answer. Bolo, the rest of you answer now. What is intercostobrachial nerve? Yes? Anyone? Intercostobrachial nerve is the lateral cutaneous branch of second intercostal nerve. This is the lateral cutaneous branch of T2, second intercostal nerve. अब ये जो lateral cutaneous branch of T2 होती है ना, it joins with the medial cutaneous nerve arm. ये join करती है medial cutaneous nerve arm के साथ. So the chest pain is referred to the medial aspect of the arm. The pain of the chest is referred to the medial aspect of the arm. Why? Intercostobrachial nerve. So intercostobrachial nerve क्या होता है? It's the lateral cutaneous branch of second intercostal nerve. बस ये याद रखना, याद रखिए. Now tell me, बच्चा, what is the extent of a lung, extent of pleura in the mid-clavicular, mid-axillary and mid-scapular line? Mid-scapular line. बोल सकते हो? Extent of lung, extent of pleura. Yes, anyone? This you should know. हाँ, ये बहुत ज़्यादा important MCQ है. Extent of lung, extent of pleura in the mid-clavicular, mid-scapular and mid-axillary line. Anyone? बोल सकते हो बच्चों? मैं लिखता हूँ यहाँ पे. Mid-clavicular line, mid-clavicular, mid-axillary and mid-scapular. Mid-clavicular, mid-axillary, mid-scapular. We start with the lung and the pleura. Yes, answer this. Lung is 6th rib, 8th rib, 10th rib. 6, 8, 10 and pleura होता है 8, 8th rib, 10th rib, 12th rib. बस ये याद रखना. This is very important. So extent of lung in the mid clavicular line, mid axillary line and mid scapular line. ये समझ रहे हो ना? Mid clavicular is this, mid clavicular, mid axillary is this and mid scapular पीछे होगा. So what is the extent of lung? 6th rib, 8th rib, 10th rib. Pleura, 8th rib, 10th rib and 12th rib. Fine. Okay. Clear now? This is very important. This you should know. Okay, so that's the extent of lung, extent of pleura we have discussed. What are the branches of left coronary artery? Very good, very good. Peaceful world, very good. Left coronary artery. Can anyone tell me the branches of left coronary artery? And the branches of right coronary artery बोल सकते हो कोई? Left coronary artery के दो branches होते हैं. Left coronary artery gives two branches. One is the left anterior descending and the circumflex branch. Circumflex branch. Left anterior descending and the circumflex branch. So left, oh wow, superb, superb. M. Siddiqui, very good, very good. Excellent, बच्चा, very good. ऐसे आंसर करना आप. Yes. So लेफ्ट कोरोनरी के दो ब्रांचेस है. वन इज LAD जिसे हम बोलते हैं लेफ्ट एंटीरियर डिसेंडिंग एंड दूसरा है जो पीछे जाता है, दैट इज सर्कमफ्लेक्स ब्रांच. द वन विच गोज बिहाइंड इज द सर्कमफ्लेक्स ब्रांच. What are the branches of right coronary? Right coronary gives one branch. This is the posterior interventricular branch. Posterior interventricular branch. That's a branch of right coronary artery. This is the branch of right coronary artery. Can anyone tell me what is this big vein? ये बड़ा सा vein कौन है? The large vein. Yes. Very good, M. Siddiqui. Very good. What is that big vein which drains the, क्या बोलूं इसको? Which drains the heart? Which opens in the right atrium, the largest vein of the heart जो right atrium के अंदर खुलता है. चलो बोलो बच्चों, the name of the vein. The largest vein of the heart which opens into the right atrium. Any guesses? Guess करना. सबसे बड़ा vein है ये. इंटरनल जुगुलर वेन नहीं है बच्चा, इट्स अ वेन ऑफ द हार्ट. हार्ट की वेन है वो. इंटरनल जुगुलर वेन तो अपने नेक में है ना बच्चे. इट्स इन द नेक. द वेन ऑफ द हार्ट, द लार्जेस्ट वेन ऑफ द हार्ट इज द कोरोनरी साइनस. इसका नाम है कोरोनरी sinus. That's a coronary sinus. The largest vein of the heart is the coronary sinus. हाँ, just remember this, हाँ, ये याद रखना. अब now I'll tell you something very important. See here, this is the right lung. ये अपना right lung है. This is the left lung. That's a cardiac notch. That's a lingula. That's the left lung. That's the right lung, left lung. What is this known as? Cardiac notch. ये है lingula. This is the oblique fissure, horizontal fissure, horizontal fissure. Upper lobe, middle lobe, lower lobe for the right lung. Upper lobe, lower lobe for the left lung. So right lung के 3 lobes हैं, left lung के 2 lobes हैं. Now understand the bronchopulmonary segment. बच्चों ये बहुत 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 ज़्यादा important है. Bronchopulmonary segments. Okay, let us understand this. So ये upper lobe है, this is the middle lobe, that's the lower lobe. What are the bronchopulmonary segments of the upper lobe of the right lung? Anyone? Come on, can you answer this? Bronchopulmonary segments of the upper lobe of the right lung. चलो बोलो बच्चों. ये ऐसे होता है apical anterior posterior. This you should know. This you should know. So bronchopulmonary segments of the upper lobe of the right lung is apical anterior posterior. Middle lobe के 2 bronchopulmonary segments है. That's medial and lateral. Medial and lateral. Lower lobe 5 bronchopulmonary segments. 5 apical, anterior basal, lateral basal, posterior basal and एक अंदर होता है medial basal. एक अंदर होता है medial basal. So total 10. Very good, peaceful world. Very good. Then there are 10 bronchopulmonary segments for the right lung and left lung also. So upper lobe के कितने bronchopulmonary segments है? 3. Apical, anterior, posterior. Middle lobe के 2. Medial, lateral. Lower lobe, apical, anterior basal, lateral basal, posterior basal and one is medial basal. ठीक है? Now for the left lung, bronchopulmonary segments are like this: apical, anterior, posterior. Apical, anterior, posterior. For the middle lobe, bronchopulmonary segments are superior lingular and inferior lingular. Superior and inferior lingular. For the lower lobe, bronchopulmonary segments same as same. Apical, anterior basal, lateral basal, posterior basal and एक अंदर, see generally books में देते हैं अंदर नहीं होता है medial basal. So there are 9 bronchopulmonary segment. Medial basal segment is absent in the left lung. So there is 9 in the left lung, 10 in the right lung. अब क्लियर है ना? सो इस पे MCQs आते हैं. Bronchopulmonary segments of the lingular lobe are. So your answer is superior, inferior, lingular. Fine है बच्चों? Okay. ठीक है, चलो. यहाँ तक क्लियर है बच्चों? बोलो. आर थिंग्स क्लियर? समझ में आ रहा है ये? डिफिकल्ट लग रहा है? फाइन है? ओके, वेरी गुड. ठीक है बच्चों. वेरी गुड. जस्ट वन मोमेंट. कैन एनीवन टेल मी दिस स्लाइड एओर्टिक आर्च आर्टरी ये कैसे बनता है, बोल सकते हो? जितनी भी चीजें वर्कबुक में दी है, रिवाइज देम प्रॉपरली. when you go through one MCQ ना, एक MCQ जब भी डिस्कस करते हैं ना अपन 4-5 MCQ साइमल्टेनियसली होते हैं. So just remember that. Okay. So can anyone tell me this? Which is this arch artery? This is the third arch artery. Third arch artery. This is the fourth arch artery and this is the sixth arch artery. Third arch artery, fourth arch artery, sixth arch artery. अब थर्ड आर्च आर्टरी से क्या बनती है? थर्ड आर्च आर्टरी से बनता है कॉमन कैरोटिड्स. थर्ड आर्च आर्टरी फॉर्म द कॉमन कैरोटिड्स. फोर्थ आर्च आर्टरी on the left side, on the right side. On the left side forms the fourth arch artery forms the arch of aorta. On the left side. arch of aorta on the left side. On the right side, it forms the subclavian artery. Subclavian artery. So the third arch artery forms the common carotid arteries. The fourth arch artery on the right side forms the subclavian. On the left side forms the arch of aorta. And the sixth arch artery hai, very good. The sixth arch artery is going to form the pulmonary artery. Pulmonary artery. Pulmonary artery, fine, that is formed by the sixth arch artery. तो थर्ड से बनती है कॉमन कैरोटिड्स, फोर्थ ऑन द राइट साइड सबक्लेवियन, ऑन द लेफ्ट साइड आर्च ऑफ एओर्टा, सिक्स से बनेगा पल्मोनरी आर्टरी. Pulmonary artery. These are the, just remember this, development of blood vessels, that's very important. Okay, now we proceed. Come on bachcho, we proceed to the next section. Session is very useful. ठीक है बच्चा, हाँ आंसर करो, आंसर करो. आप जितना आंसर करोगे ना, आप जितना इंटरैक्टिव होगे ना, दैट मच आई कैन टेल यू मोर, है ना, ज्यादा बता सकता हूँ, है ना. वेरी गुड, चलो ग्रेट. Okay, now come to this, skin over the angle of mandible. Bacha, this is extremely important. बहुत ज़्यादा important है. Tell me, who supplies the skin here over the angle of mandible? Anyone? Anyone? Come on, answer this. Who supplies the skin over the angle of mandible? Answer. ये आएगा ही आएगा. Skin over the angle of mandible is supplied by which nerve? Guess, guess, guess. Come on, guess. गलत है तो that's no problem. It's okay. Skin over the angle of mandible is supplied by the great auricular nerve. Great auricular nerve. Great auricular nerve. ठीक है. The skin over the angle, नहीं trigeminal नहीं है बच्चा. अरे वही तो एमसीक्यू है, इसीलिए तो वो इंपॉर्टेंट है. दैट इज व्हाई इट इज इंपॉर्टेंट, बिकॉज दिस एंटायर फेज, द एंटायर फेज इज सप्लाइड बाय होम, ट्राइजेमाइनल नर्व, है ना. एंटायर फेज को कौन सप्लाई करता है? ट्राइजेमाइनल नर्व, except the skin over the angle of mandible. This is supplied by the greater auricular nerve. Very good बच्चा, very good. Drooping lily. Very good. हाँ, तो that's great auricular nerve. Fine. Ansa cervicalis. What is ansa cervicalis? ये ना, ये यहाँ पे carotid sheath होती है बच्चा. In the neck there is carotid sheath, जिसमें internal carotid artery है, internal jugular vein है, vagus nerve है. Internal carotid artery, internal jugular vein, vagus nerve, carotid sheath के अंदर है. It's inside the carotid sheath. On the carotid sheath lies a U-shaped loop. ऐसे एक U होता है, U. What is this U-shaped loop of? This U-shaped loop is known as the ansa cervicalis. ये जो U-shaped loop है ना, इसका नाम है ansa cervicalis. ये ansa cervicalis lies on the carotid sheath. And what is the ansa cervicalis going to supply? ये क्या supply करती है? It supplies muscles, sternohyoid, sternothyroid, inferior belly and the superior belly of omohyoid. So what are the muscles supplied by ansa cervicalis? Ansa cervicalis क्या supply करती है? Sternohyoid, sternothyroid muscle, superior belly and inferior belly of omohyoid. Superior and inferior belly of omohyoid. ठीक है बच्चा? Very important. Very important. Which ये strap muscles होता है ना, यहाँ पे strap muscles, sternohyoid, sternothyroid, superior and inferior belly of omohyoid. Which strap muscle is not supplied by ansa cervicalis? Which strap muscle is not supplied by ansa cervicalis? Ansa cervicalis does not supply thyrohyoid. ये याद रखना, ansa cervicalis does not supply thyrohyoid muscle. थायरोहायोइड को वो सप्लाई नहीं करता है. दिस इज अ वेरी वेरी इंपॉर्टेंट एमसीक्यू. बच्चों क्लियर है? व्हाट इज आंसर सर्वाइकलिस क्लियर है? वेयर डज इट लाई क्लियर है? व्हाट इट सप्लाइज क्लियर है? स्टर्नोहायोइड, स्टर्नोथायरॉइड एंड ओमोहायोइड. व्हाट इट डज नॉट सप्लाई? द थायरोहायोइड. थायरोहायोइड याद रखना. Fine, clear. Okay, M Siddiqui, very good. So damage to the spinal accessory nerve, ये बोल सकते हो spinal accessory nerve in the posterior triangle leads to paralysis of trapezius. वैसे स्पाइनल एक्सेसरी नर्व दो मसल्स को सप्लाई करती है. स्पाइनल एक्सेसरी नर्व सप्लाइज टू मसल्स. वन इज द sternocleidomastoid and the other one is trapezius. Sternocleidomastoid and trapezius, बराबर है. But if the spinal accessory nerve is cut in the posterior triangle, अगर posterior triangle में इंजरी होता है, so only trapezius is paralyzed. Sternocleidomastoid को कुछ नहीं होता. Sternocleidomastoid is intact. ये इंटैक्ट रहेगा. वाई? बिकॉज द नर्व ऑलरेडी सप्लाइज द sternocleidomastoid. ये पहले sternocleidomastoid को सप्लाई करती है एंड देन इट गोज इन द posterior triangle of the neck. So if we cut the nerve in the posterior triangle of the neck, the muscle affected is trapezius. Trapezius. Sternocleidomastoid को कुछ नहीं होता. Muscle affected is trapezius. Fine है? तो what action will be lost? Shrugging of shoulder is lost. ये जो shrugging of shoulder है ना, that is lost. विंगिंग ऑफ स्कैपुला होता है. विंगिंग ऑफ स्कैपुला. फाइन है. व्हाट आर द ब्रांचेस ऑफ एक्सटर्नल कैरोटिड आर्टरी? ब्रांचेस ऑफ एक्सटर्नल कैरोटिड, दिस इज वेरी इंपॉर्टेंट. इस पे एमसीक्यूज आते हैं. ब्रांचेस ऑफ एक्सटर्नल कैरोटिड आर्टरी कैसे इसको याद रखोगे? एंटीरियर ब्रांचेस, पोस्टीरियर ब्रांचेस, मीडियल ब्रांच एंड टर्मिनल ब्रांचेस. टर्मिनल. Okay, anterior, posterior, medial and terminal branch. Anterior branches कौन है? One, superior thyroid artery, lingual, facial. Superior thyroid, lingual, facial. Posterior branches, posterior auricular and occipital. Medial branch, ascending pharyngeal. Ascending pharyngeal. ठीक है. And terminal branch. Terminal branches are two. That's the superficial temporal artery and maxillary artery. Superficial temporal and maxillary artery. This is very important. This you should know. मतलब ये जितना भी है वर्कबुक में, this you have to know. ठीक है बच्चों. So external carotid का anterior branch, superior thyroid, lingual, facial. Posterior branch, posterior auricular, occipital. Medial branch is ascending pharyngeal. Terminal branch is superficial temporal and maxillary artery. Fine. Okay. Relations of the lateral wall of cavernous sinus. बच्चे बोल सकते हो lateral wall of cavernous sinus में क्या क्या होता है? Lateral wall, अगर मैं ये ऐसे ड्रॉ कर लो इसको, कैवर्नस साइनस कैसे ड्रॉ करूँ अब इसको फॉर योर अंडरस्टैंडिंग. सो दैट्स अ कैवर्नस साइनस. ये कैवर्नस साइनस है. हुज ऑन द मीडियल वॉल ऑफ द कैवर्नस साइनस? यहाँ पे क्या होता है? पिट्यूटरी ग्लैंड एंड द स्पिनॉइडल एयर साइनस. पिट्यूटरी ग्लैंड एंड स्पिनॉइडल एयर साइनस. लैटरल वॉल ऑफ द कैवर्नस साइनस में कौन है? द थर्ड नर्व, द फोर्थ नर्व, the ophthalmic and the maxillary division of trigeminal nerve. Floor में है sixth nerve and internal carotid artery. That's a cavernous sinus. बच्चों क्लियर है? Cavernous sinus के lateral wall में what are the structures in the lateral wall of cavernous sinus? The third nerve, the fourth nerve, the ophthalmic and the maxillary division of trigeminal nerve. In the lateral wall, third, fourth, ophthalmic and maxillary division. In the floor is the sixth nerve and the internal carotid artery. Medially is the pituitary gland. ये कौन है? Pituitary gland and ये है sphenoidal air sinus. Medially is the pituitary gland and the sphenoidal air sinus. Relations of cavernous sinus very important है. Very important. बच्चों समझ में आ रहा है? ये क्लियर है यहाँ तक? कुछ डाउट्स है किसी को? हाँ, so this was the relations of cavernous sinus. हाँ, so branches we have done, relations of cavernous sinus we have done. What is the blood supply of thyroid gland? Blood supply of thyroid gland क्या है? Superior thyroid artery and inferior thyroid artery, right? Superior thyroid artery एंड इंफीरियर थायराइड आर्टरी द मेन ब्लड सप्लाई, फिर थायराइड इम्मा आर्टरी भी होती है. Can anyone tell me the superior thyroid artery accompanies a nerve, the inferior thyroid artery accompanies a nerve? चलो बोलो बच्चों, ये तो आपको पता ही होगा. सुपीरियर थायराइड आर्टरी के साथ एक नर्व होती है. आंसर. इंफीरियर थायराइड आर्टरी के साथ एक नर्व होती है. आंसर. I'm waiting your answer. वेरी गुड बच्चा, वेरी गुड. हाँ, क्या बोल रहे हो? सुपीरियर, हाँ, पीसफुल वर्ल्ड. सुपीरियर थायराइड आर्टरी के साथ एक नर्व है. विच नर्व? एक्सटर्नल लैरिंजियल नर्व. एक्सटर्नल लैरिंजियल नर्व. एंड इंफीरियर थायराइड आर्टरी के साथ होती है रिकरेंट लैरिंजियल नर्व. दिस यू शुड नो. बच्चा, ये बहुत ज्यादा इंपॉर्टेंट है. तो व्हेन यू आर रिमूविंग द थायराइड, व्हेन यू आर रिमूविंग द थायराइड, व्हेन यू आर कटिंग द सुपीरियर थायराइड आर्टरी, तो यू हैव टू बी वेरी केयरफुल टू प्रिजर्व. कौन सी नर्व है ये? एक्सटर्नल लैरिंजियल nerve. External laryngeal nerve. I've written in short. And internal and inferior thyroid artery के साथ होती है recurrent laryngeal nerve. Huh? So when you're cutting the superior thyroid artery, you have to be very careful to preserve external laryngeal nerve. अब ये जो external laryngeal nerve है ना बच्चे, what does it supply? This external laryngeal nerve supplies the cricothyroid. ये क्रिकोथायरॉइड मसल को सप्लाई करती है एक्सटर्नल लैरिंजियल नर्व. एंड रिकरेंट लैरिंजियल नर्व सप्लाइज ऑल द मसल्स ऑफ लैरिंग्स एक्सेप्ट क्रिकोथायरॉइड. एक्सेप्ट क्रिकोथायरॉइड, राइट? सो एक्सटर्नल लैरिंजियल नर्व क्या सप्लाई करती है? क्रिकोथायरॉइड मसल. रिकरेंट लैरिंजियल नर्व सप्लाइज ऑल द मसल्स ऑफ लैरिंग्स एक्सेप्ट क्रिकोथायरॉइड. फाइन. ओके, परफेक्ट, वेरी गुड बच्चों, वेरी गुड. चलो चलो चलो, बोलो नर्व सप्लाई ऑफ पैरोटिड ग्लैंड. एनीवन? नर्व सप्लाई ऑफ पैरोटिड बोल सकते हो? विच इज द क्रेनियल नर्व? वो कौन सी क्रेनियल नर्व है विच सप्लाइज द पैरोटिड ग्लैंड? विच इज दैट क्रेनियल नर्व विच सप्लाइज द पैरोटिड ग्लैंड? एनीवन? दिस यू शुड नो. बच्चा, जितना भी मैंने आपको वर्कबुक में दिया है, इट यू शुड नो दिस. फेशियल नहीं है बच्चा. एम सिद्दीकी नहीं बच्चे. फेशियल नर्व सप्लाइज द सबमैंडिबुलर एंड द सबलिंगुअल ग्लैंड्स. जितने भी ग्लैंड्स हैं फेशियल नर्व फेस में, दैट इज सप्लाइड बाय फेशियल नर्व एक्सेप्ट पैरोटिड. पैरोटिड इज सप्लाइड बाय समवन एल्स. वेगस नहीं बच्चे. पारुल, वेगस सप्लाइज द ग्लैंड्स ऑफ जीआईटी. बच्चा, वेगस है ना, सप्लाइज द ग्लैंड्स ऑफ जीआईटी. अब बच्चा कौन है? वेगस गया, फेशियल गया. हु इज लेफ्ट? Anyone? The ninth nerve, that's the glossopharyngeal nerve. So parotid is supplied by which cranial nerve? अगर सवाल आता है, if the question comes, your answer is glossopharyngeal nerve. Glossopharyngeal nerve. ठीक है बच्चों? Very good M Siddiqui. Parotid is supplied by glossopharyngeal nerve. याद रखना. Rest, all the glands in the head and neck are supplied by facial nerve. All the glands मतलब submandibular, sublingual, lacrimal, nasal, palatine, pharyngeal. All the glands. So parotid is supplied by glossopharyngeal nerve. Okay. Nerve supply of the larynx बोल सकते हो. I just told you nerve supply of the larynx. Motor nerve supply बताओ बच्चों. Motor nerve supply. All the muscles are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external laryngeal nerve. Cricothyroid is supplied by external laryngeal nerve. So all the muscles of the larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external laryngeal nerve. Perfect है बच्चा. अब आओ sensory nerve supply. Sensory nerve supply above the vocal folds. Sensory nerve supplies two parts. Above the vocal folds and below the vocal cords. Above the vocal cords, below the vocal cords. Above the vocal cords is what? Internal laryngeal nerve. Below the vocal cords is recurrent laryngeal nerve. Very good. So that is motor nerve supply. वो muscles का supply हो गया. अब sensory nerve supply. Sensory nerve supply of the larynx above the vocal folds, internal laryngeal nerve. Below the vocal folds is a recurrent laryngeal nerve. याद रखना, this is very important. Tongue का बोलो, motor nerve supply of the tongue. Anyone? The motor nerve supply of the tongue. Motor nerve supply is hypoglossal nerve, except palatoglossus, which is supplied by pharyngeal plexus. Okay, so all the muscles of the tongue are supplied by hypoglossal nerve. Very good, bacha, very good. Except palatoglossus, which is supplied by pharyngeal plexus. Pharyngeal plexus का दूसरा नाम है vago accessory complex. Lily, vago accessory complex is pharyngeal plexus. Same है वो, हाँ? Vago accessory complex is pharyngeal plexus. Very good, very good. अब coming to the sensory nerve supply. ये हो गया motor nerve supply. Now coming to the sensory nerve supply. Answer this, बच्चा. Answer this. Sensory nerve supply. Anterior 2/3, posterior 1/3, and the posterior most part. Sensory nerve supply. Anterior 2/3. Answer this. Hey, very nice. बहुत अच्छा आंसर कर रहे हो. Anterior 2/3 का general sensations is lingual. Special sensations is chorda tympani. That's facial nerve. Chorda tympani is a branch of facial nerve. Okay, so anterior 2/3 general sensations is lingual nerve. Special sensations is chorda tympani, branch of facial nerve. Taste. Special is taste. Special sensation matlab taste. Posterior 1/3, both general and special, is glossopharyngeal nerve. And posterior most part is internal laryngeal nerve. चलो बढ़िया सब बहुत अच्छा आंसर कर रहे हो बच्चों, बहुत अच्छा आंसर कर रहे हो. So motor nerve supply, all the muscles of the tongue are supplied by hypoglossal nerve except palatoglossus, which is supplied by vago accessory complex बोलो या फिर pharyngeal plexus बोलो, same. Sensory nerve supply, anterior 2/3 general sensations, lingual, special sensations, chorda tympani. Posterior 1/3 both general and special, glossopharyngeal nerve. Posterior most part of the tongue, that's the internal laryngeal nerve. ठीक है, कोई डाउट है? फाइन है बच्चा, क्लियर है? दिस इज वेरी इंपॉर्टेंट. दिस इज वेरी इंपॉर्टेंट. ओके फाइन, बढ़िया है. मसल्स ऑफ मैस्टिकेशन बोलो बच्चे, विच आर द मसल्स ऑफ मैस्टिकेशन? हाँ, I'll just label this. हाँ, ये identify कर लो, इसको identify कर लो. If this comes as a visual slide, who's this number 1? Who's this number 2? Who's this number 3? And who's this number 4? Identify this, muscles of mastication. Yes, बोलो. One is temporalis. Very good, बच्चा. One is temporalis. Two is masseter. तीन है lateral pterygoid. 4 है medial pterygoid. मैंने शॉर्ट में लिखा है, I've written in short. ये आइडेंटिफिकेशन बहुत ज्यादा इंपॉर्टेंट है. ओके, सो 1 is temporalis, 2 is masseter, 3 is lateral pterygoid, 4th is medial pterygoid. अब ये देख लो. अब you see this, what is this? You tell me, what is this disc? ये है ना, ये disc. This disc is known as a articular disc. Articular disc. Yes, very good. Acha, who's come? Arindam. Very good, Arindam. Very good. तो ये जो आर्टिकुलर डिस्क है ना, ये बहुत इंपॉर्टेंट एमसीक्यू बोल रहा हूं. आर्टिकुलर डिस्क ऑफ टीएम जॉइंट इज अ डीजनरेटेड पार्ट ऑफ lateral pterygoid. Lateral pterygoid, the articular disc is a degenerated part. Degenerated part of lateral pterygoid. ये याद रखना, ये बहुत ज्यादा इंपॉर्टेंट एमसीक्यू है बच्चा. Articular disc is a degenerated part of which muscle? Your answer is lateral pterygoid. Lateral pterygoid. परफेक्ट है बच्चे. सो मसल्स ऑफ मास्टिकेशन 4 मसल्स है. टेम्पोरलिस, masseter, medial and the lateral pterygoid. Articular disc of TM joint is a degenerated part of lateral pterygoid muscle. याद रखना. इसका नर्व सप्लाई बोलो. विच pharyngeal arch do they form? ये जितने भी मसल्स ऑफ मास्टिकेशन है, they develop in which pharyngeal arch? First pharyngeal arch. Which is the nerve of the first arch? Mandibular nerve. So all these muscles are supplied by mandibular nerve. ये जितने भी muscles है, all these muscles are supplied by the mandibular nerve. These are derived from the first pharyngeal arch. So it is mandibular nerve. बक्सिनेटर नहीं बक्सिनेटर दिख रहा है आपको बच्चा? बक्सिनेटर, हाँ, ओके, ये बक्सिनेटर है. दिस इज द बक्सिनेटर. बट बच्चे, बक्सिनेटर इज नॉट अ मसल ऑफ मास्टिकेशन. याद रखना लिली, बक्सिनेटर इज अ मसल ऑफ फेशियल एक्सप्रेशन. वेरी गुड बच्चे, बक्सिनेटर आपको दिख रहा है, बहुत अच्छा है. So buccinator is a muscle of facial expression and this buccinator is pierced by someone. ये दिख रहा है आपको? This buccinator is pierced by, yo. Can anyone tell me who's this? ये कौन है? Buccinator को कौन pierce करता है? There's a duct. ये जो gland है ना, parotid gland. The duct of parotid gland is going to pierce the buccinator. नाम बोल सकते हो? What is the name of the duct of parotid gland? Yes, bacha. The duct of parotid gland is going to pierce the buccinator. Stenson's duct. Stenson's duct. Duct का नाम है Stenson's duct. So okay, very good. So it pierces the buccinator. It opens inside the mouth. We put the brush. उसको बोलते हैं vestibule. Vestibule. So it opens in the vestibule of the mouth, opposite to the upper second molar tooth. Upper second molar tooth. ठीक है. So where does the parotid duct open? Another MCQ. It opens in the vestibule of the mouth opposite to the upper second molar tooth. Upper second molar tooth. Perfect है. Who pierces the buccinator? The parotid duct. Fine. बढ़िया. Now structures passing between the constrictors. बच्चे बोल सकते हो? What is this constrictor? ये कौन है? That's the superior constrictor. That's a middle constrictor. That's a inferior constrictor. These are the muscles of the pharynx. And a constrictor are the muscles of the pharynx. So what are the structures passing between the constrictor? Yes. Very good. Very good, Lily. Peaceful world. Very good. So now you tell me, what are the structures passing between the constrictor? बच्चा ये बहुत ज़्यादा important MCQ है. Structures passing between the constrictors. Chalo, let us understand. So structures passing above the superior constrictor. Superior constrictor. Above the superior constrictor. Between superior constrictor and middle constrictor. Between middle constrictor and inferior constrictor. Below inferior constrictor. 3 constrictor muscles है अपने पास, ठीक है ना? हाँ, yes. So अपने पास 3 constrictor muscle है, superior constrictor, middle constrictor, inferior constrictor. So what are the structures which go above the superior constrictor? Anyone? Can anyone answer this? A very important MCQ. One is the auditory tube. That's the auditory tube. Second is the tensor palate. Second is the levator palate, not tensor. Levator palate, ascending palatine artery, and the palatine branches of ascending pharyngeal artery. Palatine branches of ascending pharyngeal. This you should know. This you should know. बहुत ज्यादा इंपॉर्टेंट है ये. So structures passing above the superior constrictor. कौन है? Number 1, auditory tube. Number 2, levator palatii muscle. Number 3, ascending palatine artery. Ascending palatine artery. And number 4, palatine branches of ascending pharyngeal artery. Okay, these are the structures which go above the superior constrictor. Between the superior and middle constrictor क्या जाता है? One is the stylopharyngeus muscle and glossopharyngeal nerve. Stylopharyngeus muscle and glossopharyngeal nerve. बच्चे बोल सकते हो stylopharyngeus muscle is derived from which pharyngeal arch? चलो बच्चों बोलो बोलो बोलो. Stylopharyngeal, अभी first pharyngeal arch we've seen the muscles of mastication. और क्या होता है first pharyngeal arch में? muscles of mastication होता है. Mylohyoid, anterior belly of digastric. और कौन है? Tensor palatii, tensor tympani. Tensor palatii and tensor tympani, है ना? So this were the muscles in the first arch. ये MCQs आते हैं arches पे भी. Muscles in the first arch, muscles of mastication, the mylohyoid, anterior belly of digastric, tensor palatii and tensor tympani. Second arch नहीं बच्चा. Second arch में muscles of facial expression आते हैं. Muscles of facial expression comes in the second arch. Then stapedius, posterior belly of digastric, stylohyoid. ये सब second arch में आता है. Stylopharyngeus is a muscle of which arch? Third arch. Third arch. Third arch. Which is the nerve of the third arch? Glossopharyngeal nerve. First arch की nerve कौन है बच्चा? Mandibular nerve. Second arch की nerve कौन है? Facial nerve. Which is the nerve of the third arch? Glossopharyngeal nerve. Glossopharyngeal. तो see कितना MCQs clear होता है. You get to know many things when we discuss one single topic. Now you get to know many things. So the muscle in the third arch, stylopharyngeus. The nerve of the third arch, glossopharyngeal nerve. That goes between the superior and middle constrictor. ठीक है बच्चा? Between the middle and inferior constrictor कौन जाता है? That's the internal laryngeal nerve and the superior laryngeal artery. Superior laryngeal artery. Internal laryngeal nerve and superior laryngeal artery, and below the inferior constrictor goes the recurrent laryngeal nerve and inferior laryngeal artery. Recurrent laryngeal nerve and inferior laryngeal artery. Bacha, these are extremely important MCQs. Make it a point to remember this. Fine, एक बार देख लो. If anything is not clear, please do let me know. हाँ एक बार देख लो. Once you're clear, you tell me. I'll proceed. I'll go ahead. हाँ मैं proceed करता हूँ फिर. Yes, Lily. M. Siddiqui, Peaceful World. अरिंदम. ठीक है बच्चे. ओके. जितना मैं बोल रहा हूँ वो सब याद रखिए. हाँ, जस्ट रिमेंबर ऑल दिस थिंग्स बच्चा. ठीक है. ओके. वेरी गुड. चलो, ग्रेट. We go to the next page. Wow, can you tell me? This is the relations of the middle ear cavity. Relations of middle ear cavity बहुत important है. अब सब कुछ important नहीं है, but yes, some relations you have to know of the middle ear cavity. So what is this middle ear cavity? ये क्या है? Anterior wall. Just one moment. That's a anterior wall. That's a posterior wall. That's a roof. That's a floor. That's a medial wall. ये medial wall है. ये medial wall. MCQs आते हैं relations of the middle ear cavity. Now tell me, anterior wall. Anterior wall shows two openings. What is this? This is the tensor tympani. Tensor tympani. And what is this? Eustachian tube. Tensor tympani and eustachian tube. So anterior wall, बस इतना याद रखो. Important things you remember. Anterior wall is tensor tympani and eustachian tube. Posterior wall. Posterior wall पे कौन है? Posterior wall, there's a adductus to the mastoid. That's a channel to the mastoid. Adductus to the mastoid antrum. पीछे होता है adductus to the mastoid antrum. Fine. Who's in the floor? Floor में jugular vein है. That's a jugular vein. Internal jugular vein. Floor में internal jugular vein. I'm just telling you the important relations. Important relations. अब आते हैं medial wall की तरफ. Medial wall, what is this known as? What is this known as? Promontory. What is this? That's a facial nerve. Facial nerve. हाँ, facial nerve. ये बाकी आपको पता ही है. This is the oval window. This is the round window. Oval window, round window. हाँ. तो medial wall पे कौन आता है? There's a elevation जिसका नाम है promontory. Promontory. हाँ. Then there's a facial canal. Facial nerve जाती है उससे. That's a facial canal. There's a oval window and round window. Oval and round window. तो कैसे याद रखोगे? देखो. Anterior wall, tensor tympani and eustachian tube. Anterior wall में tensor tympani, eustachian tube. Posterior wall में there's a canal for mastoid, adductus to the mastoid. Lower में jugular vein, internal jugular vein. Medial wall पे promontory, facial canal, the canal for facial nerve. Oval window, to which is attached a stapes, footplate of stapes होता है, and a round window. बस इतना याद रखना. इतना ही relations याद रखना. What is the nerve supply of the middle ear cavity? Can anyone tell me the nerve supply of middle ear cavity? Anyone? The nerve supply of middle ear cavity, very important. ये MCQ आएगा. Nerve supply of middle ear cavity is the glossopharyngeal nerve. Glossopharyngeal nerve. Nerve supply of middle ear cavity is glossopharyngeal nerve. ठीक है बच्चों? ठीक है? Okay, now just tell me ये ectodermal clefts, endodermal pouches पता है आपको? हाँ, derivatives पता है? What is formed from this endodermal pouches? Can anyone tell me this? Endodermal pouches से क्या बनता है? एक quick go through करते हैं. Endodermal pouches. First, divides into a dorsal and a ventral part. This is endodermal pouches. So first divides into dorsal and ventral part. Second, then other second, third, divides into dorsal and ventral. Fourth, dorsal and ventral. चलो answer this. If you know, you can answer this. नहीं आ रहा है. Okay, ठीक है, बताता हूँ. So endodermal pouches, ये बहुत important है बच्चा. This you should know. The first endodermal pouch forms from the dorsal part, forms the tubotympanic recess. Tubotympanic recess, which forms the middle ear cavity and auditory tube. Auditory tube. ये याद रखना बच्चा. मतलब first endodermal pouch divides into dorsal and ventral part. Dorsal forms the tubotympanic recess. M सिद्दीकी बहुत अच्छे बच्चे, बहुत अच्छे. So the first, so the tubotympanic recess से दो चीजें बनती है. One is the middle ear cavity and second is the eustachian tube. Eustachian tube. The ventral joins with the second. The ventral joins with the second and forms the palatine tonsil. Palatine tonsil. तो एमसीक्यू ऐसे आता है बच्चा, द पैलेटाइन टॉन्सिल इज डिराइव्ड फ्रॉम विच pharyngeal pouch, which endodermal pouch, that's palatine tonsil or tonsillar fossa. Yes, from the third divides into a dorsal and ventral. The dorsal forms inferior parathyroid and the ventral forms thymus. वेंट्रल से बनता है थाइमस एंड डॉर्सल से बनता है इंफीरियर पैराथायरॉइड. वेरी गुड, वेरी गुड एम सिद्दीकी, वेरी गुड. एंड फोर्थ डॉर्सल से बनेगा सुपीरियर पैराथायरॉइड्स एंड द वेंट्रल पार्ट ऑफ द फोर्थ जॉइंस विद द सिक्स्थ आर्च. ये सिक्स्थ आर्च के साथ जॉइन होता है, सिक्स पाउच के साथ जॉइन होता है एंड फॉर्म्स अ बॉडी विच इज नोन एज अल्टीमो branchial body, which forms parafollicular C cells, parafollicular C cells of thyroid. मतलब बच्चा, the ventral part of the fourth joins with the sixth and forms a body जिसका नाम है ultimobranchial body, and this ultimobranchial body is going to form the parafollicular C cells of thyroid. Parafollicular C cells of thyroid, बस ऐसे याद रखना, ठीक है. सो एंडोडर्मल पाउचेस, बस बच्चा इतना याद रखना है. द फर्स्ट एंडोडर्मल पाउच डिवाइड्स इनटू अ डॉर्सल वेंट्रल पार्ट. डॉर्सल से बनता है ट्यूबोटिम्पैनिक रीसेस व्हिच फॉर्म्स द मिडल ईयर कैविटी एंड द यूस्टेशियन ट्यूब. द वेंट्रल जॉइंस विद द सेकंड टू फॉर्म द पैलेटाइन टॉन्सिल. द थर्ड डिवाइड्स इनटू डॉर्सल वेंट्रल. डॉर्सल से बनता है इंफीरियर पैराथायरॉइड, वेंट्रल से बना थाइमस. The fourth endodermal pouch divides into a dorsal ventral. Dorsal forms the superior parathyroids. The ventral joins with the sixth to form the ultimobranchial body, which forms the parafollicular C cells of thyroid. बस ये टेबल याद रखना बच्चा, इसमें सारे एमसीक्यूज आ गए. All the MCQs have come in this. Clear? ठीक है बच्चों, फाइन, अंडरस्टैंडिंग, इंफॉर्मेटिव है ना? हाँ, यू फाइंडिंग गुड? दिस इज वेरी इंपॉर्टेंट, हाँ, याद रखना. ओके, फाइन बच्चे, प्रोसीड. ओके, नाउ वी कम टू द वेरियस फोरामेन. ना बच्चा, ये फोरामेन बहुत ज्यादा इंपॉर्टेंट है. फोरामेन्स आर वेरी इंपॉर्टेंट. चलो एक फोरामेन खत्म करते हैं, एक फोरामेन खत्म करते हैं. सुपीरियर ऑर्बिटल फिशर. हु पासेस थ्रू द सुपीरियर ऑर्बिटल फिशर? एनीवन? सुपीरियर ऑर्बिटल फिशर, थर्ड नर्व, फोर्थ नर्व, सिक्स्थ नर्व, ऑफ्थैल्मिक डिवीजन ऑफ ट्राइजेमिनल नर्व. थर्ड, फोर्थ, सिक्स एंड ऑफ्थैल्मिक नर्व passes to the superior orbital fissure. तो ये कहाँ जाएगी? ऑर्बिट के अंदर. इट विल गो टू द ऑर्बिट. फाइन. ऑप्टिक कैनाल, हु गोज? द ऑप्टिक नर्व एंड ophthalmic artery. So the optic canal, who passes through the optic canal? The optic nerve and the ophthalmic artery. Ophthalmic artery. Fine. Foramen rotundum. चलो बच्चा बोलो foramen rotundum. Anyone? Foramen rotundum क्या जाता है? हेलो बच्चों, बोलो. Foramen rotundum, you should know this. Foramen rotundum, foramen ovale, foramen spinosum. Anyone? Foramen rotundum, anyone? I'm waiting. Foramen rotundum. What passes is maxillary nerve. Maxillary nerve. Foramen ovale पता है आपको? M-A-L-E. Foramen ovale, M-A-L-E. M, mandibular nerve. A, accessory meningeal artery. L, lesser petrosal nerve. Emissary vein. M सिद्दीकी, M-A-L-E है उसका न्यूमोनिक, M-A-L-E. You must be knowing this, no? हाँ, लिली, क्या बोल रहे हो? Maxillary nerve. Maxillary nerve passes to foramen rotundum. लिली. Very good, Praveen, very good. Huh? M is mandibular nerve, A is accessory meningeal artery, L is lesser petrosal nerve, E होती है emissary vein. MALE, यस, वेरी गुड वेरी गुड। फोरामेन स्पाइनोसम से क्या आ जाता है? नर्वस स्पाइनोसिस, and there's something else, and middle meningeal artery, middle meningeal vessels बोलो या middle meningeal artery बोलो, that's the same. Foramen spinosum से what passes is the nervous spinosus and middle meningeal artery. Perfect. M Siddiqui, very good. हाँ, middle meningeal artery बहुत ज्यादा इंपॉर्टेंट है, बहुत ज्यादा इंपॉर्टेंट है ये इंटरनल acoustic meatus. चलो बच्चों, let me see how much you can answer. इंटरनल acoustic meatus से कौन जाता है? चलो बोलो. If you go through the internal acoustic meatus, आप कहाँ जाओगे? We go in the middle, we go in the ear, internal ear. बोलो बच्चों. 7th nerve, 8th nerve, very good Lily. 7th nerve, 8th nerve, and there's an artery going to supply the labyrinth. So 7th nerve आ गया, 8th nerve आ गया, and there's an artery going to supply the labyrinth. नाम labyrinthine artery. Very good, excellent. तो यहां पे क्या जाएगा? 7th nerve, 8th nerve, labyrinthine artery. Perfect. बहुत बढ़िया. अब बोलो anterior condylar canal. MCQ आता है, structure passing through the anterior condylar canal. अब बच्चों को what is anterior condylar canal is not known. सिंपल है बच्चा, सिंपल है. एंटीरियर कॉन्डाइलर कैनाल इज हाइपोग्लॉसल कैनाल. द अदर नेम फॉर दिस इज हाइपोग्लॉसल कैनाल. अब बहुत इजी है ना, तो कौन देगा ये एमसीक्यू? स्ट्रक्चर पासिंग थ्रू हाइपोग्लॉसल कैनाल, इतना इजी एमसीक्यू कौन देगा? तो एमसीक्यू ऐसे आएगा, स्ट्रक्चर पासिंग थ्रू द एंटीरियर कॉन्डाइलर कैनाल. ओके, दैट्स हाइपोग्लॉसल नर्व. बढ़िया, बहुत अच्छे आंसर कर रहे हो, बहुत अच्छे. ठीक है, ये याद रखना. हाँ, परफेक्ट है. एक जुगुलर फोरामेन आता है, जुगुलर फोरामेन के 3 कंपार्टमेंट्स होते हैं. ओके, देयर आर 3 कंपार्टमेंट्स इन द जुगुलर फोरामेन. हाँ, एक होता है एंटीरियर कंपार्टमेंट, मिडिल कंपार्टमेंट, पोस्टीरियर कंपार्टमेंट. हाँ, जुगुलर फोरामेन के एंटीरियर कंपार्टमेंट है, मिडिल कंपार्टमेंट है, पोस्टीरियर कंपार्टमेंट है. So what passes to the anterior compartment? Anterior compartment से जाती है inferior petrosal sinus. Inferior petrosal sinus. Anterior compartment से कौन जाता है? Inferior petrosal sinus. Middle compartment से जाती है 9th, 10th and 11th cranial nerves. 9th, 10th and 11th cranial nerves goes to the middle compartment. And posterior compartment से what goes is the sigmoid sinus. Sigmoid sinus goes to the posterior compartment. ठीक है बच्चा. So jugular foramen के 3 compartments, anterior, middle, posterior. Anterior compartment what passes is the inferior petrosal sinus. Middle compartment so what goes is 9th and 11th cranial nerves. Posterior compartment is sigmoid sinus. Perfect. Okay. Now you tell me which is the nerve of the first pharyngeal arch. Nerve of the first pharyngeal arch is mandibular nerve. Second pharyngeal arch is facial nerve. Facial nerve is 7. Nerve of the second pharyngeal arch is facial nerve. Third is glossopharyngeal. That's 9th. है ना? Fourth pharyngeal arch is internal laryngeal nerve, and 6th is recurrent laryngeal nerve. Both are branches of vagus. ठीक है. So the nerve of the first arch is mandibular nerve. Nerve of the second arch is facial nerve. Third arch is glossopharyngeal nerve. Fourth arch is internal laryngeal nerve. The nerve of the sixth arch is a recurrent laryngeal nerve. इस पे बहुत ज्यादा MCQs आते हैं बच्चों, याद रखना. So tell me now, which are the muscles formed in the first pharyngeal arch? Muscles of the first pharyngeal arch. एक तो muscles of mastication हो गए. Then tensor palati, tensor tympani, anterior belly of digastric and mylohyoid. ये होते हैं मसल्स इन द फर्स्ट आर्च. कौन है? मसल्स ऑफ mastication, वो 4 मसल्स, temporalis, masseter, medial lateral pterygoid. Then tensor palati, tensor tympani, anterior belly of digastric and mylohyoid. ये हो गए muscles in the first arch. Muscles in the second arch, the muscles of facial expression, then stapedius, posterior belly of digastric, stylohyoid. Muscles of facial expression, stapedius, posterior belly of digastric and stylohyoid. ठीक है, ये हो गए muscles of second arch. Third arch, एक ही muscle है, there's only one muscle in the third arch. Name stylopharyngeus, nerve, glossopharyngeal nerve. Stylopharyngeus muscle, glossopharyngeal nerve. Fourth arch, internal laryngeal nerve. ठीक है ना, the muscles of internal laryngeal nerve. And sixth arch is recurrent laryngeal nerve, that's the muscles of larynx, muscles of larynx. Muscles of pharynx and soft palate is derived from the fourth arch. Fourth arch is internal laryngeal nerve. इससे क्या बनता है? Muscles of the pharynx and the soft palate. Sixth pharyngeal arch is a recurrent laryngeal nerve. That's the muscles of larynx. Muscles of larynx. Perfect है बच्चों? यहाँ तक perfect है तो बोलो, हाँ? फिर proceed करते हैं. Then we proceed. Clear with this? ये बहुत ज़्यादा important है. So I've covered all very important topics. बताओ. You tell me. I'm just waiting. Once it's done, you tell me. ठीक है बच्चों, बोलो. पीसफुल वर्ल्ड, लिली, एम सिद्दीकी, प्रवीण, फाइन है बच्चों यहां तक? अब प्रोसीड करते हैं. नाउ वी प्रोसीड टू द नेक्स्ट वन. ऑल गुड, फाइन, ठीक है, ओके. चलो अब कुछ ब्रेन के एमसीक्यूज देखते हैं बच्चों. ब्रेन के सम इंपॉर्टेंट टॉपिक्स ऑफ ब्रेन. परफेक्ट, वेरी गुड. अब बोलो वर्निकेज एरिया का नंबर बोलिए. नंबर, टेल मी द नंबर ऑफ द नंबर वर्निकेज एरिया का. व्हाट इज द नंबर? हाँ, आंसर दिस. एंड वेयर इज इट लोकेटेड? वर्निकेज एरिया, वेयर इज इट लोकेटेड एंड व्हाट इज द नंबर? वैसे ब्रोकाज एरिया का नंबर एंड लोकेशन. चलो बच्चों बोलो बोलो. Wernicke's area, that's area number 22. 22, that's Wernicke's area. Huh. 22, very good, 22. Huh. And Broca's area is 44, 45. 45. Where is this? Inferior frontal gyrus. Inferior frontal gyrus. So 44, 45 कहाँ पे होता है? Broca's area, inferior frontal gyrus. Wernicke's area is number 22. Number 22. What is uncinate fasciculus? Uncinate fasciculus connects. ये जो uncinate fasciculus है ना बच्चा, it connects these two areas. ये दोनों को जोड़ता है. So uncinate fasciculus connects the Wernicke's and the Broca's area. Uncinate fasciculus का दूसरा नाम है arcuate fasciculus. Arcuate fasciculus. So uncinate fasciculus, what does it connect? The Wernicke's and the Broca's area. The motor and the sensory area. Very good. The Wernicke's and the Broca's area. Blood supply of the motor area बोल सकते हो? What is the blood supply of the motor area? Okay. Just one moment. एक diagram draw करता हूँ. I'll just draw a diagram for you. Tell me. What is this sulcus? Lateral sulcus. हाँ, अब बोलो बच्चों, what is this artery here? Which is the artery in the lateral sulcus? This is very important. है, ये बहुत important MCQ है. And which is the artery in this sulcus? Corpus callosum के ऊपर एक sulcus होता है. callosal sulcus. Callosal sulcus. That's a callosal sulcus. And what is this sulcus? This is the lateral sulcus. Chalo, bolo. Which is the artery in the lateral sulcus? Answer this. A very important MCQ. This is extremely important. ये आपको आना ही चाहिए. Which is the artery present in the lateral sulcus? This is the middle cerebral artery. Middle cerebral artery. Which is the artery present in the callosal sulcus? ये sulcus का नाम है callosal sulcus. The artery is anterior cerebral artery. ये याद रखना. याद रखना. So middle cerebral artery is present in the lateral sulcus. Anterior cerebral artery is present in the callosal sulcus. Huh? So now this anterior cerebral artery is going to supply this entire medial surface. पूरा medial surface supply करता है. Except a small area here. यहाँ पे this is supplied by middle cerebral artery. And this is supplied by posterior cerebral artery. This entire area is supplied by anterior cerebral artery. The anterior cerebral artery also supplies a small area here. This is supplied by whom? Anterior cerebral artery. The entire superolateral surface इसे कौन supply करता है? Middle cerebral artery. The occipital lobe is supplied by posterior cerebral artery. समझ में आ रही है? So now you tell me, what is this area? What is this sulcus? Central sulcus. That's a precentral, postcentral. ये है motor area. ये है sensory area. So what is the blood supply of the motor or sensory area? Look, the blood supply of motor or sensory area, this much, itna कौन supply करेगा? Middle cerebral, itna middle cerebral, and this is supplied by whom? Anterior cerebral. So blood supply of the motor or sensory area, दो arteries है, ACA plus MCA. Blood supply of motor or sensory area, it's MCA plus ACA. And blood supply of the occipital lobe is, blood supply of the occipital lobe is posterior cerebral artery plus middle cerebral artery. Middle cerebral artery supplies the macula. अगर MCQ आता है, blood supply of the visual cortex, there are two arteries. Entire visual cortex is supplied by posterior cerebral artery except macula. Macula को कौन supply करता है? Middle cerebral artery. So blood supply of the visual cortex or the occipital lobe, posterior and middle cerebral artery. Blood supply of the motor or the sensory area, middle cerebral and the anterior cerebral artery. Perfect है ये बच्चा, perfect है. दो arteries है बच्चा. There are two arteries, not only one. हाँ, दो arteries है. This you should know. हाँ, this you should know. आपने PC MCA लिखा ना, peaceful world. You have understood this? हाँ, ये समझ में आया? So blood supply of the motor or the sensory area, if I have to write this, what do I write? MCA plus ACA. Blood supply of the visual cortex is PCA plus MCA. Middle cerebral artery. Middle cerebral supplies what? Macula. ये macula को supply करता है. Is this clear? Artery in the callosal sulcus. Artery in the callosal sulcus is anterior cerebral artery. Artery in the lateral sulcus is middle cerebral artery. Middle cerebral artery. हाँ, both supply the occipital cortex. Yes, बच्चे, समझ में आया ये? There are many things that you will understand. कैसा ना बच्चा, when you are attending a lecture, no, there are many things which will add to your knowledge. You must be knowing things, yes, but और उसमें additions होते हैं. That's the importance of the lectures. That's the charm of the lectures. ठीक है बच्चों, clear है? अब what is this basal vein? ये मैं बोलता हूँ. How is the basal vein formed? Basal vein है ना बच्चा, ये basal vein is formed by joining of three veins. हाँ, basal vein कैसे बनती है? I'll tell you. Basal vein, what is basal vein? ये मैं बाद में बोलता हूँ आपको. Basal vein is found in the brain and basal vein is formed by the joining of anterior cerebral vein, huh? Deep middle cerebral vein, anterior cerebral vein, deep middle cerebral vein, and striate veins. हाँ, so basal vein क्या होती है ना? It is present at the base of the brain. हाँ, base of the brain पे होती है, and it is formed by joining of three veins. Which are those three veins? Number one, anterior cerebral vein, deep middle cerebral vein. बस इतना याद रखो, बस इतना ही याद रखो. Anterior cerebral vein, the deep middle cerebral vein, and the striate vein. And this basal vein drains into great cerebral vein. Great cerebral vein of Galen. ये जो basal vein है ना बच्चा, it drains into the great cerebral vein of Galen. It is known as the basal vein of Rosenthal. Basal vein of Rosenthal भी बोलते हैं. So this basal vein is formed by joining of three veins. ये तीन veins join होते हैं to form the basal vein, anterior cerebral, deep middle cerebral, and striate veins. And this basal vein drains into the great cerebral vein of Galen. बस इतना याद रखना, इतना ही याद रखना. Okay, fine. Now, that's basal vein. I've told you what is basal vein. Branches of vertebral artery बोल सकते हो बच्चा? What are the branches of vertebral artery? Branches of vertebral artery: anterior spinal artery, posterior spinal artery, and posterior inferior cerebellar artery. Branches of vertebral artery. This you should know, huh? This you should know. ये है ना arteries है ना बच्चा, arteries बहुत ज़्यादा important होते हैं. So what are the branches of vertebral artery? Anterior spinal, posterior spinal, and pica, posterior inferior cerebellar artery. ठीक है? Okay. Now, what are the branches of basilar artery? Branches of basilar artery. ये मैं लिखता हूँ आपके लिए. I'll just write this for you. Basilar artery. What are the branches of basilar artery? 1. Pontine branches. 2nd. Labyrinthine artery. 3rd. Anterior, inferior, cerebellar, anterior, inferior, cerebellar. 4th. Superior cerebellar. 5th. Posterior cerebral. So what are the branches of what are the branches of basilar artery? ये याद रखना, ये MCQs आते हैं. Branches of vertebral तीन ही है: anterior spinal, posterior spinal, and pica, posterior inferior cerebellar artery. Basilar artery के इतने branches है: pontine branches, then labyrinthine artery. अब है ना, now recently it is said that labyrinthine artery is a branch of anterior inferior cerebellar. हाँ, ये नया ये है, it's a new update. Labyrinthine artery is a branch of anterior inferior cerebellar. हाँ, but this is conventional that we teach. ये conventional अपन ऐसे सीखते हैं. The branches of basilar artery: pontine branches, labyrinthine artery, anterior inferior cerebellar, superior cerebellar, and posterior cerebral. Very good, very good. Terminal branches of posterior cerebral. Very good बच्चा. हाँ, अब आते हैं internal carotid artery की तरफ. If you know, you tell me. Internal carotid artery के branches: cavernous branches, hypophyseal branches, hypophyseal branches, ophthalmic artery, और क्या है? Anterior choroidal, posterior communicating, and two terminal branches: middle cerebral artery and anterior cerebral artery. This you should know. You should know this. Branches of internal carotid artery, cavernous branches, hypophyseal branches, ophthalmic artery, anterior choroidal, posterior communicating, and दो terminal branches हैं, anterior cerebral, middle cerebral. ठीक है बच्चों, ये देख लो एक बार. इफ यू हैव एनी डाउट्स यू टेल मी. अगर इसमें कोई डाउट है तो बोलो. ठीक है, ये ना आर्टरीज याद रखना. आर्टरीज पे बहुत ज्यादा एमसीक्यूज आते हैं. ठीक है बच्चों, बैठ के सुन रहे हो बच्चों? क्लियर है? The rest of you who are not answering, you answer, my dear children. You answer. You may always make an attempt. जब गलती करोगे ना वो हमेशा याद रहेगा. You'll always remember that. Take it from me. You should always answer. Don't hesitate. This is not a final exam, है ना? ये अपना regular exam है, इसमें answer करिए. Okay, then let us go to the next slide. ये हो गया. This is done. You fine? This is clear. We have done this. We have done this. हाँ, ये सब दोनों कर लिया अपन ने. I'll proceed. चलो बच्चों बोलो. Clear है? Yes, M Siddiqui, fine. Peaceful world. Yes. Lily. Fine है बच्चा. What is this? What is this? ये कौन है? What is this? Can anyone tell me? हाँ. मिस्टीरियो. वेरी गुड. ऐसे बोलो बीच में, ठीक है ना? सो व्हाट इज दिस दैट वी लुकिंग एट? दिस इज द सर्कल ऑफ विलिस, है ना? ये क्या है? सर्कल ऑफ विलिस. दैट्स अ सर्कल ऑफ विलिस. ये वाला सर्कल ऑफ विलिस. फाइन. सो व्हाट आर द आर्टरीज व्हिच टेक्स पार्ट इन द फॉर्मेशन ऑफ सर्कल ऑफ विलिस? कैन एनीवन टेल मी? दैट्स द इंटरनल कैरोटिड आर्टरी. हाँ, ये है अपनी इंटरनल कैरोटिड आर्टरी. What is this smaller branch? Anterior cerebral artery. This smaller branch is anterior cerebral. What is this continuation? Middle cerebral artery. Middle cerebral artery. अब बोलो, what are these two? Vertebrals. What's this? Basilar. And what's this? Posterior cerebral artery. यह है posterior cerebral. What is this artery? ये कौन है बच्चा? This is the posterior communicating artery. And what's this? Anterior communicating artery. Anterior communicating artery. ठीक है ना? ये सर्कल ऑफ विलिस है. हाँ ठीक है बच्चा, जॉइंट बोलता हूँ. हाँ, जॉइंट बोलता हूँ. जस्ट याद कराना मुझे. जस्ट याद कराना. I'll tell you one very very easy way to remember the joints. Very easy. ठीक है. ओके, चलो बच्चे. ठीक है. सो दिस आर द आर्टरीज व्हिच टेक्स पार्ट इन द फॉर्मेशन ऑफ सर्कल ऑफ विलिस. सर्कल ऑफ विलिस कैसे बनती है अपना बच्चा? एंटीरियर कम्युनिकेटिंग, एंटीरियर सेरेब्रल, इंटरनल कैरोटिड, पोस्टीरियर कम्युनिकेटिंग, पोस्टीरियर सेरेब्रल. अब एमसीक्यू आता है, व्हिच इज द आर्टरी व्हिच डज नॉट टेक पार्ट इन द फॉर्मेशन ऑफ सर्कल ऑफ विलिस? क्या बोलते हो? चलो, अगर एमसीक्यू ऐसे आता है, व्हिच इज द आर्टरी व्हिच डज नॉट टेक पार्ट इन द फॉर्मेशन ऑफ सर्कल ऑफ विलिस? आंसर है मिडिल सेरेब्रल आर्टरी. आंसर है मिडिल सेरेब्रल आर्टरी. मिडिल सेरेब्रल आर्टरी. ओके, सो द आर्टरी व्हिच डज नॉट टेक पार्ट इन द फॉर्मेशन ऑफ सर्कल ऑफ विलिस इज मिडिल सेरेब्रल आर्टरी. मिडिल सेरेब्रल आर्टरी. फाइन. ठीक है बच्चों, एक स्लाइड ड्रॉ करता हूं आपके लिए. I'll just make a slide for you. See, I'll just make a slide for you. Huh? This is one vein, this is one vein, this is one vein, this is one vein. ये एक वेन आ गया, ये दूसरा वेन आ गया, ये तीसरा वेन आ गया, ये एक वेन हो गया. They join to form a vein here, vein here. Look. Now, what is this vein? I'll just write this down. Thalamostriate. Thalamostriate vein. बस बच्चा ये है ना, ऐसे याद रखना आपको. Just remember what I'm telling you. Thalamostriate vein. ये है choroidal vein. Choroidal vein. ये है septal vein. So thalamostriate, choroidal, septal. इससे बना ये vein. Internal cerebral vein. Internal cerebral vein. Two internal same on this side, huh? Two internal cerebral vein joins to form great cerebral vein of Galen. Great cerebral vein of Galen. And this great cerebral vein of Galen drains into straight sinus. Great cerebral vein of Galen drains into straight sinus. So ये क्या vein है बच्चा? That's a internal cerebral vein. Internal cerebral vein कैसे बनती बच्चा? Internal cerebral vein is formed by joining of three veins. Thalamus right, choroidal, septal. ये बना internal cerebral. ये दूसरा internal cerebral joins to form the great cerebral vein. Great cerebral vein of Galen drains into straight sinus. And थोड़ी देर पहले we have seen this. What is this vein? Sorry. What is this vein? This is the basal vein. The basal vein drains into great cerebral vein of Galen. अभी थोड़ी देर पहले हमने देखा था ना. So ये है ना पूरा venous drainage of brain है बच्चा. In one slide ये पूरा venous drainage of brain आता है. इसमें आपको क्या याद रखना है? Internal cerebral vein. How's the internal cerebral vein formed? That you have to know. How's the basal vein formed? That you have to know. Basal vein कैसे बनती है? That you have to know. And this basal vein of Galen drains into the basal vein drains into the great cerebral vein of Galen. Basal vein कैसे बनती है? Basal vein is formed by anterior cerebral, deep middle cerebral, and right vein. That forms a basal vein. And basal vein opens into what? Great cerebral vein of Galen. That's it. एक बार देख लो ये. Just try to understand this. थोड़ी देर पहले, some time back, we have studied the basal vein. बस ये याद रखना. क्या याद रखना आपको? How is the internal cerebral vein formed? Internal cerebral vein is formed by the joining of three veins. Thalamus right, choroidal, septal. Two internal cerebral vein joins to form the great cerebral vein of Galen. Great cerebral vein of Galen drains into straight sinus. What opens in the great cerebral vein of Galen is the basal vein. अब basal vein कैसे बनती है? By the three veins. Anterior cerebral, deep middle cerebral and striate veins. इससे बना basal vein. This tells you the entire blood supply of the brain. खत्म. 2 मिनट में खत्म. Blood supply of the brain. Clear है? ऐसे ना फ्लो चार्ट्स बनाइए बच्चों. Make flow charts wherever possible. Make line diagrams and try to remember like this. तो वो ज्यादा अच्छा याद रहेगा. ठीक है? ओके बच्चों, चलो we'll just proceed then. यही है वो स्लाइड. यही है वो स्लाइड. This is the same slide. Okay. Now you tell me what is this? Who's this number one? Number one is the superior colliculus. Number two is the inferior colliculus. Inferior colliculus. What is this? ये कौन है? Can anyone tell me what is this circle that I've pointed out? What is this circle? ये क्या circle है? This is very important. This is the fourth ventricle. ये क्या है? Fourth ventricle. What is this nerve? ये कौन सी nerve है? This nerve is the fourth nerve. Fourth nerve. Fourth nerve is the only nerve which emerges from the dorsal aspect. ये dorsal aspect से आती है. That's the fourth nerve. The only cranial nerve which emerges from the dorsal aspect of the brainstem is the fourth nerve. बाकी जितने भी cranial nerves हैं, they emerge from the ventral aspect of the brainstem. ये याद रखना. That's the superior colliculus. That's the inferior colliculus. What is this rounded thing? This is the facial colliculus. ये जो rounded thing है ना, that's the facial colliculus. How's the facial colliculus formed? The facial colliculus is formed by the fibers of facial nerve as they wind around the abducens nerve nucleus. How's the facial colliculus formed? By the fibers of facial nerve as they wind around the abducens nucleus. ये याद रखिए. That's facial colliculus. Fine. What is this बच्चा? ये कौन है? That's the corpus callosum. Corpus callosum. That's a corpus callosum. What are the parts of corpus callosum? पता है आपको? Parts of corpus callosum: rostrum, genu, trunk, splenium. Rostrum, genu, trunk and splenium. ठीक है? Corpus callosum is what type of fiber? It's a commissural fiber. Corpus callosum belongs to what fiber? Commissural fiber. ठीक है? Facial colliculus कैसे बनता है? It's formed by the fibers of facial nerve as they wind around the abducens nucleus. Corpus callosum is an example of commissural fiber. इसके parts क्या होता है? Rostrum, genu, trunk and splenium. These are the parts of corpus callosum. ये याद रखिए. Okay, fine. What are the nerves attached to the brainstem? Nerves attached to the brainstem. I'll just make a slide for you. इसका slide बनाता हूँ. This is the midbrain. ये midbrain है. ये pons है. ये medulla है. This is the pyramids. Oh, this is the pyramids. ये है olives. And that's the inferior cerebellar peduncle. This is the middle cerebellar peduncle. Middle cerebellar peduncle. Middle cerebellar peduncle. So this is the midbrain. ये midbrain हो गया. That's the pons हो गया. And this is the medulla. Midbrain, pons and medulla. So now students, quickly you tell me, what is this nerve? What is this nerve? And ये पीछे से आती है, पीछे से. What is this nerve? That's a fourth nerve. That's a third nerve. So third and fourth nerve is attached to the midbrain. Midbrain से निकलती है. Fourth nerve is the only nerve which emerges from the dorsal aspect. Bachcho, this is a very, very important MCQ. The only cranial nerve which emerges from the dorsal aspect, that's fourth nerve. ठीक है? Now, the nerve attached at the junction of pons with the middle cerebellar peduncle, that's a fifth nerve. ये fifth nerve है. So the nerve attached at the junction of pons with the middle cerebellar peduncle is fifth nerve. अब यहाँ पे there are three nerves. यहाँ पे तीन nerves होते हैं. There are three nerves here. 6th, 7th, 8th. 6, 7, 8. Three nerves here. यहाँ पे 9th, 10th, 11th. 9th, 10th, 11th. And this is the 12th nerve. 12th nerve. I'll just mention this. Number 1, number 2, number 3. Number 1 is the pyramid. Number 2 is the olives. And number 3 is the inferior cerebellar peduncle. Inferior cerebellar peduncle. बस ये याद रखना. Just remember this. This is a very important slide. बच्चों एक बार ये देख लो. Once this is clear, you tell me. हाँ? मतलब कैसे आता है ना MCQ? Third and fourth nerve begins from the midbrain. जितने भी cranial nerves है बच्चा, they emerge from the ventral aspect. ये ventral aspect है. There's only one nerve which comes from the dorsal aspect. That's a fourth nerve. The only cranial nerve which comes from the dorsal aspect is the fourth nerve. ठीक है? Nerve attached at the junction of pons with the middle cerebellar peduncle, fifth nerve. Pontomedullary junction पे तीन nerves है. 6, 7, 8. Pontomedullary junction 6, 7, 8. Between the olives and the inferior cerebellar peduncle. हाँ, fourth nerve is dorsal aspect. Very good बच्चा. Very good बच्चा. Very good. Mysterio. हाँ. Between the pyramids and the olives, कौन सी nerve आती है? Between the pyramids and the olives, 12th nerve. And between the olive and the inferior cerebellar peduncle, तीन nerves हैं, 9th, 10th and 11th. I hope this is clear to all of you. Clear है? यस, सबको क्लियर है बच्चा? फाइन, हाँ, तो ये बहुत ज्यादा इंपॉर्टेंट है. दिस इज वेरी इंपॉर्टेंट. द सेम थिंग, द सेम नर्व आई हैव ड्रॉन देयर फॉर यू. सेम चीज मैंने ड्रॉ किया. ठीक है. ओके, so this is the section. Look, you can see a nerve coming here. ये nerve देख रहे हो? This is the nerve which is coming like this. हाँ, this is the third nerve. A nerve going backside like this on the dorsal aspect. ये ऐसे आती है, ये ऐसे आते हैं. What is this nerve? That's a fourth nerve. So what is this section taken from? This is a section of the midbrain. Midbrain का section है. There are two nerves which come from the midbrain. This is the third nerve, and जो पीछे से आ गई, that's a fourth nerve. That's a fourth nerve. ठीक है? See, this is the sixth nerve, and that's the seventh nerve. This is the sixth nerve, and that's the seventh nerve. And ये जो elevation देख रहे हो, ये जो elevation है, this is the facial colliculus. That's a facial colliculus. So how is the facial colliculus formed? How is the facial colliculus formed? ये कैसे बनता है? By the fibers of facial nerve as they wind around the abducens nucleus. So this is the nucleus of sixth nerve. That's the nucleus of seventh nerve. The fibers of seventh nerve, they turn around the sixth nerve का nucleus. जब ये ऐसे turn करते हैं, they form this facial colliculus. Fine. So this is the middle cerebellar peduncle. Middle cerebellar peduncle. And what is this nerve? Fifth nerve. That's the fifth nerve. Fifth nerve. So the nerve which emerges at the junction of the pons with the middle cerebellar peduncle is fifth nerve. हाँ, ये याद रखना. ये इसीलिए मैंने वो sections लगाए आपके लिए. Now, what is this? This is the pyramid. What is this? Olives. And what is this? Inferior cerebellar peduncle. Inferior cerebellar peduncle. आप बोलो बच्चों, what is this nerve? ये कौन सी nerve है? What is this nerve? 12th nerve. That's a 12th nerve. And between this and this, there will be three nerves, 9th, 10th, and 11th. 9th, 10th, 11th nerves आते हैं यहाँ से. So this is the medulla. ठीक है? Just to tell the attachments of the nerves. Fine है बच्चों? Clear है? Okay. So this is the pyramidal decussation. Pyramidal decussation. Fine. Now एक है ना white matter of CNS बोलता हूं आपको. White matter of CNS. White matter of CNS is made up of white matter is made up of three types of fibers. Commissural, projection, and association. Commissural fibers, projection fibers, association fibers. अब white matter is all those white मतलब the axons, the fibers. The gray matter are the nucleus. Gray matter क्या होता है? Nucleus होता है. White matter क्या होता है? Fibers होते हैं. So fibers are of three types: commissural fibers, projection fibers, and association fibers. इससे MCQs आता है. MCQs come on this. So now you tell me what is an example of commissural fiber? Corpus callosum. अभी हमने देखा ना, corpus callosum is an example of commissural fiber. Projection fiber example is internal capsule. Fornix. And association fiber is uncinate fasciculus. What are commissural fibers? Commissural fibers are the one which connect similar areas in the opposite hemisphere, same areas in the opposite hemisphere. That's commissural fibers. What are projection fibers? They go outside the brain. They go outside the brain. They project outside the brain. And what are association fibers? Association fibers connect different areas in the same hemisphere. Different areas in the same hemisphere. That is association fiber. ठीक है बच्चों? फाइन, ये याद रखना. Now, what was left here is the nuclei of the cranial nerves. Nuclei of the cranial nerves. So I'll just write the name, numbers. बस ये याद रखना. Special visceral efferent. ये आपको पता है तो बोलो. हाँ, if you know this, you tell me. Special visceral efferent. Which cranial nerve is it present? 5. कैसे लिखो अब इसको? 5, 7, 9 and 10. 5th, 7th, 9th and 10th. हाँ, special visceral efferent. बस इतना ही याद रखना. General visceral efferent is present in 3rd, 7th, 9th and 10th. 3rd, 7th, 9th and 10th. ये बाद में, and I'll take a separate lecture on this. General somatic efferent is present in 3rd, 4th, 6th, 12th. ये आई के मसल्स को सप्लाई करते हैं एंड टंग के मसल्स को सप्लाई करते हैं. स्पेशल विसरल एफरेंट इज प्रेजेंट इन 7th, 9th and 10th. 7th, 9th and 10th. I'll tell you. General visceral afferent is present in vagus. 10th. General somatic afferent 5th. And general somatic afferent is 5th. Special somatic afferent is 1st, 2nd, 8th. 1st, 2nd, 8th. बच्चों ये पता है क्या आपको? हाँ, डू यू नो दिस? व्हाट इज दिस एफरेंट्स एंड इफरेंट्स? ये पता है आपको? एम सिद्दीकी, मिस्टीरियो, लिली, पारुल, बोलो बच्चों. डू यू नो दिस? बस अभी के लिए इतना याद रखो. लेटर नो मैं देखता हूँ इफ आई कैन टेल यू व्हाट आर दिस एफरेंट्स एंड इफरेंट्स. ये बहुत लंबा लेक्चर है. नहीं पता? ओके, तो आई जस्ट टेल यू इन शॉर्ट. ये जो स्पेशल विसरल इफरेंट है ना, दिस विल सप्लाई द मसल्स ऑफ फेरेंजियल आर्चेस. ओके, आई जस्ट टेल यू इन शॉर्ट व्हाट इज दिस कंपोनेंट सप्लाई. ये कंपोनेंट क्या सप्लाई करता है? मसल्स ऑफ फेरेंजियल आर्चेस. Pharyngeal arches. They supply the pharyngeal arches. So now you tell me which are the nerves of the pharyngeal arches. First arch की 5th nerve है तो ये 5th nerve में होगा. Second arch की 7th nerve है तो ये 7th nerve में होता है. Third arch की 9th nerve है and fourth arch की 10th nerve है. Understand? मतलब ये जो special visceral efferent है ना, this will supply the muscles of pharyngeal arches. तो जो nerves होते हैं which supply the muscles of the pharyngeal arches, उनमें ये component होता है. बस इतना आई एम एक्सप्लेनिंग इट एज इजी वे एज पॉसिबल. ठीक है. अब जनरल विसरल इफरेंट्स है ना, दे सप्लाई द ग्लैंड्स. ये ग्लैंड्स को सप्लाई करते हैं. सो विच ग्लैंड्स? ऑल द ग्लैंड्स इन द हेड एंड नेक. कौन सप्लाई करता है? फेशियल नर्व. तो ये फेशियल नर्व में होता है. पैरोटिड को कौन सप्लाई करता है? ग्लॉसोफेरेंजियल नर्व. सो ग्लॉसोफेरेंजियल नर्व में होता है. ग्लैंड्स ऑफ जीआईटी को कौन सप्लाई करता है? वेगस. तो ये वेगस में है. And third nerve does not supply any glands, but yes, we include the third nerve. There's a special reason for that. Third nerve को क्यों include करते हैं? That I'll tell you. अब ये जनरल सोमैटिक इफरेंट्स है ना, ये क्या सप्लाई करते हैं पता है? They supply the muscles of eye and tongue. Eye and tongue muscles को सप्लाई करते हैं. So eye and tongue muscles. So all the muscles of tongue are supplied by whom? Hypoglossal nerve, है ना? तो ये hypoglossal nerve आ गई. Extraocular muscle who supplies 3, 4, 6 nerves. 3rd, 4th, 6 nerves में आ गए. Understanding? That's how you remember. General visceral afferent मतलब they take sensations from the viscera. ये क्या करेगा? This will take sensations from the viscera. Sorry. Sensations from organs. Simple. Sensations from the organs. So who carries the sensations from organs? Vagus. Special somatic afferent. Special sensations. Special sensations क्या होता है? Special sensations is vision, smell. तो ये कौन से nerves में होगा? First nerve, vision, second nerve, and balancing. So 8th nerve. And finally, general somatic afferent carries sensations from body wall. Sensations from the body wall. So this is carried by the 5th nerve. 7th and 9th nerve, 5th nerve, 7th and 9th nerve. बस इतना, in the easiest way I've explained this. बस इसमें क्या याद रखना है ना, you have to remember this special visceral efferent, general visceral efferent, general somatic. ये तीन तो याद रखिए. You just remember for this, you remember the tongue. इसके लिए ना tongue याद रखिए. Tongue, special senses और taste. Tongue के taste sensations. So that is 7, 9, 10. That is sensations from the tongue. Special sensation, taste sensations from the tongue. बस this 4 you remember, हाँ? 4 याद रखना. So special visceral efferents, what do they supply? The pharyngeal arches. तो जो nerves है उसमें ये component है. General visceral efferent supplies the glands. General somatic efferent supplies the eye and the tongue muscles. So 3, 4, 6, 12. Special visceral afferent will carry taste from the tongue. Taste. तो 7, 9 and 10th. ऐसे. 4 याद रखना. This upper 4 you remember. This comes in MCQs. ये MCQ आते हैं इस पे बच्चों. Fine. Okay. चलो. So coming to the last part. अभी कितना बचा है एक बार देखने दो मुझे. Okay. Fine. Right. Now coming to this part. Just tell me 2 MCQs on this. Superficial inguinal ring is a defect in what? बोल सकते हो बच्चों? चलो. Superficial inguinal ring. Superficial inguinal ring is a defect in what? And deep inguinal ring is a defect in what? Answer this. This you must be knowing. Yes, come on. Superficial inguinal ring is a defect in. Answer this. Anyone? Hanji, superficial inguinal ring is deep inguinal ring is नहीं बच्चे, transverse abdominis नहीं है, transverse abdominis नहीं है. Superficial inguinal ring, very good बच्चा, very good. Pratiksha, very good. Superficial inguinal ring is a defect in external oblique aponeurosis. This is very important है बच्चों, ये याद रखना. Superficial inguinal ring is a defect in external oblique aponeurosis. The deep inguinal ring is a defect in fascia transversalis. Transverse abdominis नहीं, fascia transversalis है, fascia transversalis. So superficial inguinal ring is external oblique, deep inguinal ring is fascia transversalis. ठीक है? Branches of abdominal aorta. Branches of abdominal aorta, I'll just make a slide for you. Abdominal aorta. कैसे याद रखोगे इसको पता है? 2, 3, 4, 5. 2, 3, 4, 5. So 2 terminal branches. 2 terminal branches होते हैं. ये कौन है? Common iliac. 3 ventral branches. 3 ventral branches. इसमें है celiac trunk, superior mesenteric artery, inferior mesenteric artery. This you remember, हाँ? ये flow charts ऐसे बनाओ बच्चे, flow charts बनाओ. Very good, Tharani, 𝐻 yes, very good. तो aorta के 2 terminal branches कौन है? Common iliacs. Ventral branches कौन है? Celiac trunk, superior mesenteric, inferior mesenteric. हाँ? Ventral branches, celiac trunk, superior, inferior mesenteric. 4 lateral branches. 4 कौन है? Lateral branches. 4 lateral branches. Lateral branches में 1 inferior phrenic. Inferior phrenic. Second is middle suprarenal. Third is renal. And fourth is gonadal. Gonadal. ठीक है, ये lateral branches हो गए. अब 5 कौन है? 5 is dorsal branches. Dorsal branches में 4 pairs of lumbar arteries and 1 median sacral artery. 1 median sacral artery. So that's the easiest way to understand the branches of abdominal aorta. देखो बच्चे, एक फ्लो चार्ट में सब कुछ हो गया ना अपना. So 2 terminal branches, 3 ventral branches, celiac trunk, superior, inferior mesenteric. 4 lateral branches होते हैं, inferior phrenic, middle suprarenal, renal, gonadal. And 5 dorsal branches, 4 pairs of lumbar arteries and 1 median sacral artery. तो ये बन गया अपना पूरा aorta. MCQs ऐसे आते हैं, lateral branches of abdominal aorta, ventral branches of abdominal aorta, ऐसे आते हैं. ठीक है, fine, clear to all of you, branches of abdominal aorta. Fine, so this we have done. Epiploic foramen, बच्चा this is extremely important. This is the epiploic foramen. देखो ये epiploic foramen है. This is the epiploic foramen. What are the boundaries of epiploic foramen? पता है आपको boundaries? Anyone? Boundaries of epiploic foramen? आंसर करिए. Anterior, posterior, superior, inferior. Anyone? Can anyone answer this? Anterior is hepatic artery, portal vein, and bile duct. Hepatic artery, portal vein, bile duct. Posterior is IVC. Superior is caudate lobe. And inferior is first part of duodenum. First part of duodenum. बस ये याद रखना. Oh wow, superb, superb. आंसर कर रहे हो प्रवीण. Very good, very good. बढ़िया. सो आगे कौन है? हेपेटिक आर्टरी, पोर्टल वेन, बाइल डक्ट. ये कहाँ पे होती है? लेसर ओमेंटम के अंदर होता है. दिस इज देयर इन द लेसर ओमेंटम. पीछे कौन है? आईवीसी, आईवीसी एंड सुप्रारीनल ग्लैंड भी होता है. सुपीरियरली कौन है? caudate lobe of liver. Inferiorly is the first part of duodenum. This opening is known as the epiploic foramen. Epiploic foramen. Fine है बच्चा? Okay, we proceed. Fine. ये बोल सकते हो branches of superior mesenteric artery क्या है? What are the branches of superior mesenteric artery? मैं यहीं पे लिखता हूँ. Branches of superior mesenteric artery is middle colic, middle colic, right middle colic, right colic, ileocolic, फिर आता है inferior pancreaticoduodenal, jejunal branches, jejunal branches. ठीक है. So what are the branches of superior mesenteric artery? Inferior pancreaticoduodenal, jejunal branches, middle colic, right colic, ileocolic. ये जो ileocolic है ना, this gives an artery which is known as appendicular artery. Appendicular artery. MCQ ये है. MCQ ये है. MCQ आता है appendicular artery is a branch of. Your answer is ileocolic artery, which is a branch of superior mesenteric artery. देखो abdominal aorta के ventral branches क्या है? Celiac trunk, superior mesenteric, inferior mesenteric, right? So superior mesenteric के branches, inferior pancreaticoduodenal, jejunal and ileal branches, middle colic artery, right colic artery, ileocolic. Ileocolic artery gives a branch which is known as appendicular artery. Appendicular artery is a branch of ileocolic. बस ये याद रखना है आपको. Fine बच्चा. Branches of inferior mesenteric artery. Inferior mesenteric artery के branches देखिए. One is left colic, sigmoid branches and superior rectal. Superior rectal artery. बस ये याद रखना. So left colic, sigmoid branches and superior rectal artery. These are the branches of inferior mesenteric artery. Okay. So just remember the branches. इतना याद रखिए. Retroperitoneal organs. बोल सकते हो बच्चा retroperitoneal organs कौन से हैं? Retroperitoneal organs, kidneys, suprarenal. Yes, answer suprarenal. Kidneys, suprarenal. Then pancreas, duodenum, ascending and descending colon, aorta, and IVC and ureters. Retroperitoneal क्या होता है बच्चा? Retroperitoneal is behind the peritoneum. Behind the peritoneum. So which are the retroperitoneal organs? The kidneys, the suprarenal, the pancreas, पूरा peritoneum के पीछे होता है. Duodenum, ascending and descending colon, aorta, IVC, and the ureters. These are retroperitoneal. बस ये MCQs आते हैं इस पे. MCQs आते हैं. So just remember this, हाँ? MCQs आते हैं. याद रखना बच्चों. Fine. बस थोड़ा ही बाकी है. I'm finishing it now. Blood supply of stomach बोल सकते हैं? Anyone? Blood supply of stomach? Can anyone tell me this? Blood supply of stomach? If I draw the stomach like this, answer this. What is this artery? What is this artery? This is the left gastric. That's a right gastric artery. What is this artery? What is this artery? This is the left gastro epiploic. This you should know. This is the right gastro epiploic, and the fundus is supplied by short gastric branches, short gastric arteries. बच्चा ये पता है ना आपको? This you know, no? Blood supply of stomach पता है ना आपको? Along the lesser curvature of the stomach, दो arteries आते हैं, left gastric, right gastric. Along the greater curvature, दो arteries आते हैं, the left gastroepiploic and the right gastroepiploic. And the fundus is supplied by, yes, very good, Praveen, very good, excellent. The fundus is supplied by the short gastric branches of splenic artery. Very good बच्चों, very good. Perfect है. एक बार बोल दो ठीक है सब. एक बार बोल दो बच्चों ठीक है सब. All going good. Okay, perfect बच्चों, perfect. Okay, so this is done. Fetal circulation. अब इसमें क्या बोलूं आपको? इसमें ना I'll tell you two, three important things. Fetal circulation में you tell me obliterated left umbilical vein. Obliterated left umbilical vein. ये क्या बनता है? ये fetal life में होता है. After birth इसका क्या होता है? After birth the left umbilical vein obliterates. And what is this known as? इसे हम बोलते हैं ligamentum teres. Ligamentum teres. So what is ligamentum teres? बच्चा ये याद रखना. This is very important. So what is ligamentum teres? Ligamentum teres is the obliterated left umbilical vein. तो ये fetal life में होता है. After birth वो होता है ligamentum teres. ठीक है बच्चा? Second is ductus venosus. Ductus venosus का क्या बनता है? After birth ligamentum venosum. Ligamentum venosum. Just important things I'm telling you. Ductus arteriosus. Ductus arteriosus. After birth क्या होता है इसका? Ductus arteriosus. After birth becomes ligamentum arteriosum. Ligamentum arteriosum. Fine. Fossa ovalis. After birth becomes fossa ovalis नहीं बच्चा, foramen ovale है ना, foramen ovale. After birth क्या होता है इसका? fossa ovalis. Fossa ovalis होता है. Okay, and the last one is obliterated umbilical artery. इसका बनता है medial umbilical ligament. medial umbilical ligament. बस just याद रखना, this is in fetal life and that is after birth. बच्चों, this is extremely important. So लेफ्ट अम्बिलिकल वेन फीटल लाइफ में आफ्टर बर्थ इसका क्या होता है? लिगामेंटम टीरिस. डक्टस वेनोसिस का क्या होता है? लिगामेंटम वेनोसम. फोसा फोरामेन ओवेल का बनता है फोसा ओवालिस आफ्टर बर्थ. डक्टस आर्टेरियोसिस लिगामेंटम आर्टेरियोसम. ऑब्लिटरेटेड अम्बिलिकल आर्टरी बिकम्स द मीडियल अम्बिलिकल लिगामेंट. बस ये टेबल याद रखना बच्चों, ये टेबल याद रखना. दैट्स इट. ऑल एमसीक्यूज विल बी डन. Fine? Okay. Clear है ना? Fine. Okay. Now you tell me which is the artery which lies behind the first part of duodenum. Just important point बोलता. First part of the duodenum. First part. What is the posterior relation? Who's the artery which lies behind? ये बहुत clinical MCQ भी आता है. Median umbilical ligament is urachus. बच्चा, peaceful world. Medial is artery. Median umbilical ligament is the obliterated urachus or allantois. Urachus. Median है वो, median umbilical ligament. वो क्या होता है ना? In fetal life, from the umbilicus to the bladder, urinary bladder से umbilicus तक एक ये होता है, एक connection होता है. That is urachus. After birth, it obliterates. That becomes the median umbilical ligament. Fine, peaceful world, बच्चे ठीक है? Okay, great, very good. Very good. चलो, great. Tell me, which is the artery behind the first part of duodenum? बस ये important चीज बोलता हूँ. Because क्या होता है ना, ulcers होते हैं. Ulcers are very common in the posterior wall of the first part of duodenum. And अगर ulcer हुआ in the posterior wall of the first part of duodenum, तो एक artery होती है पीछे जो erode होती है. Erode. Which is that artery? That's extremely important. The artery is gastroduodenal artery. गैस्ट्रोड्यूडनल आर्टरी. बस ये याद रखना, फर्स्ट पार्ट ऑफ ड्यूडनम के पीछे पोस्टीरियर रिलेशन ऑफ द फर्स्ट पार्ट ऑफ द ड्यूडनम कौन है? गैस्ट्रोड्यूडनल आर्टरी प्लस पोर्टल वेन है, बाइल डक्ट है. पोर्टल वेन इज ऑल्सो देयर एंड बाइल डक्ट इज ऑल्सो देयर. पोर्टल वेन एंड बाइल डक्ट. बट इंपॉर्टेंट इज गैस्ट्रोड्यूडनल आर्टरी. गैस्ट्रोड्यूडनल आर्टरी बहुत ज्यादा इंपॉर्टेंट है बच्चे, याद रखिए. हाँ, याद रखिए इसको. So that's first part of duodenum. Now, I'll just tell you the important thing about the pancreas. Tell me, which is the artery which runs on the superior border of the body of the pancreas? Which is this artery which runs on the superior border of the body of pancreas? What is this? This is the uncinate process. Uncinate process. There's a vein behind the body of the pancreas. एक vein है. There's a vein here. And what is this vein? Can anyone tell me this? What is this vein? चलो, answer this. This is very important. ये बहुत ज़्यादा important है. So which is the artery here? बोलो बच्चों, which is the artery on the superior border? This is the splenic artery. That's a splenic artery. Behind the body, that's a splenic vein. Splenic vein. What is this? Superior mesenteric vein. So the splenic vein joins with the superior mesenteric vein to form. What is this vein? Can anyone tell me what is this vein? Portal vein. That's a portal vein. So how is the portal vein formed? The portal vein is formed by the joining of the splenic vein and the superior mesenteric vein. ये जो splenic vein आ गई, ये superior mesenteric vein आ गई, they join to form the portal vein. Where is the portal vein formed? Behind the neck of the pancreas. बस ये कुछ important MCQs है, याद रखिए. Portal vein is formed by the joining of splenic vein and the superior mesenteric vein. Portal vein कहाँ बनती है? Behind the neck of the pancreas. Neck of the pancreas के पीछे बनती है. What is this pancreas? Can anyone tell me what is this pancreas? This is the annular pancreas. Annular pancreas. Annular pancreas क्या करता है? It encircles the duodenum. It encircles the duodenum. बाकी relations of pancreas, important relations I've told you. Huh? What is annular pancreas? Annular pancreas is encircling the duodenum. ये obstruction करता है duodenum को. It obstructs the duodenum. And annular pancreas is formed due to failure और ऐसे लिखते हैं defective migration of ventral pancreatic bud. This results in annular pancreas. हाँ, ring, very good. Ring बनाता ही है. So annular pancreas, ये MCQ आता है. It is because of defective migration of what? The ventral pancreatic bud. याद रखना, ventral pancreatic bud. Fine. Okay, you tell me what is this kidney? What is this? ये क्या है? This is a polycystic kidney. That's a polycystic kidney. And how's a polycystic kidney formed? A congenital polycystic kidney. And congenital polycystic kidney is formed because of what? Anyone? Can anyone tell me? Congenital polycystic kidney is due to anyone? Failure of, I don't know whether you know this or not, failure of communication of secretory and collecting part of kidney. मतलब किडनी के दो पार्ट्स होते हैं. किडनी के दो पार्ट्स होते हैं. एक होता है यूरिन फॉर्मिंग पार्ट, सिक्रीटरी पार्ट, एंड एक होता है यूरिन कलेक्टिंग पार्ट. दैट इज द यूरेटर. मतलब यूरिन फॉर्मिंग पार्ट एंड यूरिन कलेक्टिंग पार्ट, दिस टू पार्ट्स आर सेपरेट. दिस टू पार्ट्स हैव टू कम्युनिकेट विद ईच अदर. मतलब यूरिन फॉर्मिंग पार्ट शुड कम्युनिकेट विद द यूरिन कलेक्टिंग पार्ट. अगर ये दोनों कम्युनिकेट नहीं होते, if they do not communicate, we get small cyst in the kidney. We call this as a congenital polycystic kidney. Fine. So congenital polycystic kidney is due to failure of communication of the collecting and the secretory part of the kidney. बस इतना याद रखिए. अब वो है ना, डेवलपमेंट ऑफ किडनी एंड ऑल इज वेरी डिफिकल्ट नाउ टू एक्सप्लेन, बट आई टोल्ड यू द इंपॉर्टेंट थिंग. ठीक है बच्चों, समझ में आ रही है? एक किडनी का पोस्टीरियर रिलेशन बताता हूं. किडनी का पोस्टीरियर रिलेशन, हाँ ओके, ये है इधर. सिक्रेटरी पार्ट ऑफ द किडनी इज डिराइव्ड फ्रॉम मेटानेफ्रॉस. Secretory part of the kidney is derived from metanephros. Collecting part of the kidney is derived from ureteric bud. So this will give rise to the ureters, calyces, ureter, and this will give rise to Bowman's capsule, PCT, DCT, loop of Henle. Okay, and this will give rise to the, समझ में आ रहा है अब? So secretory part of the kidney क्या बनता है? Secretory part of the kidney is the one which is going to form the urine, and this is what the Bowman's capsule, the PCT, the loop of Henle, DCT. ये होता है secretory part of kidney. कलेक्टिंग पार्ट ऑफ द किडनी में माइनर कैलिक्स, मेजर कैलिक्स, पेल्विस, यूरेटर आता है. अब समझ में आ रहा है? सो अगर ये दोनों पार्ट, इफ दिस टू पार्ट्स डू नॉट कम्युनिकेट विद ईच अदर, व्हाट आर वी गोइंग टू गेट? अ कंजेनाइटल पॉलिसिस्टिक किडनी. कंजेनाइटल पॉलिसिस्टिक किडनी. चलो, can anyone tell me this structures emerging from the greater sciatic foramen and entering the lesser sciatic foramen? Anyone? Can anyone tell me this? Structures emerging from the greater sciatic foramen and entering the lesser sciatic foramen. बच्चों बोलो 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 बोलो, थोड़ा ही बाकी है. That's spin. What's spin? Pudendal nerve. This is the internal pudendal vessels, and this is the nerve to obturator internus. That's spin. ठीक है? Pudendal nerve, internal pudendal vessels and the nerve to obturator internus. ये जो structures हैं वो greater sciatic foramen से निकलते हैं and lesser sciatic foramen में जाते हैं. These are all very very important MCQs. ये याद रखिए. Openings in the diaphragm. बोलो बच्चों. T8 openings in the diaphragm. This is another very important. T8, T10, T12. Answer this. T8 में कौन open होता है? T8 is IVC and the right phrenic nerve. T10 is esophagus. Esophagus. T10 is esophagus. And T12 is aorta, azygous vein and thoracic duct. Thoracic duct. ये पता है ना आपको? T8, T10, T12. Okay, very good, very good. This you must be knowing. चलो बोलो बच्चों, अब ये कुछ important MCQs है. The most dependent part of the body in supine position. बोल सकते हो? The most dependent part of dependent मतलब if there's any fluid in the body, where will it go when we lie supine? अपन supine lie करते हैं, so the entire fluid from the body will go into what? That's the Morrison's pouch. This is the Morrison pouch. So most dependent part of the body in supine position is Morrison's pouch. Very good, Praveen, very good. Bacha, very good. Most dependent part of the body in standing position, बोल सकते हो, in males and females. In females, it's the pouch of Douglas. Pouch of Douglas. In males, it is the rectovesical pouch. Rectovesical pouch. ठीक है ना? तो मेल्स में होता है रेक्टोवेसिकल पाउच, फीमेल्स में होता है पाउच ऑफ डगलस. द मोस्ट डिपेंडेंट पार्ट ऑफ द बॉडी. अपन खड़े रहते हैं, द एंटायर फ्लूइड विल गो डाउन इनटू, इन मेल्स इट इज रेक्टोवेसिकल पाउच, इन फीमेल्स इट इज पाउच ऑफ डगलस. ओके, व्हाट इज डेंटेट लाइन पता है आपको? Dentate line, that's present in the anal canal. You know this dentate line? That's present in the anal canal. Sorry. Dentate line is present in the anal canal. What is the white line? White line of Hilton? Hilton's line. It represents the mucocutaneous junction. Mucocutaneous junction in anal canal. मतलब एनल कैनाल में म्यूकस मेम्ब्रेन है, स्किन होता है. द जंक्शन ऑफ म्यूकस मेम्ब्रेन एंड स्किन इज नोन एज द व्हाइट लाइन ऑफ हिल्टन. ओके, पेक्टिनेट लाइन इज डिफरेंट. व्हाइट लाइन ऑफ हिल्टन अलग होता है. हिल्टन्स लाइन इज द म्यूकोक्यूटेनियस जंक्शन ऑफ एनल कैनाल. ओके, फाइन. जस्ट one or two more things. Okay, now you tell me males and females. चलो, ये कुछ इंपॉर्टेंट MCQs है बच्चों. Tell me, what is the mesonephric duct? Mesonephric duct form in males and form in females. So mesonephric duct क्या बनाता है? It forms the epididymis, vas deferens, seminal vesicles, ejaculatory duct and the prostate. In males. In females it disappears off. In females it forms what? Anyone? What is this mesonephric duct form in males? What is a mesonephric duct form in females? तो mesonephric duct in males क्या बनाता है? Epididymis, vas deferens, seminal vesicles, ejaculatory duct and prostate. In females, it forms the Gartner's duct. Gartner's duct. ठीक है, Gartner's duct. अब coming to the paramesonephric duct. This is very important. ये पूछते हैं एग्जाम्स में. Paramesonephric duct. Paramesonephric duct in females क्या बनाता है? It forms the fundus body, cervix, fallopian tubes, upper 1/3 of vagina. Upper 1/3 of vagina. Fundus body, cervix, fallopian tubes. हाँ, ये मैंने शॉर्ट में लिखा है, fallopian tubes and the upper 1/3 of the vagina. हाँ. Okay, what is a paramesonephric duct form in males? It disappears off. It forms a prostatic, utricle and appendix of testis. Appendix of testis. ठीक है ना? Prostatic utricle and appendix of testis. Fine. ये याद रखना. This is very important. Fate of mesonephric duct, paramesonephric duct in males, females. ठीक है? Then एक है genital tubercle. बस last genital tubercle. Genital swellings. And last is genital folds. Genital tubercle, genital swelling, genital folds. Males and females में क्या बनाते हैं? Genital tubercle in male forms the penis. In females forms the clitoris. Genital swelling forms the scrotum. In female forms the labia majora. And genital fold forms the labia minora in females, and in male forms the ventral aspect of penis. बस इतना याद रखना. This is very important. So genital tubercle in male forms the penis, in females forms the clitoris. Genital swellings, scrotum, labia majora, and genital folds, labia minora, and the ventral aspect of penis in males. ठीक है बच्चों? Is this clear to all of you? Yes? समझ में आ रही है? बस this much you remember. ठीक है, तो this we have finished. Okay. Neural crest cells के derivatives क्या होते हैं? हाँ? Can anyone tell me what is this clinical condition? हाँ, genital ridge से बनता है testis ovary. हाँ, gonadal ridge. What is this clinical condition? Can anyone tell me what is this? Sacrococcygeal teratoma. And this sacrococcygeal teratoma is due to persistence of primitive streak. बस ये याद रखना, persistence of primitive streak. That is sacrococcygeal teratoma. Fine. ये जो दिख रहा है ना, this is the sacrococcygeal teratoma. And this sacrococcygeal teratoma is due to persistence of primitive streak. What is this? This is anencephaly. And this is spina bifida. ये क्यों होता है? Failure of closure of cranial neuropore. Failure of closure of cranial neuropore, and this is failure of closure of caudal neuropore, caudal neuropore. Okay. So if the cranial neuropore does not close, तो इससे क्या होता है? Anencephaly. अगर caudal neuropore close नहीं हुआ, cranial is anterior, fine, anterior बराबर है बच्चा. अगर caudal neuropore close नहीं हुआ तो that is spina bifida. Cranial is anterior neuropore, caudal is posterior neuropore. Very good, ये आपको पता है. Derivatives of neural crest cells बोल सकते हो. Neural crest cells के derivatives: adrenal medulla, leptomeninges, odontoblast, Schwann cell, melanocytes, parafollicular C cells of thyroid, फिर endodermal cushions of the heart, the facial skeleton. बस इतना याद रखना. These are all derivatives of neural crest cells. Neural crest cells ये पहले MCQ में था. Derivative of neural crest cells. हाँ, ये देखिए, these are the derivative of neural crest cells. So what are the derivative of neural crest cells? Number one, adrenal medulla, leptomeninges, melanocytes, odontoblast, teeth forming cells, Schwann cells जो myelin बनाते हैं, endocardial cushions of the heart, parafollicular C cells of thyroid, corneal stroma, skeleton of the face. इतना याद रखना. Okay, the last part. Can you tell me where do we get simple squamous epithelium? This is simple squamous. This is simple squamous. Simple squamous epithelium. This is cuboidal epithelium. Simple cuboidal. This is simple columnar. This is stratified. ये सब stratified epithelium है. Stratified, चलो बोलो, what is the epithelial lining of trachea? कुछ important बोल रहा हूँ. Epithelium lining of trachea. Anyone? What is the lining of trachea? Anyone can tell? Epithelial lining of trachea. Pseudostratified ciliated columnar with goblet cells. Pseudostratified ciliated columnar with goblet cells. हाँ, very good. Transitional epithelium कहाँ होता है? Transitional epithelium is seen in the bladder. हाँ, urinary system. Transitional epithelium, urinary system. Fine. Simple squamous epithelium कहाँ होता है? In the blood vessels. Blood vessels, alveolus, जहाँ पे exchange of gases होता है. Blood vessels, alveolus, loop of Henle, simple squamous. Cuboidal epithelium, simple cuboidal epithelium, PCT, DCT, thyroid follicles, simple cuboidal. Columnar epithelium in the entire GIT. GIT में columnar epithelium होता है. बराबर है? Stratified squamous keratinized epithelium. Stratified squamous keratinized skin में होता है. Stratified squamous non-keratinized epithelium. Stratified squamous non-keratinized epithelium कहाँ होता है? Esophagus, vagina. हाँ, stratified squamous keratinized skin, non-keratinized esophagus, vagina. Stratified cuboidal and stratified columnar कहाँ पे होता है? In the ducts of the glands. Ducts of the glands. Fine. ये कुछ examples you have to remember. कुछ examples है, ये याद रखना. ठीक है? Just one last thing I'll tell you. एक last thing जो बच्चों आपने बोला था, I'll finish that for you. तो one last thing, joints. Joints are of three types. One is fibrous. Second is cartilaginous. And third is synovial. Okay, fibrous joints are of three types: sutures, syndesmosis, and third is gomphosis. Gomphosis. Sutures are found in the skull. Syndesmosis is intraosseous membrane between the radius and ulna, tibia and fibula. ठीक है ना? इंट्राशियस मेम्ब्रेन. सो सूचर्स कहाँ पे होता है? स्कल में. Syndesmosis is intraosseous membrane between the radius and ulna, tibia and fibula. And gomphosis is teeth. Teeth fitting in the socket. Simple बोल रहा हूँ, एकदम simple. ठीक है ना? So joints का तीन major classification है: fibrous joint, cartilaginous, synovial. Fibrous joints, Sutures, syndesmosis, gomphosis. This is of 3 types. Fibrous joints is of 3 types. Sutures, syndesmosis, gomphosis. Uske example. Cartilaginous joint is primary cartilaginous and secondary cartilaginous. Primary cartilaginous is, example bolo, the joint between epiphysis and metaphysis. Joint between epiphysis and metaphysis. Xiphisternal joint. First chondrosternal junction. First chondrosternal junction is primary cartilaginous. First chondrosternal junction. ठीक है, first chondrosternal junction. Secondary cartilaginous, pubic symphysis, intervertebral joints, pubic symphysis, intervertebral joints. ठीक है, so these are cartilaginous joints. So sutures हो गया, fibrous joints हो गया, cartilaginous joints हो गया. Up coming to synovial joints. Synovial joints में ball and socket. Synovial joints, ball and socket. Example बोलो. Ball and socket, you know, no? Shoulder joint, shoulder joint, hip joint, ball and socket. Ellipsoidal. Ellipsoidal is wrist. Metacarpophalangeal joints. Metacarpophalangeal joints, ये ellipsoidal बोलते हैं. हाँ, condylar, that's TM joint. एक दो joints याद रखना. Condylar is TM joint. पहले ना MP joint, metacarpophalangeal joints used to be called condylar, but अभी उसको ellipsoidal में include करते हैं. Saddle. Saddle is first carpometacarpal joint. First carpometacarpal joint. और कुछ बाकी है? Ellipsoidal, condylar, saddle. Hinge. Hinge में कौन है? Knee, elbow, ankle. Elbow joint, ankle joint. Anything else? Saddle joint, hinge joint, condylar, ellipsoidal, pivot, radioulnar joints, atlantoaxial joint. ओके बच्चों, ठीक है सब. तो एपिथेलियम के एग्जांपल्स याद रखना. एग्जांपल्स एमसीक्यूज में आते हैं. एंड जॉइंट्स आई मेड इट सिंपल. फाइब्रस, कार्टिलेजिनस, साइनोवियल. दैट इज एक बच्चों हमेशा याद रखना. व्हेन यू इन फ्यूचर आल्सो ऑलवेज मेक फ्लो चार्ट्स. तो है ना, क्विक रिवीजन हो जाता है. फ्लो चार्ट्स बनाओगे, क्विक रिवीजन हो जाता है. यू नीड नॉट रीड ऑल द थ्योरी. ऑलवेज मेक फ्लो चार्ट्स. ठीक है बच्चों. So PW Meded, so that's our faculty. Okay, I hope this is clear bachcho. So thank you to all of you for this patient listening, and all the very best from the entire team of PW Med Ed. Come with flying colors, and yes, be ready for the interview. I'll take your interview. ठीक है, इंटरव्यू के लिए आ जाइए. एक्सप्लेन वाई, सुभजीत एक्सप्लेन वाई है ना, कल लग जाएगा. कल है ना, वो उसमें आ जाएगा बच्चा. सो टुडे ओनली आई गॉट द मैसेज. तो एक्सप्लेन वाई कल लग जाएगा. सुभजीत रिवीजन हो गया. थैंक यू एंड हैव अ प्लेजेंट नाइट. ओके, अच्छे मार्क्स, अच्छे रैंक्स लेके आइए. बी देयर फॉर द इंटरव्यू. है ना. यस, ऐप में ही आएंगे सुभजीत, ऐप में ही आएंगे. ओके बच्चों, थैंक यू सो मच. थैंक यू. आई स्टॉप हियर. आई स्टॉप. ठीक है ना. एम सिद्दीकी, पीसफुल वर्ल्ड, क्लियर टू ऑल ऑफ यू. प्रवीण, पारुल, I hope this lecture was informative. काफ़ी चीज़ें समझ में आए, काफ़ी कुछ नया समझ में आया होगा. ओके, दैट्स फाइन. थिंग्स आर न्यू एंड समटाइम्स इट्स इंफॉर्मेटिव. ठीक है, थैंक यू. विल स्टॉप.